So I would like yes. Good morning to
Dr. Mathur.
Good morning to all of you. A warm welcome. I
am audible. Am I audible?
Yes, sir. Yes, you are. Introduce him.
Okay, sir. I am asked to introduce Dr. Girish Verma.
Yeah. Sir, let me invite you first. Sorry for the delay.
दिक्कत आ रही है आशुतोष तुम्हारी तरफ से यार.
Yes, sir. I'm here. So I invite the chairpersons for this first session of this morning, Dr. O.P. Mewara sir, Dr. Pradeep Jain sir, Dr. Girish Verma sir, Dr.
कौन है अभी हॉल में? अभी अपने दो ही कर.
Ashutosh, keep on speaking.
So Dr. O.P.
Hello.
Ashutosh, there appears
from R&T Medical College.
Your end.
Is attended and chaired in all.
There appears to be some problem at Ashutosh ends. I now request Dr. O.P. Mewara to please introduce our first speaker, Dr. Girish Verma.
Hello.
Yeah, Dr. Mewara sir.
Good morning, Girish ji.
Yes, sir. Please go ahead.
I am asked to introduce Dr. Girish Verma. He needs to introduce. He is a product from R&T Medical College, from where we came. And after passing his MD, he rapidly ascended the ladder progress and became the principal of the Government Medical College, Kota. And he was the man who invited me and made me a member of RSSDI. He is well known for his academic knowledge. He has many fellowships, and he has also published 2 chapters in Medicine Update. That's very good to know, for me at least. He is also known, very popular for his singing abilities, and everywhere in the conference he enjoys his singing as well as we enjoy his singing. Over to Dr. Girish Verma. Please start.
Thank you, sir. Thank you for your kind words. And at the outset, I thank the organizing committee for giving me this opportunity to speak upon centrally acting agents in hypertension. And I am indeed feel obliged by Dr. Parikh Saab, Dr. Girish Mathurji. They have always been a force behind me and making me enthusiastic regarding academic sessions.
Sorry to interrupt, Dr. Girish. Kindly make it full screen.
Sir, I have already made it, sir.
Achha, sir.
Is it visible, sir? Okay, sir. So I'll be speaking on centrally acting agents in hypertension. We all know that drugs that block sympathetic activity in the CNS are known as centrally acting agents. Can we? Okay. So the available drugs in use are clonidine, alpha-methyl dopa, guan bench, and moxinidine and rilmenidine. So we must know how these drugs act. Clonidine, which is a non-selective centrally acting agents on the brain, it acts on alpha-2 adrenoceptor as well as imidazolin-1 receptors. Those drugs which act selectively, alpha-methyl dopa, guan bench, guanfacine, they selectively act more on alpha-2 adrenoceptor blocker, while the moxinidine and rilmenidine, they act on imidazolin-1 receptor. So all these drugs, because clonidine is non-selective, so it has got more side effects as it works on periphery, causes dry mouth, CNS, sedation, decreased alertness, depression, and acting on imidazolin-1 receptor. So all these drugs act on the sympathetic activity and nervous activity, which is decreased by the action of these drugs, which decreases the norepinephrine, and by acting on heart, vessels, and kidneys. On heart, it decreases the heart rate, cardiac output, and by working on the vessels, they cause vasodilation and thereby decreasing the peripheral resistance. And they also have action on renin-angiotensin system. And by this action, these all drugs decrease the blood pressure. This is a busy slide showing their preparation, pharmacodynamics, daily doses, and adverse effect. So I'll be picking up the salient part from this slide. Clonidine actually has got many side effects, including sedation, drowsiness, rebound hypertension. The only interesting thing regarding clonidine is that it has got transdermal delivery patch of drug, which is available, and duration of BP lowering of this transdermal drug is for a week. So for clonidine, we should keep in mind that this clonidine acts on SA node as well as on AV node. Thereby, it can cause profound bradycardia. So it should not be used in sick sinus syndrome cases and second and third degree AV blocks. This significant bradycardia occurs in association with beta blockers especially, but it does not occur with labetalol and carvedilol if the clonidine is used with those drugs. Methyl dopa, as we all know that this can be safely used in pregnancy, but at the same time, it has got peculiar side effects. It can cause hypersensitivity reactions and leading to hepatitis and Coombs test positive. It can cause flu-like syndrome. It can cause SLE-like syndrome. So that thing we should keep in mind. Both these drugs, clonidine and methyl dopa, they are given twice a day. We all know the preparations of these drugs. Guanbench is available in 4 and 8 milligram preparation, and it should not be given in pregnancy. Guanfacine, it should not be given when somebody is allergic to it. I would like to speak upon moxinidine and rilmenidine. Moxinidine and rilmenidine, as they are extensively cleared from the kidneys. So we should be very careful while giving these drugs in patients of renal function impairment. If patient has got severe renal impairment, that means GFR less than 30 ml per minute. So this moxinidine should be avoided. It should also be avoided in advanced heart failure. There is a study when these drugs, this moxinidine was used in NYHA grade 2 to grade 4 advanced heart failure. So it increased mortality and morbidity in those patients. So moxinidine should be avoided in severe renal failure and advanced heart failure. Rilmenidine has got relative contraindication in advanced renal failure. Now I am coming to the individual agents of which act centrally as an antihypertensive. Clonidine has got very rapid onset of action, so it can be used in hypertensive emergencies. It is used in primary hypertension as 4th or 5th line drug. I must impress upon at this point of time that all these centrally acting drugs, they can be used as an add-on therapy in resistant hypertension, which we usually see in diabetics and patients who are suffering from renal disease. So this is as an add-on drug in primary hypertension. It can be used in menopause-associated vasomotor syndrome and hypertension with restless leg syndrome. As I mentioned earlier, that this clonidine is available in the form of transdermal patch. This particular preparation is useful in hypertension which require multiple medication, hospitalized patients who are unable to take oral medication, and those patients in whom we want to suppress the early morning surge of blood pressure. So, but at the same time, we have to remember this drug is best absorbed if you put this patch at the chest or arm, and it takes 1 to 2 days to have its antihypertensive effect. So after putting that patch, we have to continue the oral medication or oral clonidine 1 to 2 days after putting this patch. And this drug especially causes salt and water retention. So that, and when we remove this patch, This drug has its effect for 12 to 24 hours. So we should remember that in the beginning, it takes 1 to 2 days to its effect to appear, and the effect remains even after removal of this transdermal patch for a day. So why this has been entered? Now, next drug is methyl dopa, which is useful in intolerant patient to the clonidine, and in hypertensive emergencies, it is used intravenously. As we all know, this drug is safely used in pregnancy with hypertension because it does not cause teratogenic effect and it does not decrease the cardiac output of pregnant lady. It maintains the uterine and renal flow in the pregnant ladies. So it is safe in pregnancy-induced hypertension. As mentioned earlier, that specific side effects: hepatitis, Coombs-positive hemolytic anemia, HLE-like syndrome, flu-like syndrome, even pseudolactation can occur with this methyl dopa. Here, I would like to point out, if patient develops Coombs test positive, we can still continue the methyl dopa, but if patient develops hemolytic anemia, then we have to stop this drug. Guanbel is similar to clonidine, but it has got less side effect. It causes less postural hypertension, less postural hypertension, less rebound hypertension. And the specific advantage of this particular drug is that it reduces left ventricular hypertrophy. It reduces total cholesterol 10 to 20% by inhibiting the cholesterol and triglyceride synthesis in the liver. And a specific side effect of this drug is impotence. Guanfacine, it has got longer duration of action. It has got 24 hours duration of action. That's why it is given once daily dosage, and preferably it should be given in the evening or bedtime to suppress early morning surge of blood pressure, as this drug also has sedation, so that sedation can be aligned with the sleep if we give this drug in the evening. It is used instead of clonidine when excessive sedation is problem, but its sedation character is used if it is given in the evening or at bedtime, so that part is taken over. When given with diuretic, it enhances the antihypertensive effect. Moxonidine, we are frequently using this drug as a physician. It can be used as a monotherapy or with other hypertensive drugs. It is mainly excreted through kidneys, so we have to do the adjustment according to the GFR. It is not used in GFR less than 30 ml or if in cases of advanced heart failure. Rilmenidine can be used. It is given once a day. 1 to 2 milligram preparations are available. This rilmenidine and moxonidine is not available in USA, so FDA approval is not there. But it can be used, this rilmenidine, alone or in combination with other antihypertensive. It does not affect the heart rate as it increases the parasympathetic tone. And of course, it has got less side effect, but it Hello?
I think sir has lost the contact.
Hello? Ashutosh, am I audible?
Yes, sir.
Yes, sir, you are audible, but your slides are not there.
Sir, I will share from my side, please, sir.
Yes.
Okay. Are you sharing, Ashutosh?
I am sharing, sir.
Okay.
Sir, on which slide, sir?
Rilmenidine. Okay, I'll do that. Go down. Next. Ashutosh, next. Okay, I'm sharing. You stop it, otherwise we won't be able to control work. We can use centrally acting antihypertensives are clonidine can be used in migraine prophylaxis, post-traumatic stress syndrome to reduce postmenopausal flushes, and moderate alcohol and opioid withdrawal syndrome, and many other conditions where we do ileogynecostomy to reduce fecal output and diagnosis of pheochromocytoma. In pheochromocytoma, we give 0.1 milligram of clonidine every hour for 3 times, and after that we measure the norepinephrine level. So norepinephrine level decreases in essential hypertension, while in pheochromocytoma the norepinephrine remains the same. Guanfacine can be used in attention deficit disorder and in Fragile X syndrome. Fragile X syndrome is responsible for mental retardation in many of the children, and it decreases its arousability, aggressiveness, and impulsivity. These drugs have got interactions which we should know. Methyl dopa, if taken with iron, the therapeutic effect is decreased, and the methyl dopa interferes with the catecholaminé assay, and it also interferes with MAO inhibitors, levodopa, bromocriptine. Drug interaction, guanbench increases the absorption of hydrochlorothiazide. Clonidine and guanfacine antihypertensive effect is reduced by tricyclic antidepressant. The reason is they are sharing the same receptors. Moxonidine and rilmenidine should not be given with MAO inhibitors. So to summarize all these things, regarding centrally acting antihypertensive agents. Pardon?
Need to conclude, sir. We are running. Yeah, you are audible.
Yes,
conclude quickly, sir. We are running short of time. Yeah, thank you, sir.
This is the last slide. Good antihypertensive agents, centrally acting agents are there. They are good antihypertensive agents. Especially, we can use them in resistant hypertension as an add-on therapy. Methyl dopa can be used safely in pregnancy. Guanfacine and guanbench are better drugs, alternative to the clonidine, and rilmenidine and moxonidine, as they act on imidazoline receptors, they have less side effects, so they are better tolerated and can be given as an antihypertensive agents in the hypertension. Thank you.
Thank you, sir, for the enlightening talk on centrally acting agents. Now, I would like to invite Dr. Pradeep Kumar Jain, sir, as a chairperson for the next lecture. He has been consultant at Kekri Government Hospital and also at the Ministry of Health, Kingdom of Saudi Arabia. He is AFISC, FICP, FICM. He has been felicitated in past at eRAJAPICON Jodhpur and also at Physicians Day by eRAJAPICON and ICP. So I would like to invite Dr. Pradeep Kumar Jain, sir, to kindly welcome Dr. Puneet Saxena, sir, for his next talk.
Good morning, everybody. Dr. Puneet Saxena is a senior professor, Department of Medicine, SMS Medical College and Hospital, Jaipur. He is MD, FICP, FRSSDI, FRCP, FIACM, and FGSI. Now I will call Dr. Puneet Saxena for give the lecture.
Sir, you are muted. Please unmute yourself.
Yeah, good afternoon, everybody. The previous speaker has to stop sharing the screen, otherwise I cannot share my screen.
Sir, it's already stopped, sir.
Okay. So the screen is visible?
Yes, it is visible, sir. Kindly make it full screen.
All right, full screen. So good afternoon, everybody. At the very outset, I thank the organizers to giving me the opportunity to speak on this important, very important, and yet controversial topic of antiplatelets. That how long and how much should be given in various indications, especially the cerebrovascular and the cardiovascular diseases. So within the constant of time, I will try to do justice. But I apologize that I'll go fast. I may be excused for that. So this is the need. Arterial thrombi is the most common cause of myocardial infarction, ischemic stroke, and limb gangrene. And because it happens because of platelet aggregation and fibrin deposition, and hence the need of antiplatelet arises, and it remains the mainstay of treatment basically for these group of diseases, which is major cause of morbidity and mortality globally. This is the classification in the brief. Antiplatelet drugs, COX inhibitor, the conventional one, the aspirin. The newer ones, that is P2Y12 receptor blocker, which can be reversible, and you can see ticlopidine, clopidogrel, prasugrel are irreversible, whereas the newer ones, the ticagrelor and cangrelor, which is injectable cangrelor, they are reversible. And finally, you have these strong ones, which inhibit the final pathway, GP2B3A inhibitors, and in which you have monoclonal antibody abiximab and synthetic molecules, eptifibatide and tirofiban. And finally, you have phosphodiesterase inhibitors, dipyrrolate silastazole, which are weaker antiplatelet agents, but they have other mechanisms for preventing the clot formation. This is the mechanism of action, whereas aspirin blocks the COX-1 inhibitors and thereby thrombexane formation. And these group of drugs are basically blocking the another pathway, which is the ADP-mediated platelet recruitment and activation. And finally, the final pathway is blocked by these strong antiplatelet agents, GP2B3A activation inhibitions, which leads to stoppage of platelet aggregation. So indications is primary prevention of MI, controversial issues. Secondary prevention MI is established indication. Primary prevention of ischemic stroke, again a controversial issue. And secondary prevention of ischemic stroke and TIA, ACS, and peripheral artery disease are established indications for use of antiplatelet indications. And let's see, for primary prevention, aspirin alone has been used for primary prevention of atherosclerotic vascular disease. However, it has been questioned. And the three main groups, diabetics, elderly, and non-diabetics with intermediate risk of atherosclerotic vascular disease, it is indicated, have been questioned because of merits and demerits. And there are still key unresolved questions regarding the role of aspirin in primary prevention. That is, what should be the optimal drug formulation, what should be the dosing, and what should be the weight-based dose selection, and other factors like sex and treatment response. And so many trials were done on primary prevention. And you can see here the gist of all the trials over the timeline, right from late 80s to the present times, where the first trial was Peto et al. Then you have a big physician health survey, first physician health survey was done on 22,000 physicians where the aspirin was given. And then you have HALT trial, then women health survey, then Japanese study, JPAD and JPPP. And finally, you had ASPRI, ARRIVE, ASCENT trial, and ongoing XFD. And you can see here that the trials which are shown in gray, they have shown the positive result for effectiveness, whereas the red ones are neutral and the white ones are inconclusive. So the decision to use aspirin therapy in people ages 40 to 70 is more complicated, and you need to calculate the risk basically. And at a 10% risk, person is a candidate, can be a candidate for aspirin therapy, but not if you have a lower risk. And risk, as you all know, can be calculated by using various types of calculators like Framingham calculator or AHA-ACC calculator or Q-risk calculators, basically. And the high-risk groups, besides age, is being male, being African-American, being diabetic, and history of high blood pressure, cigarette smoking, and unhealthy cholesterol levels. So this is the group where aspirin can be used for primary prevention if the risk falls in that group and the other risk factors are present. However, in 2019, the American Heart Association and ACC recommended against the routine use of low-dose aspirin in people older than 70 years who do not have existing heart disease and haven't had a stroke. So no for a primary prevention in that age group, or in people of any age who have an increased risk for bleeding, So there, the primary prevention, the aspirin should not be given for primary prevention. And in the current era, most patients without established atherosclerotic cardiovascular should not be prescribed aspirin, and there are various modalities to assess atherosclerosis these days. Rather, aggressive management of comorbidities tailored to the expected cardiovascular needs to be emphasized, and that modifiable and non-modifiable risk factors should be controlled rather than using the drug which can cause bleeding, other side effects. And this is the table which can guide you how to decide whether the aspirin should be used for primary prevention. So is the patient 40 to 70 years old? Does he have any high burden of severe risk factors? Is the bleeding risk low? Is the patient informed basically that he can have benefit or there can be no benefit of primary prevention? And does the patient favor ASCVD prevention over bleeding awareness? If all the answers are yes, then you can use low dose aspirin. And if the answers are no, then obviously you can see here on the top in the red box, the no aspirin should be used for primary prevention. So, and this is the recommendations basically, aspirin for primary prevention in men, in whom the 10-year risk of coronary heart disease is more than 10%, then it is 1A. Then you see in women, it's slightly different basically. Then if the women is more than 65 years of age, then even if the risk is more than 10%, then the level of recommendation is 2A. And then in less than 65 years of age for ischemic stroke prevention, it is 2B. And in aspirin in optimal risk women less than 65 years of age, obviously it is 3. So should not be used in that age group if the risk is optimal and they are not high risk. Now we come to secondary prevention basically, and it is an established indication for use of antiplatelet drugs. But the big question is whether the single antiplatelet therapy, that is SAPT, should be used or the dual antiplatelet therapy should be used. And what should be the duration? So it should be a longer versus shorter duration of DAPT, that is dual antiplatelet therapy. So you can see in secondary prevention, well established, you can see it is 1A recommendation, then aspirin. When there is stenting basically, then higher dose of aspirin, that is 160 to 325 milligram for 3 to 6 months, depending on the type of stent. Again, the level of recommendation is 1B. So it is established. There is no issue on that. But the question is about the DAPT, the use of another antiplatelet drug in addition to aspirin. So as clopidogrel, it is the commonest we are using. It is most studied. The trials are present with them. But with the advent of prasugrel and ticagrelor, the scene is changing basically because there are trials now which try to compare these drugs. So another question is how long? So it depends on underlying condition, type of stent which is used, and whether the drug electric stents, whether they are of old generation or the new generation. And intensification of antiplatelet therapy with addition of P2Y12 inhibitor to aspirin monotherapy necessitates a fundamental trade-off between decreasing ischemic risk and increasing bleeding risk. Because when you're using DAPT, the bleeding risk obviously increases as compared to the single drug. And this is the recommendation by various trials in acute coronary syndrome. Primary prevention, you can see here, aspirin alone for patients in whom benefit outweigh risk, and this has been supported by these studies. And if you see the acute coronary syndrome group, then patients who are undergoing PCI, clopidogrel plus aspirin for more than a year, and for some patients, even prasugrel plus aspirin or ticagrelor plus aspirin may be a superior choice. And those who are not undergoing PCI, clopidogrel plus aspirin for some patients for even more than a year, and for some patients, obviously ticagrelor, depending on the side effect tolerance and the choice of the physician, it can be a superior choice. And for stable angina or past MI, aspirin alone is sufficient, and this has been supported by these studies you can see here. And the antiplatelet trial is collaboration, Charisma and Capri. Similarly, if your patient is undergoing elective PCI, then clopidogrel plus aspirin for more than a year should be used as shown by the CREDO trial. You see the clopidogrel evidence for secondary prevention. Then the CURE trial showed basically that when you use aspirin plus clopidogrel in patients of acute coronary syndrome as compared to aspirin alone, then the rate of events, that is death, MI or stroke, is reduced as compared. So dual antiplatelet therapy is more efficacious in NSTE and ACS patients. Right? So there are trials comparing various ADP antagonists. So one of them is Triton-TIMI trial, TIMI trial 38, where practical treatment resulted in fewer ischemic complications of stent thrombosis, but more frequent bleeding, including life-threatening and fatal bleeding. And because of this, practical, there was no net benefit of practical therapy, especially in those who were more than 75 years of age or those who were underweight. And then there was a net harm in those with prior stroke or transient ischemic attack. So this is one evidence. Then you have another trial called Plateau trial, where patients with ACI were treated with ideal medical therapy alone or medical therapy plus PCI, and treatment with ticagrelor 90 mg twice daily compared with clopidogrel 700 resulted in fewer ischemic complications and stent thrombosis. But however, the bleeding was slightly higher in the ticagrelor group. Another trial, the Pegasus TIMI 54 trial, which studied the patient for a mean of more than almost 3 years. DAPT with aspirin plus ticagrelor when compared with aspirin monotherapy was faring better, but however, there was a slight increase in major bleeding. However, there was no excess in fatal bleeding or intracranial hemorrhage in patients with prior MI. And the 2 doses of ticagrelor had similar overall efficacy, but bleeding and other side effects tended to be less frequent when you maintain the patient with 60 milligram BID dose. So this is how you choose basically DAPT. There is a therapeutic window. On one side is the ischemic risk, and on the other side is the bleeding risk. And this is the sweet spot. The patient has to be put here, and it requires balancing basically. And this should be decided by the intensity of the antiplatelet drugs which you use and the duration which you use. And short duration or prolonged duration therapy, you can see the effect on the endpoints basically. Short term means up to 12 months, and beyond 12 months is the prolonged duration dual antiplatelet therapy. And you can see in the green, it is the short and the long DAPT. There is a slight difference in the event rate basically. When you use for long time, the event rates are slightly slower in some of the studies and others. So with which they were basically matched, and there was no significant difference between the two groups. However, if you see the bleeding with the dual antiplatelet therapy in short versus long-term therapy, that is less than 12 months and more than 12 months, then the bleeding risk probably is higher when you use DAPT for more than 12 months. That is the longer duration of therapy. And this is the recommendations. Various guidelines have recommended the duration of DAPT after acute coronary syndrome, and you will see ACC, AHA, European Society of Cardiology, and others, they have recommended to APT up to 12 months, right? Most of them, whether the stenting has been done or not done, so they have recommended for 12 months. And it can be considered for more than 12 months, those who have undergone PCI, especially those who had ST elevation MI. So there you can continue for more than 12 months also. And this is a score which can guide you whether how much long you can do the DAPT. And this is if it is the score is more than 2, and various factors like age, smoking, diabetes, MI, prior MI, stent diameter, and drug-eluting stents, and presence of CHF and grafts, kind of grafts used in CABG, can give you a scoring system. And if it is more than 2, then you can choose the benefit-risk ratio for prolonged DAPT. It can be justified that you will use it for more than 12 months. So if we see the antiplatelets in stroke, it is used in thrombotic stroke. And if atrial fibrillation is there, then obviously anticoagulation is this treatment of choice. Aspirin is also effective to prevent a stroke in AFib, but not as good as oral anticoagulants. And we talk about the other thrombotic stroke. If you're not using thrombolysis, then it should be started immediately within 24 to 48 hours. And if TPA is administered, it should be delayed because there is already a bleeding risk which has been increased by use of TPA. So it should be delayed, and you should be started after 24 hours. So if we talk about DAPT in a stroke, most common combination is aspirin plus clopidogrel. However, aspirin plus dipyridamole and cilostazone have been studied. And why DAPT? Because most beneficial in large artery atherosclerosis prevent short-term recurrence, and mostly during the first few weeks of the stroke.
So request you to conclude, please.
Yes. So give me 2 minutes. I have 2 minutes just, right? So these are the criteria for using the DAPT. Please note it is minor stroke, NIHS less than 4, not a major stroke, because the hemorrhagic conversion is higher. And you can use for TIA, ABCD score for TIA. Then you, if patient is having intracranial stenosis, unstable angina STEMI, or even carotid, you then DAPT is preferred as compared to the simple. And there are various trials basically which have shown that clopidogrel alone can be as good or superior to aspirin. And the combination of clopidogrel plus aspirin is good, especially for the first 3 months in stroke also. So I'll just skip some of the slides. And these are the trials you can show which have been studied in recent stroke, past stroke, and in the peripheral artery disease, where the clopidogrel has fared at least as good or better than aspirin, and the combination has fared better than the individual drug alone. However, there has been caution because of the risk of hemorrhagic conversion and other kinds of bleeding. And this again, the combination, I will not touch upon this. And this is again the Capri trial, which has shown the superiority of aspirin for 2 years. And the combination of aspirin with clopidogrel is better than aspirin alone. And triple therapy is not advocated where you use a NOAC with DAPT. It is deleterious because of the increased bleeding risk and should not be used. Few words about aspirin resistance. Basically, suboptimum aspirin-induced inhibition of platelet function that has been proven to be independent risk factor for future cardiovascular event. And inadequate response. There are so many risk mechanisms basically which can explain the aspirin resistance, and the non-compliance is the first and the most important reason for inadequate aspirin response. And in such cases, a dual antiplatelet therapy can do better. And there are tests basically to measure aspirin resistance. These are 3 kinds of tests: optical hygrometry, the platelet function analyzer, and the verify platelet function assay. And if the aspirin resistance can come up to 25%, but the most common reason is the improper dosing and missing of the doses of the aspirin. There are few words about injectable antiplatelet. They are mainly indicated for the procedure, that is the people who are undergoing PCI or as a bridge to bypass surgery in patients who have undergone major surgery. So there are newer antiplatelet agents which are waiting, and time will tell us how good they are and in what quantity and for how long they can be used. Only time will tell us. And aspirin in COVID has also been indicated. There has been a recent paper in NEJM about that it can be beneficial. And with that, I will conclude my talk. And if there are any questions, and please excuse me for going fast and skipping some of the data because the time was really short. Thank you very much for your kind attention.
Thank you, sir, for the enlightening talk. We are really sorry that we are running short of time, so we have to run fast. So I would like to now invite our next speaker, Dr. Anil Samaria, sir, for the next talk on CCB, newer CCB agents. He is a senior professor in Department of Medicine, GLN Medical College, Ajmer. He has been faculty in many national and state level conferences. He has organized the State RSSDI Rajasthan Chapter Congress 2017 in Ajmer. He is a reviewer of International Journal of Diabetes in Developing Countries, Springer Journals. So welcome, Dr. Anil Samaria, sir, and over to you. Dr. Samaria, sir.
Then you can, if he is not there, you can call Dr. Sudhir Mehta.
He's there, sir. He's there.
Doctor, you can call Dr. Sudhir Mehta.
Dr. Ashutosh, can you hear me?
Yes, sir. Yes, you can start your talk.
Yeah. Thank you, sir. Dr. Parikh sir, good morning, sir.
Thank you. Good morning, sir.
Yes.
Good morning.
Yeah.
So I welcome Dr. Sudhir Mehta, sir. He is a renowned faculty in the field of medicine and hematology. He is a senior professor in Department of Medicine, SMS Medical College. So I welcome you, sir. Please. He's a member advisory council of ACP Indian chapter, member faculty council of ICP India also. He has chaired and has been a speaker in many international and national conferences. He has been awarded National API Ocean Awards, NAMS Award, Rajasthan University Gold Medal, and Bhamashah State Award. Welcome, Dr. Sudhir Mehta, sir.
Thank you, Dr. Ashish. Can you share my slides?
1 second, I'm sharing.
Yeah, Ashish.
A very good afternoon to all the attendees of virtual ERAJAPICON 2020. At the outset, I wish to express my gratitude to Dr. K.K. Parikh sir, Dr. Girish Mathur, and the scientific committee for inviting me and for giving me this opportunity to interact with all of you. I am also thankful to them for relocating my talk today on Sunday. In the current age of modern technology, everybody is racing for expensive and sophisticated investigations. Just like the art of clinical medicine is fading, so is the importance of basic tests. CBC generated from automated cell counter is the most widely ordered test in clinical medicine across all specialties. Yet its importance is still undervalued. There are nearly 55 numerical parameters along with histograms, scatter plots, and flags in CBC. In fact, CBC is an ocean of meaningful information. Today, I will be discussing two ratios which are derived from CBC, namely neutrophil lymphocyte ratio NLR and platelet lymphocyte ratio PLR. Both these ratios have been well studied in cancers and cardiovascular disease, but they have caught renewed attention in the current COVID-19 pandemic. Today, a large majority of COVID-19 patients are subjected to expensive biomarker tests from prognostic point of view, little realizing that we have simple and inexpensive tests to perform the same function with equal sensitivity and specificity. We all know that inflammation plays a major role in the pathophysiology of cancers, atherosclerosis, and cardiovascular disease. Previous slide, please. No, previous slide. Yes. And we all know that C-reactive protein, especially the high sensitivity CRP, is the gold standard marker of inflammation. But now these two ratios, neutrophil lymphocyte ratio and platelet lymphocyte ratio, are emerging as potential markers on inflammation, and its significance is being recognized in the current COVID-19 pandemic. Several studies have clearly demonstrated that elevated levels of these ratios are significant predictors of outcomes for patients of cardiovascular disease and cancer. These ratios are also risk factor for mortality, not only in infectious disease, but in malignancy, acute coronary syndrome, intracerebral hemorrhage, various collagen vascular disease, including polymyositis and dermatomyositis. Next slide. Next slide, please. Now, high value of these ratio is linked with increased level of cytokines. Therefore, in COVID-19, whenever there is a cytokine storm, you find high values of NLR and PLR. And these are considered also as markers to predict systemic infection. In fact, both these ratios have also been linked to various risk factors for atherosclerosis like diabetes, hypertension, metabolic syndrome, obesity, hyperlipidemia, lifestyle habits, and endothelial dysfunction. And we all know that COVID-19 is a disease of endothelitis, and these two ratios are very useful marker in COVID-19, which I'll narrate right in just few minutes. Now, NLR is calculated as the absolute neutrophil count divided by the absolute lymphocyte count, and PLR is calculated by platelet count divided by absolute lymphocyte count. Now, NLR is the most studied ratio as compared to PLR. Next slide, please. Now, this is one of the first articles which came in 2020 in the COVID-19 pandemic, where it has highlighted the importance of neutrophil lymphocyte ratio as an independent marker for mortality. And this was a study which was done in 245 Chinese patients who were hospitalized in Wuhan. And this is a landmark study which showed that the importance of these simple parameters derived from CBC. Next slide. So coming to in the context of COVID-19 pandemic, we know that patients with severe COVID-19 usually have hematological disturbances in form of neutropenia, lymphopenia, and thrombocytopenia. And all these parameters, they put patient more prone to susceptible to develop acute respiratory distress syndrome. High NLR is significantly associated with increased risk of all-cause death during hospitalization in COVID-19 patients. A higher NLR at admission is also associated with more severe outcome. In particular, if NLR is more than 4, it is a very good predictor that the patient may be shifted to ICU for further care. Therefore, these two ratios, especially NLR, are useful prognostic factor for early identification of severe COVID-19 disease. Now, this is a study which I've already narrated, and the conclusion was that NLR is an independent risk factor for the in-hospital mortality for COVID-19 patients, especially for male. Now, assessment of NLR may help identify patients who are at higher risk. Next slide, please. Next slide. Now, adjusting for age and sex, NLR, if it is more than 6.5, increases the chance of disease, that is COVID-19, by 4 times. And if NLR is more than 6.5, the chance of death is 1.5 times higher. And in fact, if you take the neutrophil and CD4 lymphocyte ratio, it is a very potential and useful marker for predicting the virus-negative conversion time in COVID-19 patients. And therefore, patients with severe COVID-19 have high values of NLR and PLR value as compared to those who have non-severe disease. When compared to other risk factors, tools such as CURB65 and multilobular infiltration, bacterial co-infection, smoking history, hypertension, and age, NLR has a high sensitivity and specificity. Next slide, please. Now, why does lymphopenia occur in COVID-19? There are four postulated mechanisms. Lymphocytes, they express the ACE2 receptors on the surface, and thus the virus may directly infect these cells and cause the lysis. Secondly, the cytokine storm may also promote apoptosis of these lymphocytes. Substantial cytokine activation is associated with atrophy of lymphoid organs, which impairs the turnover of lymphocytes. And lastly, the coexisting lactic acidosis may also inhibit lymphocyte proliferation and has been more commonly seen in patients who have patients with cancer. Next slide, please. Next slide, yeah. Now, what is the role of these ratios in atherosclerosis? We all know that inflammation plays a pivotal role in the pathophysiology of vascular diseases. NLR can be affected in atherosclerotic risk factors like hypertension, metabolic disease, hypercholesteremia, and so on. And it is also capable of identifying subclinical cardiovascular disease. We all know neutrophils, they make the plaques more vulnerable through the release of proteolytic enzymes and redoning acid radicals. Neutrophils also secrete mediators and are associated with acute inflammatory injury to the tissue and the endothelium. Next, please. Next. Now, this cartoon simply shows how the endothelial dysfunction, which is observed in, can lead to high value of iron. Next slide. Now, continuing with the goal of these issues and atherosclerosis and cardiovascular disease, especially NLR, is significantly with angiographic severity of acute coronary syndrome. And in those patients who have STEMI, if it is NLR is more 2.5, it is a predictor of infarct-related artery angiography. And even the value of these ratios has identified increased risk of death within 2 years of major surgery. Has also been studied to the previous slide. Yeah, PLR has also been studied to evaluate the critical limb ischemia in patients who have peripheral vascular disease. Next slide, please. Now, next slide. Next slide, please. Am I audible? Yes. Yeah. Now, there has been various studies which have shown that there's a strong relationship between NLR and a coronary flow velocity on patients who are present with NSTEMI, and which I have already said it is an independent indicator for no reflow development in these patients. It has also been studied as a prognostic marker in patients who are undergoing coronary bypass surgery. Next slide. And now, this high ratio of NLR has also been associated with arterial stiffness and coronary calcium score. And we all know that if NLR is more than 5, it is a strong predictor of 30-day mortality and long-term outcome in patients who undergo abdominal aortic aneurysm repair. In patients with peripheral arterial disease, after adjustment of several vascular risk factors, NLR more than 3 is an independent predictor of long-term cardiovascular mortality in these patients. Next slide, please. Now, further, the second ratio, that is the PLR, is also an independent predictor of cardiovascular mortality in patients who have acute coronary syndrome, include MI, and PIC has studied the combination of both these ratios and found to be a good predictor of in-hospital and long-term mortality in patients who undergo primary PCI. Next slide. However, there are certain confounding factors. NLR is significantly decreased after statin therapy, and antihypertensive therapy like labetalol significantly lowers NLR. In this context, the medication should be considered whenever NLR is being assessed in a patient. Next slide, please. Now, coming to the role of these ratios in hypertension, we know hypertension is a vascular inflammatory disease, and high NLR may reflect vascular inflammation in these patients. Antihypertensive treatment may improve cardiovascular outcome and decrease the biomarkers such as NLR. And that is the significance of following patients of hypertension with medication, especially labetalol. Next slide, please. Now, coming to the role of these ratios, I've already narrated that these ratios are good predictors of the future cardiovascular morbidity and mortality in patients who have diabetes and dyslipidemia. Next slide, please. And there is an inverse relationship with high density cholesterol. We know that HDL is a protective cholesterol, and there's an inverse relation between these two ratios and HDL. Now, coming to the role of these ratios in cancer, inflammation is a hallmark of cancer, and there is often a complex host-tumor relationship, with most tumors having inflammatory cells and mediators present in the microenvironment. Neutrophils are the front line of the defense system and are thought to produce several cytokines and angiogenic factors that participate in different steps in tumor development. In contrast, lymphocytes are known to act as the host defense against tumor cells. Studies have clearly demonstrated an association between low peripheral lymphocyte count and hence high NLR and PLR value and short survival in different types of cancer. Next slide.
Sorry, Dr. Mehta, you have to
Yes.
finish in 5 minutes, eh?
Yeah, I will finish. Yes, sir.
Thank you. Thank you. Thank you.
These markers are also have been used to predict recurrence and death for various cancers. Regardless of the site of the cancer, a high ratio have been reported to be associated with increased mortality and recurrence rate. And meta-analysis assessing the association of PLR and overall survival in more than 12,000 patients with various solid tumors have shown that high PLR value is associated with a significant worse prognosis. Next slide, please. Now, continuing with PLR in cancers, we all know that platelets are part of the inflammatory response, and thrombocytosis is common in patients with solid tumors. Platelets are known to interact directly with tumor cells and contain factors that contribute to tumor growth, invasion, and angiogenesis. Platelets, they protect the tumor cells from natural killer cell-mediated lysis, therefore facilitating metastasis. Therefore, high values of platelets, if seen in patients, especially in solid cancers, they are more prone to develop metastasis. And there is a strong correlation between increased platelet count and short survival time in majority of cancer patients. Next slide, please. Now, the role of these ratios have been well documented in CKD, and it is related to the endothelial dysfunction, which also occurs in patients with chronic CKD. Next slide, please. The role of these ratios, NLR and PLR, has been documented in inflammatory vasculitis. The classical example is Behçet's disease, and high NLR may be related to the endothelial dysfunction, and they reflect disease activity in patients who have Behçet's disease. Next slide, please. Now, these patients, like other collagen vascular disease, they have a role in autoimmune disorders, and they are correlated with other inflammatory markers like CRP and ESR. Next slide, please. Now, what is the normal range for NLR? It varies by age, sex, and race. The average NLR is 2.15 in the US population and 1.65 in South Korea. In other words, NLR is race specific. Of course, we do not have the value for Asian and Indian population. Normally, if NLR is 1 to 3, it is normal. If it is 6 to 9, it indicates mild stress. And if it is more than 9, it means that the critical disease is there. Now, females have higher estrogen levels than males, and therefore they have higher values of NLR and PLR as compared to males. NLR in the Asian population is usually lower than the other races. Next slide, please. Now, unlike NLR, the PLR is less investigated. Again, there's a sex difference with higher values of PLR in women than men. And this again is differential. This is related to higher platelet counts which are seen in women, especially in pre-menopausal women. Now, lower serum iron in menstruating and elder women, which stimulates the platelet production, and therefore they have reactive thrombocytosis, which leads to high values of PLR. Also, the estrogens favor the platelet synthesis. Apart from sex, platelet count varies by age, being higher in youth than in old age. Next slide, please. So to conclude, both these ratios, neutrophil lymphocyte and platelet lymphocyte ratios, can be easily calculated from CBC, which is widely available and routinely performed. Unlike other inflammatory markers, these ratios are inexpensive, reproducible, and provide additional risk stratification beyond conventional risk scores to predict in-hospital and long-term mortality. But both these ratios are yet to get due attention of physicians as a useful bedside prognostic factor. Thank you very much.
Thank you so much, sir, for the enlightening talk. So we will now proceed to our next session. Any questions are there for Dr. Sudhir Mehta, sir, if any, or we should proceed? So I now invite Dr. Anil Samaria, sir, once again, for giving his talk on newer CCB agents. He is a senior professor in Department of Medicine, JL and Medical College, Ajmer. Dr. Samaria, sir, please.
Yes. Hello?
Yes, you are audible, sir.
Yeah, I am
Please
audible. Just I am sharing my PPT. Just wait. Good morning, all of you. Are you hearing me?
Yes, sir, you are audible. Please share slides.
Yeah. Good morning, everyone, and thank you for organizing me to invite as a faculty. The newer calcium channel blockers, the current scenario, the hypertension.
Slides are not visible.
Slides are not visible, sir. Please share.
Yes.
Share screen.
Sir, I am sending a request. Please grant permission, sir, for sharing.
Yeah.
If you cannot share your slide, then we can go for the next session.
Hello?
Yes, Ashish, please share.
Yes.
Yeah.
स्क्रीन शेयरिंग हो गया आपका, शुरू करें.
Yeah.
Please start,
hypertension
sir.
is defined as an obvious. Yeah.
No, slides are not being shared, sir. आपको दिख रही है डॉक्टर आशुतोष? दिख रही है?
No, sir.
Slides?
Sir, no, not now,
Not
but
visible.
they are being shared. It is showing, it is being shared.
He can start his talk, sir. It will be visible in few minutes.
Should we go on to next session?
Yeah. आशुतोष जी शेयर कर सकते हो?
Ashish, please share.
सर मेरे पास सर के स्लाइड्स नहीं है सर.
तो ऐसा करो आशीष जी, अगले सेशन में रख लेंगे इनकी टॉक, जब तक आप नया सेशन शुरू कर दो.
Okay, sir.
डॉक्टर पुरी का.
So for the next
लिपिड वाला
session.
है अगला? लिपिड का है अगला?
Yes, sir. Next is lipidology symposium.
तो डॉक्टर पुरी साहब का वीडियो चला दो. मिल गया वो? अनिल सामरिया आपका हो रहा है क्या?
सर वो उसमें शेयर नहीं कर पा रहा हूँ.
तो फिर अभी चालू करो.
सर आप मुझे मेल कर दीजिए, आपका नेक्स्ट सेशन में.
सर मेल कर दिया मैंने, मेल किया हुआ है आपको.
हाँ.
देखो एक बात, मैंने मेल किया
I think we can start the new
You can
session,
start
sir.
the next session, dear.
We can accommodate Samaria sir's presentation in this session. So we will now start the lipidology update, and may I now invite our chairpersons, Dr. Satish Kapoor sir from Sikar, Dr. O.P. Meena sir from Udaipur, and Dr. Mayank Srivastav sir from Ajmer. So I will briefly introduce our chairpersons. Dr. Satish Kapoor sir is a director at Kapoor Hospital, Sikar. He is life member of API RSSDI and has chaired many sessions at national and state level conferences. He was chairman scientific committee eRAJAPICON 2015. Dr. O.P. Meena sir. He is a senior professor and unit head at R&T Medical College, Udaipur. He is life member of API, IACM and IPF. He has numerous guest lectures and orations at state and national level platforms and has been author of many publications. Dr. Mayank Srivastav sir, he is presently working as assistant professor in JLN Medical College, Ajmer in the Department of Geriatric Medicine. He was the organizing secretary of GeriCon 2018 at Kota, has many publications in various national and international journals of repute. So please proceed now. I invite Dr. Satish Kapoor sir to kindly introduce Dr. Ramanpuri sir.
I am audible?
Yes sir, you are audible. Please introduce Dr. Ramanpuri sir.
Okay, sir. It's my pleasure to introduce Professor Ramanpuri. He is Senior Interventional Cardiologist at IP Apollo Hospital, New Delhi. Founder and Chairman, Lipid Association of India. Formerly Head Department of Cardiology, Safdarjung Hospital, New Delhi. Member of International Lipid Expert Panel. Now it's over to Professor Ramanpuri for next session. Thank you.
Good afternoon, everybody. And first of all, I would like to convey my special thanks to Dr. Parekh for inviting me for a talk on HALIA recommendation 2020 for management of dyslipidemia in Indians. I'll be covering these 4 topics. These have been published in JAPICON. Of ASCVD. In 2001, ATP3 came out with guidelines in which they recommended LDL cholesterol less than 100 milligrams in patients with coronary artery disease or CAD equivalent, and this target was brought down to 70 milligram in 2004 in ATP3 update. Due to these recommendations, there was a decrease in death rate due to CVD, and in USA, not only in USA, there was more than 50% decline in CVD mortality in European country. But in Indian, if you look into the Indian CVD mortality, it has gone up by 40% from 1990 to 2015. There are a number of reasons. One of the possible explanation is that we have high prevalence of atherogenic dyslipidemia. But we have been following these guidelines since 1988. Even then, we have, for reasons which we don't know, that the mortality has gone up. We have high prevalence of premature coronary artery disease. 25% of those dying of coronary artery disease are less than 40 years of age. And even ACC now consider Asian ethnicity as high-risk ethnic group. So we need our own recommendations. So Lipid Association of India in 2016 published its Part 1 expert consensus in JAPI, and the highlight of this expert consensus was ASCVD risk algorithm, which is very simple and doesn't require any calculator or internet. The patients are classified into 4 ASCVD risk group based upon major ASCVD risk factors, other high-risk features, and moderate risk non-conventional risk factor. The primary target is LDL cholesterol, with and co-primary target, which we recommended in 2016, was non-HDL cholesterol. Non-HDL cholesterol target was as important as LDL cholesterol target. And the goal of LDL cholesterol in very high-risk group was less than 50 milligram, and in high-risk group less than 70. We were the first association in the world to recommend LDL cholesterol less than 50 milligram in very high-risk group patients. In same year, 4 months later, European guidelines were published, and they recommended LDL level less than 70 milligram in documented CVD. And this increased our trouble because it became difficult for us to convince our colleague that the right target is not 70, it is 50. We had a very strong basis for that. If you look into the PROVE IT trial, despite achieving LDL cholesterol of 62, there are 22.4% of these patients had events. And we had enough evidence of LDL cholesterol target less than 50 milligram from meta-analysis of 8 statin trials, IMPROVE-IT trial results, Odyssey long-term phase 3, Osler 1 and Osler 2 study, and Amazing trial. Odyssey trial results were published in 2018. It really endorsed what we said in 2016, that when in this trial, since LDL achieved was 53, from 103, there was 15% reduction in primary endpoint. In 2019, European guideline reduced or brought down LDL target in ASCVD from 70 to less than 55. Despite mean LDL cholesterol achieved of 53 in IMPROVE-IT trial, 32.7% the patient had residual risk. And we all know that lower the LDL cholesterol achieved, greater is the risk reduction in the cardiovascular event. And there is a need to reevaluate LDL cholesterol target for patients with known ASCVD and other risk factors. Other risk factor can be 1, 2, or 3 multiple risk factors. So there is a need to reduce LDL cholesterol level to level less than 30 milligram per deciliter, where data shows there is a CV benefit at this level. So we had 19 meetings in 13 cities involving 162 experts over 11 months, and we published 2 documents. And first document was published in March 2020 in Journal of Clinical Hepatology, and second was our expert consensus part 3, which was published in JAPI on 1st November this year. In our recent publication, we have added extreme risk group, and this extreme risk group is further divided into category A and B. Category A is those patients of coronary artery disease with 1 or more features of high risk group, and category B are those patients of coronary artery disease with 1 or more features of very high risk group or recurrent ECS despite LDL cholesterol less than or equal to 50 milligram or polyvascular disease. The LDL goal in extreme risk group category A is less than 50, but optional goal is less than or equal to 30 milligram. And in category B, the goal of LDL cholesterol recommended is less than or equal to 50 milligram. Now, coming to justification of extreme risk group, there are 9 independent clinical indicators of atherothrombotic risk, which is a TIMI risk score. If associated with coronary artery disease, they increases the risk of residual CV events at any level of achieved LDL cholesterol. If we apply this indicator to placebo-treated patients with previous MI, what we see that 3-year base CV event increased as the number of these risk indicator increased from 3.5 without any risk indicator to 58.6 when the risk indicators were more than 7. Now, if we apply these risk indicator to patients with IMPROVE-IT trial, what we see in blue line, what we see in blue line is the events at achieved LDL cholesterol of 70 milligram, and in the red line is the events achieved at the level of LDL cholesterol level of 53 milligram. So what we can see here is that these patients can be grouped into 3 categories: high risk group, intermediate risk group, and low risk group. In high risk group, there are those patients who have 3 or more risk indicators. Intermediate risk group, 2 indicator, and low risk group, no or 1 indicator. What we see here that these patients in high risk group have more events, greater absolute risk reduction, and lower NNT. And intermediate risk group, the events are less, even the absolute risk reduction is less as compared to high risk group, 6.3 versus 2.2, and NNT is 46. And in low risk group, the CV events are very less, and NNT is around 111. So this means that if low risk group, which according to LAI risk algorithm are patients of very high risk group, because these are patients of coronary artery disease, and they have a goal of LDL cholesterol goal of less than 50 milligram. How can we have the same goal in high-risk group of patients, where the events are more, almost 3 to 4 times more events as compared to low-risk group. So what expert decided, that these group of patients should be grouped into extreme risk group B, and the LDL cholesterol target should be less than 30 milligram, because from 50 to 30, there will be definite further reduction in CV events. And intermediate risk group is in between these two groups, and they were grouped into extreme risk group category A with goal less than 50 milligram and option goal less than 30 milligram. When we apply the TIMI score to patients in Fourier trial, we can see this blue bar is with mean LDL cholesterol of 92, and cherry one is with the median LDL cholesterol of 30 milligram. We can see that the higher the group, greater the events. So what we can do, what we did, that we classified these patients again into when we apply this TIMI score to in the patients with Fourier trial, again, we can divide these patients into 3 category: low risk group, intermediate risk group, and high risk group. And what we see here, that high risk group have more events as compared to intermediate. Intermediate has more events as compared to low risk group. And absolute risk reduction in high risk group is 3.6 as compared to intermediate, it is 1.9. And NNT in high risk group is 28. So as we, similar to what we did in IMPROVE-IT trial, we divided these patients also into so if we apply this TIMI score to the patients with Fourier trial, again, we can divide these patients into 3 groups: low risk group, intermediate risk group, and high risk group. We can see here that high risk group patients have more events as compared to intermediate, and intermediate has more as compared to low risk group. And so the patients which are in low risk group, according to LAI, new recommendation falls into very high risk group and LDL cholesterol goal of less than 50 milligram. And those with intermediate risk group, they are grouped into extreme risk group A with goal less than 50, an optional goal of less than 30. And those of high risk group, they are placed into extreme risk group category B with goal of LDL cholesterol less than 30 milligram per deciliter. In Odyssey outcome trial, those patients with 3 vascular bed involvement have more events, greater absolute risk reduction, and NNT of 8. So they are classified as an extreme risk group category B. And 2 vascular bed involvement, they have more events as compared to placebo. They are classified as extreme risk group category A, and single vascular bed means patients with coronary artery disease. They fall into a very high risk group, and with the goals which I've already discussed are for very high risk group and category A and category B. The another method of classifying these patients into categories, very high risk group and category A and B, was based upon 10-year ASFD risk. If it is between 20 to 29%, the patient is classified as a very high risk group. If it is between 30 to 39%, it is extreme risk group category A, and if it is more than 40%, it is extreme risk group category B. And since there are a number of risk indicators and comorbidities, so it will be difficult to decide in which category we have to place this patient. So to simplify it, we recommended that patients of coronary artery disease with 1 or more features of high risk group should be included as an extreme risk group category A, and those patients of coronary artery disease with 1 or more features of very high risk group should be included in category B. And now coming to the justification of LDL cholesterol target less than 30 milligram, we again have a very strong evidence based upon Fourier trial, and In Fourier trial, we have seen that lowering LDL from 93 to 30, there was 15% reduction in primary endpoint and 20% reduction in secondary endpoints. CTT meta-analysis in which baseline LDL cholesterol was less than 70, when there was 40 milligram reduction in LDL cholesterol. This resulted in 37% reduction in MACE. And even in meta-analysis of non-statin trial, reducing LDL cholesterol from 63 to 21, there was 22% reduction in events. And in Fourier trial, those patients whose baseline LDL cholesterol was less than 70, further reduction to 20, there was 30% reduction in cardiovascular event. And in post-hoc analysis of Improver trial, those who achieved LDL cholesterol less than 30 milligram as compared to more than 70, there was 21% reduction in the CV events. And in Odyssey outcome trial, the minimum mortality was seen at LDL level, achieved LDL cholesterol of 31. Below that, it was difficult to decide because of a confidential limit which was widely separated. Even patients with double loss of function mutation of PCSK9, their LDL cholesterol is less than 20 milligram, and they are absolutely healthy, fertile, and intelligent. And in GLABCO trial, in patients of statin with aleucomab, in which median LDL cholesterol was 30 milligram, there was 0.95% decrease in percent atheroma volume. So, so we have now enough evidence that lowering LDL reduction in and very low level of LDL cholesterol is also not, it doesn't cause harm because based upon human genetic studies and Fourier trial in which 2% of the patient had LDL cholesterol less than 10 and meta-analysis of non-statin trial, all these shows that despite having low LDL cholesterol, there are no adverse effect. Now coming to ApoB as a predictor of CVD, we have in our circulation two type of particles. One is atherogenic, which increases, atherosclerosis and increases incidence of coronary artery disease. Carry ApoA, and they remove cholesterol from the peripheral tissue by a process called reverse cholesterol transport. There are clinical studies which shows that ApoB is a better marker for prediction of risk of myocardial infarction. This is based upon Swedish AMORIS study. Over a 10 periods time, a non-HDL cholesterol strategy would prevent 300,000 more events as compared to LDL cholesterol strategy. And ApoB strategy would prevent 500,000 more events than a non-HDL cholesterol strategy. These results further strengthens the value of ApoB in the clinical care. When there are concordance between ApoB and LDL cholesterol, then any of these two can be taken as the target. But when there is a discordance between ApoB and LDL cholesterol, then ApoB should be taken as a target. Like, for example, if you have patient has low LDL cholesterol but high ApoB, then LDL cholesterol should not be a target, ApoB should be the target. This is important, especially in patients with extreme risk group category B and category A, because high ApoB reflects that high residual risk for cardiovascular event. So LAI recommendations 2020 for ApoB is that elevated ApoB is a moderate non-conventional risk factor. A level of more than 110 milligram per deciliter of ApoB correspond to an LDL cholesterol of more than 130 milligram per deciliter. To assess ASCVD risk, it is preferable to estimate serum ApoB in patients with diabetes, metabolic syndrome, for diagnosis of type 3 hyperlipoproteinemia. These are the different values of goal of ApoB at different risk category. For extreme risk group category B, the goal of LDL cholesterol is less than 30, non-HDL is less than 60, and ApoB should be goal is less than 50 milligram, but which is released from the activated leukocyte. There are two perspectives of CRP. It is a biomarker for ASCVD risk assessment and it's a therapeutic target for ASCVD. The incidence 8 milligram per liter in the control arm and 2.46 to 9.3 milligram per liter in patients with established CVD. Now, as a therapeutic target, we know that in CANTOS trial, by giving canakinumab at a dose of 150 milligram every 3 months, there was 15% reduction in primary endpoint. And the primary endpoint was more when, though in those patients with high sensitive CRP was reduced below 2 milligram per liter. And this benefit was independent of lipid level lowering, and canakinumab was associated with higher incidence of fatal infection than that was with placebo. Low-dose methotrexate has been tried for the prevention of atherosclerotic events, but it was stopped prematurely because there was no benefit in cardiovascular event reduction. And it is because it did not reduce level of interleukin-1 beta and interleukin-6 or high-sensitive CRP. Another drug is low-dose colchicine, which has been used in acute MI, and it has been shown to reduce risk of ischemic cardiovascular event as compared to placebo. So, earlier recommendation to 2020 is that is about high-sensitive CRP is that high-sensitive CRP 2 milligram per liter or more is identified as a moderate risk, non-conventional risk factor in the ASCVD risk assessment. In the post-ACS setting, high-sensitive CRP may be useful in identifying patients at high risk for future adverse cardiac events who may warrant more aggressive management of risk factors. For this purpose, high-sensitive CRP reading at least 4 weeks after ACS should be considered. Inflammation as a therapeutic target is being actively pursued. Now coming to lipoproteins little-a. It's a LDL-like particle which is attached to ApoA with a disulfide bond because of its characteristics and similarity to plasminogen. It is pro-thrombogenic, pro-inflammatory, and pro-thrombotic particle, and it has been associated with cardiovascular disease. When top 10 percentile of lipoprotein A is compared with lower 10 percentile, it was found that there was 2 to 3-fold increase in risk of myocardial infarctions and 2 to 3-fold increase in risk of aortic stenosis, and 1.6 to 1.8-fold increase in heart failure, and 1.2 to 1.6-fold increase in ischemic stroke, peripheral artery disease, and mortality in those with top 10 percentile. The only drug available at present is PCSK9, which reduces lipoprotein by 25%. Lipid apheresis reduces it by 35%, and ApoA antisense reduces by 90% by decreasing hepatic ApoA synthesis. And this drug ApoA LRX for a fresh sample, treat other risk factor optimally to counter multiplicative risk of raised lipoprotein small a. Lipoprotein A more than 20 milligram increases ASCVD risk. 20 to 49 milligram is a moderate risk factor, and more than 50 milligram is a high risk feature. We should screen for lipoprotein A at age 18 or earlier if there is a family history of familial hypercholesterolemia or premature coronary artery disease. And if it is not done, then it should be done in patients with premature ASCVD, less than 55 years in men and less than 65 years in women, familial hypercholesterolemia, family history of premature coronary artery disease and or elevated lipoprotein small a, recurrent ASCVD despite optimal lipid lowering therapy, poor response to maximum lipid lowering therapy, ischemic stroke of uncertain etiology, and calcific aortic valve stenosis. Now, coming to highlight of expert consensus 2020, the first three are what we recommended in 2016, impaired fasting glucose, waist circumference, ApoB more than equal to 110, and high sensitive CRP more than or equal to 2 milligram per liter incorporated as a moderate non-conventional risk factor in patients of low risk group. Stratify patients in various risk categories. LDL cholesterol is the primary target, and non-HDL cholesterol is a co-primary target. There is less than 50, and optional goal of LDL is less than equal to 30 milligram, whereas in category B, the goal of LDL cholesterol is less than equal to 30 milligram. These extreme low level of LDL cholesterol can be achieved with newer drugs and should be considered as an option in patients at extreme risk to further reduce ASCVD events. And we should have maximum tolerated dose of statin with or without azitamide, adequate lifestyle intervention and treatment of all modifiable factors must be investigated carefully prior to addition of newer drugs such as PCSK9 inhibitor. Further risk stratification in low and moderate risk group, that is lipoprotein in the range of 20 to 49 milligram per deciliter. High sensitive CRP has modest benefit in reclassifying moderate risk persons in primary prevention. Lifestyle changes is an integral and essential part of the management. Yoga is included in the lifestyle management as an add-on physical activity, and one should practice primordial prevention. Thank you very much for your kind attention.
Thank you, Dr. Puri.
Unmute yourself, Dr. Ashutosh.
Yes, sir.
Unmute yourselves, dear.
Now I invite Dr. O.P. Meena, sir, to introduce our next speaker, Dr. Narsingan, sir.
Yes.
Dr. Narsingam.
Yeah,
yes.
I'm here. Can I proceed?
No,
can I proceed? Can I?
Yes, sir. Yes,
can I share my slides?
May I proceed? You can proceed.
Hello.
Introduce him, sir.
Sir, may I introduce Narsingan, sir?
Yes,
Yeah.
yes, sir. Yes, sir. You can introduce him.
Yes, sir. I'm Dr. O.P. Meena from Udaipur.
Very short introduction will be enough, sir. Yes, sir.
Yes, sir. Yes, sir. Dr. Narsingan, sir, I is proud to introduce him. He is Vice Chancellor, Vice Chairman, Lipid Association of India. He is National President, Indian Society of Hypertension. He was former adjunct professor, the Tamil Nadu Dr. MGR University. He was Managing Director, Dr. SN Diagnostic Center and Chennai. He was Dean, Professor M. Viswanathan, Diabetes Center and MB Hospital for Diabetes. Academically, he has published more than 68 articles in prestigious medical journals. He has contributed a lot to chapters for the textbook of medicine on lipid disorders, atherosclerosis, hypertension, diabetes, and various cardiovascular disorders. He has published expert consensus statement for the lipid management in the year 2016. He has been awarded with Lifetime Achievement Award by Tamil Nadu Dr. MGR Medical University. He has been awarded as a Master Teacher Award by ICP and API India. He has been awarded with Distinguished Teacher Award by Government Stanley Medical College and Hospital. He has been awarded with Dr. Jivaraj Mehta Award in year 2015 by API and Indian College of Physicians. Thank you, sir.
Thank you.
Now may I request him to deliver the talk.
Yeah, kindly allow me to share my screen, please. The host has disabled my screen participation, please.
Yes, sir. Yes, sir.
You can share, sir.
Can you see my slide?
Yes, it is visible, sir.
Yeah. Good afternoon, everyone. At the outset, I would like to thank the organizers of eRAJAPICON in general, and in particular, I would like to thank Dr. Parikh for giving me this excellent opportunity to be with all stalwarts in the field of medicine. My topic is on triglycerides, non-HDL cholesterol, what is new? We know very well that the LDL cholesterol plays a central role in the atherosclerotic process. There are a lot of evidence, not only from observational studies, epidemiological studies, biological information, molecular studies, but the most robust evidence comes from randomized controlled trials which had used statins, which had gone to prove that more the reduction that has been witnessed in primary prevention trials secondary prevention trials, we do get benefit in the form of reduction in atherosclerotic cardiovascular events, not only in morbidity, but also in mortality. So our focus must be on the prevention of ASCVD, and it must be lowering on LDL cholesterol and keeping it low throughout our life. But we need to remember that there are problems which we had seen, which we had witnessed in primary prevention and secondary prevention studies, which had indicated that there is a residual risk ranging from 55 to 70%. One example that I would like to give you is the PROVE-22 trial, which is conducted in people with acute coronary syndrome, has clearly indicated that there is a residual risk in people who had higher levels of triglycerides also. When you look at the pathogenesis of atherosclerosis, the contribution by LDL cholesterol is about 75%. The remaining contribution is mainly by the triglyceride-rich lipoprotein particles. They play a larger role whenever the triglycerides are elevated. Triglycerides are usually carried by the lipoproteins in the bloodstream. All of us know about it. They are all chylomicrons in the VLDL. Their remnants contribute to the blocks in atherosclerosis. Both are atherogenic. The recent data clearly suggests that the VLDL cholesterol or the remnant cholesterol is a stronger promoter of atherosclerosis than LDL cholesterol. Chylomicron remnants and the VLDL remnants rapidly penetrate the arterial wall and promote atherosclerosis. Both chylomicron and VLDL, in fact, promote inflammation. Higher levels of chylomicron are responsible for acute pancreatitis. Chylomicron and VLDL remnants increase inflammation of the endothelium. What I would like to emphasize here is that triglyceride-rich lipoprotein particle increase atherosclerosis, increase inflammation, and increase the lipid content of the arterial blocks. There is a huge epidemiological study which indicated that people in whom you have lesser than 100 milligrams of triglyceride, they have a large buoyant LDL cholesterol, whereas the people in whom the triglyceride levels are more than 200, 250, they have an increased levels of small dense LDL cholesterol of platinum B type. Having seen this, I think this indication has been given to the levels of triglyceride, which are very, very important, which we have incorporated in Part 2 recommendation, as has been depicted in this particular projection by NCP-ATP3. Normal is less than 150, borderline 150 to 199, and moderately elevated is 200 to 499, and very high levels more than 500 milligram. We have been recommending that preferably we need to keep the levels less than 100 milligrams. There's an excellent data to suggest that the triglycerides are linked with the coronary artery disease or the cardiovascular disease. Good article that was published in Lancet in 2014 clearly indicated two important landmark studies. One is a Copenhagen heart study, Copenhagen general population study, which involved more than 96 and 93,000 patients respectively, clearly indicated that 5.1% is hazard ratio for myocardial infarction and 3.2 is hazard ratio for ischemic heart disease in this major trial. Having seen this, I need to tell you that there is also a genetic evidence to talk about the link between triglyceride and cardiovascular disease. More than 75,000 participants with a median follow-up of 34 years clearly indicated those people who had the loss of function mutations in ApoC3, which is responsible for reduction of triglycerides, had resulted in the reduction in the cardiovascular events, particularly those people who had kept the levels between 90 or 95 had shown a benefit of nearly 60% reduction of ischemic heart disease when compared to people whose levels were more than 350 milligram. There are two other studies which again gone to prove that there is a benefit of reducing the triglyceride levels. The DAL outcome study with a long-term follow-up clearly indicated people in whom there is a level of less than 80 milligram of triglyceride shown a reduction in cardiovascular events. All of us know about the miracle trial which was conducted in people with acute coronary syndrome, again indicated those people in whom the triglyceride levels was less than 135 resulted in further reduction of cardiovascular events. One is a long-term short study, other one is a short-term follow-up study. Both indicated that the THRLP, that is the triglyceride-rich lipoprotein particles, may have a causal relationship to the risk of the acute coronary syndrome. This is again another data in the bezafibrate infarction prevention study registry, which indicated a 22-year follow-up, indicating that elevated levels of triglyceride is associated with an increased all-cause mortality in patients with established coronary artery disease to the extent of 68% mortality. Having seen this, I think I should now take you to another level will treating high triglycerides reduce the cardiovascular events? This question begs answers from all of us. There is a data which was got it from the meta-analysis which was published in this journal. We can say that the 5 studies, like taking into consideration a CAR study, field study, PIT study, then the HHS study, WAHI study, clearly indicated that there is a 35% of patients with a high TG more than 204 and less than HDL of 34 milligram has shown a benefit of 35% reduction in the CV events, indicating that the reduction of triglyceride probably is beneficial. Do you have a benefit of using a fenofibrate along with the simvastatin? Yes, there is an answer in the Accordion trial, which had again confirmed the legacy effect of using a fibrate in those patients who received this particular drug. Probably this will benefit those patients with diabetic dyslipidemia. Ongoing study like a pemafibrate usage in this prominent study, 0.2 milligram morning, 0.2 milligram in the evening, given for both males and females of 10,000 patients with diabetes, clearly will indicate whether it's going to be really useful or not by the year 2022. I think many people are using this particular molecule, saraglitazar. No doubt it will reduce the triglyceride, particularly in people with the diabetic dyslipidemia with the predominant hypertriglyceridemia. No doubt it has been recommended. But I need to tell you that there is a cardiovascular outcome data is lacking. The most important information that I would like to share is that the REDUCE-IT trial, which was published recently, clearly indicated using the icosapent ethyl ester in those patients with hypertriglyceridemia in association with the diabetes in people with coronary artery disease in whom LDL cholesterol touched almost the goals of less than 70 milligrams, with the levels of triglyceride between 150 to 500 clearly indicated when compared to the placebo usage of this icosapent ethyl ester resulted in 28% risk reduction in the primary endpoints and 26% risk reduction in the secondary endpoints. It had happened not only in people with hypertriglyceridemia, but also in people in whom the levels were normal, indicating that probably the icosapent ethyl ester has got membrane stabilizing effect or other pleiotropic mechanisms which have been postulated to give the benefit of associated cardiovascular risk reduction. Ladies and gentlemen, this is a recent data published in European Society of Cardiology. There is a wepinorsen, which is an N-acetyl galactosamine conjugated antisense drug to the anti-3 with the messenger RNA, which lowers the triglyceride, lowers atherogenic lipoproteins in patients with diabetes, hepatic steatosis, and hypertriglyceridemia. This one on the left side, which indicates the VLDL cholesterol, the LDL cholesterol, the HDL cholesterol in different proportions, which comes under the label of total cholesterol. The people in whom the levels of triglyceride were about 292 milligrams. Look at the usage of the pepinorsen, which had been injected as a molecule here, which will probably reduce all these levels. You can just see the VLDL comes down by 38%, the LDL comes down by 7%. Surprisingly, the HDL also comes down by 24%. The triglyceride levels actually from 292, it came down to 163 milligrams. Not only that, non-HDL cholesterol came down by 18 milligrams. ANGPTL3 levels came down by 62%. ApoC3 levels came down by 58%. All these are favorable for the reduction of the triglyceride levels, which have resulted in all these parameters which are beneficial. There are also other things which are probably ongoing studies will help us to understand better with the triglyceride will be a molecule which can be targeted by these various studies, MTP inhibitor study, DGAT inhibitor study, lipoprotein lipase gene therapy. Let me now try to take you to the level of non-HDL cholesterol and our understanding. This particular slide will probably tell you the information about non-HDL cholesterol. Remove the HDL cholesterol, which is an anti-atherogenic, concentrate one and the rest of the atherogenic particles starting from LDL, IDL, VLDL, chylomicron remnants, which all have ApoB particles. ApoB48 is seen in chylomicron remnants. These are all considered as non-HDL cholesterol, which also includes lipoprotein nuclei. Very simple calculation, total cholesterol minus HDL cholesterol, you get the value, and that value is the value for non-HDL cholesterol. Is there a link between non-HDL cholesterol and cardiovascular risk? Yes, Lipid Research Clinic Program has identified this as a link, very important link, better than lipoprotein, better than LDL cholesterol. The message is simple. Every increase in the 30 milligram increase in the non-HDL cholesterol probably had resulted more mortality in men as well as in women, 19 and 11% when compared to the mortality figures projected here for LDL cholesterol. Taking all this evidence together, I think back 2001, the JAMA publication really appreciated the recommendation from NCEP ATP3 guidelines, which started talking about our concentration need to be on non-HDL cholesterol whenever you have a problem of hypertriglyceridemia, and that should be concentrated as a secondary goal. I think many of us have totally forgotten about this sort of recommendation and started concentrating only on LDL all the time. Is there a link between the LDL cholesterol and non-HDL cholesterol and cardiovascular risk? Look at the coronary artery disease risk. Hazard ratio is much more in non-HDL cholesterol, even after the adjustment for several risk factors. There's a continuous, uninterrupted increase in the hazard ratio for coronary artery disease when compared to triglycerides. There is an increase in the hazard ratio for coronary artery disease risk when compared to the LDL cholesterol as it is projected here. Yeah. This is one important meta-analysis which I thought I should share. There are about 8 trials which have been included in this meta-analysis, very important, starting from 4S study to the Jupiter study, which involved more than 62,000 patients. One standard deviation actually reduced the risk of events about 13% for LDL. One standard deviation for ApoB is for about 14%. One standard deviation increase in non-HDL increases by 16%. So the information is very clear, ladies and gentlemen who are watching this particular program. The strength of association with the cardiovascular disease is greater for non-HDL than for LDL or for ApoB. The same analysis again predicted this important data, particularly people who had reached the levels of LDL cholesterol with the statin therapy less than 100 milligram, the second one, but still their non-HDL cholesterol is more than 130 milligram, clearly indicated hazard ratio is about 1.32, indicating 32% increase in the risk when compared to the other group in whom the LDL cholesterol is still high, but the non-HDL cholesterol has been already achieved. So the message is very clear. Among statin-treated patients, non-HDL cholesterol is associated with increased risk of future cardiovascular events, even if LDL cholesterol is under control. There is again another publication published in the American Journal of Cardiology. Non-HDL cholesterol outperforms ApoB in the prediction of cardiovascular disease. This is a meta-analysis, huge one. 131,000 patients were recruited for this study. The risk hazard ratio, as far as the LDL, as for the non-HDL is concerned, every level of reduction of LDL cholesterol is hazard ratio. You can appreciate that the hazard ratio for non-HDL cholesterol is all the time high when compared to the LDL cholesterol in every parameter. Is there a link between non-HDL cholesterol and the diabetic subjects with the diabetic dyslipidemia? Yes. We also had published data from our center, and it was published in Indian Heart Journal, and I was also part of the study saying that non-HDL cholesterol was the commonest abnormality, and about 21.6% among patients who had statin therapy. What is the role for non-fasting levels of lipid profile? Yes, testing in any patient for assessment of severe risk, patients who are admitted to the ACS, in children, when they are preferred by the patient, in diabetic patients, in elderly patients, patients who are on stable drugs. In fact, Denmark is the one country which started practicing it right from 2009. Blood sampling becomes easy, and it has been used in many clinical trials also. And triglyceride levels go up only about 26 milligrams or so in the postprandial period. Most of the time, it is clinically unimportant. Very higher levels of postprandial hypertriglyceridemia are linked with the recurrence of events in people with acute coronary syndrome, following which these people need to be treated aggressively. It also predicts the cardiovascular risk. I think we need to accept that most of our people are eating almost 24 hours a day. I think probably you need to advise non-fasting lipid profile. Then what is the role for fasting lipid profile? Yes, there is a definite role. If TG levels of more than 400, do it. People are coming for follow-up of hypertension, in lipid clinic for hypertension treatment with the pancreatitis, yes, good. You would like to have some other parameters like fasting blood sugar or drug levels, do it. We came out with this recommendation in the year 2020 on November 1st, Part 3 recommendation, where we have recommended like this. If somebody enters into a clinic, do the fasting lipid profile or a non-fasting lipid profile, whatever it may be. Repeat it in the second visit, which will definitely be useful for us to proceed further in lipid lowering, particularly on LDL as well as postprandial hypertriglyceridemia. The recommendation as far as the triglycerides are concerned, as far as the Lipid Association of India's recommendation is concerned, divided into two groups. One group 150 to 199 and 200 to 499. Always advise therapeutic lifestyle changes. Very, very important. That itself will bring down the triglyceride levels to the extent of 50%. Concentrate on the control of diabetes. Rule out all secondary causes of hypertriglyceridemia before you embark on treatment of hypertriglyceridemia. The first one 150 to 159 or 200, 499. Try to concentrate on LDL. Try to concentrate on the increased levels of non-HDL cholesterol and identify the ASCVD risk 3 parameters and treat the patient with a statin plus or minus ezetimibe, then go for other drugs like omega-3 fatty acid. If the levels are between 599, the risk of getting pancreatitis is high and with ASCVD. But however, you need to treat this patient to start with the fibrate, omega-3 fatty acid, statin plus or minus ezetimibe, and then look at the parameters. If it is more than 10,000 milligrams of triglyceride, I think pancreatitis is a very big problem which needs to be controlled only with the fibrates or omega-3 fatty acids. As far as the non-HDL cholesterol is concerned, our aim is to tell you that total cholesterol minus HDL cholesterol gives you the figure, and that is the value for non-HDL. It is a co-primary target, measuring the non-HDL cholesterol. Very simple, practical. You and me can do it simply by just calculating it. What is the goal? 30 milligram more than that of the LDL goal, and that should be within the 30 milligram. Statin remained the first line of management. Add ezetimibe, and probably you need to think about using the icosapent ester, which was used and reduced your trend up to the extent of 4 grams per day. Probably would reduce the associated cardiovascular events in those people with non-HDL cholesterol. Ladies and gentlemen, this is the last leg of my talk. Triglyceride-rich lipoprotein particles. Look at this particular projection, which you will identify. Chylomicron, VLDL, IDL, up to this is considered as a triglyceride-rich lipoprotein particles. If you include LDL, it comes as ApoB particle or non-HDL. Remove the LDL, remove the HDL, remove the lipoprotein delay. You concentrate on mainly these 3 parameters. One is chylomicron, VLDL, IDL. The triglyceride component is high. As you go down, you probably get an increase in the triglyceride component is going down and the cholesterol component is increasing. This is a good picture which tells you chylomicron remnants, the VLDL particles, VLDL remnants, and IDL are the ones that are considered as triglyceride lipoprotein particles. How to calculate? Very simple. Total cholesterol minus HDL cholesterol minus LDL cholesterol. That figure is a VLDL cholesterol, which is considered as a triglyceride-rich lipoprotein particles. Recently, about 2 weeks back, there's a good publication, that 2020, which had concentrated on the Copenhagen general population study, which had come out saying that VLDL cholesterol accounts for 1/2 of the risk of myocardial infarction associated with ApoB-containing particles. In fact, this is very important data. Again, the PREDMED study, which was conducted in people with the primary prevention strategy, remnant cholesterol, not LDL cholesterol, is associated with incident cardiovascular disease. Very important information which got published again in JACC in 2020, about 2 weeks back. So, ladies and gentlemen, we should not forget about the role of the drug which is available in our country, PCSK9 inhibitor. It not only reduces the levels, which is unimaginably lowest levels of LDL, but you need to think that they also produce levels of reduction of VLDL, remnant particles, LDL particles, number, non-HDL cholesterol, lipoprotein delay. I think we should probably appreciate this particular molecule's efficacy and an important advance in the discipline of management. My last slide to tell you the take-home message for my talk is that there is a substantial evidence that triglyceride lipoprotein particle may play a positive role in atherosclerosis and coronary artery disease, number 1. Triglyceride levels remain a significant predictor of residual risk. 2. 3. Focusing on non-HDL cholesterol simplifies the management of triglycerides also. Thank you very much, ladies and gentlemen, for patient listening.
Thank you, sir. Thank you very much, Dr. Narasimhan. Thank you, sir. Thank you very much for giving informative, educative talk on the lipid management. Thank you, sir.
Thank you, Dr. Narasimhan, sir.
Ashutosh,
yes, sir.
Now we will have a panel discussion.
Yes, sir. Yes, sir.
With Dr. Prabhakar, Dr. Anger, Dr. Narasimhan, and Dr. Ramanpuri. So, introduce Dr. Prabhakar and Dr.
I
Anger.
request Dr. Mayank Srivastav, sir, to kindly introduce Dr. Prabhakar, sir.
Dr. Srivastav, are you here?
He can do away with
Are you present, sir?
panel discussion.
We can start the discussion, sir. We can do
Okay, sir. We can start the discussion.
They are from our association. I will just say,
Dr. Prabhakar is there. Dr. Angar sir is there.
Dr. Prabhakar sir, I welcome you. He is interventional cardiologist at Chennai. And
Dr. Ashutosh will go ahead with the discussion.
Okay, sir. Okay, sir. No issues.
I think we should have read it.
I also welcome Dr. Iyengar sir and Dr. Mehta
So
sir.
let's have a discussion.
Yeah, let me start saying that we had two very important talks.
Dr. Mehta is here. Dr. Prabhakar is here. Dr. Angar is here. Dr. Narsingham is here. And Dr. Puri, if he is here, he will also join discussion in 15 minutes. So since Dr. Angar, can you start, sir?
Yeah.
I request you to kindly start.
Yeah, thank you, sir. We had
Angar, sir.
We had two very important talks by two eminent speakers. Dr. Puri, who told us about the latest recommendations by LAI 2020, has emphasized that LAI has created a new risk category, the extreme risk category, where the risk of recurrent events is very high, so we need to have a very low LDL cholesterol goal. He has emphasized and explained why we should attain a goal of LDL of 30 milligram less in this extremely high risk category. And he also told us that we have included FOB and CRP in our so-called risk enhancers or additional agents or as risk markers. As a link between his talk and Dr. Narsingham's talk, the non-HDL cholesterol and FOB,
Hello, am I?
They are markers of triglyceride-rich lipoproteins. And Dr. Narsinghan has told us clearly how to deal with hypertriglyceridemia.
Sir, I think we had very good lectures on targets. I wanted to highlight one or two simple points. Primary prevention is equally important. We've been talking a lot about targets in secondary prevention. I think we should definitely focus on primary prevention and remember that the screening that LAI recommends to start at 18 years of age is very important because cholesterol lowering does not start at 40. It's a cumulative load of cholesterol and we should start early and start bringing down the cholesterol. And LDL cholesterol has to be brought down to 100 because ethnically we are more prone for coronary artery disease and we should significantly bring down the LDL cholesterol as much as possible. Now, apart from all this, there are a lot of myths and facts about the statin side effects and intolerance, which I think has been allayed. I think that we'll take a separate lecture, but I think all of us should go overboard and understand that the recent study, the N-to-1 study has clearly showed that 90% of the side effects associated with the statin-associated muscle effects are actually produced by placebo. Even placebos produce the same. It's all psychological. So I think we should take the initiative and start treating our patients more aggressively with statins. I have a comment about Dr. Narsingham's talk also. He quoted a very recent article talking about the non-HDL cholesterol important. Actually, there is a separate article within the same issue which actually says it is the cholesterol content of the VLDL particles which is more important than the triglyceride content of the non-HDL VLDL molecule. This is done through MR spectroscopy, and they clearly showed that the cholesterol in the residual cholesterol or the remnant cholesterol is very, very important. And when the LDL cholesterol comes less than 100, actually the remnant cholesterol and the non-HDL cholesterol seem to be much more important than the total cholesterol itself. So I think we should all remember that non-HDL cholesterol is a poor man's apolipoprotein B, and it can be very easily used in clinical practice.
Dr. Narsinghan should say a word about diabetic dyslipidemia because most of the Western guidelines recommend use of statins only after the age of 40, diabetic with additional risk factors. But I don't think so. That is the correct way of looking at diabetic dyslipidemia.
Yeah, the diabetic dyslipidemia is more prevalent in our country, number one. Atherogenic dyslipidemia characterized by high triglycerides, low HDL, increased proportion of small dense LDL cholesterol with the increased FOB particles are the problems which are encountered in people with diabetes. We need to remember that these people who are given the label as diabetic today, probably you need to think that they had spent nearly about 5 to 10 years of their life with the so-called mild hyperglycemia or a pre-diabetic stage. We can see people with obesity or metabolic syndrome having a problem of impaired fasting glucose. The impaired fasting glucose has been recognized as one important parameter which pushes these patients for an increased cardiovascular risk before the development of diabetes. And not only that, even impaired glucose tolerance. We had witnessed many people having impaired fasting glucose and impaired glucose tolerance getting into problems of ASCVD, high risk mortality. If that is a scenario witnessed by all of us, when the patient is seeking advice with the label as diabetic, I think we need to realize the burden that he had been holding on for a number of years probably will result in quick events of atherosclerotic cardiovascular disease early as possible. I think one has to be very careful in handling such patients. I think our recommendation as far as the Lipid Association of India is concerned, that every patient with diabetes, irrespective of the age, should receive statin. That's number one. Number two, for type 1 diabetic patients, also should receive the same type of treatment as you give it for patients with type 2 diabetes with dyslipidemia, in case the patient is also having the same atherosclerotic cardiovascular risk faced by this type 2 diabetic patient. These are the recommendations, what we have been doing it. Yeah.
Thank you. Dr. Raman there? Raman, are you there? Yeah, any other comments from the...
Sir, the diabetics, we should remember, there is nothing like a low-risk diabetic. All diabetics start with moderate risk till you have any other risk factor. And nearly 75% of the diabetics have a low HDL cholesterol, which the ICMR INDIAB had clearly shown. Clearly, all the diabetics will fall into a high-risk category. And I think that is the main justification why we are saying. We are not saying just because of these data. It's clearly shown that diabetics have at least one other risk factors. Either it's going to be age or most of them have a low HDL cholesterol like in our place. And that has to be clearly borne in mind, and putting them on a statin. We have clearly also shown that statins are more beneficial than the aspirin. So I think instead of starting an aspirin, probably look at a statin, and everybody should be on a very low LDL cholesterol. And it is not lower the better today. Today we have clearly understood that lowest LDL is the best. It's not lower the LDL. And very low levels, even less than 10 has been proven in the Fourier trial to be very safe. Even the neurocognitive function has not shown any decline. So I think we can safely bring down LDL cholesterol. In my clinical practice, I bring down patients to 20s, 30s, and if they're all right, just leave them. Don't reduce the dose of statin. Give them the maximum tolerated dose of statins. I think that is a very important message that we have to go for.
Have you seen a patient of low LDL to the extent of 10, Dr. Prabhakar? You said we can, even we are happy if we can bring it to 10. So below 30, have you seen any patient having LDL at 10?
No, sir. I am not a very big user of PCSK9 inhibitor. Those less than 10s come only with PCSK9 inhibition. In those patients where it's about 70, you do a PCSK9 inhibitor, it comes down to 10. So if it comes down to less than 70, see, bringing it down to 50 is a challenge in clinical practice, but it is very much achievable if you use a 40 milligrams of rosuvastatin along with an ezetimibe. I use 40 milligrams of rosuvastatin and the tolerance is excellent. There is absolutely no problem. It's all in our mind. And most of the statin-associated muscle side effects usually happen within the first 3 months. What patient says after 6 months and 12 months are not statin-associated muscle side effects. It's all what we perceive. It's really not there. So I think safely it can. My practice 20s to 30s is very, 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 very much seen. And nothing happens. They're all very stable, and no problem at all.
Yeah, one thing to be kept in mind is these PCSK9 trials. Very low level of LDL cholesterol, even single digits, have been safe, but that is for a short duration. We don't have the very long-term data. Keep that in mind. Secondly, the physiological level that has been described for LDL cholesterol is 25 milligram, 25 to 30. So if you are up to 25 to 30 milligram, I think one should not be worried about bringing down LDL cholesterol. In fact, the Odyssey study was if somebody's LDL cholesterol is less than 15 on 2 occasions, they de-escalated their lipid-lowering therapy. So we have to have some of our own judgment and manage these patients, bring it down. As Prabhakar said, lower is better. There's also earlier the better. Earlier you start, better it is, and longer the better. Means long-term statin therapy must be continued.
As far as physicians are concerned, the biggest, let's say, bottleneck is reduction of the LDL cholesterol, reduction of the statin dose. So when a patient comes to them with an 80 milligrams of atorvastatin or a 40 milligrams of rosuvastatin, what they tend to do is you have taken it for 1 year. Beyond that, it is not going to be beneficial. Try to reduce. It's a very high dose. I think that concept has to be broken clearly and said that you give them a high intensity statin, they tolerate it. They have crossed the 3 months, nothing is going to happen. You have to bring it down. And there have been clear data that discontinuation of statins increases the event rate subsequently. Not only with the MACE events for patients who have been medically managed, in a person who has had a PCI, if you discontinue the statins or reduce the dose of statins, even for that matter, it is going to be problematic. In fact, there is one Korean study which has shown that among patients who are having an LDL cholesterol of less than 70, those who get high intensity statin and who are not getting high intensity statins, those who are getting high intensity statin, the same level of cholesterol, the event rate is much less. So it is very, very important to continue the high intensity statin, not the dose of statin. High intensity statin clearly has to be continued. Dr. Goel, you're muted, sir.
Unmute
Dr.
yourself,
Pawan
sir.
Mehta, are you there? Dr. Pawan Mehta?
Yes, sir.
Another panelist of our panel. No.
Yes, sir.
Yes, Dr. Pawan Mehta.
Yes,
you
sir.
Want to say something, please?
No, sir. I think it's fine, sir.
Goel wants to say something.
Yes.
Dr. Goel, sir.
Hello.
Yes.
Preparing for the next session.
Preparing for the next session.
So if anything, so the message is that now at the college entering age, we must get a person to be known about the cholesterol level, lipid profile level. He should get his lipid profile level at the college entry age.
Yes, sir. I think.
Sir, I would like to add one more point. Our lipid, can you permit me, sir? Iyengar, sir?
We have recommended the age of 18 is not only cholesterol, it should be a global risk assessment, starting with his height, weight, BMI, sugar, blood pressure, and cholesterol. And nothing.
Sir, I think many of us had totally forgotten about the familial hypercholesterolemia. In fact, the Lipid Association of India has started a familial hypercholesterolemia registry. Already we have got about 55 cases of homozygous familial hypercholesterolemia. I am requesting all the stalwarts or in the field of medicine to look for the cases of homozygous familial hypercholesterolemia with the tendon xanthoma, with the children with the problems of tendon xanthoma, with the coronary artery disease, or with aortic valve stenosis. You need to probably bring them to the records. Very important. I'm requesting you to feed the cases to our registry so that we will be in a position to advise them properly.
So can we conclude our panel discussion now? If there is something to say, Dr. Iyengar, sir?
No, sir. You could conclude.
You want to give any message to the clinicians?
Message is, I think, as we all try to emphasize, primordial prevention is of utmost importance, followed by primary prevention and then secondary prevention. And therapeutic lifestyle changes is an essential and integral part of the management. Thank you.
Thank you very much, Dr. Yes, sir.
Thank you so much, all the
Dr. Narsingam.
Thank you.
And Dr. Prabhakar and Dr. Mehta. Thank you very much for your very good participation in the panel discussion, and we'll be able to, you will be able to give message to the clinicians about the lipid. What should they should keep their lipid profile. Thank you so much, sir.
Thank you.
On behalf of eRAJAPICON 2020, I once again thank all the esteemed chairpersons and speakers for the lipid session. Now I invite Dr. Anil Samaria, sir, to quickly proceed for his talk, which was left. Dr. Samaria, sir, please proceed.
Dr. Anil Samaria, you have put your slides, but you are not there. You are not audible, sir. So I think Ashutosh, start yes, next one.
Okay, sir.
Please start next session.
So we conclude this session, and now I hand over the mic to Dr. Pradyuman Sharma, sir, for the next session.
afternoon. This is Dr. Pradyum Sharma to be with you. And it's my sincere gratitude to Dr. Parik Saab, Dr. Girish Mathur to be moderating post 1 o'clock session and pre-lunch session. And we may have a pre-lunch also. As been observed, we are running rather little late. The sessions are being curtailed to rescheduled to 15 minutes. And for this session, which is endocrine update, we have eminent chairpersons as Dr. R.K. Goyal from Ajmer, Dr. K.C. Jain from Udaipur, and Dr. Madhu Bakshi. I may have a little small brief introduction to our chairpersons. Dr. Madhu Bakshi from R&D Medical College, and he has a Kayakalp Award and National Level Quality Assurance Certificate, FICP 2013, and he is a consultant at Chittor Birla Hospital. Dr. R.K. Goyal, he is a senior professor at Ajmer, ex-senior professor, and he had organized eRAJAPICON 1997-2006. He is a visiting professor, Medical University Hills, UAE, and he has more than 90 publications with Lifetime Achievement Awards. And Dr. K.C. Jain from Udaipur, head speaker at the various international and national and state level conferences. So the session is over to you, and my sincere request to the chairperson is the session has been rescheduled for 15 minutes, and we will be having the first, as a Dr. D.C. Sharma, there's a rescheduled program, and Dr. Akhil Joshi will be next. I may request Ajay, kindly, let's have a Dr. D.C. Sharma first, please, because certain engagements are there. So, Dr. Chair, over to the chairperson, sir.
Hello. Can you hear me, sir?
Yes,
hello.
Sir.
Yes, sir. Yes, sir.
I am Dr. K.C. Jain, and as has been very judiciously introduced by the host, it's a great privilege for me to chair this session where Dr. D.C. Sharma is supposed to be speaking on the interpretation of thyroid function test. Dr. D.C. Sharma is an DM from All India Institute of Medical Sciences, an MD from R&D Medical College, Udaipur, and MBBS from the same institute. He has a numerous international and national publications, a recipient of the coveted Dr. Naresh Bu Oration by Rajasthan RSSDDI in 2017, Lifetime Achievement Award by Diabetes Welfare Society, Jaipur, and Lifetime Achievement Award by Knowledge Forum 2019. He is past position he held was professor and head at the clinical unit of endocrinology in R&D Medical College, Udaipur, and present position is a senior consultant and director of the Institute of Endocrine Diseases in Udaipur. He is a very popular endocrinologist. He has attended numerous scientific conferences. As you will agree, thyroid function tests are performed ubiquitously nowadays. Dr. Sharma will throw an insight in interpretation of practical use of numerology of the thyroid function test. You will agree that there are only few branches in medicine which require the interpretation of lab test in the complete clinical profile, as is the disease of the thyroid. Dr. Sharma will also seek to throw some light as to the increasing incidence of thyroid diseases in our country, whether it is because of more clinical investigation or there is some reason why more thyroid diseases are being found out. Well, I'll not stand much between you and Dr. D.C. Sharma. I'll request Dr. D.C. Sharma to speak on the interpretation of thyroid function test. Dr. D.C. Sharma, thank you.
Sir, unmute yourself, sir.
Okay. So can you hear me? Hello? Am I audible?
Yes, sir.
Okay. Good afternoon, everyone. Thank you, Professor K.C. Jain, sir, for the kind introduction, and the respected chairpersons, Professor Goyal, sir, Dr. Jain, sir, and Dr. Madhu Bakshi, all senior and stalwarts in medicine. At the outset, I would like to express my sincere thanks to the organizers, Dr. Parik, sir, Dr. Girish Mathur, sir, and the whole team for inviting me to this prestigious conference, which is going on very well. and this opportunity. Thank you once again. As introduced by Professor Jain sir, that thyroid dysfunctions are increasing in prevalence. There are several reasons for this, and not only the thyroid disorders are on increase, but the awareness of the thyroid diseases and the easy availability of the thyroid function test is another reason for early diagnosis and many thyroid function tests being ordered. And when we come across thyroid function reports, usually we try to correlate with the clinical picture. And while interpreting with thyroid function test, there are two situations which puts us in difficult situation. Number one, when you are not getting reports which matches with your clinical impression. Second situation, the thyroid function test, the T3, T4, TSH, they are discordant amongst themselves. So your T3 is high, but T4 is normal, TSH is normal, and likewise. So while we come across such unusual thyroid function tests, we have to follow a pattern, and we call them funny thyroid function test or difficult thyroid function test or weird thyroid function test. So in next 14 minutes or so, I'll try to give you an overview how to approach to such unusual or the abnormal thyroid function test. But before that, let me recapitulate the normal physiological regulation of thyroid function. It's a very tightly regulated thyroid hormone mechanism that the TRH released from pituitary, from hypothalamus, regulates pituitary, and pituitary in turn secretes TSH and regulates thyroid hormone. Thyroid hormone in turn negatively regulate or inhibit the secretion of TSH and TRH from pituitary. And there is a second-to-second regulation, very tightly regulated synthesis of thyroid hormone, such that small amount of change in thyroid hormone leads to decreased release or shutting down of the excess. So it's a very tightly regulated system. Now, commonly when we ask for the thyroid function test, we usually ask for the TSH, only TSH being a screening tool. Why TSH? There is rationale for this, because the TSH and thyroid hormone concentration exhibits an inverse log linear relationship. Small changes in FT4 produces amplified changes in TSH. So small changes you can see in the FT4 level would lead to large changes in TSH, such that every 2 to 3-fold decrease in FT4 causes 100-fold change in TSH, which is easily understandable or easily you can make out. So the changes of changes in the thyroid function test and changes in thyroid function test are easily made out when you go for the TSH first approach. But there are situations when TSH alone may not be sufficient, and it might lead to, it might mislead you. For example, TSH when done alone, you can miss the central hypothyroidism, because TSH would be normal or TSH would be slightly on the lower side. So central hypothyroidism could be missed. In conditions of non-thyroid illnesses, TSH may be abnormal, it may be low. While the patient is on drug treatment for thyrotoxicosis, TSH might remain suppressed for a long period, and you may not really come to know the thyroid status of an individual. In the conditions of rare conditions, genetic conditions like thyroid hormone resistance, and even rare condition, TSH secreting pituitary adenoma, TSH alone may be misleading. So you have to keep in mind in which patients you order full T3, T4 TSH, and in majority of the patient, TSH alone may be a good, sort of a screening test. So when you order for TSH, there is a algorithm to diagnose hyper and hypothyroidism. When TSH is normal and clinically patient is euthyroid, you can be reassured that your patient is normal. If the TSH is high and thyroid hormone is low, you are dealing with hypothyroidism. But if TSH is high and T4 is normal, you may be dealing with subclinical hypothyroidism. On the other way around, if TSH is low and T4 is high, you are dealing with hyperthyroidism. Normal T4 with suppressed TSH, you are dealing with subclinical hyperthyroidism. So various patterns of thyroid function test you come across. For example, as I mentioned, if TSH is low and T3, T4 is high, you are dealing with hyperthyroidism. There are several conditions of hyperthyroidism as well as thyrotoxicosis. Exogenous administration, TSH secreting adenoma, multinodular goiter with increased TSH secretion, Graves' hyperthyroidism, and likewise. If TSH is high, T3, T4 low, you are dealing with hypothyroidism. And there are several causes: autoimmune hypothyroidism, iodine deficiency, drugs, irradiation, post-surgery, thyroiditis, congenital, and likewise. Similarly, low TSH with normal T3, T4, you are dealing with subclinical hypothyroidism. High T4, high TSH, normal thyroid function, you are dealing with subclinical hyperthyroidism. And even the rare conditions. So, when your thyroid function test report is not as per your expectation, there are several steps where the things would go wrong. For example, there are several variables which are there with the patient. And for example, physiological changes, age-related changes in thyroid function test, pregnancy-related thyroid function test, patient who is already receiving thyroxine hormone therapy. There are confounding medications which can interfere with the thyroid functioning, and systemic illnesses which can alter the thyroid function test. There are some factors which can be inherent to laboratory, like some assay interferences, antibody which might be interfering with thyroid function test, or post-laboratory. You may not be, I'm sorry, but the individual who is seeing the reports may not be sufficiently experienced to interpret the thyroid function test. And there are rare genetic abnormalities and rare clinical condition which you have to keep in mind. So to understand these abnormalities, I'll present few cases, and I start with a case: 61-year-old male admitted in ICU, normal height and weight, type 2 diabetic. We're presenting admitted in ICU with acute myocardial infarction. It is third day of his being in ICU. TSH and T3 were done for some reason or so. So TSH you see is low, T4 is low, T3, T4 low. So what is your diagnosis? Are we dealing a patient with central hypothyroidism, both TSH low and T4 low? No. Because while a patient is in hospital, patient is seriously sick, we have to understand that thyroid function test can change, and you should keep in mind that there is a condition known as sick euthyroid syndrome. It is influenced by the severity of illness rather than etiology of illness. So during acute illnesses, there are changes in the thyroid metabolism such that T3, T4 level goes down and RT3 levels may be raised. And I'll not go in detail of this complex diagram, but say that in hospital or patient when seriously ill would lead to low T4, low T3. The first abnormality is in T3. So T3 goes low, T4 goes low, even free hormone also goes low, and TSH may be low or slightly suppressed. So while in hospital, seriously ill patient, you might wrongly diagnose central hypothyroidism. So it's a relatively common situation while the patient is admitted for acute or chronic illness, and even without any intrinsic abnormality of thyroid disease, you might get results which are suggestive of something else. And the dictum is avoid testing thyroid function test unless there is a strong suspicion of thyroid disorder. So one should not order for the thyroid function test in a seriously ill patient. The previously available thyroid function test might be helpful. Follow-up of these patients is necessary, and thyroid hormone replacement is not required, even though the report might tell you central hypothyroidism also. So you should rely on the clinical acumen rather than read these reports in acutely sick patient. Then the second situation, there are several assay interferences. The assays are performed by different methods. I'll not go in detail, but there could be interferences in the assay method, and this might lead to wrong results. Here is a patient, again a case, 63-year-old lady, referred to endocrinologist for abnormal thyroid function test. T4 elevated, FT3 elevated, TSH low. So you might read this result as hyperthyroidism, high thyroid hormone levels, low TSH. When patient was clinically euthyroid. So when detailed medication history was taken, patient was receiving 300 milligram of biotin per day. And 6 months before, the thyroid function tests were normal. So what is known is Biotin, which is commonly used these days in multiple, vitamin B complex and immunity booster, and this is one of the biotin frequently used by dermatologists and cosmetologists for hair growth, interferes with thyroid hormone test as well as B12 estimation. So B12 estimation of these patients showed very high B12 and abnormal thyroid function test. So biotin can interfere with thyroid hormone function in many ways. I'll not go in details. There are several interferences in thyroid function test: the macro TSH interference, biotin, anti-streptavidin antibodies, several other antibodies, heterophil antibodies, TSH auto antibodies. So whenever you are in doubt, rather than taking further steps, one should revise whether any interference is there, because in one of the series, 37% patients were given thyroid hormone prescription which was not required. Good number of patients underwent further testing, clinical evaluation, scans, anti-thyroid drugs, and likewise. And here is a graph showing that biotin within few hours of injection would lead to high T3/4 and increase in the thyroglobulin levels. In this patient, biotin was stopped for 24 hours and repeat TFT and B12 levels were done. They were normal. Few months later, biotin was again challenged. Patient was given biotin and the same reports were obtained. Another case. So third situation, 24-year-old lady with Hashimoto's disease. She had wide fluctuations in her TSH levels. Sometimes low, sometimes high TSH, sometimes 50, sometimes 10, sometimes 0.5, and likewise. In this patient, based on the TSH levels, fluctuating TSH levels, the clinician was frequently changing, increasing, decreasing thyroid hormone levels, thyroid doses. What was found was this patient has HAMA, human anti-mouse antibody, which were very high, and we should be aware about such antibodies. One of them is heterophil antibodies, which interfere with the estimation. And whenever you come across, you ask the lab to look at the antibody and repeat the test with some other method, other laboratory, or there are ways and methods to diagnose such antibody levels and proper interpretation. Another common situation is several drugs which we use in a patient which can alter the thyroid function test. The common drugs are lithium, which contains a lot of lithium, which decreases thyroid hormone release. Amiodarone, which is rich in iodine, can lead to wide changes in the thyroid function test, hyperthyroidism, hypothyroidism, autoimmunity, and likewise. SSRIs are commonly used drugs for depression. They increase TSH levels. Estrogen, very frequently used by hormone specialists, by gynecologists, and other situations as contraceptive. They increase TBG, thyroxine binding globulin. As a result, thyroid hormone levels T3, T4, even T3, T4 are raised, but the free fraction remains high. Similarly, androgen and corticosteroids also alter the thyroxine binding globulin, and they might lead to change in the thyroid function test. So a case, 35-year-old lady admitted to neuro ICU for status epilepticus. Her thyroid function tests were carried out on some suspicion on thyroid function, thyroid abnormality, and what was found, T3, T4 were reduced and TSH was normal. So in a patient who is in hospital for status epilepticus, abnormal thyroid function test, further evaluation revealed that this patient was receiving carbamazepine. Carbamazepine is an anti-epileptic drug and is known to accelerate hepatic clearance, and T3, T4 levels would be low. So the dictum in this patient, one should not start thyroxine hormone. Wait, carbamazepine was changed over to some other drug, or FT4 done, clinically euthyroid patient, no hurry to put the patient on therapy. So this table gives an idea of number of drugs, lithium, iodine, which could produce hypothyroidism, picture of thyroid function test of hyperthyroidism, reduced T4 to T3 conversion, can lead to low TSH, high TSH, increased clearance, displacing thyroxine from binding globulin, and likewise. So one should understand the drugs, and you take a full history of patient who is receiving multiple drugs, and then only interpret. Another case, pregnant lady, 12 weeks of pregnancy, presenting to gynecologist for nausea, vomiting, and slight weight loss. And her pulse rate was 98. So in view of the clinical suspicion of hyperthyroidism, TFT carried out. Here, T3 is 2.2, the upper limit is 2, T4 is 13.7, the upper limit is around 13.5 to 7, and TSH was 0.52, within just lower range of the normal. So what is the diagnosis? Is she suffering from subclinical hyperthyroidism or hyperthyroidism? No. This is pregnancy-related changes in the thyroid function test. And pregnancy causes several changes in the thyroid functioning, thyroid physiology. T3 and T4 are increased in pregnancy up to a range of 1.5. So increase in T3, T4 up to 1.5 times the normal is considered to be normal. There are trimester-specific changes. For example, in the first trimester, TSH goes low, T3, T4 goes high. In the second trimester, it is stabilized to some extent. And so we should be aware about these changes. Another case, last case, 69-year-old lady followed up serially for a thyroid longitudinal study. Her TSH 5.4, FT4 high, FT3 is high. So her T3, T4 levels are high and TSH is normal. What you are dealing with? Are you dealing with a rare condition of a TSH secretory pituitary tumor or a rare genetic condition or thyroid hormone resistance? Why I'm presenting this case is to show that these cases do exist. We do come across patients of pituitary TSH secretory tumor and rare case of thyroid hormone resistance. So whenever you are in doubt, there is a proper system to evaluate. You go for evaluation of alpha subunits of TSH and ratio. Go for MRI and raised SHBG, sex hormone binding globulin, would suggest you TSH secretory pituitary tumor, or genetic testing, family history of abnormal thyroid function test would give you a clue regarding rare resistance to thyroid hormone syndrome. So resistance to thyroid hormone syndrome is a rare genetic condition with goiter palpitation patient presenting with slight hyperthyroidism in children, behavioral abnormalities, developmental problem, and likewise. I'll not go in detail, but would summarize saying that whenever you come across discordant thyroid function test, you're not able to match your thyroid results with the clinical picture, reevaluate clinical history. Maybe there are physiological changes like age, pregnancy changes, thyroid hormone therapy, confounding medications, or associated systemic illness might be responsible for these changes. And reassess patient thyroid status if a patient is really hypothyroid and your report fits in, and likewise. Decide which thyroid function test is most likely discoordinate, because you can explain rise in T3 and T4 because of thyroxine binding globulin in pregnancy, and likewise. Exclude the thyroid hormone interferences by the antibodies, by the drugs, and likewise. And rare things do exist, but they are rare. Think of rare conditions like pituitary tumor or genetic conditions, and likewise. So most of the time, I would say the reports are correct, but you need a proper interpretation. And in difficult situation, while you keep in mind these conditions which can interfere with the thyroid function testing, you may reach to the correct diagnosis. Thank you very much. I have tried to summarize and give you an overview of the abnormal thyroid function test. The time did not permit me to allow and elaborate on all the points. Thank you very much.
Thank you, Dr. DC Sharma. Am I audible?
Yes, sir.
We can have Dr. Akhil Joshi, sir. Next.
Okay.
Dr. Akhil Joshi.
I'll stop sharing, sir. Yeah.
Hello. Am I audible?
Yes,
hello. Sir. Hello.
Yes, Dr. Goyal Sahab, you are audible.
Sir, you are audible.
Yes, Dr. Akhil Joshi, he did his MBBS and MD from SMS Medical College and DM Endocrinology from SGPGI, Lucknow. He is now presently attached to Sudha Hospital at Kota. He has got a membership of Endocrine Society of India. He is a member of API, member of RSSDI, and has got multiple publications, many publications in diabetes and bone metabolism. So I invite Akhil Joshi, who shall be talking about the very common topic, vitamin D and diabetes mellitus. Of course, in the plenty of sunlight still, we see many of the patients, even without diabetes, also having vitamin D deficiency. whether it is a casual relationship or a definite relationship with deficiency of vitamin D in patients with diabetes, I invite Dr. Akhil to tell his observations. Dr. Akhil?
Yes, sir.
Yes, Dr. Akhil, you can start your, you can continue, yes.
Good afternoon, everybody. First of all, I'd like to thank organizer and chairperson to provide me the opportunity to speak on a common endocrine topic, that is regarding vitamin D and diabetes. So after a few slides, we'll be coming to the conclusion whether it's a casual or a causal relationship. So let's see what the data we do have today. If we look at the history of vitamin D, it's almost for more than 100 years. When a scientist named McCullum, he coined the term fat-soluble accessory food factor. So he was relating this factor with vitamin disease, which is going to prevent it, that is called rickets. And subsequently, in 1928, Adolf Winterhaus, he was awarded Nobel Prize for isolation and the role of steroids for a molecule which is going to prevent rickets, and then he subsequently identified this molecule as vitamin D. Now, with this background, many guidelines have come up, and the guidelines have started since 1960s. Work has been done over the vitamin D receptors, and now what do we have? Multiple guidelines available with us, which are saying regarding the various doses of vitamin D, which are emphasizing the role, the relationship with vitamin D. So in fact, the vitamin D is not required just by a children or by an adolescent. The role of vitamin D, it starts from the womb. There is a role for it. And in fact, we know till the elderly population, the various roles of vitamin D. It's just not for the bones and the muscles, but for the various organ systems which are involved with vitamin D mechanism. So in fact, the various studies have shown that vitamin D deficiency is rampant in India. Almost the various studies reports a prevalence of around 70 to 100%. And in fact, the recent data, even in the preschool and the school-going children, a good proportion of our children, they are suffering from vitamin D deficiency. This is a global overview, and India lies in a zone which is vitamin D deficient. If we look at the prevalence of vitamin D deficiency in India, so whether we take children less than 5 years of age or elderly, pregnant, female, urban or the rural population, the deficiency is rampant, and the figure shows almost 60 to 95% or almost 100% of the population is vitamin D deficient in the various studies. So the problem is huge. And in fact, as the chairman highlighted, that we are living in a country which is having plenty of sunshine. And in fact, we are having vitamin D deficiency in spite of this plenty sunshine. The problem in our country is not just vitamin D deficiency, but it's associated with low calcium intake, and that makes the problem more. So coming with this background, vitamin D is pandemic, and in fact, the problem of diabetes is increasing. So there is a relation between the two, and it has been highlighted with various studies. This slide shows basically that we are going to synthesize vitamin with an ultraviolet B wavelength of 290 to 315 nanometer. And the time period in which the sun plays a role, it's something like 10 to 2 p.m. Otherwise, the exposure is not going to synthesize much of vitamin D. And not only the various infectious disease, but it has been related to various autoimmune disorders to infections. Now coming to our topic, that is regarding the role of vitamin D in diabetes. Vitamin D, as we know, it's both a hormone and a vitamin, and its receptors, they have been found in the pancreas. So what the vitamin D receptors are doing in the pancreas, basically, there have been studies which have shown that they are having some relationship with insulin synthesis, having some role with insulin secretion, having some role with insulin resistance maintenance. There have been studies which have shown that vitamin D deficiency predisposes individuals to both type 1 and type 2 diabetes. That means autoimmune phenomena has been also related to vitamin D deficiency. And in fact, when we are optimizing the individual with normal vitamin D and calcium, we are having benefit effect in terms of glucose metabolisms. So coming to the first part, that is role of diabetes and insulin secretion. What is the effect? So if we look at the animal models, there have been studies which have shown that vitamin D deficiency, it impairs the glucose-mediated insulin secretions. There have been various studies on the red pancreatic beta cells for it. And these preclinical studies probably laid down the base to examine or to learn the role of vitamin D in human beings. And we have looked that even in human beings, it is increasing the insulin release. It is improving the insulin sensitivity. The increase in the insulin release due to vitamin D is calcium dependent. And in fact, the calcium insufficiency, which is associated with vitamin D in certain population, it really results in decreased release of insulin. How the insulin sensitivity is getting improved? It's because the vitamin D is inducing the surface expression of GLUT4 receptors. And in fact, when we are improving the vitamin D level in the blood, the data has shown that there is improvement in insulin sensitivity up to the tune of around 50 to 60%. The several pathways have been postulated by which vitamin D improves the insulin secretion. It's one of the mechanisms is increasing of the intracellular calcium. Maybe the role of vitamin D is on increasing the protein biosynthesis in the islets. And in fact, certain other direct action of vitamin D on beta cells of pancreas has been postulated as the mechanism which is increasing the insulin secretion. So if we look at this diagram, how the vitamin D is helping in insulin secretion, the receptors have been found on the pancreatic islets. There is 1-alpha hydroxylase which is present in the pancreatic cells. So that is converting 25-hydroxy-D to 1,25-dihydroxy-D. And that binds to the vitamin D response elements. And that leads to synthesis of insulin gene. So we have the receptors, we have the machinery to form 1,25-dihydroxy-D in the pancreatic cells. And then that is also improving the insulin gene formation. So these are certain facts which shows that vitamin D is improving the insulin secretions. Not only that, there is an increase in the calbindin, which is a calcium binding protein in the pancreatic beta cells. And this calcium is required for the secretion of the insulin granules. Moreover, the role of 1,25-dihydroxy-D is over the various cytokines and the various inflammatory markers, and that decreases the apoptosis. So that in all, the 1,25-hydroxy-D is improving the insulin secretions. Not only that, this vitamin D is also improving the insulin action. There is formation of insulin receptors, which goes on the surface of the, say, adipose tissue and the muscles, and that helps in decreasing the insulin resistance, helps the insulin in getting its work done. The various other mechanisms like the effects on the RAS pathways, effects on the various cytokines, which is going to decrease the apoptosis, are also postulated to improve the vitamin D action. So with this background, there have been some studies in human beings. In fact, it has shown that vitamin D, it improves the insulin resistance. The patients who are already on metformin, there have been some small trials in which vitamin D have been supplemented for, say, like 30 days, and that lead to improvement of 21% increase in insulin sensitivity over the metformin. So these are certain data which shows that vitamin D is doing some trick in our diabetic patients. The vitamin D receptors, they have been found on beta cells, the various vitamin D binding proteins like the calbindin's presence in the pancreatic cells, also builds up this issue that vitamin D is definitely important for insulin release, definitely important for insulin to act at the various target organs. So what we were taught some few years back that vitamin D is required for bones, for muscles. Now we are moving ahead with about this bones and muscle phenomena. It's probably having effects on all the target organs, and we know that we are having a good control of sugar, in which the vitamin D have been supplied to our diabetic individuals by increase of insulin secretion as well as insulin sensitivity. So now coming to the pre-diabetic stage, we have seen the animal model. Now we look at the another part, that is a pre-diabetic stage. This is a meta-analysis in which the patients who were at high risk to develop diabetes, like the overweight and the obesity patients, and in this various trials, the vitamin D was supplied to these high-risk individuals. And what we got from that there is a significant effect of vitamin D on HbA1c. Overall, the meta-analysis show favorable effects in pre-diabetic patients. Now come to a second stage, that the patient has been found to develop diabetes, and then he or she is on some treatment, maybe on oral hypoglycemic agents or insulin, and then vitamin D is supplied. So this is the effect of 1 month vitamin D in 1000 international unit per day in subjects with type 2 diabetes. What we can appreciate that in this individuals, there is improvement in insulin secretion, and the insulin resistance gets declined when vitamin D is supplied. It's on top of the medication, the baseline medication these individuals are taking. So role in pre-diabetic, role in diabetic patients with vitamin D. Not only that, a baseline serum 25-hydroxy D vitamin, it has been looked as a predictor of future risk of glycemic control or risk of becoming diabetic. It's very well highlighted in this diagram that the lower the vitamin D, and if we look at the future risk, the more the chances of getting high fasting sugar or 2-hour post-meal sugar. So we can interpret that data that vitamin D deficiency probably leads to increase in chances of hyperglycemia with the passage of time. Vitamin D, it enhances the glycemic control as add-on therapy. So this is a study which was done for 3 months. The number was less, like 52. And the idea is to again emphasize that it's not only preventing the onset of diabetes, but it's getting the HbA1c under control. So in this particular study, there was decrease of HbA1c up to the tune of around 0.7%. So add-on therapy in type 2 diabetic patients, it's causing a decrease in HbA1c. Now coming to the another part, the insulin resistance, looking at the adiponectin levels. In this particular study, the first degree relatives of type 2 diabetic patients, they were studied. So that means a high-risk population was taken into consideration, and then they were supplied vitamin D in 50,000 international unit weekly, or the another control group, it was just the placebo. So the idea was that when they were looked at after vitamin D supplementation, the insulin resistance, it got declined after the vitamin D has been supplied or has been used as an intervention procedure in these high-risk individuals. So although no much effect over the adiponectin levels, but definitely the insulin resistance is getting declined after the vitamin D has been given to high-risk population. The various kind of diabetes, like the gestational diabetes mellitus, it has been looked at the chances of getting gestational diabetes mellitus is more in the patients who are having vitamin D deficiency. And when we give vitamin D to these pregnant females, there is decrease in the fasting glucose level. So even in the subgroup of diabetes, the gestation diabetes, vitamin D has been linked. And not only to the gestation diabetes, the data is with preeclampsia, for preterm birth, for small for gestational age, and the miscarriage chance. So giving vitamin D or monitoring vitamin D in pregnancy do have a role. Most of our diabetic patients, they die because of the cardiovascular disorders. It's a leading cause of mortality. In fact, the supplementation with vitamin D, it has been shown that it decreases the chance of cardiovascular disorder, even in type 2 diabetic patients. So this shows that increasing the vitamin D levels, it decreases the relative risk of the cardiovascular disorder. So this meta-analysis gives a magic figure of 30 nanogram per ml, above which the chances or the risk of dying because of the cardiovascular death is more. The survival benefits, bears more in the patients who are having vitamin D in a normal range or in the higher range. So these kind of relationship, it has again proved that cardiovascular disorders can be prevented or minimized or can be decreased with proper vitamin D supplementation. So what we have seen that there is a role of vitamin D in decreasing the insulin resistance, the role in the pre-diabetics, we are not getting converted to the diabetes or the chances are getting declined. Glycemic control is getting better after we are giving vitamin D to high-risk individuals. In fact, I have not shown the data, but the data is for prevention of neuropathy, nephropathy, and albuminuria. So the complications are getting declined. We are getting CV benefits from vitamin D. The survival is improving, and definitely the role has been seen in the gestational diabetes mellitus and preventing the various complications. So if we look on all these evidence, probably the vitamin D is having a causal relationship in the onset of diabetes or in the management of diabetes or for the prevention of the various complications associated with diabetes. We know that diabetes is sort of like increasing, vitamin D deficiency is pandemic. So giving our patient with a cheap, safe alternative, easily available vitamin D, probably we are going to prevent the various complications associated with diabetes and will have a better HbA1c control with vitamin D supplementation. Thank you. Thank you.
Dr. Akhil,
yeah.
You very well told about the relationship. Vitamin D is associated with many problems. I have one or two questions. Is it a direct sunlight exposure or suppose sitting in drawing room with glass panels and wire meshes, vitamin D shall be there?
Sir, for vitamin D,
direct sunlight, the best time of course is the 10 a.m. to 12 o'clock in the morning.
First of all, the ultraviolet rays which are required, it's something like 290 to 315. So first of all, the waves length to be in this proper range, and then second thing is the skin exposure. So probably these two things will come into the role. So somebody who's sitting in the drawing room having a sunlight, so we don't know what kind of exposure he's going to have with the sunlight, and probably the clothes which are covering the skin will come into action.
Because exposure to direct sunlight is not because of social stigma. Nobody goes to Goa for taking sunlight.
Definitely, your point is well taken. That's why the fortification of food is becoming important. And in fact, giving vitamin D to all sort of our patients, I mean, it's becoming very common. In fact, I'll suggest that rather than monitoring the vitamin D, getting the vitamin D test done, we should make it a habit to add on vitamin D supplementation in our all, not only just a diabetic patient, but all routine individuals.
Can we invite the next speaker? Thank you very much, Dr. Joshi, for a wonderful presentation of vitamin D. Introduce Dr. Prakash Keshwani.
Good afternoon. I am Madhu Bakshi from Chittorgarh. It is my privilege to introduce Dr. Prakash Keshwani. He is MD, he is DM Endocrinology, he is DNB, he is MNMS and FICP. He is presently Professor of Medicine and Endocrinology at SMS Medical College, Jaipur. Besides this, he is teaching faculty of Medicine and Endocrinology at various institutes of India and abroad. He is the executive member of an examiner of TM in many universities. He is executive member of Endocrine Society of India. He is secretary, Endocrine Society of Rajasthan. He is joint secretary of RSCD Rajasthan. He is secretary endocrine of APH chapter India. Many times we classically diagnose the cases of hypothyroidism, but still we miss many cases because we don't know the many unusual presentation. So Dr. Keshwani, over to Dr. Keshwani, will talk on hypothyroidism still missed and with unusual presentation. Thank you.
Thank you, chairpersons, for your kind words. Respected chairpersons, senior colleagues, and dear friends, a very good afternoon to all of you. At the outset, I shall like to congratulate the organizing committee of eRAJAPICON for giving me this opportunity to be with you all in this afternoon. I am thankful to them for this inviting me to be with you all. In this part of today's session, we shall be discussing certain important aspects about the hypothyroidism. Hypothyroidism, we all know that, is a commonly diagnosed endocrine disorder and usually presents with lethargy, weakness, cold intolerance, puffiness of face, hands, feet, hoarseness of voice, dry skin, constipation, and so on. And most of the time, these are easily recognized and diagnosed. Sometimes these patients present with unusual symptoms and the diagnosis is not apparent. In such atypical presentations, we may get misled by these presentations and we think of some other diagnosis. And these are later on diagnosed with the biochemical investigations with the thyroid function test and starting treatment with the thyroxine therapy. We get good results also. So as a physician, we must be aware of these unusual presentations of hypothyroidism and should consider hypothyroidism in such atypical cases in our day-to-day practice. Here we'll be discussing certain important presentations which are not usual and occur because of the hypothyroidism. A 7-year-old female child brought by her mother in the OPD for vaginal bleeding for 2 days. Mother has also noticed the breast enlargement of the baby for last 3 months. On examination, height was 111 centimeter, weight was 23.1 kg. It was close to that of the age of 6 years. Thelarchy was present up to the stage of the tenor 3, but these were suggestive of precocious puberty, but there were no pubic or axillary hair were there. As examined by a female resident, vaginal mucosa was estrogenized. She was started being worked up on the line of the precocious puberty. Her estrogen was 65, FSH was 7, LH was 1.3, prolactin was highly raised. On sonography, there were multiple ovarian cysts with the increased size of the ovaries. Uterus was also pubertal. TSH was markedly found to be elevated with low T3 and T4. MRI cranium was ordered to evaluate for the precocious puberty and it showed blown up sella with enlarged pituitary. Depending on these, enlarged pituitary, increased TSH, low T3, T4, and high estrogen levels with multiple ovarian cysts, a diagnosis of Van Wyck-Grumbuck syndrome was considered. Child was started with the thyroxine therapy. After this, she did not have any episode of bleeding, and after 6 months, all symptoms are reversed and cysts were also absent on sonography. So there's a good association of hypothyroidism with the human reproductive system. As early as 1960, Van Wyck-Grumbuck found association of juvenile females with the long-standing hypothyroidism developing isosexual precocious pseudopuberty and multicystic ovaries. It was found to be a case because of the hypothyroidism. We will not be going in detail of this because of time constraint, but on physical examination, these patients have typical hypothyroid appearance. What happens in a true precocious puberty? These children have accelerated growth, but precocious puberty, because of the hypothyroidism, is associated with the delayed growth. Precocious uterine bleeding occurs in these patients also because of the estrogen production. Precocious thelarchy is also there, but there is absence of pubic and axillary hair. On imaging, ovaries are enlarged with multiple cysts. Uterus is enlarged because of estrogen. But bone age, which is usually accelerated in precocious puberty, is delayed in precocious puberty because of hypothyroidism. They have enlarged pituitary. They have increased TSH with low T3, T4 and increased estradiol. Without going into the detail of the pathophysiological mechanisms, we can easily understand that thyroid gland, which secretes T3, T4, in hypothyroidism, these gets reduced because of the negative feedback mechanism. There is stimulation of hypothalamus secreting a large amount of the TRH, which on pituitary acting increase the TSH and prolactin secretion, while low T3, T4 also acting on the pituitary causes increased TSH. This excess of the TSH has a spillover effect on the FSH receptors on the ovary, leads to the development of follicular cysts, increased estrogen secretion, menstruation, and breast development. While prolactin also helps in this process by sensitizing ovary to the FSH. So we can see that excess of the TSH in primary hypothyroidism can present as precocious puberty, and as we should consider it as an important cause of precocious puberty because it's totally reversible. Another interesting case, a 29-year-old female was presented in emergency after a suicidal attempt. She was having a history of decreased ability to concentrate, anxiety, insomnia, auditory hallucination, fatigue, and tiredness. On examination also, there was clear evidence of the depression, and patient was admitted in the psychiatric ward with diagnosis of major depressive disorder with psychotic features and treated with haloperidol and paroxetine. Biochemical investigation was remarkable except that of the TSH, which was found to be increased with the low T3, T4. She was started treating with the levothyroxine. Clinically, symptoms improved in around 10 days of period and was advised to continue same treatment. During the follow-up visit, she was advised to reduce the paroxetine as she was having good results with the thyroxine supplementation, and she continued to do well with her medication with the thyroxine and was comfortable up to 1 year of follow-up, and she was stopped with the antidepressant drugs. Another female, 46-year-old female, presented with altered behavior. She was anxious, had delusions and hallucinations, and was crying in between, and had history of irrelevant talks also. Previously, there was no history of psychiatric illness. On examination, there were few features which are suggestive of the hypothyroidism. Laboratory investigations were unremarkable except that of the thyroid disorders. TSH was elevated with low T3, T4. Treatment was started with the thyroxine, and she also had improvement with the thyroxine therapy in the form that she stopped crying, had no longer hallucination and delusions. Diagnosis of myxedema madness was considered in this patient. Haloperidol, which was started, was discontinued later on. 2 months later, patient returned to the OPD without any recurrence of psychotic symptoms. She was advised to continue thyroxine therapy. 4 months after this, she again came with the recurrence of auditory and visual hallucination. She had discontinued levothyroxine this time for 2 months. TSH was 120. She was again started with thyroxine and she improved. What does it suggest? Suggests that hypothyroidism in this particular patient used to cause the psychotic symptoms. Hypothyroidism has been found to be associated with various psychiatric disorders. As early as 1888, hypothyroidism was found to be result in mental disturbances. As early as 1947, myxedema madness was described in the patients who had long-standing hypothyroidism and presented with crying, hyperactivity, insomnia, irritability, anger, and auditory and visual hallucinations. So these psychiatric disorders are not the new ones, are recognized for a very long time, which occurs in the patients of the hypothyroidism, and unless we do not keep in these disorders in mind, many of the times we can miss the disorder. We can start treating patients purely on the psychiatric diseases basis. Another interesting patient, 36-year-old female, admitted in our ward during night from emergency with generalized swelling and weakness. On examination, patient was drowsy with hoarseness of voice, anasarca, and pale conjunctiva. During night only, emergency lab investigations were sent, and hemoglobin was found to be low. Creatinine was 2.4 with the low albumin, with slightly reduced sodium. Next day morning, we made the provisional diagnosis of the renal failure, and we started treating patient with the low-dose diuretics with other supportive measures. By evening, we had regular laboratory investigation, which confirmed the previous findings of low hemoglobin and increased creatinine. But at the same time, we also observed increase of the TSH with the low T3, T4. Sonographic examination revealed normal kidneys and corticomedullary differentiation was maintained, which doesn't show any evidence about the renal failure. So diagnosis of primary hypothyroidism was considered in these patients. We started treating patient with the thyroxine, and in response to thyroxine, she had good diuresis. Changes in level of consciousness and edema started improving from the next day. Even after 5 days, her swelling was reduced to quite some extent. Her creatinine came down to 1.8. Consciousness also improved. After around 1 month of therapy with the thyroxine, creatinine came down to the normal with normal T3, T4. This suggests that uncontrolled prolonged hypothyroidism can have decreased renal functions and can present these patients as renal failure. Hypothyroidism has been found to have reduced renal plasma flow and decreased GFR by the range of 25 to 30%. A number of other factors also help in promoting this altered renal functions. As time is not permitting, we will not be discussing in detail. In another good study in which first time overtly diagnosed hypothyroid patients were evaluated for the renal function, creatinine clearance was found to be low in these newly diagnosed overt hypothyroid patients. They have also increased of the creatinine level, which was more than normal in around 54% of the patients. And after treating these patients with thyroxine for 2 months, creatinine clearance was found to be increased and creatinine was also found to be reduced. This suggests that these overt hypothyroid for a longer period may present with the increased creatinine, for which we should not worry, and we should start treating thyroxine. It has also been observed the patient with the CRF, hypothyroidism results in deterioration of the renal function, which improves with the thyroxine therapy. So we should always keep in mind when a new patient of renal failure comes to us, we should go for the thyroid function test. Another interesting patient, 45-year female, presented with a fatigue, lethargy, weakness, and breathlessness. She had periorbital puffiness along with pitting edema of the feet and hands. There was congestion in the lungs. These were suggestive of the failure. BP was on the lower side, GVP was raised, and apical impulse was absent. X-ray chest showed that there was a increased cardiac size along with haziness in the lower lung fields. Echocardiography clearly suggests there was accumulation of fluid in the pericardial cavity. A diagnosis of pericardial effusion was made. Laboratory investigation suggests that increase of the cholesterol with low hemoglobin and clear-cut picture of the primary hypothyroidism with increased TSH and T3-4. And she was started with the thyroxine therapy, initially with the low doses, 50 micrograms, and while keeping a watch on the cardiac function, the dose was increased to 125 micrograms. She improved symptomatically. After 2 months of treatment, she was re-evaluated. T3, T4, TSH were normal, and pericardial effusion to a large extent was also disappeared. These were the X-ray of the patient before starting therapy with the pericardial effusion and after 2 months of therapy with the thyroxine. Fluid accumulation is commonly seen in the hypothyroid patients. Effusion can be seen in the pericardial, pleural, and peritoneal spaces in hypothyroidism and less commonly in joint and middle ear. Pericardial effusions are usually small, but large effusion can be seen in prolonged severe hypothyroidism. We would like to go for another interesting case. 62-year-old hypertensive man came with a complaint of weakness of both lower limbs. He was feeling unsteady on his feet, was losing his balance, and was no longer able to walk without assistance. He also gives a history of hoarseness of voice and constipation. There was no history of drugs or alcohol. There was on examination, hoarseness of voice was there, skin was dry. On CNS examination, power was normal in all the 4 limbs. Speech was dysarthric. Various signs of the cerebellar ataxia were positive: finger nose test, dysdiadochokinesia, heel shin test, and Rombach test. Gait was impaired, tandem walking was there. Deep tendon reflexes, which usually are pendular in the cerebellar ataxia, there was delayed relaxation of the deep tendon reflexes. A provisional diagnosis of cerebellar ataxia was made. On biochemical evaluation, CBC, renal function, liver function were normal. CT head was normal, but TSH was increased with low T3, T4. We started treating patients with the levothyroxine. After a few days, he appeared much more comfortable. He was discharged and was advised for rehabilitation for a temporary basis. And after 3 months on follow-up, he was able to walk normally. There was no evidence of incoordination, and T3, T4, TSH came out to the normal. Hypothyroidism can also lead to a number of neurological disorders. Mononeuropathy we commonly see as a carpal tunnel syndrome. Polyneuropathy, cranial nerve involvement of the 2nd, 5th, 7th, and 8th nerve. Generalized peripheral neuropathy is also an unusual presentation, but it can occur. Cerebral ataxia, as observed in our case, is another unusual presentation that may be associated with the hypothyroidism. Clinical Society of London, as early as 1888, described gait unsteadiness in patients of hypothyroidism. These patients may have various findings of the ataxia at the time of the diagnosis. In addition to cerebral disorder, other neurological disorders may be seen with the hypothyroidism include myopathy, pseudomyotonia, muscle hypertrophy, peripheral neuropathy, cranial nerve abnormality, carpal tunnel syndrome, and seizures. And most of these patients eventually recover by using thyroxine therapy. So these unusual patients, we can have miraculous effects with the thyroxine therapy, and we should not forget these patients. Another important patient, 50-year-old male, presented with abdominal distension, pain abdomen, not passing stool for last 3 days. On sonography, there was abdominal distension with the test.
We have tested more than 17 minutes.
Okay, so this patient was presented with the abdominal distension and poor bowel sounds. He was diagnosed with a case of hypothyroidism and paralytic ileus. Another important case which I will like to go for is a young boy of 8 years presented with short stature. Chronological age was 8 years, height age was less than 5, and bone age was further reduced. And on investigation found to a primary hypothyroidism. She was started with thyroxine and had a good catch-up growth. Hypothyroidism is also important for the normal skeletal development. Hypothyroidism can lead to poor bone growth and mineralization, decreased bone age, epiphyseal genesis. So we see that hypothyroidism not typically presents with the weight gain, lethargy, weakness, but sometimes unusual presentation can occur, and we should be watchful for these symptoms. And if we are able to diagnose these unusual presentation, it will help these patients a lot. In the last, I will like to thank you all for the patient listening. Thank you, Dr.
Thank you, Dr. Keshwani. A beautiful illustration in the presence of thyroxine hormone, and rightly placed, has so many relevance. So my sincere thanks to the chairperson. And now, as we are already running with the late in time, so we are proceeding to the next session. That's the diabetes update. So thanks to all chairpersons proceeding to the diabetes update. And we are just 15 minutes late enough to start. And this time I request to the chairperson, Dr. Ashutosh Chaturvedi. He is a consultant physician and diabetologist, and he has many awards. And he's been placed at Mahatma Gandhi Hospital Center, and he has a number of the original papers, case reports, pictorial CMEs published in journal JAPI and various national and international journals, and he has been the Jaipur Epicon Gold Medal Award also, Best Postgraduate Resident. Beautiful, sir. And the second chairperson, Dr. B.L. Chobasia, he is MD in Medicine, FICP, FISC. So I request our chairpersons to kindly take over the chairs, and we see that the session should not pull on more than 15 minutes, and we should have the etiquettes of the e-conference. Over to the chairperson.
Thank you so much, sir, for your warm introduction. So I would like to introduce our first speaker, none other than Dr. B.M. Makkar, sir. He is a reputed, renowned figure in the field of diabetes across the country and is a popular honorary secretary of RSSDI from 2017 to 2019. He is a fellow of ICE, Royal College of Physicians, Indian College of Physicians, and a senior diabetes and bariatric physician and director of Dr. Makkar Diabetes and Obesity Center at New Delhi. His areas of interest are diabetes, obesity, and metabolic syndrome. He has widely traveled and has keen interest in the field of education. He's a certified diabetes trainer, and we can't forget his Indian course director for Cleveland Clinic certificate course, which is attended regularly by a lot of delegates. He had been regional faculty for PHFI, CCDM and CCGDM courses in India. He has been awarded with awards and orations, including Professor KL Wing Oration, KRSSDI Oration, and UPD Oration. Dr. Makkar is a member by special invitation to American Diabetes Association and ESD, ESO, and Canadian Obesity Association. So over to you, Dr. B.M. Makkar, sir. I heartily welcome you to deliver your talk.
Thank you, chairpersons, for those kind words. Am I audible?
Yes, sir, you are audible.
Sir. You're audible. I will just share my screen. So, is my screen fine now?
Yes, sir. Yes. Very nice.
Good afternoon, everyone. At the outset, I would like to thank the organizing committee of eRAJAPICON for this great opportunity, and I am really pleased to see so many of our seniors and friends on the dais. I have been allocated the topic of remission of type 2 diabetes, and I was told it is 20 minutes, but I just heard that we have to rush it a little faster, so I'll try my level best to do it. I don't have any disclosures for this presentation. So in this presentation, I'll briefly touch upon the definition of remission. What is the link between obesity and type 2 diabetes? How does obesity lead to insulin resistance and beta cell dysfunction both? And how does acute caloric restriction lead to diabetes reversal or remission? So in this presentation, I'm using the term reversal and remission interchangeably, and I think I wanted to clarify this right at the outset. So how do we define remission? So ADA, gave definitions of remission in 2009. Partial remission of diabetes is defined as hyperglycemia below the diagnostic thresholds of diabetes. That means this includes pre-diabetes at least 1 year's duration with no pharmacological therapy or ongoing procedures. Complete remission is defined as normal glycemic measures. That means the cutoffs are below pre-diabetes at least 1 year of duration with no active pharmacological therapy or ongoing procedures. And the partial prolonged remission is defined as the same lasting for more than 5 years. Now let's look at the link between obesity and type 2 diabetes. Now we have enough data to show that almost 90% of type 2 diabetes patients have a BMI more than 23 kilograms per meter square, which is the cutoff definition for overweight in India. And obesity accounts for almost 3/4 of patients of type 2 diabetes. This is, data from National Health Surveys from US and shows increasing prevalence of obesity over 15 years across North America in different states. And if you look carefully, this is paralleled by increase in the prevalence of type 2 diabetes across these states. And the similar data has been, shown by the population studies from Australia that wherever there is increase in obesity prevalence, there is increase in prevalence of diabetes. We have data from ICMR INDAB study, and this showed a very high prevalence of type 2 diabetes in Punjab, Tamil Nadu, Sikkim, Delhi, and Chandigarh. What is interesting to note is these are the states which have highest prevalence of obesity also, and even higher prevalence of central obesity. So there is an established relationship between obesity and type 2 diabetes, especially with central obesity. And a number of studies have shown that obesity increases the risk of developing type 2 diabetes. Not only that, there is an increase in, wherever there is increase in BMI over a population, it predicts a change, or you can foresee a increase in prevalence of diabetes. So there is a parallel increase in prevalence of diabetes wherever there is increasing prevalence of obesity. And we know that type 2 diabetes is caused by two hallmark features, the insulin resistance and compromised beta cell function. And UKPDS clearly showed that there is a progressive loss of beta cell function and progressive decline in insulin secretion irrespective of the treatment strategies used to treat diabetes, and this results in progressive failure of therapies, whatever therapies we are using, and with time you have to intensify therapy to control glucose level, insulin resistance and beta cell dysfunction. Now, we have something called unified field theory, which proposes that there is a possibility that both obesity and type 2 diabetes share a common underlying defect. And the defects which favor progressive weight gain also lead to metabolic impairment, which contribute to beta cell decompensation. The potential link is that there is a sustained cell exposure to excess nutrient concentrations, which lead to damaging cellular effects of nutrient excess, leading to impaired inflammatory signaling, increased endoplasmic reticular stress, mitochondrial dysfunction, accumulation of triglycerides, and activation of kinases, which start the vicious cycle of ongoing damage. So in this slide, basically what you see is that surplus energy or increase in fat leads to increased free fatty acid turnover, which get deposited in not only in the adipose tissue, but from adipose tissue there is increased turnover of free fatty acids and increased consumption of calories, which contribute to increased fat deposits in ectopic sites, including liver and pancreas. So once there is increased deposition of fat in liver and pancreas, there is decrease in the response to insulin, which leads to increase in glucose level. So there is increased level of lipids and glucose, leading to glucolipotoxicity, resulting in hyperglycemia, which further worsens the cycle. So obesity-induced metabolic impairment can favor development of insulin resistance on one hand and progressive beta cell dysfunction on other hand. And the reduced insulin secretion further worsens the cycle by increasing hyperglycemia, thereby leading to more and more, glucolipotoxicity. So in this way, there is obesity-induced nutrient excess triggers inflammatory response, causing insulin resistance, putting a greater demand for insulin on beta cells. Beta cell function declines further because of the fat deposition in pancreas, and this further worsens the whole process. Now, not every individual with obesity will develop hyperglycemia. So there has to be underlying abnormality in beta cell, which must coexist with nutrient access to lead to type 2 diabetes. Now, if this hypothesis is correct, then caloric restriction should be able to reverse the core defects, that is insulin resistance and beta cell dysfunction of diabetes. Now, let us see what is the data supporting this. Now, if we look at the natural history, we regard type 2 diabetes as a progressive disease which cannot be cured because there is a progressive deterioration of glucose control resulting from progressive decline of insulin secretion, and we consider the disease is only treatable but not curable. And if you try to see the pathophysiology, there is a clear-cut phase of pre-diabetes before the onset of clinical diabetes, where interventions have shown that we can prevent onset of type 2 diabetes. And there are a number of studies which have looked at interventions for prevention of diabetes. Now, important thing here is that all these studies have shown that even modest weight loss can lead to dramatic reduction in the risk of diabetes development. The first hint for diabetes, that type 2 diabetes is possibly fully reversible syndrome, came from bariatric surgery, which was almost 30 years back, when it was shown that after bariatric surgery, the blood sugar levels normalized and remained normal in almost 90% of the patients for 10 years after bariatric surgery also. So normalization of blood glucose in type 2 diabetes, which occurred within days after bariatric surgery, even before the substantial weight loss was there. And this occurred almost within a week and normalized by 4 weeks. So this led to a widespread belief that surgery itself brought some specific changes which were mediated by incretin hormone secretion, which led to normalization of glucose. But this reasoning also overlooked the major change that followed bariatric surgery. That was an acute, profound decrease in the caloric intake. Now, acute massive reduction in the caloric intake, which occurs after bariatric surgery, actually leads to a sudden reversal of traffic of fat in the fat stores, which is a major change and leads to intracellular decrease in the intracellular concentration of fat metabolites. And if you look at the metabolism in the hypocaloric condition, the fat is metabolized first from the ectopic deposits rather than from the subcutaneous tissue or the visceral fat. Now, if this hypothesis is correct, and if the rapid changes in metabolism following bariatric surgery are consequence of a sudden change in caloric intake or caloric balance, then defects of type 2 diabetes, both which is insulin secretion and insulin resistance, should be correctable by change in diet alone. And this was the basis of counterpoint study, which aimed to see whether both beta cell failure and insulin resistance can be reversed by dietary restriction. Involved only 11 patients, but beautiful study, proof of concept, studied before and after 1, 4, and 8 weeks of a only 600 kilocalorie diet given to these 11 patients. All patients were given very low calorie diets for 2 months, and they were studied for beta cell function, liver and muscle insulin sensitivity, and liver and muscle pancreas fat at a 0 day, after 1 week, 4 weeks, and 8 weeks. Now, the interesting thing was there was a weight loss which was significant within 1 week. It was 3.9 kg, and this progressively increased to almost 15 kg, which was equal to 15% body weight at the end of 8 weeks or 2 months. But the glucose came down within first week and stayed normal over 8 weeks. And there was an improvement in the insulin secretion or beta cell function, which started within 1 week and improved fully by 8 weeks. Now, this improvement in insulin secretion or the beta cell function was inversely proportional to pancreatic fat. There was a decline in the fat, which was very much in sync with the insulin secretion improvement. And the MRI also showed that there was a loss of fat from pancreas. The study concluded that abnormalities underlying the type 2 diabetes are reversible by reducing dietary energy intake significantly. And this was, followed by what is now very popular direct trial by Roy Taylor, which was presented at the IDF meeting at Abu Dhabi and also presented in Lancet at the same time. So this study aimed to assess whether intensive weight management within routine primary care would lead to remission of type 2 diabetes. This was an open-label cluster randomized trial across 49 practices in England and Scotland. Involved type 2 diabetes patients in 20 to 65 years of age with BMI more than 27 and duration of diabetes less than 6 years. The intervention consisted of withdrawing all anti-diabetic and anti-hypertensive agents right from the onset, and the patients were subjected to total diet replacement in the range of 825 to 850 calories. They were given this VLCD for 3 to 5 months, followed by stepped food reintroduction over 2 to 8 weeks time, and a structured support for long-term weight loss maintenance also. So, two co-primary outcomes: weight loss of 15 kg of more, which was equal to 15% weight loss, and remission of diabetes defined as glycated A1C level of less than 6.5% after at least 2 months of all anti-diabetic agents and from baseline to at least 1 year. The average weight was, as I mentioned, 100 kg. 24% of the patients in the study achieved a weight loss of at least 15 kg, and 46% of the patients had a remission of diabetes. Now, if you look at the breakup, patients who lost more than 15 kg, 86% of them went into remission. Patients who lost between 10 to 15 kg, 57% of them went into remission. So, study concluded that remission of type 2 diabetes is a practical target even for primary care practices. And then we have 2 years follow-up results from direct trial to see what was the durability of this intervention. After 2 years as compared to 24% patients who had weight loss of more than 15 kg, only 11% were sustaining a weight loss of more than 15 kg. But of the 46% who went into remission, 36% were still in remission after 2 years. And if you look at the breakup, patients who were maintaining more than 15 kg weight loss, almost 70% were still in remission. Patients who were maintaining 10 to 15 kg weight loss, almost same number, 60% were still in remission. And those between 5 to 10 kg, again 30% were still in remission. So it is now certain that disease process can be halted by restoration of normal carbohydrate and fat metabolism. And type 2 diabetes can be understood as a potentially reversible metabolic state precipitated by a single cause of chronic excess of intra-organ fat. Both muscle and liver contribute to insulin resistance, but the early improvement in control of fasting glucose levels is associated only with improvement in liver insulin sensitivity, and seems muscle insulin resistance doesn't seem to play an important role. There is evidence linking hepatic insulin sensitivity to intra-organ triglyceride content, which is increasingly accumulating, and decreasing fat content in liver is associated with improvement in insulin suppression of glucose production from liver, leading to improvement in fasting glucose. Chronic exposure of beta cell to triacylglycerol or fatty acids, both in vitro and in vivo, leads to decreased beta cell capacity to respond to acute increase in glucose levels, which is important to have ATP production. But beta cells can import fatty acids and accumulate fatty acids by storing them within the cell. Now, this accumulation of fatty acids interferes with ATP generation required, which is caused by glucose oxidation, and therefore the capacity to respond to glucose levels decreases because of the fat inside the cells. So fatty acids have been shown to inhibit beta cell proliferation in vitro by induction of the cell cycle inhibitors also, and the effect is magnified by increased glucose concentration. So this whole story is now explained by what is called twin cycle hypothesis. There is a cycle going on in pancreas and one in the liver. So excess calories plus insulin resistance lead to increase in liver fat. Increased liver fat leads to resistance to insulin, thereby leading to increase in glucose levels. And this increase in glucose level leads to increased demand for basal insulin secretion. Increased basal insulin secretion further leads to lipogenesis at the level of liver, increasing again liver content, putting a vicious cycle here. Excess calories intake also leads to increased free fatty acids in serum, which lead to increased turnover of free fatty acids in the islets, leading to increased islet fat deposition, leading to beta cell dysfunction, further increasing the glucose level, and thereby running what is called a vicious cycle. So this is a twin cycle, one in the liver, one in the pancreas, which is causing a perpetuation of hyperglycemia. Now, if you look at how long the weight loss or can cause a remission of diabetes, so diabetes does not recur up to 10 years after bariatric surgery unless there is a substantial weight gain. And possibly there is a trigger level for adverse metabolic effects of fat in the pancreas, and this trigger level is variable between different individuals depending on their sensitivity. So for a given individual with type 2 diabetes, reducing the liver and pancreatic fat content below this personal trigger level would be expected to result in release from the fatty acid mediated dysfunction, and individual tolerance for the liposusceptibility will be different. So with this understanding, I will conclude my presentation. Type 2 diabetes is caused by nutrient excess, leading to fat accumulation in liver and pancreas beyond a trigger point. This results both in insulin resistance and beta cell dysfunction. And acute caloric restriction helps in lowering both liver and pancreatic fat and may result in a remission of diabetes. Thank you. With this, I conclude my presentation. If there are any questions, I'll be more than happy to take that.
Thank you so much, sir, for the enlightening talk. We invite any questions are there.
Sir, already we are running late. So kindly we should sit your next session, sir.
Thank you, sir.
Thank you, Dr. Makkar, for joining our conference and
sparing
your valuable time. Thank you so much.
Thank you, sir. Thank you so much. Thanks for the opportunity.
Thank you, Dr. Makar. Thank you.
Thank you so much, sir.
So I now take this pleasure to invite another renowned speaker and our President-elect of RSSDI, Chaudhry Dr. Vasant Kumar, sir. He is at present Chairman, Telangana Chapter of RSSDI, past Chairman of Hyderabad API. He is a founder President of Diabetes and Youth Society, which is supporting type 1 diabetes children since 1999. Dr. Vasant Kumar, sir, is at present working as a senior consultant physician at Apollo Hospitals, Hyderabad. He has been the Vice President of RSSDI also. He was the organizing chairman of RSSDI 2016 at Hyderabad. He was awarded fellowship in RSSDI during National RSSDI meeting at Hyderabad. He is a faculty in IMA, API, and RSSDI scientific meetings. So over to you, Vasant Kumar, sir, for your talk.
Dr. Vasant Kumar?
Yes,
yes, there, sir. My home.
Warm welcome, sir.
Good morning, sir. Good morning. Thank you so much, sir, for joining.
Thank you, sir. So thank you, Dr. Parikh, or Dr. Girish, and all my respected colleagues of Rajasthan. It's my pleasure always to be with you all. I remember the last time we have enjoyed being in the RSSDI meeting last year.
Yes,
we are not able to meet physically, sir. And thank you for giving me this opportunity. My topic is, though on diabetes, it is slightly different because probably I'm dealing with more of the social aspects of diabetes care, which is where we physicians are always concerned. And so today, my topic, as it is mentioned, is let's win the war against diabetes. You know, the Frederick Banting, we cannot forget him, the man along with the best who has discovered the insulin and made the lives of diabetes different for the last 80 years. We also know that in India, we still stand number 2 worldwide. And India, along with China and USA, have half of the diabetic people all over the world. We know very much that we Indians differ in so many ways, pathophysiology and other phenotype and other issues. That's how the Indian diabetics are different, and we need to deal with the issues. And I'm going to talk about these different, probably 7 differences that you see. We have higher insulin resistance, and we have strong family history. We see diabetes coming at young age. We have complications at young age, especially CVD. Of course, we eat high calorie and also high carb food, and most of us have become sedentary. We are, of course, thin but fat. And above all, we have beta cell dysfunction very predominantly amongst Indians. So in the Indian context, whenever you are talking, we have high prevalence of pre-diabetes. Now we say the equal number of pre-diabetics are existing. And as I mentioned, type 2 diabetes starts very much early in the Indian populations compared to the Westerners, maybe a decade earlier. So it's nowadays you very often see the parents, type 2 parents, bringing their young boys and girls who are just about 30, newly detected diabetes. And we also have high prevalence of complications, both micro and macrovascular complications. We have a large rural and urban divide. Please don't forget, still 70% of our Indians live in rural areas. We have problems which I will deal with. Not that you are not aware of it, but I want to remind our physicians about these aspects, how we can play some constructive role. And of course, the cost of the diagnosis, treatment, monitoring, all this matter a lot to most of our Indian patients who belong to poor class or lower middle class. And as I mentioned, many of the people all over the world have become sedentary, and the Indians are no exception. And of course, most important, as I mentioned, is we have limited resources, most of us. The government, for whatever reason, is not able to spend enough for healthcare, and more so for NCDs, in spite of some recent spurt in spending. Poverty literacy is very much there in India. Please don't forget, many of our patients are still not adequately literate. We have many psychosocial and cultural factors. We believe in so many things. We have faith. We have sometimes blind faith. And we have so much of belief in gurus and Godman and whatnot who claim to treat diabetes even when they have complications. And we always have a problem in adherence and compliance of our patients. We know the reasons. We are all dealing with such situations every day in and out, especially the physicians. So what are the special features of diabetes in India, which I already mentioned to you? We have seen many of our patients, either they have normal BMI or low BMI. So that's why we call them thin fat. As I mentioned, the onset is very much earlier. You're seeing them almost in 30s now, especially those who have got family history of diabetes. The CAD is higher amongst our young diabetic men and women. Incidence of complications are high due to various reasons. Maybe they are uncontrolled. They have not been exposed to proper treatment because of, the poverty and then illiteracy being in rural areas. And we have more infectious complications amongst our diabetes. Please don't forget this. We have what is called a dual disease burden or a double disease burden. We have tuberculosis, which is still unconquered. We have respiratory seasonal infections. We have food sepsis that happens among the rural and even the urban poor because of the unsanitary conditions or because of habits. So you can imagine when diabetes gets mixed with these common infections, so the things only become worse. And many of our people have misconception about diabetes, which has serious effects on the management of the disease. People have their own beliefs. They think nothing will happen. Diabetes is common. We don't need to take insulin. So many things. So in Western countries, many of them, they are doing better than we Indians because they are able to find out certain solutions, either due to their better resources, literacy, or availability of better health care. The mortality has definitely reduced. But what's happening to our battle in India? Are we able to invest enough science, institutional orientation towards actually translating and implementing our goals of diabetes management? Do we have good quality of care, which is very important? So it means that what is happening to the war against diabetes in India is the point now we are going to discuss for the next another 10 minutes. Majority of our type 2 patients, are from lower middle class, lower income group, both in urban and rural areas. Please don't forget even that 30% of the urban people who live, more than half of them live in slums. They have no access to even to a doctor. Forget about a specialist. We are talking about specialist care. We are talking about so many things. But the fact is this, they have no access to even to the minimal health care services in this country, whether they are urban or rural, as long as they are poor. And obviously, most of them are uncontrolled. They have high rate of complications. Are we looking at simple parameters like blood pressure, lipids, and kidney functions, which are sometimes not done very often? I think these are three very important things apart from hyperglycemia, at least to make sure that they suffer less, they have less complications, and at least you can extend their life. But is this really happening? Will you please think about this while we talk about so many new things, the technology and HbA1c's, glucose variability, all this. But can we apply all this to this population? We have many of our patients who don't check blood glucose very often, not even the blood pressure. Two very important things that are required for our diabetic patients to reduce their cardiovascular disease mortality as well as the morbidity. And the follow-up is very bad. Drug compliance is also poor, particularly we who either we claim as specialists or whoever we are, and if you are trying to prescribe expensive medicines to the patients, please make sure that this is going to be a lifelong treatment. Are they going to stick to the treatment? First of all, are they going to stick to you? Will they run away from you and go somewhere? That's a fact of the life, which today I want to highlight to all my dear colleagues. The disease awareness is always poor. There is always delay in diagnosis, you know. That's the reason why the complications are more. So we need to address these questions. We always talk about lifestyle modification. It's a very fashionable word. Of course, in all guidelines we mention. So now if you ask our students, how do you manage type 2 diabetes? He would just say LSM, thinking that it's enough. But is this really happening? Are we just using this word for sake of using? How do we act on this? Do we really? Sometimes I feel we need to change this lifestyle modification, this word itself, and probably call it change in the behavioral pattern or something, where people look at it more seriously. And diet, of course, is about everything, about calories. It's not just about carbs. We had a beautiful lecture by our colleague, Dr. Makkad, on this. So it's not the carbs alone. You know, people have got a lot of cheap fats available. And what is this Indian junk food that is available outside for the urban poor? It has a lot of trans fat and also calories, which attribute to increased cardiovascular disease, not only hyperglycemia and other things. And we have a lot of toxins in the food, the water, that everything that we take. And it's in a very unorganized fashion. There is no much control or system on that. So you don't know how much it is affecting the endocrine systems, and we call them endocrine disruptors. We know them. Worldwide, people are worried about it, but I'm sure things are much worse in India. So are we paying enough attention, we and the government? We don't know. How much we know about the genes and epigenetics? We've been working on it. Our researchers doing good work, but we need to more about this, how our own genes are responsible for the Asian phenotype. Of course, we are using the words like reversal of diabetes, which we just heard, but then we need to see how practicable it is and what percentage of our patients can have this, especially when you're dealing with all kinds of people in this country. And majority of them, unfortunately, belong to the section which I have been mentioning to you for the last 5 or 10 minutes. They're talking about precision management. We are shifting one point to the other point. We talked about HbA1c. Now we say HbA1c may not be really always worthy of it. We are talking about continuous glucose monitoring system. We are talking about precision management. It's true. It's nice. It looks very nice. It's good that we can achieve. But then how many of our patients are actually undergoing HbA1cs? Even if you do them, how many are under control? You know that. It's being mentioned by many of our speakers. And HbA1c versus frequent home monitoring, which is better? I'm asking you this question. I know everybody says HbA1c is a gold standard, but if that is not happening, don't we look at doing more frequent blood glucose monitoring, maybe looking at blood glucose monitors, cheaper strips, doing them in the government facilities more often in your clinics? Maybe that helps. At least people will know that they have hyperglycemia, they know what to do. You can reduce some of these risks that they suffer. So our slogan to make India a diabetes-free country, is it possible with the way we are thinking of diabetes, with the kind of attitudes the doctors and patients have? Is it only a distant dream? I wish it is not. But just think about this with the point that I mentioned. Do you think it's going to be possible in the next few decades that we can drive away diabetes in this country? So these are some of the programs that I do organize for type 1 diabetic patients. When we deal with type 1 diabetics who are poor, things are much worse in the country. Incidentally, India has got the largest number of type 1 diabetic children and 70% of the poor. So you can imagine how things can be much worse. And role of the physicians, as I mentioned, is very important. We need to play an important role in prevention as well as early detection of diabetes. Today, we are all the physicians here working under the banner of API, under the banner of Rajasthan API. And I'm sure Rajasthan has enough rural population and poor urban population. And we need to concentrate on these aspects before you talk too much about the latest things. and try how we can prevent the complications by strict control of diabetes in the possible extent. So how can we achieve this in the limited resources is something we have to keep discussing in these meetings. While we discuss about the latest things, while we discuss about the updates, it's fantastic. But how can we ignore these aspects? And how can we practice evidence-based medicine, which teaches us with all these limitations we have? You cannot just avoid these limitations. You have to find your own ways and means of working out on these aspects. We should have our own strategies. Don't forget this. You just can't follow somebody's guidelines and say that you want to do that. So we need to look at some of these important things like health education, explaining the importance of control of disease to our patients in their own language, in the way they understand. And as I mentioned, frequent checking of the sugars and looking at hypertension, which is again, 50% of our diabetics have hypertension, and many of them may have lipids because of bad eating habits. And family physicians, GPs have a very important role to play. Please don't forget this, that in India, diabetes cannot be treated by specialists alone. We, the physicians, as well as family physicians, GPs, have to be a part of diabetes prevention, spreading awareness, and even management is very important. I think the physicians have to play a role in this to a great extent. And of course, generating our own data is very important to understand the disease pattern in our own local populations, how the disease is patterning in a rural Rajasthan or rural Andhra Pradesh or Kerala. I know a lot of work has been done, but I think we can still do a lot more work with more simplicity and gather and get more work on this. So these are some of the type 1 diabetic children whom we keep meeting. We have malnourished type 1 diabetic children. We talk about pumps and CGMS and all that. But unfortunately, many of these children, even to get proper insulin is still a distant dream. Please don't forget this. We need to make sure that our children get at least simple insulins for their sustenance of the life. COVID and diabetes had been a big issue, and especially when you're dealing with issues like, lack of awareness and then uncontrolled diabetes happening during the pandemic. People don't even realize that they're diabetics. They even stop medication. They don't buy the medication because either they find an excuse or they don't want to go to a pharmacy. No access to the doctors in spite of talking about digital management, which is happening to some extent, but is it happening everywhere is the question. So many of the patients, especially I have seen type 1 children ending up in DKA, and the other adults, type 2 diabetics coming with COVID positivity, uncontrolled diabetes. So I know we are all working on that. RSSDA has been putting its efforts, also the API. So the RSSDA guidelines, if you see, we are talking this therapeutic wheel, which we are trying to popularize, which has been partly Indianized. We are looking at the Western population guidelines, but we are looking at the Indian scenario. Basically, what we are talking about ABCD, we are looking at the age of the person. Also, we are considering the affordability of the person and the complication that he has. So what is important is we need to individualize the management of type 2 diabetes, not just go by the guidelines. Now it is the time that we need to individualize every patient and see how we manage. These are some of the new guidelines that have come and where we give a lot of importance to lifestyle modification. But unfortunately, are we doing enough is the question. So coming to the insulins, now that we know many of our type 2 young diabetics, lean diabetics, many of them may have insulin deficiency, so a lot of them need insulin. But all conventional insulins, fortunately, have similar glycemic lowering effect. I mean, they are equally effective as the most expensive analogs. Although it is claimed that the hypoglycemic effects would be less if you use analogs. But then please remember that almost 70-80% of our rural and urban poor diabetics cannot afford analogs. The insulins are effective, the conventional insulins, human insulins, are equally effective, which has been mentioned in all the guidelines. So don't forget this aspect. And then insulin supply should be, of course, assured during these times of pandemic. And then our poor patients should know how to store them. And then individualizing the treatment, as I mentioned, is very important. Consider the combination of metformin and one of the treatment options based on all these factors. You look at the age, BMI, whether the patient already has complications like CKD or has he got CVD, what is his financial status, is he more prone for hypoglycemia? And we also look at the patient preference. When you're talking about patient preference, you're seeing whether he's educated or uneducated, his affordability, and the drugs that we are going to prescribe, and how much of blood sugar do you want to reduce. You know that how important it is at different stages of diabetes. So individualizing is very important for all of us. And then most of the available non-insulin agents added to metformin can reduce HbA1c to almost 1 to 1.5. And we must remember the type 2 diabetics in Indian Asian population can be, we know that Indians are different, Indian type 2 diabetes. So now, according to one of the recent studies and the articles published by Dr. V. Mohan, there are at least 4 types of phenotype clusters that we have found out amongst type 2 diabetics in India. 2 clusters are what you find in Caucasians, and the other 2 are even more common in India. These are usually the ones you can see an obese diabetic, or you can see a thin diabetic, you can see a sarcopenic diabetic, you can see a diabetic who is highly prone for DKA with a lot of insulin deficiency. So every type 2 diabetic is not same, particularly in our India. So we have sarcopenic obesity amongst our type 2 diabetic patients who may be metabolically obese. There may be more obesity, but they are sarcopenic actually, where that means they have higher complication rate, they have higher risk of developing other metabolic risk factors. So this obesity paradox, which implies that leaner diabetics have higher mortality. It is such a difficult thing to believe that a person is lean, but he has more fat, he is sarcopenic, he is actually obese in that terms. And then he has higher chances of developing complications. It's actually sometimes difficult for us to comprehend, but that is something we need to be aware and look at even some of these thin Indian diabetic populations and manage them very carefully. So these lean diabetics are an important component amongst the Indians, especially the rural Indians. We know Indian obesity is a very common situation, but at the same time, we cannot forget this entity, because these are the patients who might require insulin at early stage. And of course, there is a slight more preponderance amongst males, and also people having some addictions like smoking and alcohol. We deal with a lot of elderly people. You know how in India, especially again talking about the rural and even the urban poor, how the poor old people are almost ignored and neglected. How many of them do they really go to the doctor? How many of them are taken? And then they have several geriatric issues. Managing them is a huge challenge for both the physicians as well as the patients.
Sir, can I request you? We have crossed more than 22 minutes, sir, please.
Oh, wonderful, sir. I'm finishing.
I have high respect for you.
Thank you. It's over. It's over
now. Time, sir.
I am finished now. So I'm just wanting to say that nurses are very important. We need to train them. So many times we forget that diet is very important amongst diabetic patients. So is this going to be reality? This is the last slide. Towards making India diabetes care capital of the world. We are talking about it. Please see that I have tried to impress on you some of the important aspects that are necessary for all of us to work on it individually and see how we can reach out to our patients in this country. Especially as physicians, we have a huge role to play. And thank you very much, sir, for giving me this opportunity. Thank you.
Thank you very much, sir. It's my sincere request to the chairpersons. We understand there are certain problems, but we cannot afford to cut the timing of the rest of the team in today's evening, sir. So I request to the chairpersons to kindly move on to the next, Dr. Sanjay Agrawal, diabetes and kidney disease, and be careful staying into the time, please.
Welcome, Dr. Sanjay Agarwal. Renal diseases are very common in the diabetes, and he will speak on this topic. Dr. Sanjay Agarwal.
Thank you, Dr. Vasant Kumar, for an excellent lecture, sir. Thank you.
Thank you for your introduction. Can I share my screen, please?
Yes, sir, you can share.
Thank you. Is my screen visible to you?
Yes.
Yes, Dr. Sanjay. You're welcome. Thank you very much. Yes.
I would like to thank the organizers for inviting me to speak today over here on a rather important topic that I feel is required to be discussed. Just give me 1 minute. So I'm going to talk a little bit about diabetic kidney disease, and I'll try and stick to my time because I know we are all behind time. We know that 30% of our patients with diabetes over a period of time tend to develop diabetic kidney disease. And we know that...
Can you make it a full screen, sir? Full screen.
You're not seeing it as a full screen?
It is full screen, sir. It is full screen.
Okay.
It is full screen, sir. Please go ahead.
Okay. Thank you.
So the diabetic kidney disease is a strong predictor of mortality that we know that is associated with diabetes. And diabetic kidney disease occurs as a consequence of multiple pathognomic pathways. And we need to understand that hyperglycemia plays a very major but not an exclusive role. Now, important is to understand that if I've tried to look at how many patients really get aware about the diabetic kidney disease based on the stages at which they present to us. And if you see over here in this table, that majority of the patients, by the time they present to us, are already in stage 4 kidney disease. So we need to do our preventive programs more aggressively so that we don't wait till the patient reaches us at advanced kidney disease. So estimation of the microalbuminuria and looking at all other parameters of control are very important, lest they come to us at a very late stage where we can't really do very much for them. Now, if you look at this graph, and that's very interesting, that initial stages of diabetic kidney disease, there is a hyperfiltration process, and because the kidney has a functional reserve, it is able to compensate. Now, if you look at this graph over here, by the time that we lose 50% of the nephrons, the eGFR is still in the normal range. And it's the eGFR starts falling after the 50% of the nephron mass is actually lost. So the rate of progression of the proteinuria is directly proportional to the amount of GFR drop that we get. And the more the proteinuria, the faster the GFR decline that tends to occur. So it is important that we need to identify microalbuminuria early and prevent the microalbuminuria to progressing to macroalbuminuria and overt proteinuria. Why is this so important? Because as the patient progresses from microalbuminuria to proteinuria and development of the kidney disease, where there is a progression of the kidney disease to end-stage renal disease, all these stages ultimately are also responsible for increased occurrences of the cardiovascular events and increased mortality. And if you look at the amount of the proteinuria that predicts stroke or coronary heart disease events, you find that with the increased amounts of proteinuria, there is a high incidence of mortality. And here you can see the two groups: urinary protein less than 150, urinary protein between 150 and 300, and urinary protein of more than 100. And you can see here with the increased amount of proteinuria, the amount of stroke events or coronary heart disease events tend to go up. Now, equally important is the fact as people progress from no nephropathy to macroalbuminuria and renal replacement therapy or end-stage kidney disease, the mortality increases right from 1.4% to almost about 19%. So it is very, very important that we try and prevent the progression of the kidney disease so that we can reduce the overall mortality and prevent our patients going into end-stage kidney disease. Now, these are the various biomarkers that are available. So a lot of them are just research tools, but some of them are there with us, and we can use them to predict early kidney disease. I'm going to really talk about what is really the changing landscape of treatment that we have seen over here. Now, if you look at all the glucose-lowering agents that are available for us for cardiovascular and renal outcomes, where metformin is concerned, it has weak cardiovascular evidence for benefit, but there is no kidney data. Sulfonylurea is again neutral on cardiovascular events, and there is no kidney data. DPP-4 agents are again neutral on cardiovascular events, but there is no kidney data except for linagliptin, which is a little neutral. And acarbose, again, the cardiovascular and kidney data is neutral or there is no data at all. What about the GLP-1 analogs? And we know that there is some amount of positive cardiovascular data and there is some positive kidney data that is available. But the strongest data about the cardiovascular and kidney data comes from the SGLT2 inhibitors. And I'm going to go briefly over this. Let's look at the role of incretins. And this comes from the Marlin-Lina trial. They compared linagliptin 5 milligram versus placebo. And you can see that the A1C reduction was about 0.6. And when it was looked at placebo adjusted, you find that there is no really significant change in the amount of proteinuria as evidenced by this graph over here. So there isn't really much in the short term that there is an impact on the albuminuria. But if you look at the post hoc analysis and if you look at the more than 20% reduction in the UACR, you find there is some amount of significant reduction that tends to occur with linagliptin in the long term, or increase in the albumin-urea creatinine ratio is prevented in about small percentage of people. So there is a 67% higher odds of clinical meaningful UACR response of more than 20% reduction with linagliptin, but this is on long-term studies. Now, if you look at all the other outcome studies with the DPP-4 inhibitors, you've got the SAVOR-TIMI, the EXAMINE, the TICOS, and the CARMEN-LINA trial. These were primarily patients who had established cardiovascular disease, and there was some pre-specified kidney endpoints with reduction of albumin-creatinine ratio, and the post-hoc analysis of either doubling of serum creatinine, initiation of renal replacement therapy, or composite endpoints of death or any of the above. So all these were kind of looked at from the outcome trials, the CV outcome trials as an offshoot. And if you look at the pre-specified endpoints where the Carmelina study was concerned, the primary and pre-specified adjudicated kidney endpoints of sustained ESKD, sustained more than 40% eGFR decrease from baseline, or death due to kidney disease, that was neutral. When it comes to sustained end-stage kidney disease or death due to kidney disease, again, this was neutral and with no significant benefit. And if you look at the role of albuminuria progression, there was about 14% significant reduction in the albuminuria with the Carmelina trial with linagliptin. Now, there were also exploratory kidney endpoints with other DPP-4 CVOTs. So they looked at in SAVOR-TIMI UACR as well as in TICOS UACR and the eGFR decline, which was really not significant in any kind of a work. So if you have to look at the risk reduction for albuminuria with linagliptin, there's a 14% lower risk of progression of albuminuria, and there's a 15% greater likelihood of significant reduction of albumin-creatinine ratio. So how do you really go about dosing of the gliptins where renal insufficiency? So majority of all the DPP-4 inhibitors can be used. Linagliptin, of course, can be used with unchanged dose, but all the other gliptins with a decreasing eGFR, you have to reduce the dose of the gliptins proportionally to either half or 1/4 based on the eGFR. Okay. Don't know why my slides are. Okay. Now I'm going to come to the GLP-1 analogs, and they looked at the liraglutide in the LEADER trial. And this was a renal outcome, was a composite of new onset persistent macroalbuminuria, persistent doubling of the serum creatinine level, end-stage renal disease or death due to renal disease, and a total of about 9,000 odd patients were followed up for about 3.84 years. And you can see that the composite renal outcome was reduced by about 22%, and this was primarily driven by the new onset of persistent macroalbuminuria, which was reduced by about 26%. But there was really no significant change in the persistent doubling of the creatinine level or the time to continuous renal replacement therapy. So you can see here that the GFR decline did not really change, but the albumin creatinine ratio was reduced with the liraglutide subgroup analysis. If you look at the dulaglutide group, here you can see there were three arms, the 1.5, 0.75, and this was compared against glargine. And they looked at various sub-analysis according to GFR or the albumin creatinine ratio in the different values of the albumin excretion or in terms of different values of the eGFR. And what it did show was that there was a slowing down of decline of the eGFR with dulaglutide 1.5 and 0.75 and 1.5. And this was also driven primarily, if you can see over here, that this was compared against glargine, and you find that this was robust for the dulaglutide, and glargine really did not impact the eGFR decline very much. Now, if you look at the patients who had macroalbuminuria versus no macroalbuminuria, dulaglutide had a significant benefit in regression of the macroalbuminuria for both the strengths that was used. Now, I'm going to come to the last part of my talk, and that was the where the data is strongest and the role of SGLT2 therapy in renal replacement. And this data comes from three important molecules. There's the empagliflozin with the EMPA-REG study, canagliflozin from the CANVAS and CREDENCE, and the dapagliflozin from the DECLARE and the DAPA-CKD trial. These were the demographics of the different trials that we had looked at. The DAPA-CKD, of course, looked at patient population who were diabetic and non-diabetic with the eGFR between 25 to 75 and an albumin creatinine ratio between 200 to 5,000, and compared that against the CREDENCE trial, which looked at canagliflozin. Again, this was only in patients with diabetes, eGFR between 30 to 90, and the albumin creatinine ratio between 300 to 5,000. Now, the composite endpoints of DAPA-CKD was more than 50% sustained eGFR decline, and occurrence of end-stage kidney disease or renal and cardiovascular death, and very similar endpoints where CREDENCE was concerned in the primary composite endpoint of doubling of serum creatinine, end-stage kidney disease, or renal or cardiovascular death. And there was a host of secondary endpoints that was looked at in both these studies. This was also, there was a third study, the EMPA kidney study, which was looked at on the background. All these studies had ACE or ARBs. The EMPA kidney is also an ongoing study. They're looking at diabetic and non-diabetic population, very similar patient population, and the endpoints are, of course, very similar. And the last one is, of course, with the Fidelgo DKD, and this one, finerenone versus placebo. And they're looking at, of course, an eGFR between 25 to 60 in diabetic population and an albumin creatinine ratio between 30 to 300. Composite endpoints of kidney failure or more than 40% sustained eGFR decline and renal death. I'm just going to briefly touch base on what the results are. The EMPA-REG, of course, showed that there was a 39% relative risk reduction of new onset worsening nephropathy, a 38% relative risk reduction of new onset macroalbuminuria. The doubling of serum creatinine was slowed down by 44%, and the first initiation of continuous renal replacement therapy was reduced by 55%. If you look at the regression of macroalbuminuria to normal or microalbuminuria, you find that there is a significant decline that tends to occur in the EMPA group, whether it was 10 or 25 milligram. Similar data also comes from the canagliflozin, where you found that there was a regression of the albumin creatinine ratio, and from the regression from macro to micro and micro to normal albuminuria in the canagliflozin group, and the mean difference was about 18%. If you look at the progression of albuminuria, it was reduced by 27%, and regression albuminuria was reduced by about 70%. If you look at the composite of 40% reduction of eGFR, time to end-stage kidney disease or renal death, you find that there was a 40% reduction in all these outcomes in the canagliflozin group. I'm going to come to the CREDENT study, and this was the trial design that we looked at. And the CREDENT study showed very similar results, where we saw that there was a 30% decline in the primary outcome of end-stage kidney disease, doubling of creatinine or renal or cardiovascular death. And the effects of albuminuria was again similar, that there was a 32% reduction in the canagliflozin group. The DAPA-CKD was, of course, the most robust study. And if you look at the primary outcome of composite of more than 50% eGFR decline, end-stage kidney disease or renal or cardiovascular death, it was driven by all the secondary endpoints, and all the secondary endpoints as well as the primary composite endpoints were significantly reduced in the DAPA 10 milligram group versus placebo. And the primary and composite endpoints which was reduced was driven by all the components of the primary composite endpoints. That was more than 50% eGFR decline or time to end-stage kidney disease. The only endpoint that did not show any difference was the cardiovascular death. Now, if you look at all the sub-analysis, the analysis showed that the benefits were seen in patients who had diabetes against also who did not have diabetes, patients who had an albuminuria of less than or more than 1,000, or an eGFR less than 45 or more than 45. In all the subgroups, the benefits were clearly seen. So the summary was that there was a 39% relative risk reduction in the primary composite endpoints, 44% relative risk reduction of the renal composite endpoints, 29% reduction in the composite of cardiovascular death and hospitalization from heart failure, and 31% reduction in all-cause mortality. I'm going to come to just a small passing reference to the Fidelio DKD. This was a phenomenon trial, which is very important. And what it showed was it delayed the progression of chronic kidney disease by reducing the risk for the first time to occurrence of renal failure, defined as a sustained decrease of estimated GFR of at least 40% from the baseline of at least 4 weeks or renal death. And the reduced risk of key secondary endpoints of time to first occurrence of CV death, non-fatal MI, non-fatal stroke or heart failure from hospitalization. So in summary, you do realize that it's important that we need to address albuminuria early. We need to identify patients who are at microalbuminuria to prevent the progression, because we know that as proteinuria progresses, the eGFR comes down and the decline in eGFR is accelerated. We know that as proteinuria increases, the chances of mortality goes exponentially higher. So we need to make all efforts to reduce albuminuria very early, and we have to use SGLT2 inhibitors earlier on. And I just gave a lecture yesterday to say that should SGLT2 inhibitors should be used in all our Indian patients who have diabetes, and the answer is very strongly it is yes. Can nephropathy be prevented? The primary prevention and the secondary prevention data is very good. If we address it earlier, we can prevent the progression of the kidney disease. We know that of all the available oral agents, the best data is with the SGLT2 inhibitors and the GLP-1 analogs. So all the others haven't got such a robust data. Thank you very much for your patient listening. Thank you very much.
Thank you. Thank you very much, Dr. Sanjay Agarwal. And my sincere thanks to Dr. B.M. Makkar and Sri Vasant Kumarji also. And my sincere thanks to the chairpersons. May I do apology because the time restrictions have been there. We are already one session late. So coming to the next session, that's...
Thank you, Dr. Sanjay Agarwal.
Thank you.
Be part of this conference. Thank you so much. So nice of you sparing your valuable time.
Pleasure to be here. Thank you so much for the opportunity.
Very important topic. Yes, yes. Thank you so much, sir. Thank you.
So coming to the next session, that's the hypertension update. And that's a 3 to 4 session. We have eminent chairpersons, Dr. Preetam Gupta, Dr. Saurabh Chitora, and Dr. Sumit Garg. Let me introduce their CVs also. Let's have Dr. Preetam Gupta. He is HOD at Yati Sundar Lal Jain Hospital at Ashok Vihar, Delhi, Senior Consultant Fortis Hospital, and he had been a Dean of ICP 2014-2015, President API 2018-19, Editor-in-Chief Medicine Update 2019, and Scientific Chairman EPICON 2018. He will be introducing Dr. K.K. Parikh. Next, coming to Dr. Saurabh Chitora. Dr. Saurabh Jitara is Assistant Professor, MD Medicine and Department General Medicine at Kota Rajasthan, and he had 4 international and 10 national publications. The next chairperson, Dr. Sumit Garg, who will be addressing to Dr. B.B. Thakur. And Dr. Sumit Garg, he is a very dynamic, and he is MD Medicine, Fellow of ACP, Post Cardiology, Johns Hopkins, USA, and he had many publications also. And most one is studied erectile dysfunction, type 2 diabetes mellitus, and many precipitating factors. So, coming to the session, and I'll request kindly take, and it's a request as a time constraint, and have been designed and has been rescheduling the time schedule. There's a 15 minutes. So over to chairpersons.
Good afternoon, sir. Hi. Now the session is on hypertension. But it's a disease burden which involves probably all the organs of the body. Incidence and prevalence is increasing day by day, and I'm very happy that API State Chapter of Rajasthan has taken this session as on priority. Now, speaker is Dr. K.K. Parikh, who will be delivering a talk on international guidelines of for management of hypertension. Dr. Parikh needs no introduction. He is a well-known personality in Kota, in Rajasthan, but not only Rajasthan, in whole over India. He was our leader and president of Association of Physicians of India in 2019 and scientific chairman of APICON 2019. During his leadership, API attained heights, and he was the person who released the guidelines, Indian guidelines for gastrointestinal reflux disease. I know him personally, he's a personal friend of mine, a thorough gentleman, a nice personality, excellent leader, excellent guide, an inspiring personality rather. With these words, I bring you Dr. K.K. Parikh. Dr. K.K. Parikh, please.
Sir, unmute, sir.
Hello, am I audible?
Yes, sir.
Am I audible?
Yes, sir. Yes, sir, you are audible, sir.
Yeah.
You are very much audible, sir. Please go ahead.
Am I audible?
Yes, sir. Yes.
Yes, sir. You are fully audible, and there's a main screen, but please slide share on the main screen, sir.
So it's really a proud privilege for me, and I extend my sincere thanks to all the speakers, all the chairpersons, and all delegates who are attending this conference. I think they are I found out that more than 500 physicians and clinicians are attending this conference. Thank you very much. And thank you very much, Dr. Preetham Gupta, for your kind words. And I'll be talking in a very short about 2020 International Society of Hypertension Clinical Practice Guidelines. We know that the burden of hypertension is very high and the awareness is very low, leading cause of death globally. And in recent years, BP tends to show a clear shift of higher BP from high income to low income group. The special features for hypertension in India is something different. Onset is early, rural area, divide in prevalence, clustering of multiple cardiovascular risk factors, significant seasonal variations which we are aware, and rising average of BP of general population. Low awareness, as I told you, for treatment and control rates, and early hypertensive mediated organ damage because of poor control. So in Indian scenario, poor control, low awareness, and rising average of BP general population are the most important factors. In last few years, a plethora of different hypertension guidelines are released from different bodies of hypertensive societies in the world. European Society of Cardiology, International Society of Hypertension, and American Heart Association, and the most important Indian guidelines on hypertension by Hypertensive Society of India are most important because we are Indians. We need Indian guidelines in every, not only in hypertension, but in every subject. Due to difference in these guidelines in definition, diagnosis and treatment of hypertension, it has created some confusion. I'll say it has created a maximum confusion in the physicians what guidelines we should follow. The 2020 International Society of Hypertension guidelines, they have been developed by the ISH Hypertensive Guidelines Committee to be used globally and fit for application in low and high resources in essential and optimal standards. So this is for the first time that some guidelines on hypertension have included the essential and optimal, essential for low income group and optimal for high resources group. So this is very important and to be concise, simplified, and easy to use. They were critically reviewed by the numerous external hypertension experts from all over the country. And the most important thing that they were without support of industry. So they are not biased. I'm very happy to share with you that from India, Dr. S.N. Narsingan and Dr. Srinath Reddy from India were part of these guidelines. Am I audible? Am I audible to you? Essential and optimal standards of care, as I said, the essential refers to the minimum standards of care, because optimal standards would not always be possible every time. So they have put essential standard of care, and optimal standard of care, they are refers to evidence-based standard of care. So they are evidence-based, they were minimum standards of care. The optimal involves essential also. The international targets of blood pressure in 2020, all guidelines says that it should be less than 130/80 if one can tolerate, otherwise less than 140/90, except the Canadian guidelines which says it should be less than 140. To whom we should diagnose hypertension? If a person is having a blood pressure of 140 and 90, after repeated examination, this is a very important line. Repeated examination is needed to diagnose hypertension. The diagnosis should be made after 2 to 3 office visits and not only by a single office visit. But it is also important that the BP is 180-100 millimeter of mercury, and there are evidence of cardiovascular diseases, then only a single visit is important and one must start treatment immediately. The The recommendations for the diagnosis for hypertension should be confirmed by out-of-office BP measurement. So out-of-office BP measurement is very important, and how the blood pressure should be measured is very, very important. I will not go in much details, but I will tell you very important two things, that at each visits take 3 measurements with 1 minute between them and calculate the average of last 2 measurements. And if BP of the first reading is less than 130/80, no further measurement is required. So it is very important, and now there are BP instruments which are available, which take automated 3 measurements with 1 minute between them. The blood pressure of 2 to 3 office visits, if it is more than 140/90, we have to label him hypertension. So this is the right way how one should take blood pressure, because if you don't take blood pressure in a right way, you can increase or decrease the blood pressure. Back supported, no talking, arm bare, resting and mid-arm at the heart level, and empty bladder, no smoking, quiet room. Valedictory electronic upper arm instrument should be oscillatory instrument should be used, as mercury instruments are banned. Now, how to classify hypertension based on office blood pressure? I may remind you that all the guidelines are being made on office blood pressure measurement. So they have put the international guidelines say that normal blood pressure is less than 130/85, high normal BP 130 to 139 and 85 to 89, grade 1 hypertension 140 to 159 and 90/99 diastolic. Grade 2 hypertension if it is more than 160 and more than 100 diastolic. What Indian guidelines says that they have added one more optimal, which should be less than 120/80, and they have also put a stage 3, which is more than 180 and more than 110 diastolic, then it is stage 3 hypertension. And they have also added isolated systolic hypertension grade 1 and grade 2. So they are almost similar, like to Indian international guidelines are similar to Indian guidelines. The criteria of hypertension based on office, ambulatory and home blood pressure measurement. The office BP, if it is 140/90, then by the ABPM, it is 24 hours average is 130/80. Daytime awake is 135/85 because it is more. Nighttime, because there is a nighttime dip, it should be 120/70. And if we compare with home BP measurement, it should be 135/85. So friends, you should know that office BP is always more as compared to office home blood pressure monitoring and ABPM. ABPM, since it is not very feasible, so we must use ABPM. This is the same Indian guidelines on, I have compared both guidelines, and Indian guidelines are almost the same as international guidelines. The hypertension diagnosis, office BP measurement, how should we evaluate? Measure BP in both arms, and if the difference of more than 20, consider further investigations. And it is very important in that in elderly people with diabetes, measure standing BP in the first visit also. Otherwise, in a normal patient of hypertension, if one feels symptoms of postural hypertension, then you must take standing blood pressure also after 3 minutes. Unattended office blood pressure has become very, very important. Multiple automated BP measurements, as I said, while patient remains alone in the office confirmation, and out of office BP is needed for the treatment decision. So how we can take unattended office blood pressure? By home blood pressure monitoring, or asking the patient to sit in the lobby and ask your nursing staff to take blood pressure after every 1 minute and take 3 readings, and then average is taken. Because why out of office BP measurement is important? Because it is more reproducible than office measurement, and it is closely associated with hypertension-mediated organ damage and the risk of cardiovascular events. That's why out-of-office BP measurement is important. And it also identifies the white coat and masked hypertension, which is very important. And it is also very important that if BP remains 130 to 159 systolic and 85 to 99 diastolic, then the BP level needs to be confirmed using home or ambulatory BP monitoring. So, what are the diagnostic tests for essential and for optimal? For essential, history of blood pressure in the family, risk factors, assessment of overall cardiovascular risk, symptoms and signs of coexistent morbidity, and symptoms suggestive of secondary hypertension. We must exclude secondary hypertension because it is one of the hypertension which can be treated and you need not to take tablets or medicines lifelong. Physical examination, the cardiovascular system is very important, and other organs systems like large kidney, large thyroid, and increased BMI must be considered. The blood test, renal function test, and lipid profile are very important. Urine test and 12-lead ECG to know left ventricular hypertrophy. In optimal, now it is essential. These are the minimum things. Optimal, you can go for echocardiography, carotid ultrasound, kidney, renal artery and internal imaging, fundoscopy, brain and CT MRI. And the functional test, ankle brachial index, which has become very, very important even in the diabetic patients. Further testing for secondary hypertension. If you suspect, you have to exclude urinary albumin creatinine ratio, serum uric acid levels, and liver function test. Mind it, they are for optimal, those who can afford, but the essential or minimum, what I said, these are the tests. So, this is I have told. So, the diagnostic approach for cardiovascular risk, this is also very important. And at the first consultation, you must think for assessment of cardiovascular risk. Cardiovascular risk should be assessed by easy-to-use scores based on BP level and additional risk factors according to the ESC and ESH guidelines. Other risk factors which are important: age, more than 65 years, heart rate, if more than 80, body weight, diabetes, high LDL or triglyceride levels, family history of cardiovascular disease and hypertension, early onset of menopause, smoking, psychosocial and socio-economical factors, which are very, very important. Then hypertension-mediated organ damage like left ventricular hypertrophy by ECG, moderate and severe CKD, EGFR, and any other evidence of organ damage. Past history of CHD, heart failure, stroke, and peripheral vascular disease and atrial fibrillation, CKD stage 3 should also be evaluated. White coat and masked hypertension, because 10 to 13% subjects attending clinics due to high BP are diagnosed as white coat hypertension, and 10 to 15% have masked hypertension because there is an incidence of sustained hypertension in those cases, and also in masked hypertension there is evidence of sustained hypertension, and there is a cardiovascular risk also in both white coat as well as in masked hypertension. The pattern of blood pressure variation in ABPM, this will be talked by our very senior and a very stalwart of hypertension, Dr. Venkatram. Dipping, there is a nocturnal BP fall about 15% in night time as compared to daytime values. Non-dipping, absence of nocturnal fall. Extreme dipping, marked fall in BP during night by 20%. And reverse dipping, if blood pressure does not fall in the night, rather it increases. It is related with cardiovascular events. And there is one more, morning surge. The blood pressure normally slightly increases early in the morning, but it remains throughout the day. Then it is a morning surge, and it is also responsible for cardiovascular events. This is a very simplified classification of hypertension risk, and hypertension mediated organ damage risk. Since it is there is a time constraint, I'm not going to talk about this, but that is very easy and you can copy it, you can take a picture of it and can keep on your table either no risk, 1 to 2 risk, 3 risk, or HMOD or CKD or grade 3 diabetes, and high normal, grade 1 and grade 2, and risk according to them. The Indian guidelines I have compared, and they are also the same in the Indian guidelines. The assessment of detect hypertensive mediated organ damage, brain, heart, kidneys, arteries, and eyes should be assessed. In essential evaluation of HMOD as routine in patients with hypertension, serum creatinine levels and GFR, dipstick urine test, and 12-lead ECG. In optimal serial assessment of HMOD, left ventricular hypertrophy and albuminuria, to monitor regression with antihypertensive treatment, to determine the efficacy of treatment in patients with hypertension. So this is also for the first time it had been added that you can know the progress or whether there is a benefit of the treatment, to monitor the benefit of the treatment with the pharmacotherapy. The exacerbators and inducers of hypertension should be screened because they are the drugs or substances which can increase blood pressure. These are so we are going to treatment. Now, non-pharmacotherapy treatment, lifestyle intervention for BP reduction. This I have taken from Hypertension Society of India, because weight reduction, DASH eating plan, dietary sodium restriction, physical activity, and alcohol abstinence, tobacco abstinence they can decrease blood pressure, 20 millimeter of mercury systolic and up to 10 millimeter of diastolic blood pressure. What is DASH diet? You know, it is rich in fruits, vegetable, low fat and dairy products, and eat less saturated and total fat. So it should be the first line of prescription when you write a prescription for a hypertensive patient, that lifestyle intervention of BP are very, very important, and even you may not need any tablet or any pharmacotherapy treatment if you decrease your blood pressure with lifestyle interventions. So the pharmacotherapy treatment of hypertension with the ISH guidelines, international guidelines, very, very easy. If a person suffering from hypertension, advise lifestyle advice, and if lifestyle advice does not work, if BP remains 140, 159, then start treatment with high-risk patient and those with CKD, CVD, and diabetes mellitus and HMOD. Now, if there is an essential part, then if there is a limited drug availability, then prescribe lifestyle modification for 3 to 6 months, and if blood pressure is not controlled, then start treatment. And in optimal, drug treatment in low to moderate risk patients without CVD, CKD, diabetes mellitus, and HMOD for after 3 to 6 months of lifestyle intervention. If BP does not fall, then start treatment. In grade 2, when you know that blood pressure is more than 160, 100 in spite of lifetime advice, then immediately start the treatment. So it is a very, very easy slide. And pharmacology therapy treatment of hypertension in essential target BP reduction by at least 10 to 20 millimeter of mercury, ideally less than 140/90. In optimal, if age is 65 years, then BP target should be 130/80. If one can tolerate, then otherwise you can keep, if one can tolerate, 120/70. And if age is more than 65 years, BP targets can be put as 140/90 if one can tolerate. But the most important thing for all of us, that individualized BP target in the context of frailty, independence, and likely tolerability issues are there with all those who have got age factor.
GD, have we lost Dr. KK Parikh?
I think it's not audible.
Yeah. Can somebody call Dr. KK Parikh?
should go ahead with his second talk when Dr. Parikh joins. He will complete his talk. Jawagis, did you talk to Parikh?
I think Dr. Sumit, we should move on with the other talk as Dr. B.B. Thakur was talking. I believe let's move on to the other speaker, I believe.
Can you go for another talk? Am I audible?
Yeah, very much.
So can you go for next speaker?
Yeah, no problem.
I think we should move on to the next.
Now I would like to invite Dr. Marunathan sir for his talk. Dr. Marunathan is governor of the American College of Physicians. He is ex-emeritus professor of Tamil Nadu, Dr. MGR Medical University, Dean Indian College of Physicians, President of Hypertension Society of India from 2015 to 16, past President Association of Physicians of India 2013 to 2014, past President Tamil Nadu IMA, past Dean IMCGP, editor of Adult Immunization 2014, Progress of Medicine 2017, Medicine Update 2013 to 2017, Manual of Hypertension 2015 and 2019. Awards, he received many awards like PC Rai Awards from President of India in 2005. He received Best Performance in Doctor Award from Tamil Nadu government on Doctor State 2014. received Lifetime Achievement Award by TN, Dr. MGR Medical Savitar Medical University, KG Foundation, Dr. Mohan's Diabetes Foundation, and Indian Society of Hypertension. Over to you, Marunathan sir, please. I think Marunathan sir is not audible.
No, he was very much there.
He's not audible, I think.
You need to unmute yourself, Muruganathan sir. You have to unmute yourself. You are not audible, sir.
Can you hear me now?
Yeah.
Yes.
No.
Yeah. Okay. Can you allow me to share the slides, please?
Is allowed, sir?
Enable me to share the slides, please.
Sir, it's allowed. You
It's
can
allowed
share.
only. You'll have to go down to the screen and there is a share screen option, sir. That is all.
Mangesh, don't teach me, man. I know.
I am aware, sir. I thought that,
No. This is okay. Talk. I'm going to talk on pharmacological management of hypertension in different conditions. Of course, I have nothing to declare at the outset. Is the slides are very visible?
Please do it full.
Yes, sir.
Please do it full screen, sir.
Okay. Is it okay now?
No, sir. Yes, sir. Now it's okay. Yeah.
Okay. The treatment and control of hypertension in 2020, there's a big article in JAMA, says need for substantial improvement. And in the midst of the worldwide COVID-19 pandemic, in which elevated blood pressure level is a major comorbidity, it is especially important that clinicians and healthcare systems not to be complacent about the control of hypertension. I'll come to the pharmacotherapy because I don't want to waste time on non-pharmacological. Already KK Parikh was mentioning. Except one more thing, a good sleep is also good for reducing. When you control the hypertension, you must think four things. You should first rule out secondary causes, which is a curable form of hypertension. Then think for associated risk factors or target organ damage or concomitant disease and conditions. So when there is no compelling indication, there are 5 classes of drugs we can use in the absence of compelling indication. If there is a compelling indication like associated risk factors or target organ damage, the treatment is individualized. This is the guideline in 2018. They only mentioned beta blocker. Many guidelines, they don't mention beta blockers as the first line treatment. The ESC has said 5 drugs: ACE inhibitor, ARB, beta blockers, CCB, and diuretics. And normally, if there is less than 55, we prefer A or B, that is ACE, ARB, or beta blocker. Above 55, diuretics and CCBs. And this is the optimal which he was mentioning. The 2020 international guidelines said even for the first incident, you should start low dose of combination, like half tablet, then 1 tablet, then 2 tablets. And specifically, if there is a monotherapy in low risk cases, A and D in post-stroke and very elderly and incipient cases. Consider A and C or D in black patients. This is what international guidelines are saying. But the choice of drugs generally is ramipril, perindopril, ARB, telmisartan or valsartan and losartan, calcium blockers, amlodipine, benidipine also shows some promise, diuretics, chlorothalidone, indapamide, beta blockers, bisoprolol, metoprolol, carvedilol, and nebivolol. I come to 1, HMOD, hypertension mediated organ damage. When there is electroventricular hypertrophy, the choice of drugs is ACE and ARB, CCB. Indapamide also is useful. Vasodilators like hydralazine, minoxidil can increase LVH, so you should avoid that. And then beta blockers with hypertension, heart CAD, beta blockers, RAS inhibitors, irrespective of BP levels, with or without calcium channel blockers, are the first line drugs in hypertensive patients. Metoprolol, carvedilol, bisoprolol, ramipril and perindopril, and amlodipine and nitrates can be used, but direct vasodilators are not indicated. In a hypertensive cardiac failure, hypertension is a risk factor for the development of heart failure with reduced ejection fraction and with preserved ejection fraction. Carvedilol, metoprolol, long-acting, bisoprolol, ARNI and ACE or valsartan, aldosterone antagonist and loop diuretics in the Hypertension with preserved ejection fraction also the same drugs as above. Only things contraindicated is verapamil, diltiazem, and older beta blockers. Hypertension with stroke, the BP should be lower if more than 140/90 and treated to target less than 130/80. RAS blockers, diuretics, CCBs are first-line drugs. Periendopril, indapamide, and amlodipine can be tried. The progress trials, there is a secondary prevention evidence in the form of ACE inhibitor and indapamide, the secondary prevention of stroke. Then chronic kidney disease, the target is 130/80, and chronic kidney disease we use ACE, ARB, if ACE if is not tolerated. Additive therapy, thiazide diuretics, if the eGFR is more than 30. Alternatively, volume overload, loop diuretic, metalazone can be given. Other agents, if ACE or ARB can't be used, calcium blocker, alpha blockers, and hydrazine and clonidine. Definitely ACE and ARB not indicated when there is a bilateral renal artery stenosis. If the albumin creatinine ratio is more than 30 or urinary protein is more than 500, if the creatinine increases from the baseline more than 30%, potassium more than 5.5, if the eGFR falls below 20, you have to reassess. The monitor sodium, serum potassium and creatinine carefully in patients with CKD, prescribe ACE and ARB. Combinations of ACE and ARB are specifically not recommended in the absence of proteinuria. I've completed the HMOD, now I go to the risk factors. In diabetes, when the patient has got albuminuria, all the guidelines says ACE and ARB should be given. If there is no albuminuria, you can give any one of the 5 drugs which I mentioned. If there is a albuminuria, first you give ACE ARB. If BP are not gold, add calcium channel blocker and diuretic. If still BP are not on gold, you can give beta blocker, preferably carvedilol in a diabetes. If still not at gold, alpha blocker, aldactone or clonidine. If the patient has got cardiovascular disease along with diabetes, you have to give ACE inhibitor with carvedilol. And if there is no improvement in the BP, add calcium channel blocker and same thing, alpha blocker and clonidine if there is no improvement. Lipids, there is no specific drug for lipids. BP should be lowered as done in the general population, preferably with RAS inhibitor and CCB. Beta blockers, carvedilol and bisoprolol can be given. They are lipid neutral. Diuretics, indapamine, especially elderly, we can do. Statins are the best lipid lowering treatment of choice with additional BP lowering. Avoid older beta blockers and thiazides. If the patient is using tobacco or smoking, don't give beta blocker as a first-line drug. Dihydropyridine, CCBs and ARBs. The benefit of treating smokers with beta blockers remain uncertain in the absence of a specific indication like angina or post-MI. Unless compelling indication, beta blocker need not be started in a smoker. Then angiotensin inhibitors, high incidence of CAD, and best drug is ACE inhibitor ARB. In a salt non-sensitive, the angiotensin inhibitors, beta blockers may not be effective. The amlodipine, carvedilol, bisoprolol can be tried. And in the erectile dysfunction, the calcium channel blocker, ACE inhibitor, ARB, the preferred ARB in erectile dysfunction is valsartan. The beta blocker, if you have to give, bisoprolol and nebivolol if there is a compelling indication. Otherwise, calcium channel blocker can be given. Avoid atenolol, metoprolol, propranolol, and thiazides in erectile dysfunction. Erectile dysfunction is not only emotional dysfunction, it is an endothelial dysfunction. So you'll have to give drugs which are vasodilating beta blockers. Sleep apnea, obese hypertensives, angiotensin inhibitors, aldosterone inhibitors have specific role. Always look for sleep apnea in refractory hypertension. When the AHI index is more than 15, CPAP may be helpful. You can avoid beta blocker unless there is no compelling indication. I finished HMOD, now I come to comorbid conditions. The comorbid condition, I first take uric acid. Uric acid, losartan can be added to a module because this has got a first thiazide, enters the proximal tubule cell and then is exchanged with uric acid driving the reabsorption of urate. So the ideal drug for if you want to give any ARB, you should give losartan in hyperuricemia. When somebody has got HIV/AIDS, then you will have to think about the drugs which may react with the protease inhibitors, which may react with antihypertensives. So candesartan, irbesartan, olmesartan do not have any problem. Even the beta blockers like metoprolol, no problem. Other drugs may have same metabolized through CYP 450. So you must be careful. Inquire about the HIV drugs and then suitable drugs should be given. Then hypertension, pulmonary problem, COPD. There was a hypertension, a patient dying in the COPD is mostly due to hypertension and cardiovascular disease. Though it is COPD, patient dies of CVS and hypertension. So BP should be treated to target of less than 130/80, and preferred drug is dihydropyridine, CCB, ARB. Bisoprolol, nebivolol, if there is compelling indication. Even the beta blockers can be given in a COPD if there is a compelling indication. So best drug in beta blocker is bisoprolol, nebivolol. Otherwise, calcium channel blocker, ARB can be given. Avoid the first-line beta blockers and diuretics. The patient is using NSAID, try to avoid NSAID. If they are using calcium blockers, are the best drugs to choose. ACE inhibitor may not be maybe less effective if the patient is using NSAID. In the case of rheumatic disorders or psychiatric disorders, you'll have to choose proper drugs. CCBs are good, but in the rheumatoid and rheumatic arthritis, biological drugs you can replace with NSAID. In the psychiatric drugs, avoid CCB because it may produce orthostatic hypotension if you are using SRIs in antipsychotic drug. Then coming to combination. You have heard about combination already. Everybody know every guidelines, including our Indian guidelines, says you have to give combination. If you see telmisartan 40 milligram alone, it is 6.9. If you use telmisartan 80, if you increase the optimal dose 12.2 only. But in case if you are giving the other drug telmisartan with hydrochloride, the effect is 18.8. Same way, valsartan alone is 12.6. If you add hydrochloride, it's 16.8. So combination therapy is always good. You know this basic physiology. The blood pressure is cardiac output into total peripheral resistance. The blood pressure, the cardiac output can be increased by preload and contractility. The TPR is vasoconstriction and vascular hypertrophy. So diuretics can reduce fluid volume. Beta blockers reduce contraction. Calcium blocker improve the peripheral vascular resistance and the angiotensin. So the principles of combination, different mechanisms, cardiac output and peripheral resistance, same mechanism, different pathway, or same mechanism, same pathway. This is a different mechanism, beta blocker and calcium blocker combination. Beta blocker, angiotensin blocker, diuretic and angiotensin inhibitor. And this is the same pathway, different same mechanism, different pathway. You can use beta blocker and diuretic, calcium blocker, angiotensin, calcium blocker and alpha blocker. And this is the same mechanism, same pathway. You combine diuretics, thiazide diuretic with other diuretics. So you can start even in a CAD, beta blockers and ramipril. LV for LV dysfunction, specific beta blocker, you must give ramipril. Heart failure, specific beta blocker, ACE and aldosterone inhibitors. In diabetes and CAD, carvedilol and ramipril. Stroke, ACE inhibitor, indapamide. Heart failure, renal failure, if ACE intolerance, hydrazine and nitrates can be given. So nowadays, as I said, all the guidelines recommend combination therapy. So you can start even international guidelines, what Dr. Parikh was alluded to. You have to start a drug like telmisartan 40 milligram and amlodipine 5 milligram, take it as a tablet. First visit, give off tablet. The best combination is ARB with calcium channel blocker. And if there is no control, give one tablet. And then if there is no control, second 2 tablets. So combination, you can try straight away, especially depending on the condition. If it is a coronary artery disease, beta blocker, ramipril. If it is LV dysfunction, specific beta blocker and ramipril. Heart failure, again, specific beta blocker and ACE inhibitor. And diabetes, carvedilol and CCB can be given. Then combination therapy to be avoided, beta blockers and diuretics to be avoided, ACE and ARB to be avoided, beta blockers and clonidine because of the bradycardia, beta blockers and non-hydroprotonine bradycardia, beta blockers and ACE or ARB in simple hypertension, ACE, ARB and aldoanticonins in hyperkalemia. So there is always that discussion whether to give morning or evening. A lot of discussion are going on. Usually the beta blockers, diuretic can be started in the morning. And then nighttime, ACE and ARB, because HOPE trial and all has proved that ACE inhibitor in the nighttime is good. First, do no harm. This is the drugs non-selection. What are the drugs you should not give in the hypertension? In the compelling indication, if there is a gout, you should not give diuretics. And then beta blockers in asthma, any high-grade sinoatrial, especially first group of drugs, any high-grade sinoatrial block, bradycardia, calcium channel blocker, there is no compelling indication, compelling contraindication. Of course, tachyarrhythmia and heart failure, you may think is possible contraindication. The other drug, calcium channel blocker, verapamil and diltiazem, it produces a high-grade sinoarterial block, severe LV dysfunction, you should not give, bradycardia, and possible contraindication is constipation, ACE inhibitor in pregnancy, and hyperkalemia, same way, pregnancy and hyperkalemia. Then the secondary hypertension, the drug should be avoided is CKD, you avoid atenolol. In renal artery stenosis, ACE and ARB to be avoided. Obstructive sleep apnea, beta blockers and sedatives. Primary hyperaldosteronism, thiazides and loop diuretics. Alcohol, there is no drug which you can take and then take alcohol. My advice is stop alcohol. Drugs avoid NSAID, COX-2 inhibitors, pheochromocytoma, alpha blocker and then beta blocker. Beta blocker primarily we don't give, only with alpha blocker we give. Hypothyroidism, beta blockers and CCBs avoided. Hyperthyroidism, CCBs and alpha blocker. Cushing syndrome, beta blockers is to be avoided. Hyperparathyroidism, thiazides. Ladies and gentlemen, I rushed because Greece Mathur requested me to finish in 15 minutes, and already KK Parikh also, because of that there is some time wasted. So I rushed Greece with your request. And Sumit Garg, you should understand, I have to talk very slowly, but as I have to finish fast, I rush through. But my drive home message, whether you understand what I said, pharmacotherapy, but at least this drive home message, everybody must do. Mangesh Tivaskar always knows that I always be fond of talking these things. Whenever you have a hypertension, so your clinic, buy 3 different cup size in your hypertension clinic. Validate BP monitor. If you cannot validate regularly, buy new BP monitor. Promote home blood pressure monitoring. Start hypertension clinic. I am always fond of promoting this. Always I request every physician to focus on hypertension. Just like you are focusing on diabetes, you should focus on hypertension. I see everybody is fond of talking about hypertension, diabetes, SGLT. So many trials everybody knows. But in hypertension, many people don't focus and they don't even look at the normal BP monitors. So validate the BP monitors, buy different cup size and promote hypertension clinic. I congratulate the Rajasthan Epicon, Greece Mathur, KK Parikh, my chairperson Sumit Garg, and all our good friends for the wonderful opportunity for me. But unfortunately, I'm not able to visit Rajasthan. I'm only seeing you virtually. All the best. Thank you. Happy New Year. And we'll have a safe and healthy 2021, COVID-free. Thank you, sir.
Thank you, Dr. Munathan, for the wonderful talk. And thanks for joining.
Now we would be starting with our next session. I invite Dr. B.B. Thakur sir, a very senior, humble and dynamic pearl of API. He has been a chief consultant at Healthcare Center Muzaffarnagar. He is a professor and head Department of Medicine, SKMCH, Muzaffarpur, Bihar. He had been the past president, Association of Physicians of India. He had been the past dean of ICP, had been past president at the Hypertension Society of India, edited many medicine updates and postgraduate medicine during Epicons, has more than 125 publications. He has delivered many orations and more than 200 lectures. He has also received the prestigious Dr. V. Parmeshwara and Dr. Jivraj Mehta Lifetime Achievement Award. I now invite Dr. B.B. Thakur sir to please start this session.
Good afternoon, friends. At the outset, I would like to convey my deep sense of respect and regards to the organizing team, especially Dr. KK Parikh and Dr. Mathur, for having allowed me to participate in this prestigious session. I thank the chairman for a very elaborate introduction of me.
I will try to finish in 15 minutes as per the orders of Greece Mathur. Although the preparation was for 20 minutes, no problem. You are already aware of whatever I'm going to tell you. Friends, the association, I have been asked to talk on sympathetic overactivity in hypertension. Friends, we already know that for the last nearly 1 century, or slightly less than 1 century, since then we know that these two are associated with each other. Sorry, yeah. They are associated with each other. So the sympathetic nervous system plays a crucial role in cardiovascular homeostasis that we know beyond doubt. Through its action on heart rate, its contractility, neural modification of venous capacitance, arteriolar resistance, and fluid volume, it controls our regional blood flow in health and diseases that we know. It was the Thomas Willis who was first to say the anatomy, come out with the anatomy of sympathetic nervous system in year 1664. Then this efferent sympathetic nerve was vasomotor fibers as efferent sympathetic nerve was identified in 1840. And they were subsequently identified as pressure nerve. And in the early 20th century, we wanted to control this hypertension by doing thoracolumbar sympathectomy. And thereafter, few drugs also came, and many of them, it worked, but it had a lot of complications, especially profound hypoglycemia. In 40s, the ganglionic blocking agents came out, and they replaced the sympathectomy until the era of inhibition of the RAS, the central sympathetic inhibitors like clonidine, reserpine, alpha-methylidopa, and it was followed by alpha and beta adrenergic receptor blockers. They were the main drugs for the treatment. And these historical backgrounds, because all were directed towards controlling the adrenergic activity, and these provided evidence for dominant work of SNS over the hypertension. Sympathetic activation is common in patients with essential hypertension, and it contributes to its initiation, maintenance, and progression of the disease. It has been investigated for a long time, both in experimental animals and humans, and finally it has been agreed upon that it is the reason for that. Normotensive persons with family history of hypertension also show greater rates of norepinephrine spillover and decreased norepinephrine uptake than those compared to without family history of hypertension. In approximately 50% of all cases of essential hypertension, the cause is neurogenic. And there are many other causes also, but in around 50%, it is neurogenic. We are already aware of this RAS system, sympathetic overactivity. This activates the RAS system, which leads to hypertension, electrical instability, heart failure, left ventricular hypertrophy, tachycardia, dyslipidemia, vasoconstriction, insulin resistance, atrial fibrillation. We are already aware of it, and it also stimulates coagulation, atherogenesis, and finally, it does acute coronary syndrome or acute syndromes. There is a direct correlation between the central sympathetic activity and a stage of human hypertension. You see, from normotensive to the different stages of hypertension, MSNA goes on, is higher and higher. Sympathetic activity per minute is more in those patients who have got stage 2, 3 hypertensions. and this has been also proved in this slide also. Then in resistant oblique refractory hypertension, sympathetic overactivity is more pronounced as compared to the other class of patients. I should say essential hypertension. However, in resistant hypertension, the fluid volume is also more. Due to its multifactorial origin, there are several underlying conditions that lead to this phenomena. And it has also been found that older age group, high baseline BP, obesity, excessive salt ingestion, and chronic kidney disease, they do not allow the refractory or essential hypertension to be controlled easily. And the fundamental basis is this, that in all these conditions, the sympathetic overactivity is there. You can see this nerve, the artery here, it is thickened, and here it is not thickened because of the sympathetic overactivity. The sympathetic overactivity is also there in all the conditions, in heart, in diabetes, in diabetes, in obesity, in hypertension, all the metabolic syndrome, in all the features of metabolic syndrome, sympathetic overactivity is a feature that we already know of it, and it has been incidentally these are covered. According age and SNA, according to several studies, whole body sympathetic neural activity increases with aging. As you grow in age, your sympathetic activity increases. Age and muscle sympathetic nerve activity are associated in normal subjects, presenting increase in MSNA, whole body NES spillover, and plasma NE levels. So therefore, as you know, with aging process, there is a thickening of the epithelium and endothelium and rise in blood pressure. There is a well-established relationship between salt intake and SNS activity. Obesity, metabolic syndrome, and SNA are directly correlated. In obesity, through RAS activation, through increased leptin, OSA, increased SNS activity, insulin resistance, hyperinsulinemia, and they finally lead to a structural effect. There is vasoconstrictions, sodium retention, and increased cardiac output, and through all these intricate mechanisms, it leads to hypertension. We already know that there is a clear-cut correlation between acute stress and SNS, and it has also been seen many times that due to acute stress, sudden death can also occur. It leads to two types of problems. It has physiological effects and clinical consequences. Heart rate rises, BP rises, vasoconstriction is there, pro-arrhythmogenic potential is there, worsening endothelial function, endothelial injury, platelet aggregation, etc., leading to myocardial ischemia, arrhythmia, more vulnerable plaque is there, potential for thrombosis. If it is acute state, if it is temporary, then these will come and go. You can manage it. But if this stress continues for a longer time, then it plays havoc. Sleep apnea and SNS, we all have observed that obstructive sleep apnea is associated with increased SNA and is linked to heart disease. We also have experienced that if you manage sleep apnea, then the blood pressure is controlled. Type 2 diabetes, obesity, OSA, and SNA are good friends. Sympathetic overactivity, insulin resistance, and diabetes mellitus, it has been found that sympathetic activation is a major component of insulin resistance, and in clinical experiments and in humans with type 2 diabetes, it has been found that cardiac autonomic dysfunction occurs in 30 to 50% of patients with diabetes, 40% of obese patients without diabetes. And we also know that there is a disease known as sudden cardiac death, silent cardiac death, and microvascular problem, and that is all because of these regions. And we can assess the increased energetic activity in humans through heart rate and heart rate variability, blood pressure variability. We can measure the neurotransmitter levels. We can have bioreflex sensitivity testing, cardiovascular reflex evaluation, and microneurography, muscle sympathetic nerve activity. And through all these means, we can check the level. Now, how do we manage this increased sympathetic activity? As I told you, in 30s to 40, sympathectomy was done. Then came the ganglion blocking drug, reserpine, which is not in use nowadays. Then came the alpha-methyl-dopa, guanethidine, propranolol, clonidine, prazosin, and atenolol. And in 90s to 95, monoxidine, rilmethidine came. And then the trial was given for device-guided breathing. And then came carotid body ablation, median nerve stimulation, renal denervation, and baroreceptor activation therapy, of which you are known. Modulation of SNA is very much important. There are very limited drugs to modulate it. In the late 40s, as I told you, there was some drugs. The sympathectomy was there. Then the drugs came out. And most recent sympatholytic drugs has been the imidazoline, one receptor agonist like minoxidil and rilmethidine. And this is where it works. It works. Sympathetic tone is regulated centrally in the rostral ventrolateral medulla, and this is where it works. And this region has got imidazoline, one L1 receptor, and alpha-2 adrenoreceptors, which is controlled by this. Then we have some device therapy also for modulation of SNS, like renal denervation, baroreceptor activation therapy, carotid body ablation, device-guided breathing, and median nerve stimulator. These are the methodology. And we already know that if there is an impulse from here, it not only affects the arterioles, it affects heart, it affects kidney, and then renin release, RAS activation, sodium retention, renal blood flow, kidney function. So if we could control these activities of kidney, then possibly the blood pressure could be controlled. And with this philosophy, this kidney, the renal denervation came out. Afferent and efferent renal sympathetic nerves are intimately linked with the pathophysiology of hypertension. We are already aware of that. And increased activity of efferent nerves causes a reduction in the renal flow and glomerular filtration rate, and there is upregulation of renin secretion, increased sodium and water reabsorption. We know that, and that is why then renal denervation was tried, and it was ultimately found that in this simplicity is hypertension trial 3 proved that it's not of that worth. And there are 3 different methods: radiofrequency, main renal artery ablation, radiofrequency, main and branch renal artery ablation, and ultrasound guided renal artery ablation. Endovascular ultrasound based renal denervation is also tried, but till date, definite recommendations regarding the preferable renal denervation approach is not there. Then we also know that there is a BAT therapy, baroreceptor activation therapy, and this is where we try baroreceptor activation leads are applied here, and implantable pulse generator is there, and this is how it works, and this is how the RIOJ system works. I will not go into the details of it, and it has been found that yes, it reduces the blood pressure substantially, but not up to the but on 6 months to 1 year interval, it's not substantial. Then there is another way of treating central arteriovenous anastomosis is done, and this also reduces the blood pressure to some extent, but it is not also in vogue, and this is where the blood pressure reduction is there, systolic and diastolic, as compared to the control group in arteriovenous anastomosis. Then other invasive procedures like carotid body ablation, median nerve stimulator, deep brain stimulation, and vagal nerve stimulation are also there. Carotid bodies are located at the bifurcation of the internal and external carotid arteries, we know, and then it is here that it is carotid body lying, and this is how it is treated. But this too is not in use for the majority for management of patients. A proof of concept study for unilateral carotid body dissection was conducted involving 15 patients with resistant hypertension. At 6 months, there was no significant change in either office or ambulatory blood pressure. However, 8 patients who responded had decrease in daytime ambulatory blood pressure of 26 millimeter mercury originally. Then there is another way to control the sympathetic overdrive, and that is through median nerve stimulator. And this is how this unit is applied, and it is stimulated, and it possibly works. There are some alternative approaches like acupuncture, yoga, shavasana does wonder. Then pranayam, basically Savitri pranayam. Fundamentally, what you want the sympathetic overactivity to be calmed down, and yoga is known to calm down, savasana is known to calm down, pranayam is known to calm down, dhyana is known to calm down the sympathetic overactivity, and it may not work in a patient who is suffering from resistant or refractory hypertension, but it does work in patients who are mostly of essential hypertension. Savasana, pranayam, especially Savitri pranayam, this is a pranayam in which you give a slow rhythmic breathing. And device-guided slow breathing is already a known methodology. Transcendental meditation is very important, and this does help. Isometric hand grip is also applied to calm down, and then improving sleep quality, as referred by Dr. Muruganathan, that sleep quality, if sleep quality is bad, then no drug is going to work, and the stress management is very important. We have to manage stress, and if you manage stress, then you manage many diseases. So, to conclude, friends, the sympathetic nervous system is an important contributor to hypertension, particularly resistant and refractory hypertension. I say particularly because in that case it is of drugs from different along with diuretics are currently available. Innovative therapy using non-pharmacological means to modulate the sympathetic nervous system are being actively studied to treat resistant hypertension or refractory hypertension. However, more data is needed before we adopt novel treatments. Till date, it is not accepted for routine therapy. Further tests and trials are needed to identify patients who could respond to this therapy and which device is important for them, as well as reliable biomarkers for the procedures. Lastly, data on the long-term effects on cardiovascular morbidity and mortality for these methodologies are needed. Till then, we have to depend on the drugs and the other, say, holistic approach to management of hypertension. I wish you that you should keep smiling and be at pace. This corona tunnel is going to end, as any tunnel after a certain time has a light. So we are going to have light in 3 to 4 months' time. I wish you to be safe, stay safe, be healthy, happy, and for coming years and years to come, I wish you a very good luck, good time. Thank you very much for your patient hearing.
Thank you, sir. Thank you very much, Dr. Baby Thakur. Our sincere thanks to Dr. Preetam Gupta, Dr. Saurabh Chittora, and Dr. Sumit Garg for sharing hypertension update, and my sincere thanks to Dr. K.K. Parikh sir, Dr. Muruganathan sir, Dr. Baby Thakur sir. Now it's time to over to the organizers for the hypertension symposium. Thank you, sir. Thank you very much.
Dr. S.K. Goyal is here as a chairperson.
No, sir. Dr. S.K. Goyal has been replaced by Dr. Manoj. Dr. Pradyuman?
Pradyuman? Yes. Dr. Pathan?
Hello.
Dr. Pathan, are you there?
Sir, S.K.
Dr. Pathan, are you there? Dr. Pradyuman?
S.K. Goyal नहीं chairperson.
Dr. Mathur, देखो यार. प्रद्युमन कहाँ चला गया?
Organizers of this wonderful conference, who has done a tremendous job in this difficult COVID era. Next talk is by a teacher of teachers, Dr. Kulpreet Singh Wander. He is the professor and head of cardiology, Dayanand Medical College and Hospital, Ludhiana. He had been the president of the Association of Physicians of India for 2016-17, ex-president of Hypertension Society of India 2012 and 13. He had been awarded by Dr. B.C. Roy National Award for year 2006. He had been the editor of cardiology section of API textbook of medicine, 8th, 9th, 10th and 11th edition, and awarded V.R. Joshi Japi Award for outstanding referee. Now I'll invite Dr. G.S. Wander to deliver his talk on BP measurement and evaluation. Dr. G.S. Wander, sir.
Thank you, Dr. Mukesh, for this introduction. And thank you, Dr. Parekh, sir, Dr. Girish Mathur, Dr. Ramchandani for giving me this opportunity to speak in this symposium, which is actually, it's a great honor for me to speak in a session which is, we are going to have actually my mentor, Dr. Siddharth Shah and Dr. Venkatram in the faculty, and my good friend Mangesh is going to be there. So the task assigned to me is to just talk actually about the basics of blood pressure measurement and evaluation, because friends, you all know blood pressure measurement is the first skill that we acquire as medical students. And this skill is pretty dear to all of us because we learn how to record blood pressure, use the stethoscope. And then we know historically this was started about 300 years back when Dr. Stephen Hales actually put a needle into the carotid artery of a horse, and it went up to 9 feet, the glass tube. And so the whole era of blood pressure recording actually started. The mercury sphygmomanometers were the first ones about 100 years back. Riva Rocky invented the mercury sphygmomanometer, and Dr. Korotkov actually told us that there are 5 Korotkov sounds. The appearance of the sound denotes the systolic and the disappearance denotes the diastolic pressure. But in the mid-60s, actually in Japan, in an area of Minamata, a lot of people came with toxic effects of mercury because it is an environmental toxin and it accumulated in the lake where the mercury was being discarded, and many neurological, psychiatric and developmental abnormalities were seen. And so the world was awakened to the harmful effects of mercury, which was used in thermometers and sphygmomanometers. Even in our country, 15 years later, actually, Kodai Canal down in south, we realized that mercury was being brought to this country where mercury sphygmomanometers were being made. And in that vicinity of about 20-25 kilometers, lot of people were having congenital abnormalities and neurological disorders. And so mercury sphygmomanometers have actually been discarded world over. We did actually the India heart study recently, and we realized that mercury sphygmomanometers are still being used in about 70% of the clinics across the country, whereas aneroid sphygmomanometer, the spring one, is used in about 1/4 cases. And the most popular device, in fact, the oscillometric sphygmomanometer, which has been adopted world over, is still being used only by 10% of the population. So it is actually quite ironic that we have not shifted according to the shift that has happened world over. And we actually need to now shift from the mercury sphygmomanometer, which we have been using, to either the, I would say, the larger dial aneroid sphygmomanometer or one of the oscillometric digital devices. The problem, I think, in our country is physicians have not developed so much confidence on these digital devices and validated digital devices. I would say it would fall upon the Hypertension Society of India, the Association of Physicians of India now, that we validate some blood pressure apparatuses so that physicians across the country then develop a confidence on those devices, and we are able to shift just as the world is shifting. The British Hypertension Society does this, and they validate blood pressure apparatuses, and so the physicians, the GPs over there, get to know as to how and which one apparatuses they should use. Well, blood pressure recording is the most important actually aspect, because we keep dwelling. We had beautiful talks on hypertension by Dr. B.B. Thakur sir, Dr. Muruganathan, and Dr. K.K. Parekh sir. But the problem is that the amount of time that we spend on discussing what is the best medicine, how much to reduce blood pressure, we actually in real life do not spend that much time on recording of blood pressure. And we did a study which was an ICMR funded study and published in Indian Heart Journal. Although 80% of us and 60% of our paramedics are aware as to how blood pressure should be recorded, the appropriate sized cuff should be used, the person should be relaxing, should not have had a coffee or tea, and it should be covering 2/3 of the circumference.
So we are not able to hear you.
Percent of us actually, and less than 1% of the paramedics have right practices because of the want of time. And it is very important that we record blood pressures accurately, because we would otherwise be falsely actually putting some of our patients, and on the other hand, we will be depriving some patients of hypertension, the benefits of therapy. Now, what are we actually trying to see? We want to know what is the blood pressure of an individual during most part of the day. Even if you don't use ambulatory blood pressure recording, actually this slide of a 24-hour recording does show you actually blood pressure fluctuates about 30 to 35 millimeters of mercury systolic and about 20 to 25 millimeters of mercury diastolic. And what you want to see is the mean kind of normal blood pressure which your patient is having most of the time of the day and the night. So is the clinic blood pressure appropriate? Or do we actually need to use the home blood pressure along with it? Or do we need a 24-hour average blood pressure? Or is it the daytime blood pressure? So that is a kind of a concept we need to form in our mind before we start managing patients of hypertension, so that we do not depend upon a solitary reading of clinic blood pressure and then as a knee-jerk reflex we start putting our patients. But we need to imbibe this habit that we see what the blood pressure of a patient is at this time, give them rest for a period of time, have a second, third. Last week I was reading actually a study in 2020 JAMA, which shows that the fourth blood pressure recording in the clinic was actually more representative and more close to the ambulatory daytime blood pressures. So our endeavor is actually to see what the blood pressure of the person is. And Professor Siddharsha sir will recollect when we came up with the second Indian hypertension guidelines. At that time, we felt that although he's a distinguished diabetologist and they depend upon actually blood sugar home monitoring so extensively, at that time, home blood pressure monitoring equipments were not available in our country. And at the time, in 2009, we said home blood pressure apparatuses are not encouraged. But ever since then, good apparatuses for home monitoring are now available in our country. And just as the Americans say that out-of-office blood pressure measurements are recommended, we as Indian physicians now depend a lot on the home blood pressure recording, because we know even the ESC guidelines in 2013 said office blood pressure is recommended for screening and diagnosis. But recently in 2018 said repeat office and out of office blood pressure with ambulatory and home blood pressure. So all that I'm actually emphasizing at the cost of repetition is that home blood pressure is today an integral part of blood pressure recording. And we have emphasized this. Professor Siddharth Shah sir, who's the architect of the Indian guidelines on hypertension, has actually emphasized that we must depend on the home blood pressure apparatuses which are today available, because they tell us actually what the average blood pressure is. I would like to say here, this is again from our guidelines, that although 140 by 90 is the pressure which we call as hypertension, although the recent American guidelines consider 130 by 90, but leave that aside. Let's come back to 140/90, which is the standard actually definition of hypertension in Indian, in the ISH and also in the ESC guidelines. Now, home blood pressure, when it is more than 135 by 85, is to be taken as hypertension, which is equal to the daytime blood pressure that you do on an ambulatory blood pressure recording. But if you're looking at the 24-hour blood pressure recording, of course, we know 130 by 90, anything more than that. So the value is 5 millimeters less, and keep this in mind when you are looking at actually defining hypertension in the office or in the home or in daytime or 24-hour ambulatory blood pressure recordings. Now, these are four terms which we all not only, I know as physicians, you are all very aware of it, but how frequently are we using them in our clinical day-to-day practices? That is important. Now, true hypertension is when blood pressure is high. When I record in the clinic, my patient goes back home, and even at home, his blood pressure is high. White coat hypertension is at home. The home blood pressure recordings are normal, but when he rushes into my clinic, I don't wait for the requisite 20 minutes. I record the blood pressure. It is coming high because of the white coat effect or because of the rapidity or other factors. Now, masked hypertension is opposite of this. Masked hypertension is when in my clinic I am finding normal blood pressure, but patient is recording high blood pressures at home. And mind you, this gets missed, and this is more dangerous than even sustained hypertension, when actually we have high home and high office blood pressures, which is actually the definition for sustained hypertension. But masked is when in my clinics I am not getting high recordings. And this is actually the India Heart study, which we published actually this year only, which had 18,000 individuals. Blood pressure were recorded by 1,200 physicians. And we found that inter-clinic, two different recordings, there was a 30% variation in the blood pressures. And the home blood pressure and the office blood pressure were significantly different. So all that I'm trying to emphasize here is that single office blood pressure recording, do not depend upon that. Combine with home blood pressure recording, combine with multiple office readings, and combine it with, after having given rest, the second, third, and the fourth readings. Because we know today that white coat hypertension from the India Heart study itself is the prevalence is about 15%, and even masked hypertension is 20%. And the prognosis of masked hypertension is actually as bad or even worse than sustained hypertension patients. So unless we do home recordings, we will be missing these two entities. And so I urge that we do take a recording of these. Now, ambulatory blood pressure, we know, is not feasible in most of the situations. It is a little expensive, but it does tell us the nighttime hypertension. And we all know blood pressure in the night should be less than the daytime pressures by 10 to 20%. But there are certain people who are non-dippers, when the fall is less than 10%, they have a worse prognosis as compared to. Now, hypertensives who are non-dipping have a worse prognosis than hypertensives who are dippers. Extreme dipping is when blood pressures fall more than 20%. We know patients of obstructive sleep apnea, patients who have snoring, patients who have nighttime work activities, they are all non-dippers and they are at a high risk. The India ambulatory blood pressure monitoring study was published in the Journal of Human Hypertension. And in this study, actually 27,000, one of the largest studies ever to have been done from India. And we again showed in this study that 12% prevalence of white coat hypertension and about 20% prevalence of masked hypertension. So masked hypertension and white coat hypertension, and mind you, about 10% patients had only nighttime hypertension, which we know diabetics have more of nighttime hypertension. Their blood pressures are normal at home and in the office, but they only have nighttime hypertension. Now, friends, we actually wrote an editorial with Dr. Venkatram about the methods of recording, whether numbers, because we have become very number-centric. And today we should realize that it is not just the numbers, it is the overall risk of the individuals. Because we, another editorial, we mentioned that since the Western guidelines have now brought the cardiovascular risk prediction as a parameter, and we know the age, the sex, presence of diabetes, smoking, lipid levels, all these make a difference as to how aggressive we have to be in a patient with high blood pressure. So beside accurate blood pressure measurement, we have to be accurate in terms of overall individual's risk for the effects of high blood pressure. So look at the individual in its totality. These are some series of studies which I wanted to share with you. Now, beautifully, it shows that clinic blood pressures have found to be higher than research study blood pressures. Whenever these same individuals were taken actually as part of research programs, because those were done with proper methodologies, there was a difference of 10 systolic and 5 diastolic millimeters of mercury. And this is a study, beautiful study published by Dr. Myers, which shows that when specialists are recording blood pressure, they record much higher pressures. Family physicians take a little bit longer time. Research technicians are more meticulous, and these combine actually are more close to the blood pressure with the automatic office blood pressure apparatus. I know Dr. Kriplani from Bombay actually was using the BP2, which gives a period of couple of minutes of rest, and then the physician does not need to be in the office, and it gives 5 readings and then an average of that. And you can see that the true BP or the automatic office blood pressure apparatus comes closest to the ambulatory daytime blood pressure recording. So we need to actually see as to how we are recording our blood pressures. And these are some of the newer automatic office blood pressure devices which are available. The Welchelen and the Microlight are available in my office. The BP2 actually started from Canada, but sadly it has been withdrawn, although this was the first automatic office blood pressure apparatus. And if you look at actually these studies, it shows that the automatic office blood pressure most closely mimics the ambulatory daytime blood pressure recording, the awake ambulatory blood pressure, whether it is daytime or awake, it's the same thing. So you can see what we are actually trying to look at is shown by the automatic office blood pressure apparatus. And the famous SPRINT trial, which was published in 2015, which has emphasized that the targets for blood pressure control have to be more stringent than what we were doing earlier. We know that the automatic office blood pressure recording was done in the SPRINT trial, and possibly this is the way people are going to go now, because this is said to be the preferred method by the Canadian guidelines. The ESC, ACC, AHA have recognized. We have not yet actually advocated this in the Indian guidelines, because we do recognize these apparatuses are not commonly available. They are expensive, but that doesn't make a difference. We in the Indian guidelines in 2019 do emphasize that this is an upcoming method of blood pressure recording, and especially the kind of hypertension clinics some people are embarking upon. One should have this, because this actually mimics more closely with the awake ambulatory blood pressure recording. Now, I'll just spend a couple of 3-4 minutes on evaluation of these patients. Essentially, the evaluation of these patients with high blood pressure, where you have recorded, it is in terms of you are looking at secondary hypertension, because some people you want to rule out secondary hypertension. And commonest causes of secondary hypertension are renovascular hypertension, renal parenchymal hypertension, endocrine hypertension, primary aldosteronism, and pheochromocytoma. So historically, you have to actually look at if somebody has caffeolate spots, someone has neurofibromatomas, or a thin, lean person with palpitations, with anxious-looking face, fluctuating blood pressure, orthostatic hypotension comes to you, you suspect a pheochromocytoma. On the other hand, someone has hypokalemia, which is not triggered by diuretics, must suspect primary aldosteronism, suspected, do potassium levels, and then do their aldosterone to renin levels. And if the ratio is more than 20:1, suspect it, and then do imaging for diagnosis. Because some of these secondary causes are very important to rule out. Also, not only this, actually, we must keep in mind the white coat hypertension and abnormal recording levels, because at times we are just recording high blood pressures and the actual risk of an individual may not be to that extent. Now, this is a beautiful slide from the Indian guidelines, hypertension guidelines 4. It's not just the blood pressure, it is the risk factors your patient is having, the target organ damage, what they call as the hypertension-mediated organ damage, and the associated clinical conditions. They will all make a difference as to what the risk, a given level of blood pressure. Now, stage 1 is 140 to 160 systolic and 90 to 100, and you keep adding 20 to the systolic and 10 to the diastolic to go from stage 1 to 2 to 3. But it's not just the stage you can see. The risk also depends upon whether hypertension has caused a target. So your evaluation of an individual should be whether your patient has diabetes, patient is smoking, what is the dyslipidemia level, because we know the HOPE-3 trial has now shown that if you put patients of hypertension on statins, they give you significant benefit, even more. In fact, in that trial, even more benefit of rosuvastatin was shown as compared to a combination of candesartan and a diuretic. So suffices to say at this stage that statins are a part and parcel of patient with hypertension who have lipid abnormalities, because you're wanting to hit at the overall risk of an individual and not so elderly people, male smokers, diabetes, those who have family history, central obesity, with high HDL levels, HSCRPs. So all these parameters will tell you that your patient is harboring more than one risk factors. And so you need to be, because ultimately you are actually trying to reduce the target organ damage that this causes, hypertension causes, whether it is in the heart in terms of left ventricular hypertrophy, heart failure, preserved ejection fraction or reduced, urinary abnormal urinary albumin creatinine ratios, which are markers of actually renal involvement, atherosclerotic markers in carotid intimal medial thickness, and of course the ankle. So you are trying to look at the subtle effects hypertension has caused before your patients present with TIAs, cerebral hemorrhages, infarctions, or have overt hypertensive nephrosclerosis, diabetic nephropathy, or peripheral arterial disease. So these are the various target organ damage that occurs because of hypertension, and your evaluation of the patient essentially depends upon where all hypertension has caused damage in your patient. Secondly, what are the other risk factors in your patient? And thirdly, what are the associated diseases? Because we just heard actually from Dr. Muruganathan that your drug choice is significantly altered by the other associated diseases your patients have. As I said, almost 90% of hypertension is essential or primary, but we do know that we have to recognize and diagnose some of these conditions, because some of them can be surgically actually corrected, whether it is primary last month we had a patient of primary aldosteronism, wife of a hospital employee actually of ours, where we diagnosed an adrenal adenoma, and then this patient was operated. Of course, coarctation of aorta, feel the pulses. Drugs are a very, very important aspect, because sometimes just alcohol somebody is taking, or amphetamines, or non-steroidal anti-inflammatories, steroids, cyclosporin, erythropoietin, yohimbine, all these things can make blood pressures rise. And I would end here by my last slide. Actually, office blood pressure, home blood pressure, ambulatory blood pressure, all three can and they should be used for evaluation because we are trying to have an overall evaluation of our patient. Secondly, I would say we need to have an idea as to what is the usual blood pressure of an individual rather than depending upon the single. And not only that, we need to look at the person in totality. And besides the level of blood pressure, we need to look at the risk factors, the damaged organs, and the associated diseases, because all that will determine how aggressively and what agents we use for management of hypertension. Thank you.
Thank you very much, Dr. Gurpreet Vanda sir, for that very comprehensive and enlightening on hypertension and their significance. You told of blood pressure, home monitoring, and ambulatory monitoring as well. I request the chairpersons to take over if there are any questions. I think. Okay, I think as there are.
We have got a lot of time. I think we'll be discussing panel discussion, so you can invite.
Fine, sir. So I request now the next chair.
Introduce Dr. Venkatram.
Yeah, Dr. Pathan, kindly introduce Dr. Venkatram, sir.
Yes, madam. Thank you. Professor Sriram Venkatram is a MD, MSCP, FSCC, FASH, Director, Apollo Institute of Blood Pressure Management, and Professor, Apollo Medical College, Director, World Hypertension League, Professor of Clinical Medicine, University of Texas Southeastern Medical Center, Director, Texas Blood Pressure Institute of Dallas, Dean, McQueen University Medical School, Sydney, Australia. He is graduated from the Osmania Medical College, Hyderabad, and trained at Brown University, Provinces, USA, and University of Pennsylvania.
Yes.
He is faculty of University of Texas, Southeastern Medicine. He is a director of hypertension clinic at Parkland and St. Paul's University Hospital, Dallas, USA. Extensive and lifelong career for the clinical equator and researcher in hypertension. Founder member of American Society of Hypertension.
Dr. Pathan, Dr. Venkatram hardly needs an introduction. Please brief and go ahead.
He is a very excellent and very wonderful person, and he is a very experienced person. I called Professor C. Venkatram. Please deliver his talk.
Thank you very much. Let me see if I can share the slides. Just hold on. Yes. Let me go to the slide show. Just hold on. Ladies and gentlemen, good afternoon. Greetings to all of you, and my very best for the continued success of the conference. Really, I looked at the breadth and length of the conference. I offer my respects and deep appreciation for the organizers under the leadership of Dr. Parikh to make this happen in such a wonderful fashion. And I'm saying it, as I say it, man ki baat, heart to heart. Non-political, but man ki baat. Having said that, my role is continuation of the theme that is already set by Dr. Parikh, Dr. Muruganathan, Dr. Wander on certain aspects of hypertension. I am going to speak about nocturnal hypertension, which is not a separate entity. It is a continuation of daytime hypertension. But when people have blood pressure at night, when they're asleep, it is one of the most dangerous phenomenon in human health. Because when you sleep, you are disconnected from the world. you're disconnected from your vision, you're disconnected from your hearing, and you're disconnected from your mental attention to worldly things. When you're so much disconnected, your blood pressure also should be disconnected from the society. But in some people, they are asleep, but the blood pressure is awake. And that is a phenomenon that is very, very significant and very dangerous. And let me discuss that. This is something that Dr. Wander has already shown, that about the 24-hour blood pressure pattern, that during sleep, the blood pressure is supposed to go down by about 10%. These are the numbers for averages of ambulatory blood pressure monitoring if you do it. I know that most of us, myself included, we don't do ambulatory blood pressure monitoring as much as we should. But if you do that, the nighttime blood pressure should be less than 115/65 at nighttime. So when you're asleep, the average blood pressure at nighttime should be less than 115/65. Any elevation above that only indicates significant hypertension. We don't do nighttime blood pressure in most people, but if we do, then the blood pressure should be less than 115/65. That is physiological. Now, what happens when people talk about sleep BP? Be aware if the patient is really asleep, because there are many people who work at night. And if you do ambulatory blood pressure monitoring, you're not really taking their sleep BP at all, you're taking their nocturnal blood pressure. And there are many people who don't sleep soundly for whatever reason, so you're taking the blood pressure during a disrupted sleep. So when people talk about the sleep BP, you have to have some idea that the patient is actually asleep and not awake most of the time. Now, nocturnal hypertension, I mentioned to you the definition. If you really take it already, that is nocturnal hypertension. The thing is, although we recognize nocturnal hypertension, we still do not know how to treat it properly. There are some indications that giving the nighttime medication might be helpful, but there are not that many studies. Believe it or not, there are only 2 studies which have ever been done to look at the nighttime administration and the fall in blood pressure, which I am going to discuss. This is a very large study from Italy looking at what happens when the blood pressure decreases at night or increases at night. You will notice if the blood pressure does not fall or increases at night, there is higher cardiovascular morbidity and mortality compared to the normal nocturnal fall in blood pressure, which is less than 10%. This is a study looking at people whose blood pressure actually goes up at night. Instead of going down, it goes up. So-called reverse hypertension or reverse white coat hypertension. You will notice when the blood pressure goes up at night, their survival is significantly decreased. So, ladies and gentlemen, if you know of somebody whose blood pressure is rising during nighttime, I don't know, however you will come to know, their prognosis in the long term is very poor because of significant target organ damage. This is in people who have hypertension and congestive heart failure. You will notice if during nighttime sleep, the blood pressure is less than 120, your survival is good. But if the blood pressure during nighttime systolic is more than 120, you really have a significant risk of stroke. So ladies and gentlemen, in patients who have comorbidities such as congestive heart failure, if they have nocturnal hypertension, there is a very, very high risk of significant stroke. The mortality of nighttime hypertension has been studied recently. And you will notice when the nighttime blood pressure goes high compared to office BP, the risk of mortality is quite high. And this is a very beautiful study. I want you to pay attention to this slide. Very, very important. This is the night blood pressure systolic 110 to 120, 120 to 130, or more than 130. You will notice when the systolic blood pressure at night goes more than 120, there is development of left ventricular hypertrophy. That means these patients are developing significant target organ damage. So ladies and gentlemen, and Mr. Chairman, when nighttime blood pressure is greater than 120, target organ damage, as evidenced by left ventricular hypertrophy, is very, very prominent. Cardiovascular disease, similarly like left ventricular hypertrophy, significantly goes up when there is night increase in blood pressure. So left ventricular hypertrophy and cardiovascular disease go very, very high if you have nocturnal high BP. Now, what to do with nocturnal hypertension? This is a question that you should ask, and this is a question that I should answer if we have an answer. At the present time, we only know that nighttime blood pressure is dangerous, but we are not sure how to intervene with the nighttime blood pressure, because we are also afraid that if you drop the blood pressure too much at nighttime, which Dr. Wander has shown, so-called extreme dippers, their mortality actually goes up. So it is still unclear how to prevent nighttime hypertension. The only moral that I can give you is control the blood pressure as much as possible during daytime. As much as possible, control the blood pressure aggressively the way you do, hoping that you will not have nocturnal hypertension. So there are two studies which have looked at so-called chronotherapy and the effects I'm going to show you. These are, it's very strange. These are the only two good studies in the literature that looked at the nighttime dosage versus daytime dosage and outcome. One is called MAPEC study, where they looked at nighttime administration, and you will notice the risk is reduced significantly, the risk of stroke and heart disease. Another study called HYGEA study looked at the ambulatory blood pressure monitoring and looked at the nighttime BP. When nighttime medications were given, there was a significant reduction in cardiovascular disease. So, ladies and gentlemen, these two studies suggest that nighttime administration of antihypertensive drug therapy is significantly beneficial compared to daytime administration in some individuals. The only thing is, we don't know who these individuals are because we don't see patients at nighttime. We do see patients at daytime. So that is a paradox. But there is evidence to suggest that controlling nocturnal hypertension, as done in these studies, is beneficial. Now, what is the mechanism? Dr. Thakur has given an excellent talk on sympathetic nervous system. But in terms of nocturnal hypertension, endothelin might be very important. When you block endothelin at nighttime, shown here in the red color, there is a significant reduction in nighttime blood pressure. In the future, it is possible that endothelin antagonists might be useful in preventing nocturnal hypertension or treating nocturnal hypertension. Now I am going to show you a couple of examples on the seriousness of so-called nocturnal hypertension. In patients who have chronic kidney disease, when they have nocturnal hypertension, their renal function actually fails rapidly. You will see in this study creatinine ranging from 1.2 to 6.8, namely significant renal failure. Renal failure is much more common in patients who have nocturnal hypertension compared to those who do not have nocturnal hypertension. So, ladies and gentlemen, one of the risk factors for onset and progression of chronic kidney disease is so-called nocturnal hypertension. Very, very important to know. And this is a study looking at patients with CKD. When they have nocturnal hypertension, there's increase in microalbuminuria. So the target organ damage that I've shown with the heart, now I'm showing with the kidney. There is significant proteinuria in patients with CKD who have nighttime hypertension, suggesting nighttime hypertension accelerates target organ damage. Now, when you look at serum creatinine, or let us say chronic kidney function, it is much more severe in non-dippers compared to dippers. And this is a slide showing rapid decline in renal function who have non-dippers in the red color compared to those who have normal renal function, namely the green color. Now, diabetes has been discussed quite a bit in this meeting and also in another meeting that is going on simultaneously now. One of the features of diabetic hypertension is that they do not have a nocturnal drop in blood pressure. So one of the pathophysiological attributes of hypertension and diabetes, both in hypertension and normotensives, they do not drop the blood pressure at night time. So one hemodynamic abnormality that is very, very unique to diabetic hypertensives is nocturnal hypertension. Similarly, those people who have so-called hypertension in pregnancy, they have nocturnal hypertension. So diabetic individuals are identified by the lack of drop in blood pressure at night time, namely nocturnal hypertension. Similarly, when you look at central aortic BP, which is better than peripheral BP, patients who have diabetes, shown here in the green color, they have central aortic BP that is higher during daytime and also nighttime. So diabetic individuals have significant nocturnal hypertension and significant increase in central aortic BP. So, Mr. Chairman, ladies and gentlemen, and all the wonderful faculty who have spoken so far, let me conclude that nocturnal hypertension or lack of drop in blood pressure at night time is a very dangerous phenomenon. It is associated with increased mortality, increased left ventricular failure, left ventricular heart failure, chronic kidney disease, etc. But we do not know how to treat nighttime hypertension, although some studies suggest that nighttime administration might be beneficial. So, in conclusion then, I'm hoping that in the future, we will utilize 24-hour blood pressure monitoring more and more, especially the cuffless BP, because when you use the blood pressure without the cuff, the patients have a normal sleep, and then we will be able to know the real nighttime blood pressure. Currently, when you use with the cuff, it is really very disturbed and not a real blood pressure. I'm hoping that in the future, that nighttime blood pressure without the cuff will give us on how to treat this phenomenon much more better. It's very easy to do it. Now, let me comment finally about something Dr. Wander has mentioned about the cost. Cost is very important in anything that we do in life, but the cost of CKD and end-stage renal failure is phenomenal. Cost of coronary artery disease is phenomenal. Cost of stroke is phenomenal. Cost of losing a job is phenomenal. Loss of productivity as a citizen is phenomenal. Those are very, very high costs. Compared to them, the cost of blood pressure monitors, the cost of seeing the patient is very less. By the way, evaluation is only 10% of the cost of any condition. 90% is we're taking care of the complications. Cost is important, but the cost of disease overrides, unfortunately, the little bit of cost on medications, etc. So, Dr. Parikh, ladies and gentlemen, let me conclude by suggesting that we have now evidence that persistent increase in blood pressure at night time when you are completely asleep is not a benign phenomenon. It is a very serious antecedent to various complications and target organ damage. In the future, I think we'll be shifting towards a little bit of nighttime dosing, if not all the drugs, but at least 1 or 2 drugs taken at nighttime in addition to daytime might prevent the serious complications. And I have shown you 2 studies which have looked at the phenomenon. I hope that I have discussed the biophysics of blood pressure regulation at nighttime and perhaps future therapeutic approaches to prevent nighttime hypertension and to control it, to reduce morbidity and mortality, especially in high-risk patients. With those remarks, let me offer my congratulations to the organizers and also thank them for asking me to participate in this program. Thank you very much.
Thank you very much for excellent show, and thank you to the chairpersons. Now over to organizers.
Yeah, thank you very much, sir, for a wonderful talk on hypertension. Now we move on to the panel discussion, and for this panel discussion we have with us 3 doyens of medicine in the field of hypertension. I must say, we have the panelists, Dr. Siddharth Shah, Dr. Gurpreet Singh Wander, and Dr. C. Venkatraman. Dr. C. Venkatraman is already with us. He has been introduced. Dr. Gurpreet Singh Wander is also already with us. Dr. Siddharth Shah is Director, PRF, Executive Chairman of Hypertension Society of India and the past President, API. And he has extensive laurels and achievements to his credit. all of us him very well. So much of an introduction. Moderate this excellent session, we have with us Dr. K.K. Barik Saab and Dr. Mangesh Tivaskar. Dr. K.K. Barik Saab does not need any introduction as he is the mentor to the API Rajasthan and a doyen of medicine in the national scenario. Also, just to say a few lines, he's a president-elect Indian Association of Clinical Medicine. He's past president API. He is a past chairman of Specific Committee EPICON 2019, past Dean ICP, and there are many more lawyers to it. Dr. Mangesh Tivaskar is also moderator. Dr. Mangesh Tivaskar is the he is the Honorary General Secretary API. He is on editorial board JAPI Medicine Update IJD. He is governing body representative, guest editor to some highly indexed journals, and he has delivered a large number of lectures. He has many achievements to his credit. Having said that, I would not come in the way of for the next panel discussion. I hand over to the moderators, Dr. K.K. Parik Saab, Dr. Mangesh Tivaskar Saab.
Thank you very much, Dr. Wanda and Dr. Ram, for a very excellent talk and description of nocturnal hypertension. Now we have got panel discussion on this very important topic, and I would like to ask Dr. Ram, what 220 hypertension guidelines say that essential and optimal. How much you agree with this? The essential is for minimum standard and optimal is for those who can afford treatment.
Okay, very bold and very courageous question. And I would also like to give you an uninhibited viewpoint. International Society of Hypertension Guidelines, which were published. By the way, I congratulate the country of India because India was asked to give the comments on these guidelines before they were published. So it's an important honor that India was bestowed. I completely disagree with discriminating people based upon where they live. I completely disagree on our assessment of their social status. I completely disagree on our assessment of their financial status. A human being is a human being. Blood pressure does not make any distinction where you live. If you live makes a distinction that your blood pressure will be normal somewhere, I would like to move there immediately after this meeting. So unfortunately, the international guidelines have taken the WHO and UN mentality, where they divide the world into lower income, middle income, higher income. It has no meaning at all. It is soil. Neil Armstrong, the person who walked on the moon, when he was coming down, he made one statement. To him, all the earth looks like one single planet. So, ladies and gentlemen, I do believe that all individuals should have what is known as essentially new normal blood pressure, independent of where you live, and not optimal blood pressure because you are identified by different color by this map. Somebody sitting in a comfortable office in Geneva telling you that you deserve high BP. This makes no sense at all. And somebody is sitting in the comfort in Geneva sipping coffee the way Dr. Wanda was sipping coffee this afternoon and saying that you deserve to have stroke. So, Dr. Parikh, you raised a very, very sensitive question. To me, all human beings should have normal blood pressure, new normal blood pressure wherever they live.
Sir, don't you feel that cost is a very important obstacle in managing hypertension? Our aim, when the burden of hypertension in India is very high and awareness is very low. So is it not that minimum, at least we must be able to treat hypertension, whatever medicines are available. Our aim is to bring out the blood pressure first priority, then the other thing comes.
No, listen, we never disagree with cost in medicine because it's a very important point in medical career, in medical field compared to others. Human cost is very important. But when you are spending money 3 times a week for dialysis, kidney transplantation, heart failure, coronary artery disease, angioplasty, repeat procedures, hospitalizations, morbidity, anticoagulation, lipid lowering therapy, they're all very, very expensive. What I suggest is compared to disease treatment, prevention is very less expensive. Actually, luckily in India, the cost of antihypertensive drugs is not that much. Really, even if you take an ACE inhibitor, ARB combination, new beta blockers, and diuretics, etc., is it's really not that much. But I'm not saying would disregard cost, but I don't think that is a barrier to control hypertension. It is a consideration. It is not a barrier to control hypertension. We are not talking about boutique drugs. We are not talking about plastic surgery, which is optional. Especially, I believe the plastic surgeon's business has gone up after the Zoom came in. So this is what I'm told. So that is, to me, that is expensive. You can probably, to remove one scar on your face, you can probably treat all the people with hypertension in your town. So Dr. Parikh, I'm sorry I'm being very blunt, but what I'm trying to say is cost is important, but let us not use it as a tool to obstruct the treatment. It is important. I'm not saying pick the most expensive drug and give it to the poorest person in your clinic. I'm not saying that. But I think with the combination of CCB and diuretics and few things, it's not that expensive cost, day-to-day cost. Cigarettes are expensive. Alcohol is also expensive.
Thank you, sir. Thank you, sir. We have got another stalwart in hypertension, Dr. Siddharthan Shah, who has brought Indian guidelines and which are very much needed in India. We are Indians living in India, needs Indian guidelines. And recently, last year, we have released our Indian guidelines on hypertension by Hypertension Society of India. And he is the person who has brought from last 20 years, he has been bringing out the Indian guidelines every 7th year. So I would like to talk, I would like to invite Dr. Siddharthan Shah about his comments on management of hypertension. Dr. Siddharthan Shah.
Thank you, Dr. K.K. Parekh. Welcome, Dr. Mangesh Tiwaskar. Welcome, Dr. Venkatram and Dr. Wander. Thank you, Dr. Girish Mathur, for bringing me into this. The important point Dr. Venkatram has said that what is important is bringing down the blood pressure. My only point that I'm going to make, Dr. Venkatram has already talked about the economics, but what is important is already made by the UKPDS, that whatever you may do, whatever drug you may use, what is important is that you bring down the blood pressure. So that should be our aim rather than discussing whether it is costly or not. What is important is to prevent and delay the complications associated with hypertension. Whether you use 1 drug, 2 drugs, 3 drugs, multiple drugs to control hypertension is important. Whatever you may do, our physicians are competent enough to bring down the blood pressure. What is most important is follow-up of, this is what Dr. Wander has said, and this is what we have talked about in Indian guidelines, is what is important is follow-up of these patients. Most of these patients disappear after taking treatment, and they land up with the complications saying that I didn't know that I'm supposed to continue medicine. So what is important is follow-up of these patients and see that they are controlled well to delay and to prevent the complications of hypertension. Thank you.
Thank you, sir.
Sir, can I ask a question, sir?
Yes.
Yeah.
Dr. Wander, another celebrity in hypertension, Dr. Wander is here. What is your opinion? Any comment, Dr. Wander?
Sir, thank you for giving this opportunity to me to participate in this deliberation. I agree with what Professor Siddharsha sir and what Dr. Venkatram was saying, that it's the blood pressure levels actually which we have now realized after the SPRINT trial, that the level of control of blood pressure is very important. In fact, even the age-old all-hat study also showed us that it is, before that we were very drug-centric. It did show us that whichever drug can reduce the blood pressure, and now we know drug combinations are more important than solitary drugs. And although we all, as Dr. Venkatram very beautifully explicitly said that we do not actually, in fact, I have been thinking of writing on this particular aspect. How can you distinguish this world between, how can the WHO talk in terms of low middle income, and high income? Because health is a universal phenomenon and health is equally precious to all individuals. But one good thing actually that guideline does show is that the combination, they are saying that right from the first go, you start with a low dose of a combination. So the combination therapy for hypertension has actually really come in the center stage. And we today realize that the first step in hypertension itself is a combination. And what most people in the world today feel is that RAS blocker with a calcium channel blocker or a diuretic on the other side, that forms the best combination. And as Professor Siddharsha sir said, the blood pressure levels have to be brought down to normal. And of course, the biggest obstacle, I would say, in blood pressure is the compliance of the patient. And if we can spend some time talking to patients, whether we use the digital technologies to make them more compliant on a long-term basis, that is what will, because we know our studies have shown that 20% of Indians in the urban areas and 10% of Indians in rural areas have their blood pressures controlled. Whereas in the West, almost 40 to 50% patients have their blood pressures controlled. So we need to actually hit at hypertension in a bigger way and control blood pressures of a larger proportion of our population.
Thank you so much. I have got, now I can see Dr. Mangesh Tiwaskar, my younger brother.
Yes.
What is your opinion, Dr. Mangesh? You are one of the panelists. So anything you want to know or ask?
No, I actually would like to learn, sir.
Of hypertension.
I actually would like to learn when all these galaxies are here. And I
yes, we are learning. But do you have any query or
yes,
you
sir.
want?
Yes, sir. Yes, sir. I have. So my question is to Dr. Wander, sir. Is this that you spoke about, different gadgets of measuring blood pressure, and we probably, now are discouraging the use of mercury manometers, as you have rightly pointed out. But nowadays also we are seeing these LED manometric, sphygmomanometers which are available or which are replacing probably the. What is your take on their standardization and their accuracy?
Actually, you have hit at the real issue. The accuracy is what bothers every physician, I think, in this country. And that's why I was urging with such stalwarts like Professor Siddharsha, Dr. Venkatram being here. There should be a process. If the government is not validating blood pressure apparatuses, maybe people should get together and form some sort of a group which validates, whether it's a couple of groups of bodies does it. I don't know how. But at present in India, various blood pressure apparatuses are on sale. Why people had faith in mercury? You see, even still 65%, although we are signatories of Minamata Convention, we have taken a special exemption from the world for 2 more years that we are allowed to sell the mercury sphygmomanometer. And we have not yet the aneroid blood pressure apparatuses are invariably available as small dial, in which actually to look at the blood pressure apparatus also becomes a very tedious task, leave aside measuring it accurately. And the oscillometric devices are, of course, the way the world is now going. But we know the oscillometric devices measure the mean blood pressure. They don't measure the systolic and diastolic. And those are derived by an algorithm, which is peculiar to the company. And within a company, the 2 different devices will not necessarily have the same algorithm. So there are issues with blood pressure recording. And I wish Dr. Siddharsha and Dr. Venkatram also, because it's a very important question. Probably I am not the right person. I spoke on this topic, but maybe we have their comments also on this very important aspect. How do they feel actually? I really want to know how others feel on this issue.
Can I answer, sir? Wander, sir, Muruganathan. Can I answer? Actually, 2 years back, the ICMR called some of us and then said we'll have to bring that LED monitors and then do a thorough study. But unfortunately, that project did not take up. because we are supposed to bring the LED monitors across the country and then standardize and validate. And that project by Meenakshi was initiated. I was one of the members, but unfortunately that did not take up. I think after this COVID thing, we will have to pursue and make sure what Mangesh is asking, very pertinent question, because most of them are using now LED, very comparatively cheaper, and also they say it's very good. So we'll have to validate and then come to some conclusion, especially Indian standard.
Yeah, I believe Siddharsha sir, I would like to have your take on this.
And I will like to put 2 points.
Yes, sir.
I had initiated this in Bombay, the validation of this meters. We had validated these machines at the central office, but then because of the cost constraints, we couldn't proceed over different states. So I feel that this should be taken by the central office. Somewhere the central government has to have control over this to do this. And regarding the various LED meters and all that, we have found that it is not long lasting. You have to see that these meters are well validated. So LED also has its points, but I still feel that we'll have to withdraw the mercury manometers and replace it with another manometers with a larger dials to see that we do not have any errors. So we must have error-free BP apparatus and should be validated every year or every 6 months, which can be taken up by various agencies. Thank you.
Thank you very much, sir. So we conclude our discussion, discussion on hypertension, because we are already very late and other persons are also waiting. We can discuss it on another seminar or webinar. I think I will keep a 3-4 hours webinar and panel discussion, and will invite all of you, and I request to be part of that webinar. Thank you very much, Dr. Venkatram. Thank you very much, Dr. Siddharthan Shah, Dr. Mangesh, Dr. Wander, Dr. Thakur, Dr. Mugnathan. I'm really grateful to you to be a part of this most important topic, hypertension. And I'm really very happy to see all of you, and really very much happy that you all spared your valuable time for this very important topic of hypertension. A message should go to the clinician and to the physicians. So thank you very much, sir. Thank you. Thank you all.
Sir, one very important message.
Yes, sir. Yes,
one
sir.
very important message should go to the clinician.
Sure, sir.
Because the clinician is most important, and that is the only reason for uncontrolled blood pressure. They don't have time for education, information, and counseling. So they are responsible. The
Thank you very much, sir. Thank you very much.
Thank you very much. Thank you,
message, sir.
Dr. K.K. Parekh. Thank you, and Dr. Girish Mathur.
Thank you, sir.
For
Thank you.
leading this show.
Sir.
Thank you.
Thank you so much, sir. Thank you, Dr. Ram.
Sir.
Yes.
Dr. Parekh, thank you very much. I just want to make one point, although we're running late. ICMR has started a study on blood pressure control in the country in 5 states. So now they have invited, finally, they have invited the private parties, and the APA president was invited last week. And he is going to run by through the committee on how they can participate in this ICMR study as a private entity, which is very, very important because 90% of the medical care is private. So I'm glad that finally ICMR is relaxing a rule to involve private, and the API was very nicely represented, and hope it will happen. Thank you.
Thank you, sir. Thank you so much. Thank you,
everybody.
Session is over. Thank you so much.
Thank you very much, sir.
Thank you, Dr. Swati. Thank you very much.
Swati,
Yes.
take Dr. Shiv Sarin because he is going. He has
Yes.
got another webinar to
Yes,
invite
sir.
Dr. Shiv Sarin.
Yes, sir.
Thank you so much, sir. Dr. Tiwari.
Thanks to all the very much senior stalwarts of medicine for that excellent panel discussion on hypertension. Moving on, we have the next session is on diabetes update, and the speakers are Dr. Shashank Joshi, Dr. Shiv Sareen, Dr. N.K. Soni. For this session, we have the chairpersons, Professor Kamlesh Tiwari, Professor K. Tiwari is the next professor, HOD Medicine, SK Medical College. He is MD FRCP Glasgow and Edinburgh. He is FICP FIAMS and FFACM. He is ex-professor and past president of Hypertension Society India. He is president-elect API 2020-2021, and he is the scientific chairman EPICON 2021. Welcome, Dr. Tiwari, sir. We have with us, and the other second chairperson is Dr. Sunil Gotwal. He is Associate Professor, JLN Medical College, Ajmer, with a large number of publications. Welcome, Dr. Sunil Gotwal. Now, as there is a small change in the schedule, we will be taking Dr. Sareen, Dr. Shiv Kumar Sareen, sir, for the first talk. So I will be introducing him now, Professor Dr. Shiv Kumar Sareen, MD DM, DSc Honorary FNA, FNS, and is a Senior Professor, Hepatology and Director, Institute of Liver and Biliary Sciences. He does not need any introduction because everyone knows him very well, and I've heard him several times. And he is a Senior Professor, Hepatology, Director at Institute of Liver and Biliary Disorders, Delhi. He is instrumental in setting up the Institute of Institute of Liver and Biliary Sciences under the auspices of the Government of Delhi. He is Director, WHO Collaborative Center on Chronic Liver Disease, Viral Hepatitis at ILBS. He serves as an adjunct faculty, Molecular Medicine at JNU due to his deep interest and contributions to translational science. He's created with several new treatment protocols of liver disease. He has various medals, gold medals, and honors and achievements. I would not, as Dr. Sareen has to leave for somewhere, I would not come in the way with his lecture. I invite Dr. Shiv Kumar Sareen, sir, to kindly start the lecture.
He is a legend. He doesn't need any introduction. All over the world knows him.
Exactly.
So, Dr. Sareen.
And we are proud that he is an ex-alumni of Jaipur.
Yes, and he is the alumni of SMS Medical College. He belongs to Rajasthan. So we are very proud that he belongs to our state.
Yes, that's a bigger introduction. Thank you, Parikh sir, Maheshwari sir, Girish, and all other people, and Swati for your kind words. My apologies, but I have to go by around 6. And congratulations to EPICON. I remember how good it was in Kota, in Ajmer. I will bring greetings from ILBS. Are my slides visible?
Yes, sir. Yes, sir.
I want to bring this topic, diabetes and liver. I have spoken on it a few times, but I think it is the right time now, one more time, because I heard about such nice talks on hypertension from Dr. Siddharth, from Dr. Vendor and others, and Venkatram. I have nothing to disclose, except we have very bright faculty and brighter students, and for 3rd year in a row, ILBS is ranked 2nd by UGC next to AIIMS Delhi in scholastic output. Diabetes and fatty liver are two sides of the same coin. This is the pandemic year, but I want to tell you the pandemic century. 2020 to 2120, 100 years, this will be the pandemic. 1/4 to 1/5 of the world has fatty liver. 1/4 to 1/5. And you can see hepatitis B causes cancer in about 1%, while fatty liver about 10%. In India, you can see that 1/3, and like US, 1/3. But what is important for physicians all across is that 2/3 of diabetics, 2/3 have fatty liver disease. And of course, 1/3 of cirrhosis have diabetes. This is to show you where we fall. Red means 30% of population. 30% or more of population has NAFLD. Now let's look at diabetes versus NAFLD. In India, above 18 years is just 816 million. 20% of that will be 163 million. Now you imagine how many diabetics you have, maybe 1/3 of this. And I'll tell you the relevance of this data. How many people die of cirrhosis? Red is B, light blue is C, but you can see half the upper line is alcohol and fatty liver. How do you diagnose it? Ultrasound, CT, or a fibroscan and ALT, and of course many other methods. So when the liver normally should have less than 5%, but if it has more than 10% of its weight, it is fatty liver. An ultrasound, liver kidney, or liver spleen preferably ratio. This is your skin, this is the fat underneath, and liver resembles this. It's a fatty liver. Now this is a simple machine, fibroscan. The controlled attenuation parameter gives you the fat. Normally should be around 200, 250 is upper limit, 300 means 33% of liver is fat. You only are permitted 5%. This is the time in milliseconds. Soft liver takes 60 milliseconds, hard liver 20 milliseconds. 40 milliseconds is around 8.5. This is stage 2 to 3 fibrosis. Now the question is, does fatty liver disease come first or diabetes comes first? Chicken or egg? I'll show you how fatty liver and how fat makes all the difference. Additional calories get deposited into ectopic areas. One of the ectopic area is liver. 6%, 8%, muscle. If it is 6% in impaired glucose tolerance, 8% you start having cardiac events, pancreas, white, or your blood vessels. So hypertension, hypertriglyceridemia, all the events. And as very clearly shown here, you will have insulin resistance, glucose, all those are part of an abnormal adipose tissue and fat. So NAFLD is the core. Now this is a 2020 study, and I want you to have 1 minute attention to this. You have genes and you have environment. Anybody who has these bacteria which are facultative, which are stimulating your fat absorption, this will lead to a fatty liver. Now you have genes and you have food, and then you have a bad adipose tissue. So a metabolically burdened liver will have all these things coming. Now this is the association of fatty liver to diabetes. Everywhere you will see, if somebody has fatty liver, the risk of diabetes is several-fold high. Liver, therefore, is the key role in the pathogenesis of insulin resistance and diabetes. I believe for the last 20 years, diabetes is a liver disease, not to take anybody's bread and butter. Liver inflammation leads to diabetes. We all take 40 ALT as normal, but believe me, and we use at less than 30 at ILBS or less than 90. These are the US standards. ALT correlates not only with fatty liver, but the risk of diabetes, dyslipidemia, hypertension, heart disease. It's a marker of inflammation. These are large Japanese data released in 2011. If you take a guy with fatty liver, you will find normal sugar only in 27%. 73% have abnormal sugar. So what you do? My sugar, yaar, meri thodi sugar high hai. Arey bhai, sugar high hai to liver dekh lo. This is the third generation Framingham study. Children born to the third generation were followed. Those who had high ALT, by the time they were 30 to 40, risk of diabetes was 5 to 20 times. This shows you 129 patients followed for 14 years. Almost 75-80% developed diabetes or impaired glucose. NAFLD increases the risk, but this is the most important step, most important. Regression of fatty liver reverses to normal risk of diabetes. This Chinese study of about 63,000 people, please see carefully, see carefully that those people who had diabetes, those who have got diabetes and they are followed up and have high ALT. If somebody has an ALT of 120 and has diabetes, his risk of cancer of liver is several fold higher. So please remember, if you have a diabetic patient, his ALT should be less than 30. This is ILBS data. Please pay attention. Alcoholic cirrhosis plus diabetes, 9 times more risk. Alcohol alone versus alcohol plus diabetes. Hepatitis B alone plus diabetes. So presence of diabetes increases liver cancer. So part 1 of my talk is fatty liver is common. Diabetes is in 10%, this is in 30%. Fatty liver precedes, and NAFLD patients have cirrhosis and vice versa. Diabetes is a liver disease. Okay, let's go on to the assessment tools and then we'll come back to diabetes. How do you know that I have diabetes or I have fatty liver? If there is a family history of metabolic syndrome, diabetes, hypertension, kidney, liver, or cancer or obesity, you have fatty liver. Ultrasound, blood tests. Now, GPs would be the first to catch fatty liver because they see obese patient. मेरी clinic में आया, यार उसके तो obesity, overweight है, fatty liver होगा. And this is the new guideline. Easy fatigue. By 3 o'clock you are tired, means your muscle have used all your energy. Can your tailors and barbers help? Yes. The waist, if it is more than 90 for male, therefore don't put jeans on you, you fit into the jeans. Tell all your barbers in Rajasthan that please look for these warts and these black lines, metabolic syndrome. How else? The lab people, any lab in Rajasthan or anywhere, please tell them, why not make an alert if ALT is high or gamma GT is high? These are very, very fat in the liver cell, ALT will be high. Fat in the bile duct cell, cholangiocyte, gamma GT is high. But normal labs do not exclude NAFLD. Now this is an important, this is an index patient of cirrhosis. You ask, भाई तेरे भाई को diabetes है? Yes. बहन को? Yes. Mother, father को? Yes. So in a patient with fatty liver disease and cirrhosis, we found 2/3 have metabolic trait. But if you have everything else in metabolic trait, obesity, diabetes, hypertension, why not liver disease? Fatty liver is core of metabolic disease. Now this is the very important slide. ALT or SGPT correlate with NASH, but gamma GT correlates with dyslipidemia, hypertension. You have a patient with high gamma GT, normal ALT might be hypertensive. Please remember to get gamma GT and insulin resistance. How do I assess now? First line physicians can do simple FIB4 test. What is FIB4? Age, AST, platelet and ALT. Anybody can do it. FIB4 more than 1.3, cause of worry. NFS has age, BMI, diabetes, AST, ALT and bilirubin. Now you can find out that if FIB4 is high, NFS is high, he is intermediate risk. He needs to go for a fibroscan. Now simple fibroscan, I told you, 40 milliseconds, 45. If it is above 8 kilopascal, he has stage 2 or more fibrosis. He needs a liver biopsy. What will biopsy show? It will show you fat. Now this is a liver biopsy. All these are normal cells, but some cells are white, they have fat. Now the body thinks this is not a normal liver cell. They will send you T cell, NK cell, and they will try to kill it. You get an inflammation. That is the beginning of NASH. Then you get ballooning, then you get fibrosis and cirrhosis. So biopsy will tell you the stage, the grade of activity and inflammation. It is called SAF, steatosis, activity, fibrosis score. These are new guidelines. Now why I'm showing you this, not for any reason, the name NAFLD is now changing to MAFLD, metabolic dysfunction associated fatty liver. I showed you NAFLD is part of the major, in fact, it's the core for things. Now, this is clear. Whom to suspect? Family or obesity. ALT high, gamma GT, and your capped value, fat in the fibroscan or stiffness, and biopsy. Now, these are the new guidelines. How do we define MAFLD, not NAFLD? Very simple. All diabetics go into MA, all overweight, above 23 BMI or obesity, 25, will go there. So what will remain for metabolic syndrome is a lean guy or a normal weight guy who has a waist or BP and other parameters, triglyceride. So all diabetics need to be screened for fatty liver. So now I have to come and tell you the journey from NAFLD to MAFLD has begun. Everything may not be good. We may have to look back, but this is the way the world is, and 2021 will show it. Now, just for treatment, you use pioglitazone for NASH. You use pioglitazone for diabetes. It helps in many ways. I won't go into details, but yes, it works on both the sides, adipose, liver, and of course, fatty acids go down. You also are using a pioglitazone for reduction in fibrosis. That is in a New England and Annals paper. You can see that there is a reduction in NASH score and resolution of NASH by giving pio. This is a diabetes drug. The lean study shows liraglutide. You are using it for diabetes, for weight reduction or whatever, but it also decreases the NAFLD score, the fibrosis, steatosis, and therefore drugs are common. You are using the SGLT2 inhibitors. These are also the drugs people are now going to use for fatty liver disease. Metformin, your basic drug in diabetes, and this is one of my, I'm very fond of this study. Patient's normal liver pressure is 5 millimeter of mercury. Hepatic vein pressure gradient or liver pressure is 5. We had patients, in cirrhosis you have up to 20, 18 millimeter, like somebody's BP is 600 millimeter, 4 times higher. Metformin is the single drug which decreases portal pressure. It decreases liver fat, the cap value. You can see this is metformin. And the portal pressure. 10% reduction means from 20, it has come to, let's say, 18. Huge benefit. If it comes to 16, 20%, much better. Now, the people who have got reduction of 10% pressure in the liver with metformin is 60% compared to the standard therapy. This is the drug. I have seen people coming from 20 to 6 millimeter, means their liver is normal. So my last summary slide is screen all, family history, can be careful. COVID is more severe in MAFLD. I forgot to add slides on this. One sentence. You say there are comorbidities. What comorbidity? Obesity, diabetes, blood pressure, heart disease. But they're all part of an MAFLD. So COVID is more severe. In fact, the liver enzymes, the liver pressures, the release of cytokines is all from the sinusoidal endothelium. Therefore, MAFLD should be a comorbidity. Please learn to stratify your patients early, stage 1, 2, 3, 4, fatty liver or biopsy, and you can help your patients in real life. My carry home to all my friends, my seniors and my colleagues is, please remember, 2/3 of the diabetics have fatty liver disease. Therefore, screen them all. Today's guideline for MAFLD, screen all diabetics. And if your diabetic patient has a high ALT, his chance of liver cancer is 3 times or more. If your diabetic has a more than 8 liver stiffness, please think of assessing fibrosis because he has a high chance of liver cancer. And now we have like about 2,700 cirrhosis and diabetes. If there is cirrhosis and diabetes, drugs are very few. Metformin, saraglitazar, maybe some gliptins and SGLT2. If your patient is obese and cirrhotic and diabetic, we don't have many options except we place balloons to reduce the weight and do many things. In my opinion, to win over diabetes, please detect, prevent and treat MAFLD. And you all, physicians of Rajasthan and anywhere who are listening, please join the journey to prevent diabetes, prevent fatty liver and all kinds of cancers. Thank you for your kind attention and allowing me to speak before time. Thank you.
Thank you very much, sir, for that very enlightening lecture on how important NAFLD is in our metabolic syndrome scenario, which we probably tend to forget so well. So I had a question, a small query, that since we know that NAFLD is the natural history, we see it more or less progresses. It's a progressive disorder, but some 20% to 30% progress very rapidly. Are there any specific predictors which could guide us to which will be more rapid progresses, or which are the warning signs which we have to keep in mind, or they all can move in the same direction?
So this is a very, very good question. I just dropped that slide of 3 spheres. The first sphere is your genes, second is your environment, and third is your environment alone means work, and third is your food. If your grandfather had diabetes or blood pressure or fatty liver, the next generation is earlier and the next generation is earlier. This is walking gene theory. So the role of genes becomes more and more important by third generation. So it is extremely important. If I am the first person with fatty liver, genes will have less role. There will be limited benefit of doing genetic study. But if it is a third generation, PNPLA3 is the most important single gene where if it is homologous, the speed of fibrosis is very fast. You say some people, they are very lean and thin. Sab patla dubla tha, par usko heart attack ho gaya. 30 saal ka tha. But it is not this person, it is the 2 generations ahead what they had in the family. Therefore, lean and obese are different. Today, you may have a lean person but metabolically unhealthy. So to simplify, I think there are rapid progressors, but they are based on genes.
Thank you,
sir. Thank you, Dr. Shiv Sarin. It's a great honor for us that you have joined us and you are part of this important conference. Thank you so much for sparing your valuable time. Thank you, sir.
Thank you very much.
I would now like to call upon and invite Dr. Kamlesh Tiwari sir to kindly introduce the next speaker, Dr. Shashank Joshi.
Good evening. Dr. Shashank Joshi, he is President, Indian Academy of Diabetes, past President, Endocrine Society of India, past President, Association of Physicians of India, Emeritus Editor, JAPI, past President, RSDDI, Editor, 4th edition, RSDDI textbook, Indian chapter, Chair, American Association of Clinical Endocrinology, and many more things. It is very difficult. Overall, he is Padma Shri in our doctor fraternity. So I will invite Dr. Shashank to introduce his subject.
Cardiovascular outcomes in diabetes. And it is so crucial to understand. So, today we are going to discuss cardiovascular outcomes in diabetes. And it is so crucial to understand why the cardiovascular outcome trials in diabetes have changed the landscape of diabetes. In 2020, this year, in March, actually the US FDA did a full U-turn on the cardiovascular trial recommendations because they felt that there is no more compelling need to do that. And that's something which we recognize. So clearly we have seen that there is a full U-turn of the US FDA on the cardiovascular outcome trials, which actually were initiated in 2008 after the famous rosiglitazone controversy. So let us quickly review the decreased cardiovascular risk with new agents based on the various cardiovascular outcome trials which have been published in the last decade. The decade between 2010 and 2020 can be called as the decade of cardiovascular outcome trials in the modern era of diabetes. Clearly, we know that the cardiovascular disease is a leading cause of death in people living with diabetes. Patients with type 2 diabetes have an increased risk of cardiovascular complications compared to those without diabetes. Clearly, we know that 50% of all deaths in people living with diabetes with type 2 are attributable to cardiovascular disease. We clearly know that there is a 53% increased risk of unstable angina for people living with type 2 diabetes. There's a 54% increased risk of myocardial infarction with people living with diabetes. There's a 56% increase in risk of heart failure and 72% risk of stroke. So when we are looking at the 4-point MACE, 3-point MACE, we are basically looking at unstable angina, myocardial infarction, hospitalizations due to heart failure or stroke. Those are the endpoints. So you can see that 2015, 5 years we are celebrating when the first positive CV outcome trial came out, namely the EMPA-REG trial. And that EMPA-REG trial which came out clearly made an impact. And that EMPA-REG trial which we see has clearly impacted guidelines in 2016, in 2017, 2018, 2019, and even 2020 as we enter 2021. So this was the original guidance of the US FDA. The US FDA had a guidance that for new anti-diabetic therapies to treat type 2 diabetes, they should not have an unacceptable risk to increase cardiovascular risk. And therefore, based on that, they had various bounds. For example, they looked at if there was a hazard ratio more than 1.8, it was not approvable. If there was a hazard ratio between 1.3 and 1.8, it was approvable, but you need a post-marketing study. And if it was below 1.3, then it was approvable and there was no need for a post-marketing study. This was an FDA requirement for cardiovascular outcome trial. So when we look at designing a cardiovascular outcome trial in diabetes, we have to look whether it was a pre-approval or a post-approval design, whether it was an event-driven trial or a time-driven trial, and whether it was only powered for a primary endpoint. And you can see this is the plethora of cardiovascular outcome trials in the diabetes space, which started somewhere in 2008, 2010, and you can see the first outcomes which came out were the SAVOR-TIMI trial, the EXAMINE trial, EMPA-REG trial, ELIXA trial, TACOS trial, SUSTAIN-6, FREEDOM, LEADER, CANVAS, DEVOTE, ACE, EXCEL, CARMELINA, HARMONY, CREDENCE, DECLARE-TIMI, PIONEER-6, REWIND, AMPLITUDE, VERTIS-CV, SCORE, SELECT, CAROLINA, and you can see the various agents on which these trials are addressed to. They're addressed right from alpha-glucosidase inhibitors to glitazones to insulin, but the predominant ones are coming up from SGLT2 inhibitors and GLP-1, apart from gliptins, PPAR gamma, and even the 5-hydroxy receptors. So let us look at the first breaking trials of this decade. The first breaking trials of this decade are from 2013 and 2015. EXAMINE, ELIXA, TACOS, and SAVOR-TIMI. And clearly these 4 trials showed that when you use a gliptin or a GLP-1 analog, you can see whether it's SAVOR-TIMI, saxagliptin, whether it is EXAMINE allogliptin, whether it's TACOS sitagliptin or lixisenatide, they all showed a hazard ratio near unity, which means that they were neutral trials. So the first 4 trials showed neutrality, and that was something which we all know. And therefore, if you see the 2015 guidance, predominantly they said glucose control is a major focus. And in that context, we should look at a comprehensive cardiovascular risk program and look at impact of glucose control on cardiovascular complications remains uncertain. So in 2015, the approach was a general approach with no specific treatments after metformin what to do. Then came another 3 trials which got out between 15 and 16. The EMPA-REG trial, which was a game changer, and the LEADER trial. Both the trials showed respectively for empagliflozin and liraglutide that there was a positive CV outcome, and then came SUSTAIN, which was also a positive trial for semaglutide. So clearly we saw a hazard ratio of LEADER 0.87 a sustained hazard ratio of 0.74, and EMPA-REGA hazard ratio of 0.86. All the three trials outstandingly giving a very unique result of CV outcome positivity, which changed the landscape of cardiovascular medicine. And therefore, you saw that in the ADA standards of care guidance in 2017, clearly people with diabetes, long-standing, suboptimally controlled, with established atherosclerotic cardiovascular disease, EMPA-LIRA should be considered as preferential agents with a level of evidence B. Then, of course, the story continued. We had the DEVOTE trial from degludec, which showed neutrality. We had the EXCEL trial from exenatide, which showed neutrality. And then we had another outstanding positive CV outcome trial in the SGLT2 space, the CANVAS program with canagliflozin. And clearly you can see a hazard ratio of 0.91 for DEVOTE, a hazard ratio of 0.91 for exenatide, but an outstandingly compelling positive trial, the second positive CV outcome trial in the SGLT2 space, the CANVAS program. So therefore, if you see that time, the ESC, European Society of Cardiology position paper stated, after metformin, either give SGLT2 inhibitor with empagliflozin or a GLP-1 receptor agent with liraglutide or semaglutide. The story didn't stop there. By the time 2017 and 18 had entered, we had the Camilla TB61, and that trial got into the armamentarium, apart from the various trials which were published. And therefore, then you saw the ADA changing its gear. First line is metformin with comprehensive lifestyle management, with weight management and physical activity. If there is established atherosclerotic vascular disease or chronic kidney disease, and if the atherosclerotic vascular disease predominates, it could either be a GLP-1 receptor agent or SGLT2, and the preferential hierarchy is the one which is given, which has generated a CV outcome evidence base. If there was heart failure or CKD predominant, then SGLT2 became top on the pecking order, followed by, of course, the other agents. And if there was no established atherosclerotic vascular disease or CKD, then there were three groups. One is a group with cost, other is a group with weight gain not being promoted or weight loss being promoted, and third is a group where there is a compelling need to minimize hypoglycemia. Clearly in 18, choosing a glucose-lowering medicine where atherosclerotic vascular disease predominated was either a GLP-1 receptor agent with a proven cardiovascular benefit or a SGLT2 inhibitor which was oral with a proven cardiovascular benefit if eGFR was adequate. And that was a preferential hierarchy. GLP-1, SGLT2 with proven CVD benefit, followed by a gliptin, followed by basal insulin, glitazone and SU. And in the evidence-based hierarchy of the GLP-1 backbone, it was liraglutide, semaglutide, exenatide. In the evidence-based hierarchy of SGLT2, it was empagliflozin and canagliflozin. And then obviously, when it came how to change these agents, SGLT2 inhibitors, if it was heart failure and CKD, got preferred over GLP-1 receptor agents because they not only reduce hospitalizations for heart failure, but also had cardiorenal protection. And in that evidence-based hierarchy, EMPA and CANA were right up there, followed by LIRA, SEMA, and exenatide XAR. So there was a clear change of the second-line therapy in people living with type 2 diabetes with established cardiovascular disease from 2015 to 2018 because of these outcome trials. From a general approach with no specific preferences, it became an approach where people with established atherosclerotic vascular heart disease, CKD or heart failure, a GLP-1 receptor agent or SGLT2 inhibitor with proven CVD benefit became recommended. Then came Harmony, Carmelina, and declared TB58. And obviously, these gave more compelling evidence in 2018 to actually have the American College of Cardiology and European Society for Cardiology in 2018 to give a guidance on cardiovascular risk in people living with type 2 diabetes and established cardiovascular disease. And then came another positive trial called Rewind and Carolina, which was a neutral trial, and the Pioneer program. So in 2019, we had Rewind, Carolina, and Pioneer, which again showed some outstanding results. Rewind clearly showed dulaglutide, showed a positive CV outcome at 0.88. Carolina was a neutral trial head-to-head with linagliptin and glimepiride, and Pioneer 6 was a neutral trial at 0.79 of oral semaglutide versus the placebo. So clearly in 2019, which now continues even today in 2020 and 21 as we enter 2021, the choosing a glucose-lowering medication, if atherosclerotic vascular disease predominates, if there is either you use a GLP-1 receptor agent with a proven cardiovascular benefit, or use a SGLT2 inhibitor with a proven cardiovascular benefit, if eGFR was adequate. And then, if things are not okay, you can consider other agents. Clearly, the Rewind got in there, and the GLP-1 receptor agent with known cardiovascular benefits, liraglutide was already FDA approved, but dulaglutide also got in there. And obviously, the benefit was compelling for liraglutide, dulaglutide, and semaglutide. All the three trials now are right up there in the GLP-1 space. But then came the renal space, an outstanding result with a trial which was prematurely terminated called the Credence trial, which was with canagliflozin, which clearly showed that there was a reduction of 0.70, 30% reduction in hazard ratio, the primary composite endpoint of Credence. And clearly then if you see, when you choose heart failure or CKD, SGLT2 inhibitor came right up the pecking order, and then came the other agents, and avoidance of glitazones were clearly spelled out there. Obviously, when you therefore choose a glucose-lowering medication with established heart failure or CKD, obviously the benefit for EMPA, CANA, and DAPA was huge. As far as heart failure was concerned, as far as EMPA, DAPA, and CANA was concerned, also the reduction of CKD progression in CVOT was huge. And therefore, if somebody has an EGFR about 30 or an albuminuria of 300 milligram per gram albuminuria, there was a level A evidence to reduce CKD progression, cardiovascular events, or both. And therefore, these therapies went right up the pecking order. And in 2019, the ESC guidelines for diabetes, pre-diabetes, and cardiovascular disease also recognized them. In fact, they went one step further. They said in type 2 diabetics, which are drug naive, and if they have very high risk or high cardiovascular risk with target organ damage, multiple cardiac risk factors, or atherosclerotic vascular disease, you don't even have to go to metformin. You can straight go to a SGLT2 inhibitor or a GLP-1 receptor agent and later on add metformin. If there is no high risk or very high risk cases from the vascular standpoint, then you can do metformin monotherapy. That was the big difference. So obviously, the big change which occurred that even in drug-naive patients, it was recommended with people with high or very high cardiovascular risk as a first-line therapy with atherosclerotic vascular disease, and SGLT2 inhibitors, and they came right up the pecking order. So clearly we know that irrespective of the A1C, they were right up there. And even the heart failure position statement clearly showed that the SGLT2 inhibitors are right up there in terms of the management. And if you see various updates, clearly they recognize the SGLT2 inhibitor recommendations, GLP-1 receptor agent recommendations, all based on cardiovascular outcome trials. So the story of 2019 and 20 on the CV outcome trials continued. We had a Vertis CV trial which came out, which was a little disappointing. Amplitude O trial awaited. Select trial of semaglutide, SOUL trial of semaglutide are ongoing. So we will have many more answers as we go into the journey of cardiovascular outcome management. So how did the management of diabetes change from a multifactorial cause to a multifactorial intervention? That is where we are looking at. We are not just looking at glucocentricity, not just avoidance of hypoglycemia and weight gain. We are looking at cardiovascular protection. So before 2008, when the US FDA said there is a need for CV outcome trials, it was just lowering glucose. Lower the A1C, the better it is. Keep it at 6.5, 7 or 7.5. In 2008, there was a change. Lower the better, but no weight gain, no hypoglycemia, no adverse events. That was the aim. This was the gliptin era. And then in 2015, you saw the birth of the SGLT2 inhibitor era, the GLP-1 era. And now in 2021, as we enter in 2020, cardiovascular risk with blood pressure reduction, LDL reduction, and efficacy and safety being supreme. Obviously now, the U-turn and the pendulum swing so much that a cardiovascular risk of new therapies does not need a CVOT. That was what in March 2020, as COVIDized world we were living in, came out that there is no need to do that. And that is what I wanted to share with you and talk to you today, that cardiovascular outcome trials came in from 2008. Their best results got published in the diabetes space from 2015. And we saw two big categories of agents, SGLT2 inhibitors as well as GLP-1 analogs with proven cardiovascular benefits. As far as the GLP-1 backbone was concerned, there was a heterogeneity. Some were neutral, some were positive. And in that GLP-1 category, we have on the pecking order dulaglutide, semaglutide, and liraglutide. When it came to the SGLT2 inhibitor space, again, on the 3.4 point MACE, we had EMPA and CANA right up the pecking order. We had a neutrality for DAPA, but when we add hospitalization for heart failure, we had all the three equated. And when it came to renal protection, again, we had all the three almost equated. So obviously, SGLT2 inhibitors also showed a very, very compelling need and a reason for having this. Thank you for a patient hearing, and I'll be happy to answer any questions.
Thank you, sir, for for an excellent lecture. I would request Dr. Kamlesh Tiwari sir if he wants to have an expert comments on this very wonderful lecture on CVOT trials and the change which has occurred over these few years and the latest in India. Dr. Kamlesh Tiwari sir.
Thank you, Susan. Thank you for the nice presentation. I would like to ask, what should be the exact level of blood sugar to prevent these complications in Indian patients?
So we have now moving targets. So for a non-pregnant adult patient, it should be less than 7%. For somebody with diabetes with duration of less than 10 years, young person without complications, the target of A1C is 6.5. And if somebody is a senior citizen or has limited life expectancy or a lot of vascular complications, you can relax up to 7.5. So the target is a moving target. And now we are graduating from A1C and trying to keep it below 7% to something called as time in range. So time in range is something what we want to achieve. And we want to ensure that our glucose is in range most of the time, at least 70% of the time. That is the in thing today, Dr. Saab.
So I think most of the diabetics are keeping their blood sugar in that range. Still, they are moving towards complication. Everybody.
So that is very true because it is not just A1C control. It is A1C control, blood pressure control, lipid control. It is a consortium because it's a dysglycemia based chronic disease. And therefore, we need to ensure that we tackle cardiometabolic risk factors with glucose control. So the old adage that tight glycemic control works in the first 10 years and first decade of a diabetic's life and is more impactful in a type 1 diabetic. In a type 2 diabetic, we need actionable cardiometabolic endpoints so that we can keep the complications at bay.
Okay. Anybody else?
Dr. Shashank, you will agree that the CVOT trial was a boon for all of us. They brought such a good molecule. We were thinking for the cardiovascular safety of the anti-diabetic drugs. But then they came out with a shining star. You know what I say? कि जैसे समुद्र का मंथन हुआ था और अमृत कलश निकला था, like that SGLT2 came out.
That is very true. That is very true.
It's really because it is going to be helpful. Even time will come, then the GI experts will also use SGLT2.
No, already cardiologists and nephrologists have hijacked SGLT2 inhibitors.
Yes.
And I'm certain after some time, every specialist will hijack SGLT2 inhibitors, including liver specialists, which we just heard.
Even in non-diabetics, non-diabetics, we are using it.
Non-diabetic heart failure as well as in non-diabetic kidney disease, these SGLT2 drugs have arrived, and it is all because of that accidental, outstanding result of EMPA-REG, which happened exactly 5 years back, 5 years, 1 month back.
Can we, as we are talking of non-diabetic, can we use SGLT2 in a patient of resistant hypertension when we are using 4 drugs, 5 drugs, and we are not getting results? Can we use SGLT2 inhibitor in those patients?
No, I would not use that. In absence of diabetes, I would be hesitant to use it unless there is an element of some, renal element to that hypertensive resistance. So it's unlikely that I'll use it because they don't really work on insulin resistance.
Thank you. Thank you, Shashank. It's a great honor and opportunity for us to have you in our conference. Thank you so much, and we are grateful to you for your presence. Thank you so much.
Thank you.
Yes,
Thank
Dr.
you so much, and I wish everybody a happy and a healthy 2021, and let us celebrate 2021. Thank you so much, Professor Parikh, and I would love to be in Kota soon.
Sure. It will be a pleasure and an honor.
Thank you very much, sir, for that wonderful lecture and a wonderful interaction also and a response also. Thank you, sir. Now I request the next chairperson, Dr. Sunil Kumar Gotwal, to introduce the next speaker, Dr. N.K. Soni.
Thank you, ma'am. Now I will welcome Dr. N.K. Soni, MD, FRCS Glasgow, FACP, FIS, FICP, FISAM. He is right now senior consultant in the Department of Internal Medicine, Super Specialty Hospital, Greater Noida. He is Vice President API National Body. He is past President UP Diabetic Association, past Chairman RSSDI UP Chapter, past President Indian Association of Clinical Medicine, Principal Guide of DNB Internal Medicine, Regional Faculty in Public Health Foundation. He has more than 20 chapters and articles in various books and medicine update and journals. I now welcome Dr. N.K. Soni, sir. Over to.
Well, thank you very much. My slides are visible now?
No, sir.
No,
No? Oh,
no, the screen sharing has not started, sir.
okay. Oh, the screen sharing. Yes, I asked for it. Yes, now I think it will be visible. Share.
No, yeah.
Yes, now they are. Yeah.
Okay. Well, to begin with, thank you very much. Thank you very much, Professor Parekh, Dr. Girish Mathur, and all the people there from Kota and Rajasthan Epicon, API. They are all very close to me, and I always enjoy their company. Well, the ball has already started rolling. Dr. Shashank Joshi has already said that we are moving as far as the estimation of blood sugar is concerned, that how should we measure the blood sugar level and how should we go for a meticulous control of blood sugar. Well, if I take you through this journey of time in range, which Dr. Shashank Joshi mentioned while having a discussion, it's a novel measurement tool beyond the gold standard of HbA1c. Well, if I take you through my presentations, I have got no actual or potential conflict of interest as far as the relation to this presentation. And my agenda for this talk is on these three headlines. Well, if we take the era of HbA1c, we must agree that HbA1c as a tool of measurement of good glycemic control have served for a very, very long time, and it is a gold standard which is considered from all the angles, from the patient's point of view, from physician's point of view, as well as from the regulator's point of view. Well, from the patient's point of view, we see the HbA1c gives a good glycemic metric for guiding the therapy changes, where we say that, as Dr. Shashank Joshi has mentioned, that for a young diabetic, type 2 diabetic, it should be around 6.5%, for 6.5 to 7%. With comorbidities and elderly, we can go even up to 7.5%. So for patient's point of view, it's the main measurement criteria for rating the quality of diabetes care as far as deciding about the medication as such. Now, for the physician's point of view, it's a main diagnostic criteria, as all the guidelines have mentioned about HbA1c only, and it has been the target standard used in diabetes algorithm, whether it is the national or international guidelines. They have all used the criteria of HbA1c serving for the good glycemic control. Even for the regulators, the main outcome marker is HbA1c for health authorities' approval of new glucose-lowering medication, as well as technology for diabetes management. So, if you see, it has served a very good purpose for a good glycemic control in large number of type 2 diabetic patients. And we have seen in about 25 years back, when DCCT also established the importance of HbA1c, saying that once the HbA1c goes on increasing, it increases the microvascular complications like retinopathy, nephropathy, neuropathy, or microalbuminuria. Well, but now we have started realizing that HbA1c has got its own limitations as well. As medical science is always an evolving science, whatever we have learned in the past, it goes on changing, and newer evidences they pour in. And then it changes our approach also for a better care of our patients. Well, the limitations, if we say for HbA1c, the most important one being that it does not capture the hypoglycemia. And in impact study, it was shown that those patients who had the good HbA1c level of 6.7%, they spent more than 3 hours in a day where their blood sugar went below 70. That was, they were in hypoglycemia, and that usually is not captured by HbA1c. The second important part, which is not captured by HbA1c estimation, is the individual differences in HbA1c. That two patients having the same HbA1c can have a different levels of blood sugar during the day. So intraday variation is not being captured. And then the comorbid condition, which is associated like anemia, hemoglobinopathies, or iron deficiencies, or even in pregnancies, that can affect the change in the level of HbA1c, that is also not captured by the estimation of this. And third and most important, as Professor Tiwari was asking, that even in spite of the control, good control of HbA1c and good glycemic control, even then the morbidity and mortality is not decreasing. Probably this is the answer, that it does not capture the glycemic variability. That studies have shown that intraday variation in the glycemic variability causing hypoglycemia, or this variability, if it is more, it causes more cardiovascular events and macrovascular complications. Probably that increases the morbidity and mortality. So definitely HbA1c has got some limitations also, which have come to a fore once we have started realizing. The example, very good example is of these two patients. If we do the continuous glucose monitoring, we will observe that with HbA1c of 8% in both the patients, there is a variation of glycemic variability in the first patients, where there are many episodes of hyperglycemia associated with many episodes of hypoglycemia, while in the other patients, there are less glycemic variability throughout the day. Still, the HbA1c says that in both the cases, it is around 8%. And it has been established in many of the trials, like DEVOTE trial, which says that if glycemic variability is more, the adverse outcomes are also more, like this gray bar, which shows high variability, blue bar, which shows a low variability, and it all shows that high variability causes severe hypoglycemia and major adverse cardiovascular events, or even all-cause mortality. So probably here lies the answer of Professor Tiwari, that even in spite of good control of HbA1c, this variability causes more of a disease or morbidity and mortality. At the same time, once we prescribe, we ask the patient to do SMBG, self-monitoring blood glucose. Even then, it does not give us the complete picture of the intraday variation. But at the same time, if we do the CGM, the continuous glucose monitoring, it tells us the story that for how many hours or minutes the patient was in hypo or was in hyper, or again in the night he was in hypoglycemia. So this is probably gives us the better information of intraday variability of glucose levels, which can give us an idea that how should we manage our type 2 diabetic patients to provide them a better quality of life. So my dear friends, the world is changing. The world is changing. Now we are realizing the shortcomings of HbA1c also. And so the world is changing towards TIR. The TIR is time spent in range of glycemic control. And this was discussed in last February in Advanced Technology and Treatment for Diabetes, this conference which was held in Berlin. And although the different countries, they are moving at the different rates, but then definitely there is a movement from HbA1c going into TIR, or time in range. So what now the time in range is, this is a novel metric or novel assessment of good glycemic control. Now what is time in range? As we all know, as the name suggests, time in range refers to the time spent by an individual in targeted glucose range. The targeted glucose range, which has been prescribed, is between 70 to 180 milligram %. So that is the good control, and where the maximum the patient spends in time in range as far as his glycemic control is concerned, the better it is. But occasionally in young individuals, it may be between 70 to 140, but majorly it is 70 to 180. Along with this TIR, there are nomenclatures of TBR, which is the time spent below range, which is synonymous to hypoglycemia, which is nowadays as considered. So now the nomenclature for hypoglycemia is changing to TBR as well as TAR, which is above the range, for hyperglycemia respectively. So I'm sure that in the coming months or you will hear more about TIR, TBR or TAR rather than hypoglycemia or hyperglycemia. So TIR may be used as an appropriate endpoint for the clinical research, and it is emerging evidence. They are suggesting that TIR is inversely correlated to the development of various microvascular and macrovascular combination, the complications. The more the individual spends the time in TIR, lesser are the complications and likewise. So let us see what is the relationship, what is the advantages and disadvantages of HbA1c versus TIR. The HbA1c, of course, evaluates a single value, compares every 3 months, and does not capture the hypoglycemia, as well as immediate effect of the therapy changes are not recorded. While in TIR, we can evaluate continuous glucose levels, compare any time period whenever we have given the therapy, whether the blood sugar is well under control or not, and captures all the glucose levels given at the time frame. And also the immediate effect or immediate effect of the therapy. If we intensify the therapy, it has been recorded. But then HbA1c has got a good correlation to clinical endpoints, and there are many long-term studies or even guidelines. They still suggest the HbA1c levels as the gold standard. In comparison to that, even the correlation to endpoints are still not clear, and this is evolving method of estimation. So probably in the coming time, we will have more information about that. At the same time, if we see in type 1 and type 2 diabetics, there is a strong correlation between HbA1c and TIR. And if you see at the 50% times, if the patient remains in TIR, that is time in range, usually the HbA1c is around 8.3. Now, if we increase the TIR by 10%, there is a decrease in HbA1c to the tune of around 0.8%. So every 10% increase in TIR decreases the HbA1c of around 0.8%. So the recommendation is that if a patient spends the time in 70% of TIR, then the HbA1c is around 6.7%, and that is the targeted range. And this study clearly shows that if TIR is less, for each 10% less TIR, retinopathy or microalbuminuria, it increases tremendously, around 64% increase in retinopathy and 40% increase in microalbuminuria if TIR decreases by less than 10%. Well, not only this, even 10-year cumulative incidences of developing diabetes-related complications have also shown that whether in type 1 diabetic or type 2 diabetic, whether macrovascular complications or microvascular complications like retinopathy or nephropathy, they have all shown that with the increase in TIR, the complication rate decreases considerably. So naturally, it is very well correlated. TIR is very well correlated with the development of complications. Now, my last and the point is the guidelines on time and range. What it has been suggested is that in the current update of 2019, where it was advised for advanced technology and treatment for diabetes, it has suggested to develop continuous glucose monitoring targets based on the currently agreed upon CGM metrics, which is TIR. That was the purpose of this report. And 10 CGM metric clinics for the clinical care, it has been suggested that guidance on the target of TIR or TBR or TAR for all the adults of type 1, type 2 diabetics or special populations, including older or high-risk individuals, as well as during pregnancy. So what international consensus for CGM data interpretation says that if in type 1 or type 2 diabetics, it is about 17 hours of spending in TIR, that is more than 70%, then it's a good control. Similarly, for older or high-risk individuals, it may be even for more than 50%, that is around 12 hours. But for pregnancy, again, it should be more strict, around 17 hours or more than 70%. And for GDM, usually the data are still awaited. Similarly, the time of hyperglycemia or TAR is also determined in this study as well as for TBR. So what it says is that each incremental 5% increase in TIR is associated with clinically significant benefits for type 1 and type 2 individuals. Well, my dear friends, my last two slides, which is there are recommendations to achieve this TIR. The key points to emphasize upon is that for type 1 and type 2 diabetics, one should try to achieve the goal for both TBR and TIR, that below the range as well as in the range. And first priority should be to reduce the TBR to target levels and then address the TIR and TAR targets that it should not go up. Now, in older or high-risk individuals, the individualized and conservative approach with a strong focus on reducing TBR and preventing excess TAR. It should not be very high, it should not be very low, but focus should be in reducing the incidences of TBR or hypoglycemia. For pregnancy or type 1 diabetics, we safely increase the TIR at early stage of gestation while reducing the TAR and glycemic variability. So tighter control is more important to have a better outcome of pregnancy. Well, for gestational diabetes, even more data is needed, stricter control, and it is said that 90 to 100% times the patient should be in TIR and then can have a better outcome. Well, my dear friends, to summarize my talk, I would like to say that HbA1c is the gold standard for diabetes management. However, it does not demonstrate a holistic and individualized glucose profile, as TIR provides a closer view of the person's glycemic status and aids in the better glycemic control. Increasing TIR has been shown to have association with reducing microvascular and macrovascular complications in people with the diabetes, and international guidelines have now been updated to include the consensus on continuous glucose monitoring, and according to this, the data interpretation. A need exists to move beyond HbA1c because we want to provide a better quality of life. We want to further reduce the morbidity and mortality. We want to reduce the microvascular and macrovascular complication to a great extent. At the same time, we want a safety also where the patient should not go in hypoglycemia. So we should move beyond HbA1c alone and also consider continuous glucose monitoring data for optimal diabetes management. Well, my dear friends, I would like to end my talk with my favorite slide, that I would say that whatever science and guidelines they say, we should know and we should update our knowledge for a better care of our patients. But managing your diabetes is not a science, it becomes an art. And the clinician should be an artist at the same time once they know about the science for a better control and better management of their diabetic patients. Well, thank you. Thank you very much once again for your patient listening.
Thank you,
sir. Thank you, sir. Thank you.
Thank you very much, sir, for this very good lecture. That it's much beyond HbA1c, more so with now we move on to time in range and glycemic variability, and there is so much more for glycemic targets. Dr. Tiwari, sir, your comments. I would like. Sir, kindly unmute yourself.
Unmute Dr. Tiwari.
Yes,
sir.
Dr. Soni, I have seen few patients with complications of diabetes without diabetes. Patient has got no diabetic, but he has got complications of diabetes. And after 5, 6, 7 years, he has developed diabetes. So what is that?
Sir, there are the criterias. The criterias where the patient can, this diabetes is also a metabolic disorder. Now, we consider rather this diabetes to be a vasculopathy. So most of the time what happens that vasculopathy, even in pre-diabetics, even before that, once there are a predisposition, like genetic predisposition, like dietary, like other factors, smoking, hypertension, or other predispose or dyslipidemia, these predispose for the development of vasculopathy in these patients. And once vasculopathy starts, the complication starts developing, as all these studies, even UKPDS has also shown that even in a clinically evident diabetic patients, the complications of microvascular and macrovascular, they start much earlier. Particularly macrovascular complications, they start even 10 years in advance. The macrovascular complications, they proceed to the clinically evident diabetes, while microvascular complications, they follow the development of diabetes. UKPDS has also shown the tighter control, the better is the outcome as far as the microvascular complications are concerned. But mortality is not decreased. Mortality is related to macrovascular, where vasculopathy starts earlier than the development of clinical diabetes. That is why the problem occurs.
Thank
you, sir. Thank you very much. Dr. Soni, we'll be meeting probably after March somewhere.
Yes, sure, sir.
Some CME or some conference.
But one comment I would like to say, that at least you should also color your hair. You are looking older in this your setup.
Sir, मेरी इच्छा तो ये है कि ये सारे बाल मैं आपको दे दूं, आपके लगा दूं. Thank you, sir. Thank you very much.
Soni sir, Dr. Soni.
Yes, sir.
But TIR, you need CGM. So how frequently you recommend CGM?
The CGM which is recommended is that even up to 3 to 4 times in a month. That is the issue. That is the only issue which is to be worked out. And probably in due course of time, we will have a little more painless procedures, little more. Even one CGM gives us the information for 14 days, even up to 14 days. Yeah. So even every month or alternate months, we can do that, but better assessment can occur with the painless procedures or painless devices also, which I'm sure that in due course of time it is going to come.
Yes, thank you. I think second time when we use, first time when we know what is the pattern of TIR, then we can use it less frequently, every month or every 2 months. But at least after the first device, then we must know what are the results of the treatment in the second device. So subsequent is very important, but later on you can use bi-monthly or 3 monthly or.
That's right.
Thank you, sir. Thank you so much.
Thank you very much.
Thank you.
Thank you.
Thank you, sir.
Thank you.
So now we go on to the next session.
And we go on to the next session of neurology update. For this, we have the chairpersons, Dr. Ashok Singh Rathod. He's the principal specialist, Medicine District Hospital, Powda, Jodhpur District Level Award for Excellent Services. Welcome, Dr. Ashok Singh Rathod. We have with us Dr. Sanjay Jaiswal. He's DOM Neurology. He's Director at Senior Consultant Neurology, Jaiswal Hospital Neuro Institute, Kota. And he has started first stroke unit in private sector in Hadoti, and he has several publications and awards to his name. The next chairperson is Dr. Arvind Kumar Jain. He is a senior professor, unit in charge, a senior he's working at SN Medical College, Jodhpur. He has various awards, research papers, and to his name. I request the chairpersons to kindly introduce the speaker. The first talk will be of Dr. Shrikant Sharma. Dr. Ajay will introduce Dr. Shrikant Sharma.
So after diabetes and hypertension update, now we will move to neurology update. And I'm going to introduce Dr. Shrikant, who is Professor and Head of the Department of he is Associate Professor in the Department of Medicine, Medical College, Jaipur. He has also worked as a senior resident in the Fortis Hospital in Noida. And he has published more than 50 papers in national and international journals. He has also presented 2 posters in the Los Angeles in American Association of Clinical Endocrinology and 1 poster in the Gulf chapter of American Association of Clinical Endocrinology. Now I request Dr. Shrikant to deliver his speech on advances in the management of acute ischemic stroke.
At the onset, I thank you all. I thank the organizer of eRAJAPICON to give me the opportunity. Can you see my slides?
We can see your slides. Thank you, sir.
Thank you. The topic I will be discussing will be advances in the management of acute ischemic stroke. Why it is said that time is brain? Because as you can see, salvageable area after a stroke, which is known as penumbra, it should be saved or it should be minimized by recanalization of occluded vessels and by preventing the expansion of ischemic tissue volume. Over days, it increases. So we have to act fast. This is the outline of my presentation. Stroke is the leading cause of long-term disability in the developed countries and one of the top causes of mortality worldwide. In the past decade, there have been substantial advances in diagnostic and treatment options available to minimize the impact. The first 2 key steps, will be early identification of patient with stroke and these patients to be traced to the center capable of delivering the appropriate therapy. As we can see, stroke are primarily 80% are primary ischemic stroke. Out of these, 50% are because of thrombotic phenomena, 30% are because of embolus from other side, whereas intracerebral hemorrhage 15% and subarachnoid hemorrhage 5% are responsible for primary hemorrhagic strokes. If we see the epidemiology, it is the second most common cause of mortality and third most cause of disability worldwide. If we talk of overall prevalence in India, it ranges from 147 to 922 per 1 lakh of patient population in India. We just see the right side of slide, 70% of strokes and out of the and 87% of stroke related death and morbidity occur in low and middle class countries, that is LMI. And these LMI countries like India, this phenomena is observed 15 years earlier than the developed one. So this makes an alarming situation for us. The moment we receive a patient with symptoms of acute ischemic stroke, there are certain tests which should be done in all patients, like non-contrast brain CT, blood glucose, serum electrolyte, ECG, a complete blood count, including platelet count, prothrombin, activated partial thrombin, and oxygen saturation. But in addition to that, there are certain conditions which mimic the patients of acute ischemic stroke. In these selected patients, we have to do these tests also, like hepatic function tests, toxicology screen, blood alcohol level, pregnancy test, arterial blood gas test, and chest radiography. Lumbar puncture in a patient of acute ischemic stroke is done if subarachnoid hemorrhage is suspected and CT suspected and ACT is negative for blood. And EEG can be planned if the seizures are suspected. If you receive a patient, there are certain scales to assess the patient. The preferred one is NIHSS, that is Institute of Health and Stroke. This score is the preferred one. It has 11 items included with a score of 0 to 42. If the score is less than 5, then score is said to be mild. A score of 5 to 9 is moderate, and more than 9 is considered to be severe one. Other scores for saying the how much occlusion occur in large artery have been said, like rapid arterial occlusion evaluation score. Once we have assessed the patient, we should see the poor prognostic factor in stroke. These are accompanying fever, hypotension or hypertension, low oxygen saturation, hypo or hyperglycemia. If the patient has total anterior circulation stroke, that is 55% of the area, this is considered as poor prognostic factor. Pontine hemorrhage, low GCS score, heart failure are again a poor prognostic markers. This pyramid shows what we are going to do in a patient of acute ischemic stroke. The foremost is supportive management, that is airway, temperature, blood pressure, blood glucose, and cardiac assessment, followed by thrombolysis, either intravenous or intra-arterial. Antiplatelet and anticoagulant drugs have been planned. There are certain conditions, like in SCH, we plan for hemodilation, vasodilator, and induced hypertension is done. Last, although not very promising, neuroprotective agents are there. To start with, I show you 2 slides for general supportive care with their level of evidence. In immobile AIS patient without contraindication, intermittent pneumatic compression is device is recommended to prevent DVT. It is a COR score of 1, whereas the benefit of prophylactic dose of heparin is not well established with a COR score of 2B. Blood glucose levels should be maintained in a range of 140 to 180, and close monitoring should be done for hypo or hyperglycemia. Hypotension and hypovolemia should be corrected to systemic perfusion level. Continuing with the general supportive care, the benefit of flat head positioning early after hospitalization is uncertain with a level of evidence of 2B. Supplemental oxygen, although used in or required in condition, but is not recommended in non-hypoxic patient. Hyperbaric oxygen therapy is not recommended except when AIS is caused by air embolism. The benefit of treatment with induced hypothermia is uncertain. There should be dysphagia screening before the patient starts taking over, because in patients who are prone for risk of aspiration, they should be screened for dysphagia screening. And in those which we have a reasonable dysphagia, use of nasogastric tube for early phase of stroke, that is first 7 days, is recommended. Those who has dysphagia expected for more than 3 weeks, percutaneous gastrectomy should be placed in patient with in these. In 2019, Government of India gives the guidelines for prevention and management of stroke. In this, patients who are received within 0 to 3 hours of the symptoms onset, IV tenecteplase or alteplase is recommended, whereas the patient in which the time period is 3 to 4 hours, IV alteplase is recommended with additional screening of age, history of diabetes and previous stroke, and patient should not be on anticoagulation, or the NIHSS score should be less than 25. You can see these are the 2 approved thrombolytic agent, alteplase versus tenecteplase. We can see that fibrin specificity, thrombolytic potency, and PRT, that is platelet-rich thrombus activity, is more with tenecteplase, whereas fibrinogen depletion activity is more with alteplase. Discussing IV alteplase first, as per ASA 2019 guidelines, it should be given in 0.9 milligram per kg with a maximum dose of 90 milligram over 60 minutes with an initial 10% of dose to be given bolus over 1 minute. And if this patient has 3 points I will going to discuss in patients who are received within 3 hours. The age of these patients should be more than 18 and less than 80 years. And the last 2 points you can see, either patient is having severe or mild disabling score. Despite the risk of hemorrhagic transformation in severe stroke, there is still proven clinical benefit for patient with severe strokes. A second group of patient in which we have the patient presenting to us in a time period of 3 to 4.5 hours, IV LT plays in a dose of 0.0 milligram per kg, maximum dose of 90 milligram of 60 minutes. And there are certain criteria for which we have to look again, like less than 80 years of age without history of diabetes and prior stroke. The score of NIHSS should be less than 25. He should not be on oral anticoagulant and without evidence of any bleed and injury involving more than 1/3 of MCA territory. Suppose the patient is being planned for IV LT-place, but he is on drug monotherapy or drug combination therapy, that is either aspirin or aspirin plus clopidogrel. But the evidence shows that the benefit of LT-place overweighs a possible increase of ICH. So these are recommended to be given IV LT-place in patient presenting to in this particular time period. If the patient is of end-stage renal disease and he is on hemodialysis with a normal APTT, IV LT-place is recommended. However, those with elevated APTT may have elevated risk for hemorrhagic complication. A slide, couple of slides for IV tenecteplase. It is given in a dose of 0.25 milligram per kg, maximum of 25 in patient who are eligible to undergo medical thrombectomy. And at dose of 0.4 milligram single bolus who are considered, we have seen this slide shows that when the patient was given a 0.25 milligram per kg in comparison to LT-place, the conclusion of this study was published in Journal of Emergency Medicine and Trauma 2020, that tenecteplase should be considered as an alternative to LT-place, especially at the site where we have to transfer the patient for thrombectomy. There are some certain limitation of LT-place used in ischemic stroke, like current intracranial hemorrhage, subarachnoid hemorrhage, internal bleeding, recent within 3 months spine surgery or intracranial surgery, presence of intracranial conditions like neoplasm, AV malformation or aneurysm. There should not be a bleeding diastasis history, and patient should not have current severe uncontrolled hypertension. How do we assess what we have achieved? There are certain scores to see the reperfusion. This is TICI, that is thrombolysis in cerebral infarction score, ranging from 0 to 3. 0 is no perfusion beyond the point of occlusion, whereas complete perfusion is 3. With a mild modification in the grade 2, we have another score which is known as modified TICI scale, just to see the how much reperfusion we have achieved by this our IV LT-place or IV thrombolytics. Although not very much promising, but we have to discuss neuroprotective agents as well. There are certain free radical scavengers available like vitamin C, vitamin E, and NC-fabol. At present, no pharmacological agents have demonstrated efficacy in improving outcomes, so neuroprotective agents are not routinely recommended. Statins or HMG-CoA enzyme reductase inhibitor exert neuroprotective properties by effects on endothelial function, by increasing cerebral blood flow and inflammation. So, a level of class 2A, COR of 2A or level of evidence B says that continuation of statin therapy, those who are taking statin before AIS should be continued and this is accepted. Now we summarize the evaluation treatment summary with a meta-analysis that stroke scare NIHSS is recommended with a class of recommendation 1 and level of evidence B. Imaging for IVLT place, NCT head is sufficient, no need of MRI for IVLT place. CT angio or MRI angio with TWMRI with or without perfusion is recommended in wake-up stroke patient. Wake-up stroke patient are those patients who wake up with the symptoms of acute ischemic stroke, but they slept well with in normal health. This is a diagnostic dilemma because in 1 in 5 these are in ischemic. So we have to look further deeply in this patient with CT angio or MR angio as well. Imaging for a medical thrombectomy should be done as early as possible. Imaging for extracranial carotid and vertebral arteries may be reasonable before mechanical thrombectomy to rule out any occlusion there. Patient of AIS within 6 hours of onset can be selected for mechanical thrombectomy on the basis of CT or MR angio. In recent past, we have got various type of thrombolytics. You can see fibrin specific and non-fibrin specific in this slide. Out of these, alteplase and tenecteplase have been approved by FDA for use in acute ischemic stroke. Now we see the endovascular therapy. After FDA approval of IV TPA, it has innovated the entire field of emergency neurology because up to 69% of a stroke patient, they are ineligible to receive ITP because of delay. So the time window has been extended due to EVT and has put the physician with a strong therapeutic arsenal. The recent advances in acute endovascular therapy is that currently initial CT scan without evidence of large infection is sufficient enough if the patient is initiated with the procedure within 7 hours of stroke onset. We cannot ignore the secondary prevention of ischemic stroke. We have multiple agents in our basket for this. These are antithrombotic agents like ticagrelor combined with aspirin, or low-dose factor Xa inhibitors combined with aspirin, or oral factor inhibitor combined with antiplatelet. There are certain lipid-modifying agents like proprotein convertase type 9 inhibitor or antisense oligonucleotide lipoprotein A inhibitor. GLP-1 is a receptor agonist and PPAR gamma agonist used for glucose metabolism can be used. Studies are being going for anti-inflammatory therapy like low-dose colchicine. As you can see, that this slide, these RCTs are being carried out at various places.
Shrikant, you will have to summarize in 1 minute. You will have to.
Okay. Yeah. Now there are eight T's of stroke care: detection, dispatch, delivery, door, data, decision, drug and device, which we should plan for stroke care. We can improve stroke system of care by improving door to needle time. We can equip the ambulance with a direct line to stroke neurologist. Consent for thrombolytic can be taken on phone. Prompt CT scanning should be done. Once the patient arrives, it should be taken to ambulance to CT scan directly, where it can be quickly examined by neurological examination. And if the CT scan excludes hemorrhage, thrombolytic can be given immediately. So 3 features of protocol are for this is a pre-notification ambulance, direct to CT include, and pre-mixing of thrombolytic. Telestroke can be done by audiovisual connection with hub as a stroke unit and spokes as non-stroke central and smart rural hospital. Mobile stroke units can be made by ambulances equipped by mobile CT scanner or installation of telemedicine equipment for remote interview and neurologist. I summarize in last 2 slides that administration of RTPTA has been shown to effective in up to 4.5 hours. acute endovascular intervention has dramatic results for AIS patient, and advances in technology through pre-hospital trials via telephone or TPA administration via telemedicine, or actually administering thrombolytic in ambulance has given us no treatment to one with multiple prone option. So need for the hour is that we quickly identify the patient and necessary clinical and logic evaluation is done, and rapid administration of intravenous thrombolytic therapy and endoscopy. Thank you.
Okay, thank you so much, Dr. Shrikant, for that very comprehensive talk, and it was very enlightening talk on advanced management of stroke. We are running a little delayed in time, so I think we will not be taking any questions right now. There was a small correction to be made that one of the chairpersons who had introduced Dr. Shrikant Sharma is Dr. Ajay Singh Rathod. He is Senior Consultant Physician, Deepmala Pagarani Hospital and Research Center, Holy Family Hospital, Ajmer. He is MD from SPS Medical College. He has FICP awarded by Indian College of Physicians. He has distinguished physician awards. He is the Honorary Joint Secretary, APA Rajasthan 2019-20. He has a lot of laurels of distinctions. We probably, the technical team probably displayed as some, there are two, Dr. Ajay Singh Rathod, so that was probably the error. So we thank you, Dr. Ajay Singh Rathod, for chairing the session. Now, moving on, I would request the chairperson, Dr. Sanjay, to kindly introduce our next speaker, Dr. Vijay Sardana.
Dr. Vijay Sardana is professor and head Department of Neurology in Medical College Kota. He is principal and controller, Government Medical College Kota. He did his DM Neurology from a prestigious institute, Vijay Chandigarh, and then he joined as a consultant neurologist at AIIMS New Delhi before joining to the Medical College Kota. He has more than 75 papers in various national and international journals, and he is MCI assessor. He has produced a very important movie on the stroke regarding the stroke awareness in the general public. He has established stroke unit, first time in government sector in whole Rajasthan, and he has started DM Neurology training program in Government Medical College Kota. Apart from this, he is a very great human being, always ready to help his colleagues, friends, and poor and needy patients. He is an excellent teacher and clinician. Now I invite Dr. Sardana to deliver his lecture. Now I invite Dr. Sardana to deliver his lecture.
Dr. Sardana, are you here?
Yeah. Thank you. Thank you, Chairperson.
Thank you, dear. Thank you.
At the outset, I thank Dr. K.K. Parikh, Dr. Girish Mathur, and the whole team for giving me opportunity to speak on this topic, which is a very common problem. And I'll try to focus my presentation on whatever dilemmas in day-to-day practice we have regarding management of intercerebral bleed. My focus will be on hypertensive intercerebral bleed. We know that the hypertensive intercerebral bleed affects more than 1 million patients annually worldwide, and it is one of the most disabling disease. It constitutes 10 to 15% of all strokes. The main risk factor we all know being uncontrolled hypertension, and in 70 to 80% of cases, it's because of spontaneous rupture of small vessels because of hypertension. Incidence is higher in Asians because of limited primary care of hypertension and poor compliance of the drugs. The small ICH, on one hand, patients are readily survivable and they have very questionable deficit if at all. But on the other hand, large ICH, they require multidisciplinary care, specialized neurocritical care to reduce number of hospital stay days and reduce mortality. We all know there are 4 or 5 sites of hypertensive bleed. the most common being putamen, followed by thalamus. Lobar subcortical bleeds are also because of hypertension, pontine and cerebellar hemorrhages. Early diagnosis is key to successful treatment, and it's crucial, we all know. When do we suspect clinically? We know that 30% of times we suspect ischemia, it turns out to be hemorrhage. We suspect hemorrhage, it turns out to be ischemia. But then there are certain things which compels us, which guides us that it could be hemorrhage. That is, if it is of sudden onset, severe headache associated with vomiting, if the blood pressure is elevated to a great extent, and if there's a decreased level of consciousness, then we can be reasonably sure that it is possibly ICH and not ischemic stroke. But still, we can be wrong sometimes. Non-contrast CT is highly sensitive and specific for ICH and is key to early diagnosis. Now, how do we manage ICH? The principles are, first we have to predict whether the hematoma is going to expand or not, to see what our attitude towards treatment should be in next 24 to 48 hours. Then we have to prevent hematoma extension by good blood pressure control, reversing INR, platelet transfusion if required, and treating metabolic factors. And then, of course, we have to monitor for complications of ICH, like seizures and hydrocephalus. The million-dollar question initially is it expanding? See, almost all hematomas, they extend by 24 hours, but the maximum expansion takes place during first 3 hours, amounting to 36%, followed by 16% in next 3 hours. Beyond 24 hours, rarely, if any, there is expansion, especially I'm talking about hypertensive bleed. Now, how do we predict whether hematoma is going to expand or not? There's a sign called spot sign in radiology, where you do CT scan plain, patient shows hematoma, you go for CT angio, and if you see a concentrated, contrast-taking spot inside the hematoma, that is known as spot sign. It indicates dynamic nature of the bleed, and you can be pretty sure that the bleed is going to expand in next few hours. Like in this picture, the fourth CT scan is of same patient and is taken at 24 hours, and the hematoma is expanded. Calculating ICH volume is again important for many aspects, for prognosticating, for planning the management, and it can be calculated by a simple formula given here. And 30-day mortality depend on ICH score. We can score all the patients, and it's a good practice to score. It depends on ICH volume, intraventricular extension, presence or absence, the location, whether it is infratentorial or supratentorial, age of the patient, and GCS. The total score is from 0 to 6, and if the score is 5 or 6, mortality, 30-day mortality is 100%, as opposed to if the score is 0 to 1, the mortality is less than 13%. Now, how do we prevent hematoma extension? First, the blood pressure control. Here, the criteria are slightly different than the ischemic stroke. We are more liberal in controlling blood pressure in case of hemorrhagic stroke. This is one of the largest trial, indirect trial, 2,839 patients. Treatment arm consisted of controlling systolic blood pressure less than 140, control arm less than 180, and intensive blood pressure lowering showed better functional outcome at 90 days. This is a good large study, and of course the death and severe disability was similar, but it does show clearly statistically significant difference of early treatment, aggressive treatment of blood pressure in case of ICH. Attached 2 study went a little further. They treated 1,000 patients and brought down blood pressure, systolic blood pressure from 110 to 139, and target systolic blood pressure of 140 to 79. No difference in death or disability rate was noted, But the rate of renal adverse events were a little higher in intensive treatment group, 9 versus 4%. So meta-analysis, what did that meta-analysis show? Patient who achieved early stable systolic blood pressure reduction in first 24 hours to level as low as 120 to 130 millimeter of mercury had a more favorable outcome. What AHA stand is there for BP control? If the SBP is between 150 to 220 without contraindication, if there's no contraindication, then lowering of systolic blood pressure to 140 is safe. It improves functional outcome. If the systolic blood pressure initially is more than 220, consider aggressive reduction, but then systolic blood pressure target in this case is 140 to 160, and continuous intravenous infusion or frequent BP monitoring is indicated. These are the drugs we all know. I'll not go in detail. Commonly, we use intravenous labetalol, nitroprusside for lowering acutely blood pressure in case of hemorrhagic stroke. As far as the intracranial pressure management is concerned, one, hematoma itself can cause it. Second, the mass effect due to hematoma surrounding edema or hydrocephalus can also contribute to it. One should take certain basic measures, which includes head elevation to 30 degrees, mild sedation as needed for comfort. We should avoid endotracheal tube holder, securement devices ties, constrictive central line dressings. Twisting of head might constrict the cervical vein. All these things can further rise intracranial pressure, so we should avoid. And as far as the fluid is concerned, normal saline is best as opposed to hypertonic fluid, which is contraindicated. Now again, the million-dollar question, steroids. The ICH management differs in different setups, and still many people are using steroids. But this study in New England Journal of Medicine, which is a landmark, though slightly old, but the things have not changed, that there is no role of steroids. Even the study had to be terminated because 93 patients had adverse effect complications due to steroids. So as on today, steroid has got no role in management of ICH. Invasive ICP monitoring in good centers does have a role, especially if the GCS is less than 8, if there's a clinical evidence of transtentorial herniation, if there's a hydrocephalus, significant intraventricular component, and if there's a the goal should be the cerebral perfusion pressure of 50 to 70 millimeter of Hg. Now, one simple thing has come up recently, ocular ultrasound, which measures optic nerve sheath diameter using ocular ultrasound. Whenever there is a raised ICP, the optic sheath and the optic nerve, between that, the fluid increases. It seeps from the brain because of raised ICP, and that diameter increases. If it is less than 5, there's no ICP. If it is more than 5, it's suggestive of raised ICP. So this is a simple ultrasound measure which is possible at bedside to know the raised ICP. Fluid drainage is another way, especially used wherever there is a hydrocephalus, trapped ventricle, and patient has got poor GCS, though not commonly used. Osmotic therapy, hypertonic saline or mannitol, both can be used. There is no compelling evidence to support the superiority of either agent. Some studies suggest that the hypertonic saline is more effective. If you want to compare the two, this is the comparison. And in hypertonic saline, the sodium goal is 145 to 155, not beyond that. You can give 3%. You can also 23.4%. The circulatory overload is, of course, one of the risks. And in case of mannitol, a reversible acute renal failure is one of the risks. There are certain salvage therapies to reduce ICP if the CSF drainage or osmotic therapies fail. And these therapies include, one is pharmacological coma. You can induce it with pentobarbital, but you have to do continuous monitoring with EEG, and it should be given till you achieve the burst suppression. It can also be given in a good setup where you have stroke unit kind of a setup with all intensive care facilities available. You can also give propofol with a loading dose of 1 to 3 milligram per kilogram and later on infusion. Hyperventilation can also be used. It causes rapid lowering of ICP by inducing cerebral vasoconstriction. Effect lasts for a few years. You can buy time for other measures till that time. Especially you can use it when you have acute brain herniation until more definitely therapies can be implemented. Neuromuscular blockade is useful theoretically because muscle activity, if the patient is restless, can increase ICP by raising intrathoracic pressure and reducing the cerebral venous outflow. Increased risk of pneumonia and sepsis is always there. So it helps in a short term, as a short-term measure, but then the disadvantage is that you lose the ability to evaluate the neurological status of the patient because the patient is paralyzed because of the neuromuscular blockade. Now again, the situation is platelet transfusion or ASA use. This study with 282 cases managed at onset and at 72 hours, including 70, that is 25% taking antiplatelet medication. As against the common belief, there was no difference in baseline hematoma volume. Those patients who were taking antiplatelet just before hematoma and those patients who were not taking. So this is a common belief that patients who were on antiplatelet, hematoma is going to expand, it is going to take more kind of wild shape. This is not true. And patients who are on aspirin are going to have the same course with the hematoma as with the patients who are not taking aspirin. Platelet transfusion may come to your mind as a salvage therapy or as a therapy, but the usefulness of platelet transfusion in ICH patient with a history of antiplatelet use is uncertain. So it is not advised, it is not advocated. Patients with severe coagulation factor deficiency, documented, or severe thrombocytopenia, documented, they should of course receive appropriate factor or platelet therapy. But otherwise, in a garden variety of patient who was on antiplatelet, there is no role of platelet transfusion. Tranexamic acid, there may be temptation to use that as in cases of many hemorrhagic disorders. But then a study, one of the largest, has shown that there is a short-term improvement in hematoma growth at day 2 and improvement in death at day 7. But factor 8, but long-term, there is no difference and it should be discouraged and it is not used. The same is with factor 8. Factor 8 trial was, fast trial was done. So it reduces ICH growth with 80 microgram per kilogram dose versus placebo. But in long term, there is an increased risk of thromboembolic phenomena and the MI and ischemic stroke risk has increased. So it has not been advocated. As far as the metabolic factors are concerned, hyperglycemia and hypoglycemia should be avoided. It causes harm to the stroke patients. Fever should be treated. Systemic screening for MI and ECG with ECG cardiac enzyme monitoring. Dysphagia screen should be done before initiating oral intake. Proton pump inhibitors, this is important. Proton pump inhibitors, histamine 2 receptors antagonists, they have increased risk of hospital-acquired pneumonia, and routine use should be avoided unless it is indicated. See how
Sir,
these
kindly summarize. Sir,
yes.
kindly summarize.
How these factors, they are important. Seizures should be treated on its own merit, but there is no role of prophylactic anti-epileptic drug in ICH. Hydrocephalus should be treated with EVD, especially if there is intraventricular extension. And intraventricular hemorrhage, there have been trials with RTPA, but those trials have not been successful, so routine use is not advocated. Intraventricular hemorrhage, the role of endoscopic treatment is also not proven. Lastly, important thing is whether to go for surgery or not. The STITCH trial, one of the important trial, clearly indicated that there is no role of surgery, early surgery versus conservative treatment in cases of hypertensive bleed. And this STITCH-2 trial, which tried conservative management against the surgical management of superficial hematoma, again showed some benefit, but then the benefit was better than the deep-seated hypertensive bleed, but the routine use is not advocated. So this is the summary. Cerebellar hemorrhage surgery is indicated in specific circumstances. Ventricular drainage is recommended in hydrocephalus. Supratentorial ICH, useful of the surgery, is not well established. So I'll summarize with the notion, with the statement that the hypertension needs to be treated aggressively in ICH patients. The role of medical therapy is as good as surgical, or rather surgical treatment is not superior. Patients who are on antiplatelet therapy, ischemic stroke is not very wild in them. Antiplatelet can be restarted if there is a risk after 2 weeks of having ICH, and similarly anticoagulant can be started after 4 weeks of having ICH. And these were the major practical guidelines for managing intracerebral stroke. Thank you very much.
Thank you very much for that very good deliberation on management of hypertensive bleed. That was really very enlightening. I do not see any questions in the chat box. So moving on to the next talk, I invite Dr. Arvind to introduce the next speaker, Dr. Rajendra Kumar Bansal, for his talk.
Thank you, Dr. Sardana, to be part of this conference. And I'm really thankful to you and extend my gratitude.
Thank you, sir. Thank you, sir. I'm honored.
Thank you. Hello. Yes. Yeah, I have joined.
Yes, sir. Hey, Dr. Bansal, aage ki nahi?
Yes, sir. Yes, sir. Yes, sir.
Thank you, sir. Thank you, sir. Namaskar.
Namaskar, sir.
Bansal sahab, namaskar. Good. No, battery ka ho rahi hai. Introduce, sir.
Yes, sir. Dr. Bansal. Is Professor of Neurology in DMC Ludhiana. This slide is missing, sir, on the screen.
Dr. Swati, put his slide, introductory slide of Dr. Rajendra Bansal.
The team has to do that.
Yes, sir.
Yes, sir. Yeah, he is working as Professor of Neurology at DMC, Dayanand Medical College and Hospital, Ludhiana. He has got a special interest in neurophysiology and the stroke. He was organizing secretary of EPICON in 2014 at Ludhiana. He is editor of Medicine Update 2016 and organizing secretary of Indian Epilepsy School and in 2016 at Ludhiana. I invite Dr. Rajendra Bansal to deliberate his talk. Dr. Rajendra Bansal.
Thank you, chairpersons. And I thank K.K. Parekh, sir, Dr. Garish Mathur, and Dr. Maheshwari for making me part of this excellent scientific meeting. For next 17 minutes, I will be talking about pre-hospital treatment of status epilepticus. This is not a conventional topic which is discussed in the meetings. So coming to why it is important to discuss this topic is the overall incidence of status epilepticus is about 10 to 40 episodes per 100,000 population per year. So approximately we will get 1.25 lakh to 5 lakh episodes of status in India every year. And if this status is not treated early, it becomes refractory and mortality increases significantly. So I will be basically talking about how much is the delay in status treatment, especially from India, how much is the mortality in status epilepticus, how much is the treatment gap in status, and what are the treatment options we have today in pre-hospital treatment of status. So this was a full-length article from Nizam's Institute, Hyderabad, that is convulsive status epilepticus clinical profile in a developing country. This data is from India. It showed that etiology was acute symptomatic in 54% of patients, and 20% patient who had established epilepsy, they developed status epilepticus. But more important than everything else, this was the mean stated duration before these patients came to hospital was 18 hours. The range was 1 to 72 hours. Only 10% patients came within 1 hour of status onset, and 28% patients came within 3 hours of status onset. If you look at this slide, about 40% patients, they came beyond 12 hours of status onset. Not only in India, this is an interesting study from Senegal also, which showed that only 4.6% of patients arrived within 6 hours of status onset. And this is very important that neurologists treated only 23% of patients. So it is of interest to all the physicians also, which treated 77% of status patients, that we should be concentrating on pre-hospital treatment of status. So let us look at the mortality data in status epilepticus, why we should be concentrating on pre-hospital treatment. The published mortality data in status varies from 11% to 34%. This wide range is because there are different causes and mortality varies in different ages. Also, mortality data varies from where the data is taken. This data varied from about 12% in a university hospital to 6.7% in a community hospital, and this mortality was only 1.9% in an epilepsy clinic. This was a landmark paper, short-term mortality after first episode of status epilepticus, published in Epilepsia. This study was a population-based retrospective cohort study to determine the short-term mortality after first episode of status. What was most important was that all patients in 20 years in Rochester, Minnesota were included in this study, and they were followed until death or at the end of the study till February 1996. So this study continued for about 30 years. Total of 201 episodes of status were there, and 38 deaths were there. So 90% people died within first 30 days after the onset of the status. 34 deaths, that is 89% of the deaths, occurred in acute symptomatic status, while 4 deaths occurred in those with unprovoked status. The summary was that 1 out of 5 patients died with status in the first 30 days, and short-term mortality is associated with the presence of an underlying acute etiology. This was another important paper talking about the determinants of mortality in status epilepticus. The inference was that this was a retrospective study of status epilepticus from 1982 to 86. Total 253 adults with status presented in the Medical College of Virginia. What was important? The seizure duration before coming to treatment was 30 minutes to 84 hours. So this data tells us that this is not significantly different even in developed countries. It is as bad as in developing countries. The conclusion was that in patient where duration of status before coming to the hospital was less than 60 minutes, mortality was only 2.7%. But in patients who had a duration of status more than 60 minutes, the mortality was 32%. So this brings us to a very important point. This paper in Epilepsy Currents, which talked about the mortality associated with status epilepticus, this study concluded that it is very uncommon for patients to die during status. During seizures, they don't die. The most of the mortality occurs within first 30 days after status onset. If we presume that we treat all patients with optimal treatment as per recommendation, there are the 3 other variables of mortality. These are age, etiology, and duration. We cannot change the age and etiology, but definitely we can look at the duration part before we start the treatment. This paper in Epilepsia, this paper talked about treatment gap for convulsive status epilepticus in a source 4 country. This was again had landmark observations. The key observation were that in low income countries, there is severe shortage in broad aspects of healthcare. This we all know. But in middle income countries, treatment gap in status epilepticus was mainly due to biased resource allocation. You will see there are ambulances for treatment of acute stroke, acute myocardial infarction, accident victims, but you will never come across a rescue team for status epilepticus. And more important than this, intravenous diazepam was the only drug available. Midazolam and lorazepam were not available. Intravenous lorazepam was available only in 4 countries, and there was lack of trained professional and inefficient emergency transport facilities. But if you look at high-income countries, there is a significant treatment gap, as we saw in that paper. Now, what are the treatment options available to us after talking about these things? So what are the characteristics of a non-IV drug which we use for status? The ideal drug should be usable in small volumes. It should have rapid onset of action if we are not using IV route for treating status epilepticus, and it should have a moderate duration of action up to few hours, and drug administration should be quick, easy, and safe. And this drug should be actually lipid soluble. More the lipid solubility, faster is the absorption across the tissue membranes, and we will be able to give it in the non-IV route. Diazepam and midazolam these are 4 and 6 times more lipid soluble than lorazepam. That is why whenever we talk about non-IV routes, we talk about diazepam and midazolam. On the other hand, lorazepam has a very slow redistribution, so it is a drug of choice in the IV route. So out of these 3 drugs, diazepam, midazolam, and lorazepam, let us look at the scientific evidence for using in the non-IV route. This was the paper for using rectal diazepam for pre-hospital pediatric status epilepticus patients. In this patient, the routes which were compared was rectal diazepam and intravenous diazepam. 81% patients who received rectal diazepam, the seizure stopped after a single dose. And no child treated with rectal diazepam required pre-hospital endotracheal intubation. That was very important observation. So this paper concluded that rectal diazepam is a simple, effective, and safe method for pre-hospital management of pediatric status epilepticus patients. And similar drug, intrarectal diazepam, was tried in adult patients also. Here also, the efficacy of intrarectal diazepam in the treatment of serial seizures in adult was confirmed. Onset of effect was noted approximately 10 minutes after the intrarectal injection, and the effective dose was 0.5 milligram per kg. This paper, here there was comparison of intranasal midazolam with intravenous diazepam was made. This was again intranasal midazolam and IV diazepam. This was an open label trial in children with prolonged seizure where duration of seizure was more than 10 minutes. The intranasal midazolam was similar in effectiveness to IV diazepam, but it resulted in earlier cessation of seizure due to rapid initiation of intranasal therapy than IV therapy. So this Lancet, again, this was a landmark paper where buccal midazolam and rectal diazepam were compared, and they were found to be, buccal midazolam was found to be as effective as rectal diazepam. This paper showed the efficacy of buccal midazolam compared with intravenous diazepam in controlling convulsions in children. This paper was significant because this drug was used, buccal midazolam was used in the emergency setup, and it was compared with IV diazepam, and it was found that buccal midazolam can be used as an alternative to intravenous diazepam, especially when getting an IV line becomes difficult, because overall control of convulsions within 5 minutes were 85% and 93% in buccal midazolam and intravenous diazepam group. So buccal midazolam was almost as effective as intravenous diazepam. This trial is the actually key trial which I wanted to show. This rampant trial, this was published in New England Journal of Medicine in 2012. What was compared was intramuscular versus intravenous therapy for pre-hospital status epilepticus. This is very widely quoted trial. In this trial, pre-hospitalized patient in ambulances who were presented in status, it was seen that how effective is intramuscular midazolam in comparison to intravenous lorazepam for seizure termination. So this was a multi-center randomized double-blind phase 3 non-inferiority clinical trial where 893 patients they were randomized into either midazolam group or lorazepam group. Primary outcome was termination of seizure without need for rescue therapy by arrival in emergency department. So what were the outcomes? Cessation of seizure without rescue therapy was seen in 73% patients in the midazolam group than in the lorazepam group, which was 63%. You required hospitalization in 57% patients in midazolam group, but in 65% patients in IV lorazepam group. ICU admission was again required in lesser number of patients in midazolam group in comparison to IV lorazepam group. Recurrent seizures within 12 hours of emergency room arrival, they were almost same in both the groups. Median time to administration of drug was significantly less in midazolam group. Onset of action was definitely less in lorazepam group. But there was criticism to this trial. This criticism was due to study design because this trial was unable to conclude if superior seizure termination was due to intramuscular route of administration versus IP route of administration or due to superiority of the midazolam as a drug than to lorazepam. And secondly, for giving intramuscular midazolam, an auto-injector was used in this study, and the results, many people thought that they may not be fully replicable in conventional settings. So what should be prescribed for acute seizures when there is no intravenous route? This paper was very important, and it concluded that for seizure cessation in less than 10 minutes, intranasal and buccal midazolam are better than either rectal diazepam or sublingual lorazepam. For seizure cessation in less than 5 minutes, intramuscular midazolam is definitely better. This Rampart trial showed that. Time from drug administration to seizure cessation, intramuscular midazolam was the fastest drug. It controlled within 2.1 minutes. In terms of time from arrival at the hospital to seizure cessation, intramuscular midazolam was again best. This could control seizure within 3.8 minutes and was superior to both IV diazepam and intranasal midazolam by about 2 minutes. So the bottom line is that intramuscular midazolam is supported by better evidence than intranasal route. It's likely to be more reliable, and considering the patient cannot feel the injection, it should be our first line agent, and we don't have an IV access during treatment of status epilepticus. So I will conclude that in India and world over, there is significant delay and there is a lot of treatment gap in the management of status epilepticus. And pre-hospital treatment is very important because it reduces morbidity. And we have seen from existing data that if the duration of status increases beyond 60 minutes before we start treatment, then the mortality increases significantly. So to accomplish this aim, we need to create awareness about the pre-hospital treatment to healthcare workers and general public. And we should tell all our patients who have epilepsy that whenever you get seizures, you should try to take intranasal midazolam or intramuscular midazolam. Thank you very much.
Thank you, Dr. Bansal, for your nice and comprehensive talk about pre-hospital management of epilepsy. I think it will be very helpful to those persons who are treating and guiding the ambulance workers for pre-hospital treatment.
Thank you, Doctor.
Thank you, sir, for giving me this opportunity. It is a great conference. Thank you, sir.
So we thank all the speakers and esteemed chairpersons, Dr. A.S. Rathod, sir, Dr. Sanjay Jaiswal, sir, Dr. Arvind Jain, sir, and our speakers, Dr. Shrikant Sharma, sir, Dr. Vijay Sardana, sir, and Dr. R.K. Bansal, sir, for sparing their valuable time. And now we move on to the next session, that is the diabetes update, including a galaxy of star speakers. I invite the chairpersons for this session, Dr. R.K. Khivsara sir from Jodhpur, Dr. Ashok Jain sir from Kota. Dr. R.K. Khivsara sir is an MD FICP and a consultant physician and diabetologist at Siddhi Nursing Home, Jodhpur. He is a fellow of Diabetes India, life member of RSSDI and API. He has been an assistant in the diabetes unit of Bombay Hospital, Mumbai, governing body member of RSSDI Rajasthan chapter, and a regular speaker and a renowned personality in Rajasthan. So I welcome you, sir.
Thank you, sir. Thank you very much for your kind introduction.
I also welcome Dr. Ashok Jain, sir. He is MD, FICP and Senior Consultant Physician and Director at Ratna Nursing Home, Kota. He is a Fellow of ICP. He has been past President, API Kota Chapter and past Vice President of IMA Kota Chapter. I welcome Dr. Ashok Jain, sir. Now I request Dr. Khivsara, sir, to kindly welcome our first speaker, Dr. Meenal Mohit, for deliberating her talk on endocrine hypertension.
Thank you very much for your kind introduction. I invite Dr. Meenal Mohit. She is a consultant and head of Department of Endocrinology at Manipal Hospital, Jaipur. She is the Chief Medical Director of Sashakt Thyroid Endocrine and Diabetes Center, Jaipur. She is a founder, secretary of Metabolic Club, Jaipur. Numerous oral and poster presentation in conferences and also authored many books. I invite Dr. Meenal Mohit for his talk on endocrine hypertension.
Thank you, sir. Thank you for your kind words. A very good evening to all of you. And thank you, Dr. K.K. Parikh, sir, Dr. Girish Mathur, sir, G.D. Ramchandani, sir, and the entire team of ERAJAPICON for giving me this platform. Can I have the permission to share my screen, sir? Yeah, thank you so much.
Thank you, Meenal, for your acceptance for this lecture. And I hope you will finish it within 15 minutes. We can say to you, because our two other speakers are also waiting. We are late, so I would like to request to you that you finish within 15 minutes. Thank you so much.
Sure, sir. So I begin my talk for next 15 minutes. I will take your permission.
Thank you. Thank you.
So I begin with a very simple slide that says these are the various endocrine glands, and we pretty well know them since our MBBS days. But not all of them are responsible for hypertension. There are few endocrine glands which do lead to endocrine hypertension specifically. And when we talk of endocrine hypertension, the very first gland, the culprit, is the adrenals most commonly, though we do have hypertension in thyroid disorders as well as some of the pituitary disorders. So when we classify hypertension, mostly it is primary. Very rarely we do come across a secondary hypertension, which is around 15%. And out of this 15% of the total burden, only around 5% we can attribute to endocrine hypertension actually. So when I focus my talk on endocrine hypertension, and as sir has asked me to rush a little, it would be classified as adrenal dependent and non-adrenal dependent. When we talk of adrenal dependent, it would be something beginning with medulla and also something with cortical hypertension, the adrenal cortex related. When we talk of thyroid dependent hypertension, we know both hypo and hyperthyroidism do have hypertension, though hypo is more of the diastolic hypertension, whereas hyperthyroidism is more of a systolic hypertension. Again, when we talk of pituitary, the most common two disorders which come across our mind are acromegaly and Cushing's disease. And then there are certain conditions which are not exactly directly related to any of the glands, but they mimic the disorders. And they do give us a picture of syndrome of apparent mineralocorticoid excess that we label as SAME, or the syndrome of apparent mineralocorticoid excess. So how do we actually suspect that yes, this particular patient cannot be essential hypertension and it can be something more? So probably whenever you come across a young patient who's hypertensive and may or may not be having a positive family history, and specifically if the hypertension is associated with hypokalemia, even if the patient is on diuretics and there is hypokalemia, do think of mineralocorticoid excess. Another reason can be severe hypertension when we talk of more than 160 systolic and more than 100 diastolic. If it is a resistant hypertension, that is the patient is having hypertension despite of being on 3 antihypertensives and one of which being diuretic. If there is significant fluctuation with hypertension and associated with fluctuating blood blood pressure, there is anxiety, diaphoresis, palpitation, then you must again think of, and also if you find in a woman a sudden onset of signs of virilization, you might think of adrenal androgens going up. Then there can be hypertension in adrenal incidentalloma. You might come across just a mass on a CT which was done for some other reason, and also the patient is hypertensive. Then do think of adrenal adenoma, which might be a Conn's syndrome. Then again, it can be a syndromic disorder like MEN1, MEN2, or it can be FAO associated with syndromic pictures or thyroid disorders associated with some syndromes. So whenever you come across any of these things, think beyond the box. And how do we approach such patients? Of course, a proper history taking, the duration of the symptoms, aggravating and relieving factors, transient or stable hypertension, associated symptoms, past medical history, family history, drug history, all these things become very important. And going back to our basic classes, that history taking in medicine is very important. So again, we continue, but because of the time, I'll skip this slide. But the idea is just we should have a detailed clinical examination. And how do we take a blood pressure? That is very important. The position, the period of relaxation, no talking, and documenting more than once the high blood pressure. Then also giving due importance to the examination of other systems, may it be cardiovascular, renal, or abdominal. Of course, if you are suspecting a FAO, just be very careful not to manipulate the mass too much. So coming to the main point, that when we are talking of adrenal gland as the culprit and as the cause of endocrine hypertension mostly, it can be medulla causing pheochromocytoma, that is catecholamine rise, or it can be the adrenal cortex. When we talk of adrenal cortex, it can be glomerulosa causing the rise because of the rise in mineralocorticoids or the primary hyperaldosteronism, or it can be the fasciculata, the second layer, which is giving rise to the glucocorticoids and leading to Cushing syndrome. So we will not be discussing all the causes of secondary hypertension or the endocrine hypertension. I will just be covering the most important few. And to begin, the most important, the very first is that most commonly a fluctuating or a paroxysmal hypertension associated with symptomatic diaphoresis, anxiety, palpitation, a feeling of dyspnea, impending death, sudden dooms, epigastric pain, headache, hypertension, associated again with vomiting, nausea, palpitation, and all this paroxysm do give us an alert that probably we are dealing with FAO. Then there are some chronic signs and symptoms, like the patient is always fatigued, there is generalized increase in sweating, there is hypertensive retinopathy, patient might have high blood glucose, the hypertension is resistant in nature, orthostatic maybe, and of course the patient might also come to you with CHF directly, with painless hematuria and some weight loss. Just remember, flushing is not a very typical sign of FAO. Flushing is more commonly associated with carcinoid syndrome. And another important point about FAO is that it can be a part of a syndrome. It can be MEN1, MEN2, it can be neurofibromatosis, it can be von Hippel-Lindau syndrome, or it can be Carney's triad. So just keep your eyes open and just look for most of the other things that can be there. And they will not come apparent till you don't look for them. So if it is FAO and you think of FAO, the most important thing is that I will give you a table here. Maybe I can skip this slide and come here first. But just remember this mnemonic, tab, lap, wire. So these are the drugs that you must stop before analyzing your FAO. So tricyclic antidepressants, amphetamines, buspirone, levodopa, adrenergic agonist, prochlorperazine, any illicit drugs, reserpine, and ethanol. These are the drugs which should be withdrawn before you analyze your FAO. With tab, lap, and wire. So these drugs should not be there. And then once you have withdrawn these drugs and ensured that these drugs are not there, and still the patient is symptomatic, and you find a mass somewhere of the size 3 centimeter on your CT abdomen, which is round to oval with the 10 Hounsfield units and less than 50% washout, hyperintense on MRI, you might think of FAO again. Then, of course, this is a common workup that you will find the very first on the clinical suspicion, that is 24-hour urinary fractionated metanephrines and fractionated catecholamines. This is the most important line that we have to remember, that the moment you think of FAO, just go for one assessment of 24-hour urinary fractionated metanephrines and fractionated catecholamines. You can also go for plasma fractionated metanephrines. If they all come back normal, then of course things can be normal. But if they come back to be positive, there's more than twofold rise, then we need to localize the mass with the help of our imaging studies. And once the localization is clear, the only treatment option in case of PO is surgery. But before we take our patient for surgery, we need to achieve a normotensor status, and we also need to have a team to manage the intraoperative management, because there is significant blood pressure fluctuation and there is significant volume fluctuation, which we need to remember. So the management part, immediately you take the patient on alpha blockers. We have to avoid the beta blockers, we all know. So immediately we take the patient on alpha blockers, the drug of choice of phenoxybenzamine and prazosin. Then, of course, to prevent the orthostasis, you have to give IV fluids because dehydration has to be prevented. And we need to ensure a normal sodium intake, a high salt intake rather in the diet. Beta blockers, the dual action, the alpha and the beta blockers can be added labetalol, then esmolol, bisoprolol. During crisis, you need to manage the hypertensive crisis with IV management, that is pentolamine and nitroprusside. For hypotensive crisis, again, the drug of choice is IV fluids. Now, after FAO, the next comes the cortex. And when we talk of adrenal cortical hypertension, it can be either a low renin with a high aldosterone, that is primary hyperaldosteronism, or it can be both low renin, low aldosterone, that is a picture of syndromes similar to hypermineralocorticoid state, that is syndrome of apparent mineralocorticoid excess. So once we talk of high aldosterone and primary hyperaldosteronism, we know that this is the most common cause of endocrine hypertension in our case. And the most common cause of PHA is not the tumor, not the cons, but it is the bilateral idiopathic adrenal hyperplasia, which is the most common cause. Second most common is, of course, the adrenal mass, that is Cons syndrome. It can be unilateral hyperplasia also, or it can be adrenal the carcinomas, the adrenal cortical carcinoma, which is very rare. It can be familial hyperaldosteronism, or it can be some ectopic mass, but these are very rare cases, maybe less than some 1%. Coming to the low renin, low aldosterone conditions, like again the congenital causes, the congenital adrenal hyperplasia. We know the CAH most common is 21-hydroxylase. The 21-hydroxylase is a non-hypertensive condition. So the CAH causing endocrine hypertension is either 11-beta-hydroxylase deficiency or 17-alpha-hydroxylase deficiency. So it can be a DOCA-producing tumor, or it can be a state of primary cortisol resistance. And lastly, we do have a little syndrome, which we have been studying in differentiation to Bartter syndrome, and the another one syndrome is there, which I'm forgetting the name right now. So we are talking about the primary hyperaldosteronism here. So the features that warrant the investigations for primary hyperaldosteronism. Why do we look for primary hyperaldosteronism? Any hypertension coming with hypokalemia, again resistant hypertension, or you come across any incidental adrenal mass, or you find a young patient less than 20 coming to with hypertension, severe hypertension. Specifically, if you look for hypokalemia with hypertension, especially when a patient is on diuretic, then again you must think of primary mineralocorticoid excess. So whenever we are considering endocrine hypertension, and if there is periodic paralysis because of hypokalemia, hypokalemic periodic paralysis, there can even be tetany because of metabolic alkalosis. So all these things these are pointers to endocrine hypertension or a state of mineralocorticoid excess. You will definitely, the question is that why are we so much worried? We can just manage hypertension as we can. But the idea is, because even if you manage a hypertension and you can achieve a normal blood pressure control with 2 or 3 or 4 molecules, still these patients are at higher risk of stroke, higher risk of AF and MI. So these are the patients who need to be treated beyond hypertension. So we need to have a confirmed diagnosis. To confirm the diagnosis, again, I'll come to this slide later. First, let me come to this slide. Whenever you suspect a case of mineralocorticoid excess, that is, you must go for first a plasma aldosterone level and a plasma renin level. And then we must have an aldosterone renin ratio. After we have an aldosterone renin ratio, and if the ratio is on the higher side, that is, the ratio is more than 20 nanograms per DL per nanogram per ml per hour, then we think of, yes, this is a case of PHA. And when we are talking of a case of primary hyperaldosteronism, then we can also go for our imaging studies. And on imaging, if you come across a mass, then definitely in a younger patient, you are thinking of unilateral adrenectomy. If it is an elderly patient, again, we need to first go for a adrenal venous sampling to go for lateralization of the mass. And once we confirm the lateralization of the mass, then yes, again, unilateral adrenectomy is the only treatment of choice. But if you do not find a mass and there is bilateral micronodularity, but still you are clinically very sure that you are dealing with an adrenal mass, then of course you can go for adrenal venous sampling. But if you are not clinically very sure and you find that there is low probability of adrenal mass, in that case you can treat the patient just as a normal case of hypertension. To confirm, you can have some confirmatory tests, and most commonly we are using a IV saline loading test. We can also go for oral salt loading test or a fluid recon suppression test. So this is the chart again, that if there is a clinical suspicion, go for a screening. For the screening, go for ARR ratio. And if the screening is negative or positive, you can go for your confirmatory test with saline infusion or sodium loading or fluorocortisone. And if everything is negative, you don't find anything, even imaging comes out to be normal, all your blood biochemistry comes out to be normal, and you are still suspecting that, no, I'm very sure it is not normal essential hypertension, then you can go for 24-hour urinary steroid profile, that is glucocorticoid metabolic profile, the mineralocorticoid and the glucocorticoid ratio, and this will give you that whether we are dealing with some conditions of low aldosterone, low renin, that is a CAH condition, or maybe a condition of apparent mineralocorticoid excess, or maybe Little syndrome, where we have the innate defects. So this is how we are taking the case further. So once we have diagnosed that this is PH or primary hyperaldosteronism, then how do we manage? Again, as we talk, if it is a mass, surgery is the only answer. If we do not find a mass, then we have to treat it with our pharmacotherapeutics. And mostly we are using mineralocorticoid receptor antagonist, that is either spironolactone or aplerenone. In cases of GRA, we can also go for ACTH suppressive. So GRA is a glucocorticoid remediable hyperaldosteronism. So there are a few more conditions like causing mineralocorticoid excess. As we talked, that is congenital adrenal hyperplasia, which is mostly 11 beta or 17 alpha. But for these, we need a germline mutation testing. And if there is a deoxycorticosterone producing tumor, they are mostly malignant and they need resection. Now, a syndrome of apparent mineralocorticoid excess. This is mostly a condition where cortisol, we are unable to convert cortisol to an inactive cortisol in the kidney. So we have a hypercortisolism. And because of the increased cortisol level, deficiency of 11 beta HSD2, hypercortisolism causes mineralocorticoid receptor activation and gives a picture just same as hypermineralocorticoid state. Though the mineralocorticoid levels are low, it is the cortisol levels which are actually raised. So if you are suspecting this, you can go for a cortisol is to cortisone ratio. So cortisol is to cortisone ratio will give you a picture of syndrome of apparent mineralocorticoid excess. Another important cause that is causing Cushing syndrome, of course, the Cushing syndrome is very quite easy to diagnose. You may not go for hypertension alone as a misdiagnosis for Cushing syndrome, but just to complete the picture, Cushing syndrome, that is a hormone, the glucocorticoid excess coming from the fasciculator, the second layer of adrenal cortex. The cause of hypertension is important here to remember. As we talked in the previous same syndrome, the syndrome of apparent mineralocorticoid excess, high levels of cortisol cause the saturation of the mineralocorticoid receptors, and the mineralocorticoid receptors, they lead to, they are in a state of persistent stimulation, so they lead to hypertension. Also, there is activation of the RAS system by the increased angiotensinogen, and there is increased receptor sensitivity to endogenous vasoconstrictors at the same time. Also, there is increased deoxycorticosterone. So deoxycorticosterone, higher sensitivity, increased cardiac output, hyperactivation of the RAS, and saturation of the mineralocorticoid receptors all together lead to a state of hypertension. And treatment, we all know in Cushing's, again, it is either surgery or we have to cause the mineralocorticoid receptor blockers. Now that comes on the common ones, that is hyperthyroidism, a state of increased metabolic rate. We know that this is a state of increased cardiac output, increased the peripheral vascular resistance, and increased systolic blood pressure. So this is one of the causes of endocrine hypertension, but this does not, we rarely treat directly the hypertension because the beta blockers which are given to control the symptoms of hyperthyroidism also help us in achieving a normotensive state rather, And first we target achieving a euthyroid state, and then if still the blood pressure persists, we do treat the blood pressure. Similarly, in hypothyroidism, the diastolic blood pressure is on the higher side, and the condition is because of the fluid retention here. And because of the fluid retention, there is increased vascular resistance, extracellular volume expansion causing hypertension. And here again, we treat the primary hypothyroidism first, and then we treat the blood pressure. Some very few conditions like hyperpara causing hypercalcemia, and hypercalcemia leading to increased vascular resistance and hypertension. Then acromegaly, again acromegaly because of the fluid retention and increased cardiac output state causing hypertension. Some other metabolic conditions like diabetes and obesity, they also go hand in hand with hypertension. So if we treat obesity, many a times we treat most of the diseases. So it's a mother of most of the metabolic diseases, I should say. These are very similar cases, like if we do not even discuss them, it would be okay. Like this lady is a case of hypertension whom we found to have Cushing's syndrome, and she's being treated for Cushing's, and her blood pressure has responded to our treatment of Cushing's syndrome. Similarly, another case scenario, this lady of 60 years was found to have paroxysmal hypertension and found to have pheochromocytoma and was operated upon, and now she is doing good. So just to remember a few points, I hope I have finished in time or rather earlier. Hypertension and endocrine disorders, they do go hand in hand. So whenever you find any endocrine disorder with hypertension, do think of a common link or a common seed. Then it is the responsibility of we physicians to give the correct diagnosis, though the treatment might remain the same, but we should at least be very sure of what we are treating. So with that, sir, Parikh sir, thank you so much. I would take your, I would really say thank you so much for the session.
Thank you very much, Dr. Meenal. It was a very nicely presented. I know it is not a usual lecture in conference. I will just say that you have spoken excellent. Thank you.
I've just rushed through it.
No. Well in time.
Thank you so much.
Thank you, Meenal. Finishing very much in time.
Thank you, sir.
Thank you so much. So nice of you.
So we now move on to our second lecture of this session. And I now take this wonderful opportunity to welcome our next speaker, for whom even I don't need to read the introductory slide. He's President RSSDI. He's a dynamic.
Who is going to introduce him?
Sir, I'm introducing. He is at present our President RSSDI. He's a dynamic, visionary, and inspirational personality in the field of diabetes care, not only in India, but across the globe. He has been honored with a lot of fellowships. He's the President of Indian Obesity Society and Honorary Secretary of Diabetes India. He has launched many projects for establishing the basics of care of diabetes in India. And one most important feature is he has been instrumental in establishing the basics of care for type 1 diabetes in India. Yes, dear friends, he is none other than our loving President, Dr. Banshi Saboo sir. So I welcome you, sir.
Thank you. First of all, thanks, Dr. Ashutosh. I think, first of all, thanks, Dr. KK Parikh sir.
Thank you. Thank you so much. Welcome to you.
And the API Rajasthan. So I mean, anytime, whenever API is inviting, and particularly when Rajasthan is inviting, I'm always there. Unluckily, this time, because of COVID, I am not in position to go to Rajasthan. But I was there at Kota long back for RSSDI chapter of Rajasthan chapter meeting, as well as for API meeting also. I'm sharing the slides. Sir, can you see my slides?
Yes, sir.
Yes.
You can see your slides.
First of all, I mean, when I was seeing the program, I was seeing that already one talk was there on the time in range. So, I mean, when topic was given and discussed with Dr. Mathur, I thought this will be a good topic. But at the same time, I can understand that this topic is becoming very popular as we are moving from A1C to time in range. And when I was studying my MD medicine and in postgraduate immediate after passing, we were having a similar type of discussion for A1C, that how frequently we should get A1C, and then any meeting wherever we used to go, we always used to talk about the HbA1c. So I mean, now we are moving after 25 years from A1C to the newer mode of beyond A1C, a glycemic control which we must achieve. The era of A1C in last 25 years or before that, that was that era of A1C, and then we will talk about this limitation, and then I will be talking about the time in range. A quarter of century ago, a DCCT, a very important trial in type 1 diabetes, had established the importance of A1C. We know that age A1C increases above the 6 or 7, there is an increase in risk of microvascular complication. And you can see in this particular slide that as the A1C is higher, more the complication. So it has been well established that A1C and average glucose of a patient is very, very important, and that is directly proportional for increasing the complication in type 1 diabetes as well as in type 2 diabetes that was established in UKPDS. But A1C has its own limitation. It does not capture hypoglycemia. People with diabetes whose HbA1c level are less than 7, they spend more than 90 minutes per day with mean glucose level of less than 70. So we may be very happy that your patient is having A1C of less than 7, but if you do their continuous glucose monitoring, you will find that in more than 70 minutes of the time, they are actually having hypoglycemia. In one of the important study of impact study, which is a real world data, the participants with similarly well-controlled diabetes, those patients who's having A1C of average A1C of 6.7, they were actually spending more than 200 minutes per day with mean blood glucose level of less than 70. So I mean, the target which we are trying to achieve in our patient, less than 7 or even less than 6.5, you will find that many of these patients who are on hypoglycemic agent, particularly on sulfonylurea and insulin, they are actually spending more than 200 minutes per day in hypoglycemia or less than 70. It does not capture, the A1C does not capture the individual differences because there are varying patterns of glycemic control and they may have similar A1C. You may have two different type of patient, even in the same patient, 2 different times in a year, they may have a same A1C, but still their glycemic patterns may be completely different. And there are some conditions like anemia, hemoglobinopathy, iron deficiency, pregnancy, which can confound the HbA1c measurement. It does not capture the glycemic variability. The study have shown that glycemic variability with increased risk of hypoglycemia, cardiovascular outcome, and all-cause mortality is there, and that does not capture on A1C alone. For that, we have to get a continuous glucose monitoring, or we have to find a new way or new parameter, that's time in range. You may have 2 different patients. As I told you, that A1C may be same. The upper patient with A1C of 8 having multiple hyper and hypoglycemia, while the lower side the patient you can see with low glycemic variability. And what we want or what we are expecting in our patient, that they should have achieve a tighter glycemic control with lower glycemic variability without getting any hypoglycemia or not even hyperglycemia too. So the utility of A1C can be enhanced significantly when we complement it with a continuous glucose monitoring. I mean, you have a patient with a good A1C control, but still if you can get the continuous glucose monitoring data, that probably this will complement our patients, and then we can have that less glycemic variability, less hypoglycemia, and the utility of A1C is too much enhanced when patient is having tighter glycemic control without getting hypoglycemia. One of the example which many of our type 1 diabetic patients might be doing in multiple times self-monitoring of blood glucose. This is one of the patient who is doing before breakfast, before lunch, and even at bedtime, and 3 times or 4 times even before lunch also. All 4 showed reports are absolutely normal. So all 4 sugar reports are normal, but still he is getting actually hypoglycemia before lunch. Post lunch there is a hyperglycemia, and even midnight hypoglycemia also. So glucose value, even by doing multiple times self-monitoring of blood glucose, still we may miss multiple things, and that you can pick up only on continuous glucose monitoring. It's like a real-time glucose monitoring is like a videography. It's like a continuous CCTV, while just random blood glucose is just a still photo. So you are just trying to take the photo at that time. Random blood glucose tell you that what is the blood glucose level, but it never tells that what is the glycemic pattern on when the person is going to go in hypo and hyperglycemia. So on this, there was an international consensus that how frequently we should use the continuous glucose monitoring. Still, we don't know how frequently we should use even self-monitoring of blood glucose level. I mean, self-monitoring of blood glucose level in a type 2 diabetic patient In a patient who is not on a hypoglycemic agent, we don't know that how frequently that patient should do it, and we don't have any outcome data. So similar way, we don't have the data for a using of a continuous glucose monitoring for a type 2 diabetic patient who is not on hypoglycemic agent. But this consensus was primarily done for the patients who are on insulin, who are on pump therapy, or who are type 1 or a type 2 diabetic patients who are on hypoglycemic agent. And we know that the use of continuous glucose monitoring, particularly in type 1 diabetic patient, has reduced significantly hypoglycemia. The risk of hypoglycemia was in DCCT trial, which was done in 1983. The average A1C of the patients was 9, and they could reduce to 7.2. In DCCT trial, the hypoglycemia, severe hypoglycemia rate was 62 per 100 patient year. When 2008, after 25 years, JDRF CGM trial, which had done, and with average A1C was 7.6, and they could bring down to 7.1, but the risk of hypoglycemia is reduced significantly just because these patients was on continuous glucose monitoring. From 7.2 to they could reach 7.1, and the risk of hypoglycemia was 20 instead of 62. In pivotal trial, after 8 years, in 2016, when the similar type of patients, adult as well as pediatric type 1 diabetic patients, they were put on the continuous glucose monitoring along with the pump, and with multiple shots of short-acting and longer-acting insulin, they could have reduced the hypoglycemia risk 0%, and they could achieve the target A1C of less than 7, and the baseline A1C was 7.7, which they could reduce to 6.9. But there are definite indications which we, in 2017, when there was an international consensus that patient with type 1 diabetes who is not meeting A1C target, at least they should be put on a continuous glucose monitoring. Or those patients who are getting recurrent diabetic ketoacidosis. I mean, even with 1 unit or 1.5 unit increase or decrease, either they go in hypoglycemia, or they go in diabetic ketoacidosis, or we can say it's a brittle type of diabetes, they should be on continuous glucose monitoring. Patient with repeated hypoglycemic episodes or an hypoglycemia unawareness, they should be definitely on continuous glucose monitoring. They could be even type 2 diabetic patients, long-standing type 2 diabetic patient with the autonomic neuropathy, they should be put on continuous glucose monitoring. Subjects requiring better glycemic control, like during GDM in a perioperative period, they need a continuous glucose monitoring for a better or a tighter glycemic control. And definitely patients who are, we call them brittle, but now after CGM, probably the number of patients with brittle diabetes have significantly reduced. So what novel metric, from where HbA1c, can we have a newer metric of average A1C or average glucose control? That's what time in range. And time in range refers to time spent in an individual target glucose range between 70 to 180, but occasionally 70 to 140 that we do in pregnancy and diabetes. The percentage of time when it goes below or when it goes above, it indicates hypo or hyperglycemia. Time in range may be used an appropriate endpoint in a clinical research and as a measure of glycemic control in patient with diabetes. And now there are future research which are happening, which are trying to do the continuous glucose monitoring, and we are trying to find out which molecule is better, and that's what we are doing with time in range. There are emerging evidence that suggests that time in range is inversely correlated to the risk of developing micro and macrovascular complication in patient with diabetes also. So the time in range, if you do an ambulatory glucose profile or a continuous glucose monitoring, when it goes below 70, we call it time below range. When it goes more than 180, we call it time above range. But if it remains between 70 to 180, that we call it glucose in range. And how much time in 24 hours somebody is remaining in that range, and that is what we call it time in range. Why time is range is important. Like you may have a patient with the A1C of less than 7. It is possible that 100% of the time the person's sugar is remaining between 70 to 180, and that's what A1C is getting you less than 7. But there is a possibility that this patient might be having a time in range, only 17% of his 24 hours time is remaining actually in glucose control, but 58% of the time person is having a high, or 24% of the time patient is going in low, and that patient also can have a A1C of 7. There could be other patients where he could be in 2/3 of the time he is in A1C, time in range in 70 to 180, but other time patient is either going hyperglycemia or hypoglycemia. So there could be different phase of 7 HbA1c. So now we cannot have somebody who is having a tighter or good glycemic control does not mean that he is remaining all the time in good glucose control unless we do a continuous glucose monitoring. So there is a significant difference between A1C and time in range. A1C just evaluates a single A1C value, while time in range evaluates continuous glucose value. A1C compares every 3 months, time in range compares any time period. A1C does not capture any hypoglycemia and hyperglycemic level, while time in range capture all glucose level for the given frame and identifies time within safe range. It has got immediate effect. A1C does not give you any effect of therapy which is changed, is done for shorter period of time, is not getting recorded, while time in range will detect even acute effect of therapy change. Also, A1C have a bad correlation with patient reported outcome, while time in range, because if somebody is remaining all the time in a good range, then good relation with patient, correlation with patient related outcome, good quality of life. A1C have a high susceptibility to interference with various lab or anemia, while time in range with these 3 different companies who are making continuous glucose monitoring, Medtronic, Dexcom, and Libre, all of them are using the ambulatory glucose profile. So the time in range is more or less, have less susceptibility to interference. A1C have a good correlation at this point of time with clinical endpoints because of many long-term study in last 25 or 30 years, while time in range is a new concept. So we don't have any long-term study, but probably in future, maybe in another 3 or 5 years or 10 years, we will have many long-term studies with this. But do we have any validation of time in range as an outcome measure? Because that's very important. When we have come out with a new parameter, do we have any outcome measure? There is a strong association of time in range in a risk of microvascular complication in decisive trial. In decisive trial, the patients were using self-monitoring of blood glucose. Those patients who were using more than 4 times in a day, and if it was remaining between 70 to 180, we put that it is in time in range, while those person whose sugar was above or below the range, it was out of the range, and they found that patients who are having better time in range found to have less microvascular complication in compared to the person who are having less time in range found to have more microvascular complication. Association of time in range, do we have data for type 2 diabetes? A recent publication in 2018 had talked about it. The person with a better glycemic control, better time in range found to have less complication, particularly diabetic retinopathy in type 2 diabetes. And this is a long-term study which has been done in type 2 diabetic patients for a microvascular complication on a diabetic retinopathy. But there was an indirect macrovascular complication was also decreased with the patients with better glycemic control, better time in range, found to have less carotid intima media thickness. While those who have less in time in range, they have more carotid intima media thickness, which gives you indirect evidence that time in range or a better glucose glycemic control also have direct impact on macrovascular complication too. So what the guideline? What the guideline is talking that how much time the person should be in that range. And the recent guideline in 2019, they had standardized the CGM metrics and they have done the reporting. The standardization of CGM metrics that person should remain within time in range. I mean, within range, glucose should remain in that range between 70 to 180. And out of 24 hours, we should increase this time in range. That should be our primary goal for effective and safe glucose control. There should be less time person should spend below that range, that is below 70, and time above range also should be as low as possible. So that should be our primary goal for an effective and a safe glucose control. And this is international consensus for CGM data to be get interpreted in type 1 or type 2 diabetic patient. More than 70% of the time, that comes around 16 hours, 48 minutes in a day. A person should spend his this much time in a sugar value of between 70 to 180. But it is acceptable for less than 5% of the time if he goes below 70. But it is not acceptable more than this time, and it is not acceptable for more than 1% of the time if he is going below 54 also. The similar way, more than 180, less than 25% of the time. So I mean, if somebody is getting less than 25% of the time, it is acceptable. But again, it should be less than 5%. He should not go more than 250 milligram. And if he is achieving this target, his A1C will be roughly around 6.7. The other who are elderly or older patient, type 1 or type 2, high risk for hypoglycemia, this time in range, instead of 70%, it should be more than 50%. But one thing which is not acceptable with these elderly patients, that is less than 54 milligram. That less than 54, even 1% of the time, person, if going below 54, you have to change the therapy. I mean, that is the consensus, that we have to change the therapy. If somebody is not able to achieve this time in range, then we should change the therapy rather than accepting that yes, occasional hypoglycemia is okay. For the person with elderly or high risk for hypoglycemia, we should not accept even less than 1% of the time going for less than 54. In a pregnancy, type 1 diabetes, becoming pregnant, again the tighter glycemic control between 63 to 140. Again, acceptable range is less than 25%, but again, not more than 180. So it can be between 140 to 180, but less than 25% of the time. And somebody who is already type 2 and becoming pregnant or gestational diabetes, in that the target range is 90% of the time, the sugar should be between 63 to 140. Again, it is not acceptable going more than 140 by more than 5% of the time. And similar way, less than 5% of the time person is not acceptable going below 63 also. So this is 4 different varieties of person with diabetes. We have a consensus for a continuous glucose monitoring data interpretation. And in simple way, the type 1, type 2, what routinely we see the patients, there are elderly patients with higher risk of hypoglycemia or a cardiovascular disease, or the patients who are already on a premixed insulin or sulfonylurea, patients with pregnancy and type 1 diabetes, and pregnancy with type 2 diabetes or GDM. These 4 different varieties of patients which we see, and this is what the time in range consensus. And this has been accepted by American Diabetic Association in 2019, in 2020, and again in 2021. Only before few weeks, even 2021 publication had also come. Even American Association of Clinical Endocrinology, they are also talking about the continuous glucose monitoring. It's an 11 principle of comprehensive management of type 2 diabetes, because many of these physicians, they think that when we are talking of time in range, they are talking that continuous glucose monitoring and time in range should be achieved only for type 1 diabetes. But this is the ACE guideline in 2020, and they are talking very that CGM appears to be whenever indicated to assist patient in reaching glycemic goal. Even there in tabular form, they have also written that lifestyle monitoring and ongoing glucose, lifestyle therapy and ongoing glucose monitoring, a continuous glucose monitoring is preferred for type 2 diabetic patients to achieve a good glycemic control. There are practical implications that with this type of ambulatory glucose profile, I'm sure all of you must have seen multiple times, because you might be doing for your patient. And in this particular, also you can find what are the above range, what is time in range, and what is time below range. So this is what it has written: time below target, time in range, and above glucose. And you can find even the average time also, the percentage of time patient is spending in time in target, time below the target, and time above the target. And the range is saying that we want to have more than 70% of the time the person should be in the target. And just giving an example, that one of our patients on a multiple oral anti-diabetic agent, sulfonylurea, metformin with gliptin, the patient was on 3 drugs. Patient was asked to get the insulin because A1C was 9. And patient was not ready to take the insulin. Patient had come to me. I just asked to get the AGPA, continuous glucose monitoring, and we could see his all sugar reports are high, fasting and postprandial. And patient is a perfect example to start the insulin or a basal insulin therapy should be started. But we explained the patient, I think we can give you instead of insulin because your diet and it's not getting good control. We should give you the GLP-1. We should reduce your glimepiride part, and we should add the SGLT2 and removing the gliptin. So now the patient was on a 3 oral drugs along with GLP-1 on a once in a week, and the patient was asked for a again after 5 days to come, but every day patient has to do the sugar report. and we had reduced the glimepiride from 4 milligram to 2, and then 1, and then 0.5. And again, when patient came on the 12th day, you can see patient sugar is absolutely well controlled, and now patient is only on GLP-1, metformin, and SGLT2. And the last 4 days, again, you can see the patient sugar is absolutely fine. So, I mean, these are the example and benefits of doing a continuous glucose monitoring, even in type 2 diabetic patient, as per the guideline, with the A1C of more than 8.5 or 9, who is not controlled on a triple oral anti-diabetic agent, probably a right choice to start these patients on insulin. But I think this continuous glucose monitoring gives us the precise medicine for that particular patient, and that is what we are trying to do. That is individualized therapy. We should not have a just blanket statement for each and every patient with the A1C of more than 8.5 should be on insulin. Probably by doing a continuous glucose monitoring, some of our patients can be controlled on other things also. To summarize my talk, the HbA1c is the gold standard for diabetes management. However, it does not demonstrate a holistic and individualized glucose profile. So, I mean, only just by getting A1c, we will not get a complete glycemic profile, as I had shown you the last case report also. The glycemic variability is associated with increased risk of severe hypoglycemia, diabetic complication, and reduced quality of life. Time in range provides a closer view of the person's glycemic status and aids in a better glycemic control. Increasing time in range has been shown to have association with reducing micro and macrovascular complications in people with diabetes, and international guidelines have now been updated to include consensus on CGM data interpretation. A need to exist to move beyond A1C. So now only A1C is insufficient, and we have to consider continuous glucose monitoring for many of our patients for optimized diabetes management. With this, I thank you, Dr. K.K. Parikh Saab, Dr. Girish Mathur, and the team of Rajasthan API for giving me an opportunity. Thank you.
Thank you so much, sir, for your enlightening words on this newer metric, time in range. And in fact, it remains a challenge for us to implement the use of this really new metric in a cost-effective manner in a country like India. So
I agree with you, Ashutosh, fully.
Yes. So if any questions are there for Vanchi Sabu, sir?
I think we are already running late, so people are...
Thank you so much, sir. Thank you once again for joining us this evening. So we now proceed to our next lecture, and for this I request our chairperson, Dr. Ashok Jain sir, to kindly invite our next star speaker of this evening, Dr. Rajiv Chawla sir.
Good evening, all of you. Dr. Rajiv Chawla is a towering and talented personality in the field of diabetes in North Delhi. He is MD, FRCP, FRSSDI, FSCP, FSCE, USA. He trained at Diabetic and Endocrinology Center in New York. He is Senior Diabetologist and Director, North Delhi Diabetic Center. He is Honorary Professor, Jaipur National University. He is a teacher and guide of DNB for last 18 years. He has presented innumerable papers on micro and macrovascular complications. He authored 6 books on diabetes. He served RSDI in various capacities of secretary and chairman. He was president of RSDI 2018 and 2019. Now I welcome Dr. Rajiv Chawla for his
Good evening, Dr. Jain, for all those kind words. May I share my slides?
Welcome, Dr. Chawla.
Good evening,
nice
sir.
To see you, sir. Good evening. Good evening, sir.
Very good evening, sir.
Thank you very much, sir, for joining this conference and this platform. Thank you very much, sir.
At the outset, I am thankful to Dr. Parikh, Dr. Girish Mathur, Dr. G.D. Ramchandani, Dr. Maheshwari, everyone in entire team of Rajasthan Epicon to have given me this important conference. And I seem to be the last batsman, so I'll try to rush as early as possible. Task you have assigned to me is to discuss about RSSG Endocrine Society Joint Consensus on Clinical Practice Recommendation Management of Type 2 Diabetes 2020, which just got published this year both in IGM as well as IJJDC journal, which is International Journal of Diabetes in Developing Countries. So, yeah. Why there is a need for having Indian guidelines when every year you have on 1st of January, India guidelines getting published, ACE guideline and IDF guideline, then NICE guideline, Australian and Canadian guidelines, so many guidelines are already there. So why we have put so much effort on bringing out Indian guidelines, because there are certain relevant factors to Indian context. We have very high prevalence of pre-diabetes and diabetes. Onset of diabetes happens at a age as compared to the Caucasian patient, maybe 1-2 decades earlier. We have very high prevalence of micro and macrovascular complication. There is a large rural-urban divide, but that is now fading away because even some metros and smaller urban towns are also getting very high prevalence of diabetes. The cost of diagnosis, treatment, monitoring, and prevention is a issue in our country. Most of us, we have sedentary lifestyle with limited resources, poverty, illiteracy, and those psychosocial and cultural factors to accept diabetes happening in our country. And there are issues on adherence and compliance to anti-diabetic therapy. So flow of my talk will be starting from role of diet, physical exercise, treatment, both oral as well as insulins, and finally to conclude on complications. We know that medical nutrition therapy still remains an important area in management of type 2 diabetes. So I think give a sufficient trial of medical nutrition therapy right in the beginning, maybe along with metformin therapy, maybe for 3 months. It could be done by either any healthcare professional or a dietitian or an educator. But overall, we need to emphasize that there has to be a very less consumption of simple carbohydrate, sugars, and fried foods, and we should primarily emphasize on complex carbohydrate. Salt intake has to be in moderation, and we should encourage duration and frequency of physical activity at least 30 minutes on daily basis, at least 150 minutes on weekly basis, and there has to be a mass awareness campaign for healthy diet and lifestyle. This is what is, I'm not going to go into the details, but we recommend that 55 to 60% calories should come from complex carbohydrate. Protein intake should be at least 15%, and it should be from good sources. We should avoid use of red meat and other things. It could be legumes and dals and all those things which are more prevalent in our country and which are easily affordable. Most of us, we tend to be vegetarian, so we must emphasize the role of protein. Fat intake has to be up to 25 to 30%, but we should avoid using saturated fat less than 10% only. And there has to be a rotation of oils, which is very, very important. And again, diet should also have diet factors like fibers and whole grains or legumes, I told you, pulses, and maybe even nuts also in sufficient amount, with some moderation of salt, which is very, very important. There has to be at least 150 minutes of exercise on weekly basis, out of which 30 minutes of moderate intensity aerobic activity should be there. There could be 15 to 30 minutes of work-related activity daily, like walking up to the railway station or to the bus stop, going and coming back before you go to a public transport. So that also should be a routine practice. And 15 minutes of exercise as muscle strengthening, again, that should be a part of regular routine. Coming to oral anti-diabetic drugs, the choice of oral anti-diabetic drugs in patient is based on overall efficacy and safety of the drug, presence of comorbidities, and the cost, which is very, very important in Asian or in Indian patient. Sulfonylureas, that is why we are still continuing with sulfonyl or smart sulfonylureas. We don't induce too much of hypoglycemia, and they have a comparable CV safety with DPP-4. We know the Carmelina trial. TZs are very, very useful in Indian context because of high amount of insulin resistance which our patient have. All DPP-4 are almost equally effective. And these days we are advocating that all those patients who have established atherosclerotic cardiovascular disease should ideally be on SGLT2 inhibitor or maybe on GLP-1 analog after the metformin therapy. Coming to the injectable therapies, we know that all conventional in terms of glycemic efficacy are sort of almost equivalent to analogs, but only thing is with analogs, risk of hypo is very, very less as compared to the conventional insulin. And then it also provides you the flexibility of administration. You don't have to wait for 30 minutes for having meal after the insulin. So it can be taken immediately prior to the meals also. And another important thing is that insulin supplies has to be assured, which is very, very relevant in COVID time, because we know until unless you are again and supplying insulin regularly to the patient, obviously patient will default and that will result in higher HbA1c. And I'll be talking about RSSDI wheel, which we have published, I told you, in this IJJDC as well as IGM publication, which came in March 2020. We talked about ABCDEFGH approach. I am sure Bansi is there. Bansi, me, Dr. Madhu, Sanjay Kalra, Makkar, Sujay Ghosh, we have been main authors of this. Well, we had a huge team of diabetologists across the country as well as endocrinologists in coming out this joint consensus. We were almost close to 150 people. Dr. Parikh was also part of that. Couple of endocrinologists from your state have been part of that. We talk about using ABCDFGH approach. This is what is RSSDI Endocrine Society Therapeutic Wheel, which I told you is getting very, very popular. Here I like to spend some time. A stands for advancing age of the patient. So in the center, you see that for every patient, lifestyle modification, as I said in the beginning, has to be there. Every patient has to be on metformin until unless there are contraindications to metformin therapy. And in this circles, you can see that this book is C, which stands for presence of advancing CKD. There you may not start with metformin, or if EGFR is already falling at 45, you need to reduce the dose of metformin to half. If EGFR is already 30, you will have to stop metformin. Otherwise, metformin has to be part of core therapy in every patient after the lifestyle modification. Then we need to have consideration on ABCDEFGH approach. A stands for advancing age. So from the center towards the periphery, as we move, age of the patient is advancing. Someone who is here has younger age. Someone who is in the red zone has, say, very high age group, maybe 70 or 75. So every spoke you see as it moves from the center toward the periphery, BMI is going to increase. Same way, C means it stands for presence of advancing CKD. So here you might have a normal EGFR. Here you might have a EGFR close to 30 only. D is duration of diabetes. So as we start from here, these are new onset diabetics. As we move towards the red circle, that means patient is already having diabetes for almost 10 to 12 years. E is presence of atherosclerotic cardiovascular disease. Establish what we have been talking in ACE guidelines and ADA guidelines, where we say that if you have established CVD, you must be on either GLP-1 analog or on SGLT2 like drugs. So that was also part of wheel as early as 2015, which was the first edition of RSSG guideline. Subsequently, it was revised in 2017, and this is the third volume or the third edition of RSSGI Joint Consensus with Endocrine Society of India. Then F is the financial status. We are very, very particular. I said that affordability of the patient is also going to be very, very important. That is why you could see that those patients who are not very well off, they may be on sulfonylurea. So here you see that if you have presence of atherosclerotic cardiovascular disease, obviously first option will be GLP-1 analog or SGLT2 inhibitor or even pioglitazone to reduce insulin resistance. Someone who is not having sufficient funds, financial constraint is there. So there you could use conventional sulfonylurea or drugs like pioglitazone, which are very, very cheap in our country, or these days even cheaper DPP-4s are available. That is why in this column you don't see SGLT2 or GLP-1 like drugs. Then G is again talking about glycemic status of the patient. As you move from the center towards the periphery, that means glycemic status is worsening. Someone who is here might have an HbA1c close to 7, who is already in the red circle, that means HbA1c is more than 10. That is why as you move towards the periphery, you see that options like insulin and GLP or sulfonylurea become very, very important because these have a huge amount of glycemic reduction. H is proneness to hypoglycemia. This is very, very important, which has not been highlighted in many guidelines, although ADAs these days, they have been talking of avoiding hypoglycemia. But we said the choice of drug has to be based on, again, if there is a hypoglycemia proneness or patient has hypoglycemia unawareness, there we should not use drugs like sulfonylurea or insulin because then the risk of hypo is much higher. So we said these patients ideally should be on SGLT2 or DPP-4 or GLP-1 depending on the affordability. So if you see that this ABCDEFGH approach, in the green circle, you have all the options of drugs which can be used. As you move from green towards the orange and the red circle, that means options are getting narrowed. It does not mean that in red you cannot choose the drug. It only means that in green you can use any amount of drug or any type of drug. In the red circle, you have limited choices. So options in green and in orange are much more, while in red circle, like if I give you an example of presence of CKD, obviously there will be a limited option of using only DPP-4 or insulin if EGFR is already less than 30. Similarly, someone who is prone to hypoglycemia, obviously drugs which you can use in green, you will not be able to use in red because these patients are at a much greater risk for developing hypoglycemia. Similarly, in BMI category, you could see that SGLT2 or GLP or DPP-4 have to be first line option, because with SGLT2 or with GLP, you can induce weight loss. DPP-4 are weight neutral. That is why someone who is into the red zone has to be on only on SGLT2 or maybe GLP-1 analog. Here, we are not even giving the option of using sulfonylurea or insulin, because then obviously weight gain will be much more. So that means not only you have ABCDFGH approach, you have a hierarchy of drug fix. So as you move towards the right side in a clockwise pattern, there is a hierarchy. So someone who is having advancing age, best option could be DPP-4. Someone who is very, very obese, best option could be SGLT2. Last option will be sulfonylurea. Someone who has presence of CKD, obviously SGLT2 or DPP-4 will be the best option. Someone who has long duration of diabetes, SGLT2 or DPP-4 may be good enough. Similarly, someone who has established atherosclerotic cardiovascular disease, best option will be SGLT2 or GLP-1 analog. Someone who cannot afford costly drugs, obviously sulfonylurea or insulin will be better option. So that is how the hierarchy of the drug has been fixed up, and it is as you move towards the right side, hierarchy keeps changing. So now how to make a choice and individualize treatment for type 2 diabetes, because we say that it has to be based on overall profile of the patient, depending on the comorbidities, presence of CVD or financial condition or the glycemic status. Drug choices should be based on patient preferences. You should discuss it with the patient that which drug will be better based on the overall profile of the patient, presence of comorbidities and the complication and the drug characteristics, and with the goal of reducing HbA1c, every effort has to be there to reduce weight gain as well as not to induce hypoglycemia. And we know that all the drugs will get you an HbA1c reduction close to 0.9, except the insulin or maybe GLP-1 analog, where you may get much higher HbA1c reduction. And National Insulin Summit consensus from India has said that all oral anti-diabetic agents and GLP can reduce HbA1c to the range of up to 2, especially insulin and GLP-1 analog. And with insulin, there is no limit. If it is being used as a monotherapy or with other drugs, you can have significant amount of HbA1c reduction. So I'll skip these slides for want of time, but we'll go toward the end at how to make a choice based on ABCDFGH approach. So how to use this wheel which we have been talking, this we are trying to disseminate through the RSSDI coordinator, which we have made, district coordinators all across the country in almost 450 districts. And we are giving them these presentations so that they can make CMEs and make their physician also well aware how to use these guidelines and how to use this therapeutic wheel. So this wheel is designed to be a very, very simple, user-friendly approach toward management of type 2 diabetes. Whenever a patient walks into your clinic, based on overall profile of the patient, start with lifestyle modification, add metformin, there you could wait. Then try to identify 2 to 3 most important concerns amongst ABCDFGH, because it may not be possible for you to go through everything ABCDFGH. So you try to pick up the best concerns which are important in that particular patient. For someone, it may be presence of DKD. For someone, it may be financial constraint. For someone, it may be advancing age. For someone, it may be advancing BMI. So based on 2 to 3 important concerns in that particular patient, then try to get the best choices which are available. So in the green zone, you can have option of using all the drugs. In the red zone, based on overall profile of the patient, you will have to fine tune the drugs. And based on the individualized approach, you will have to go on the choices of drugs. What about complication? We all know that postprandial hyperglycemia, this we talked for the first time. in Indian guidelines, because we said postprandial hyperglycemia is very, very important in Indian patient, because there is going to be a greater risk of stroke or macrovascular complication or cardiovascular mortality if you have persistent postprandial hyperglycemia, and even the risk of diabetic kidney disease and neuropathy is also high. PVD also, we know that if there is a persistent hyperglycemia postprandial, that can worsen PVD also. So we said this also needs to be addressed. Similarly, as I talked in the beginning, all patients, those who are likely to have hyperglycemia or those in the past have been getting recurrent hyperglycemia, or if they are having hyperglycemia unawareness, there we should choose drugs which will not induce hypoglycemia. So the best option after metformin could be DPP4, SGLT2 or GLP-1 or pioglitazone. So if someone who is prone to hypoglycemia ideally should not be on long-acting sulfonylureas or even on insulin. Chronic complications which are very, very important in the management of type 2 diabetes, may it be microangiopathy like retinopathy, neuropathy, diabetic kidney disease, diabetic foot and peripheral arterial disease, which is a macrovascular complication, and overall risk of developing cardiovascular complication. So screening for retinopathy has to be there right at the time of diagnosis for the first time in type 2, and after 5 years of diagnosis in type 1, then every 1 year, either by a trained retina specialist or you may do a direct fundoscopy. These days, AIs and all those options are available. You may get a report right sitting in your clinic, or you may sort of refer it to a eye specialist through iCloud. So that is all possible. But a screening for diabetic retinopathy has to be there. Similarly, diabetic neuropathy screening has to be there. This is our own publication where we have been saying that you can do a NSS NDS score, which is symptom score and neuropathy disability score in our patient. And it just takes 2 to 3 minutes on the bedside to make the diagnosis of peripheral neuropathy based on this score. You don't have to go for every patient for a nerve conduction or another sophisticated test. What you need is you need a 10-gram monofilament, a tunic form, and just do NSS NDS score. I cannot go into the details because this itself will take a long time. Again, screening for diabetic kidney disease is very, very important. Assessment for microalbuminuria right at the time of diagnosis, either as a spot test or maybe a 24-hour or ACR, which is very, very, you can say practical, doing by only a simple single sample of urine, albumin creatinine ratio, and you can find out whether the patient is having persistent microalbuminuria or no. So all those patients who are having positive ACR or microalbuminuria, they have to be on ACE and ARB. We must be in a habit of doing a eGFR calculation before prescribing any drug by CKD-PI method, which is one of the best, and we should rule out the causes of albuminuria before interpreting something like UTIs or fever where you might have presence of albuminuria. So all those patients who have persistent albuminuria, proven at least on 2 occasions, they must be on ACE or ARB. Someone who is already hypertensive again has to be on ACE or ARB to check the progression of diabetic nephropathy in the setting of a presence of microalbuminuria or hypertension, because that is possibly the only way to check the progression of diabetic retinopathy other than getting a good glycemic control. And for the first time again, we said that an assessment of sexual dysfunction also, this also should be discussed with the patient. Maybe you may do a symptom score for ED. There are various criteria, Adams scores and other which are available. So you may display a chart in your reception area, and you can just open up with the patient, because many of Indian patients may not straightway come out, but moment you start talking to them, they will come out with huge number of problems, both sexual dysfunction in males and females. It is important. I'll not be again going into the details, but this also needs to be assessed. And of course, toward the end, we should not advocate using complementary and alternate therapy, because these are not approved by our Medical Council of India. And even in fact, I think we all know that there has been one ruling by the Supreme Court that if you are prescribing other drugs which don't belong to your therapy, it amounts to a quackery. So that should be avoided. Not that these therapies are not effective, but because we have not been taught on those guidelines and we don't have enough evidence to advocate the uses of therapies and management of type 2 diabetes. So to conclude, the physical impact of type 2 diabetes is well known, and its management has substantial effects both on individual and social health and psychosocial well-being and quality of life, as well as economical repercussions also for whole society as such, not only for the family but for society also. There is not one size which fits all. That is why these days we are advocating a individualized or a profile based approach in management of type 2 diabetes based on ABCDFGH, which defines the overall profile of the patient, whether the patient is obese, whether patient is elderly, whether patient has established CVD, or whether patient has diabetic nephropathy. So based on that, we should actually try to address 2 or 3 major concerns, or we should try to identify 2-3 major concerns in that particular patient and then pinpoint a particular type of therapy. It has to be an input type 2 diabetes, which could serve as a real world approach, providing care that is responsive to individual specific needs, preferences, values, and it has to be again based on choices made in discussion with the patient. Not every patient will be able to afford GLP-1 analog or SGLT2. So choices has to be the patient preferences, and it has to be discussed with the patient before we make the final prescription. Thank you very much for your patience listening. You have any questions, I'll be more than happy to answer that. I'm sorry I had to really rush because of want of time. We were already late, so I didn't spend too much time on wheel also. Wheel is in fact itself a 30-minute presentation.
Thank you, Dr. Chawla. It's a excellent presentation, and we are grateful to you to be a part of this conference. Thank you so much, sir.
It's a pleasure being with you, and my gratitude to all of you, Dr. Mathur, GD, Dr. Parekh yourself, and Dr. Maheshwari and other people. Thanks a lot for this opportunity.
Thank you, sir. Thank you, sir. Thank you.
Good night, everyone.
Good night. Thank you, sir.
We thank you, all the speakers and esteemed chairpersons of this session, and we now proceed towards our concluding session, that is the metabolic update. For that, I invite our chairperson, Dr. Prem Mittal, sir. He is MD, FICP, and working as senior consultant physician at Supreme Hospital, Anwar. So I welcome you, sir. And for beginning session, I invite Dr. Rakesh Sahai, sir, for delivering his talk. He is a senior consultant endocrinologist at Sahai's Endocrine and Diabetes Center. He is at present professor and head department of endocrinology, Usmania Medical College and Hospital, Hyderabad. He is a renowned figure in the field of endocrinology and chaired various societies. He has been the founder secretary of Endocrine Society of India. He's FACE, FRSSDI, FICP, FIACM, and also received senior lectureship oration of API 2008. He has over 100 publications to his credit in various national and international journals of repute, and has also authored many chapters in various textbooks and monograms. So I wholeheartedly welcome you, Dr. Rakesh Sahai, sir. Dr. Rakesh Sahai, sir.
Thank you, sir, for the kind words of introduction. At the outset, I would like to congratulate the entire team of eRAJAPICON and thank Dr. Girish Mathur, Dr. Parekh, Dr. Ramchandani, and Dr. Maheshwari for inviting me to be amongst all of you in this a very important session that is going on today. And I would now move on to my talk.
Welcome, Rakesh. Thank you so much to be a part of this conference, and we are very happy to see you and your involvement in this conference. Thank you very much.
Thank you, sir. Thank you, sir. So the topic that I'll be discussing is about metabolic syndrome, which is an emerging threat, and which there are so many different aspects that have been studied. So in the 20 minutes that I have, I won't be able to cover every aspect of metabolic syndrome. So I'll try to just highlight a few aspects and highlight some of the important aspects of metabolic syndrome. So let us look at some of the things. Like if you look at this picture says a lot. Everybody is familiar with this picture. This says a lot of things. It says that, over the centuries we have been we have evolved from our earlier this thing as apes. We have become more erect, and now we have become, our lifestyle has changed tremendously. As you can see, the last two photographs are showing that we have changed our lifestyle so much so that we have actually gained a lot of weight, and that has contributed to a significant number of metabolic problems. And that is what is basically saying that, we have developed this constellation of metabolic abnormalities that are providing increased risk of diabetes and cardiovascular disease. So that is what is metabolic syndrome. It has been recognized several decades back, maybe about 4 or 5 decades back, and it was initially called as Syndrome X, and then it was Revan who described it in little more detail, and then it was called as a deadly quadrate, and several other names were given to the metabolic syndrome. And subsequently now we call it as insulin resistance syndrome or the metabolic syndrome. So this is what we now call it as, but there have been several different names that have been earlier alluded to, have been used for this syndrome. And the major features of this syndrome are basically that the presence of central obesity, hypertriglyceridemia, low levels of HDL cholesterol, hyperglycemia, and hypertension. And the major problems that we have said is that development of type 2 diabetes and cardiovascular disease, which is the major cause of morbidity and mortality. And the whole, the driving factor behind this syndrome is probably the insulin resistance, which has been recognized by time and again recognized that this is the major factor which is driving the whole syndrome. And that can manifest in different ways. So the insulin resistance is present very early in the course of the problem. And initially there's compensation for the insulin resistance with increased production of insulin levels, and the high insulin levels maintain the glucose levels in the normal range, but can contribute to the development of hypertension, atherosclerosis, dyslipidemia, a whole lot of changes in the fibrinolytic activity, in the coagulation pathway, and ultimately that can also present with polycystic ovarian syndrome, and later when the compensation of hyperinsulinemia starts coming down, then type 2 diabetes manifests. So this is how insulin resistance manifests in different ways and can lead to many of the components of the metabolic syndrome that we are discussing. And there has been a lot of confusion on the diagnosis of metabolic syndrome also, in the sense that different organizations have given different criteria for diagnosis of metabolic syndrome. We have the different, the most commonly used one was the ATP3 criteria. ATP3 criteria was using 3 out of 5 of these abnormalities, that is presence of hyperglycemia in the form of fasting glucose being more than 110, a triglyceride level more than 150 milligram per DL, or HDL level of less than 14 males and less than 15 females, and a blood pressure value of more than 130/85, or people who are on anti-hypertensive medication, and the presence of obesity. So this was the major, this was the one which was very commonly used, 3 out of 5 of these criteria being present. And then we have got modification of this by the IDF which spoke about the presence of the waist circumference becoming one of the important criteria. That is, and they've also made it region specific, so which I'll show you in the next couple of slides. And then there have been other organizations, other criteria laid down by WHO, which have spoken about insulin resistance being an important factor to be present in all these patients, and two out of the other factors being present. So similarly, the European group for study of insulin resistance has also highlighted the need for insulin resistance to be present in all these patients who are diagnosed, all these people who are diagnosed as having metabolic syndrome. So different criteria have been used, different these things have been used. But if you look at the IDF have actually tried to use region-specific criteria for defining obesity or central obesity, and they've looked at a waist circumference of more than 90 in males and more than 80 in females, particularly for the South Asian region. And because we see that we have a significantly increased risk of diabetes and cardiovascular disease at lower waist circumferences. And they have suggested the presence of a waist circumference being important criteria, and plus 2 out of the other 4, that is hypertriglyceridemia or low HDL cholesterol, as we've discussed, hypertension, presence of BP more than 130/80, 85 millimeters, or when people are on medications, and a fasting plasma glucose of more than 100, or specific medications, or previously diagnosed type 2 diabetes. So this is how the IDF criteria go on, and as I was mentioning that they have highlighted the need for using specific region specific criteria for defining abdominal obesity. And the important, I mean, as you can see in this picture, South Asian population have a higher risk at lower abdominal circumference, and that's the cutoff suggested. And while for the European population and the Caucasian population, 94 centimeters in males and 80 centimeters in females is suggested, and for the Caucasian population, it is even higher, as we have seen in the previous criteria. So, if you look at the epidemiology of metabolic syndrome, we can see that the prevalence keeps increasing with age, and greater industrialization and urbanization have been the major factors contributing towards the rise in the prevalence of metabolic syndrome, and this has led to central obesity, increased fat deposition in the visceral compartment, and this fat being metabolically active, contributing to all the other constellation of abnormalities that we have just spoken of, and this is what is happening. And if you look at the prevalence of metabolic syndrome across different countries, as you can see, different parts of the globe, what you can see is that it is all age dependent. So if you look at the x-axis, it is showing the age that has been used, that is in India more than 20. If you look at individuals who are more than 20 years of age, the prevalence is close to about 20% in women, and about close to about 10% in males. So women across the world, as you can see, in most parts of the world, you can see that women tend to have higher prevalence rates of metabolic syndrome. Some parts of the world, it's more of men also. As you can see in US, men are having higher prevalence rates of metabolic syndrome. In other parts of the world, it has been similar in males and females, as you can see here. So these are the prevalence rates, showing pretty high prevalence rates across the globe. And if we look at the factors contributing towards the development of metabolic syndrome, as we have seen, that we can see it in many different ways. I mean, if you look at central obesity contributing to various problems, the central obesity being caused because of insulin resistance and the hyperinsulinemia, there's central obesity, and that in turn leads to alterations in the glucose metabolism, leads to alterations in the lipid levels, leads to alteration in the hemodynamics. Because of hyperinsulinemia, there's sodium retention. There's elevated sympathetic activity because of insulin resistance. Against high levels of insulin lead to increased sympathetic activity. There is, and this ultimately leads to hypertension. And then there could be effects on the coagulation pathway and inflammatory pathways. Again, insulin has direct effects on the coagulation pathways, increases the levels of CRP, increases levels of PAI1, decreases adiponectin levels, and increases the TNF alpha levels. All this, as we see, all these contribute towards the increased risk of coronary artery disease, which we are seeing in our population. That's very high, particularly in individuals with metabolic syndrome. They tend to have a very high risk of coronary artery disease. If you try to look at it in a different way, we can say that overeating and decreased physical activity, which are the major factors we are saying is contributing towards the metabolic syndrome. They both lead to, again, visceral adiposity. The fat cells in the abdominal compartment are metabolically very active. They lead to the release of several adipokines like leptin, which is increased. Adiponectin levels are decreased. IL-6 levels are increased. TNF alpha is increased. Increased levels of fibrinogen. So all these are contributing towards inflammation and alteration in the coagulation pathways. And then there is, because of the insulin resistance, there is decreased activity of the LPL activity, which has to be suppressed by insulin, doesn't happen, and there is increased free fatty acid production, and that leads to increased gluconeogenesis in the liver, increased lipogenesis, increased triglyceride production in the liver. That leads to dyslipidemia, and also there is RAS activation also through the visceral adiposity. There is RAS activation also. RAS activation, that the renin-angiotensin aldosterone system is activated. So through all these mechanisms, there is activation of the RAS pathways, the activation of the adipokines, there's activation, neurohormonal activation, chronic inflammation, and insulin resistance. All this contributes towards the consequences that we see of the metabolic syndrome. So if you look at some of the other mechanisms that are coming in play, one of the things that is being increasingly understood nowadays and spoken of by many people is that there is alteration in utero. The alteration starts off not in after birth, but before birth also. In fetal programming itself is defective in people who have metabolic syndrome. Probably they have a very early origin of the problem, and this is showing how fetal programming itself can contribute towards the development of metabolic syndrome. I'm not going into details of that, but the other interesting area which is being studied is the role of gut microbiota. So what is suggested is that in a normal individual, there is eubiosis with the abundance of different flora in the gut. There is a balance between the harmful flora and the good flora. So the good flora probably are in the green, and the harmful ones are in the red. And when there is intake of high fat, low fiber diet, there is increased preponderance of this type of dysbiotic bacteria, and these lead to impairment in the tight junction integrity, and that leads to sort of leakage of entry of these entry of various factors through the gut lumen, and lead to the activation of several mechanisms that happen. As you can see here, the lipopolysaccharides, the various metabolites of various other metabolites, the inflammatory mediators enter into the circulation through the impaired gap junctions because of the dysbiotic bacteria, and they in turn lead to chronic inflammation, liver and adipose tissue conversion of metabolites, and they in turn lead to insulin resistance, and through different mechanisms lead to increased fat deposition in the liver, and also lead to atherosclerotic cardiovascular disease. So gut microbiota dysbiosis also has a very important role to play in the pathogenesis of metabolic syndrome and all its consequences. So if you look at how we need to identify this, we probably don't have a high index of suspicion has to be kept in mind to identify markers of insulin resistance, as we can say, clinical markers of insulin resistance, presence of acanthosis nigricans, skin tags, lipoatrophy, increased blood pressure, increased waist circumference. These should all alert us to search for other markers of insulin resistance. As we all know that there could be additionally presence of hyperuricemia, presence of non-alcoholic fatty liver disease being recognized more and more often in our patients, particularly those with other components of the metabolic syndrome. And then you have a high prevalence of PCOS also amongst them, polycystic ovarian syndrome amongst the women with metabolic syndrome, and obstructive sleep apnea is also another feature which is being increasingly recognized. And so all these things have to be looked for. Probably we can do a couple of tests to identify. We can look at whether the individual is satisfying this IDF criteria which we spoke of. Then look for history of symptoms of OSA, history of PCOS in a premenopausal woman. Look for family history of CVD and diabetes. Waist circumference, BP measurements are very important, and always do a fasting lipid profile, fasting glucose, and then wherever possible, where you can further investigate, get some more investigation done, you can look for uric acid, fibrinogen, and HSCRP levels can help us in identifying these problems. Such individuals have altered sleep studies showing obstructive sleep apnea, and then there could be alterations in the hormonal levels. When you're looking at suspecting PCOS, get a testosterone level done, and that may help us in identifying hyperandrogenism. One interesting feature which has been very clearly seen and discussed many times. All of you are familiar with this photograph of the bye-bye paradox with Professor Yudkin, and showing that for the same amount of BMI, we tend to have a very high body fat, 21% versus 9%, with the same BMI, 22.3. So showing that we tend to have a higher body fat, higher visceral fat, and that makes us more prone to develop metabolic syndrome. And because of this, we have this unique presentation in whether you look at people with diabetes or people with cardiovascular disease. We tend to have different phenotype in our population, and we see a different type of dyslipidemia that is characterized by high triglycerides, normal HDL levels or slightly elevated HDL levels, and normal or slightly elevated LDL levels and low HDL levels. So this is something which we are very familiar with. We see in most of our patients, we see almost 80 to 90% of our patients having dyslipidemia. 80 to 90% of diabetics have dyslipidemia with low LDL, low HDL, and raised triglycerides, normal or slightly elevated LDL cholesterol levels. If you look at women with PCOS, we find that many of them have metabolic syndrome. In this study from Ashraf Ghani, he has shown that almost 33 to 47% of women with PCOS had metabolic syndrome. So metabolic syndrome is a very common manifestation of PCOS. It can manifest with PCOS, and similarly it can manifest with non-alcoholic fatty liver disease also. You can say that non-alcoholic fatty liver disease, which we are commonly seeing in many of our patients who are obese and have diabetes, this is probably a hepatic manifestation of the metabolic syndrome. And there's a bidirectional relationship between the presence of non-alcoholic fatty liver disease and diabetes. Presence of this increases the risk of cardiovascular disease amongst patients with diabetes, increases the risk for all the microvascular complications also. And as you can see here, people with no NAFLD versus those with NASH have a very significant increase in cardiovascular disease risk, and also other problems related to diabetes and its complications. So how do you, when you come to management, quickly coming to the management in the next few minutes, I will speak about what we can do about management. And the most important thing is lifestyle modification probably is the most important factor which is going to play an important role in managing this condition or preventing metabolic syndrome. Weight reduction includes a combination of calorie restriction, increased physical activity, and the most important part is the behavior modification. We all know about physical activity and weight calorie restriction having the beneficial effects, but behavior modification very important, because as you can see here, people who are obese, they tend to sort of be consuming more and more of stuff like this, which is full of simple sugar, and we need to sort of change the behavior towards more of using this kind of food and exercising regularly. That is what is very important. And 500 kilocalorie of food restriction, dietary restriction every day leads to a good reduction in weight. And we have different types of diets which have been studied. I would not go into details of that. That itself can be discussed for a very long time. And the most important thing that has been shown in the recent studies where reversal of diabetes has been attempted and has been shown, there the major aspect has been restriction of the calorie restriction, irrespective of the type of food that you're taking. Calorie restriction has been shown to have an important effect. There are several different substances found in our traditional foods like turmeric, garlic have got various active ingredients which have anti-inflammatory properties, antioxidant properties, and they have several beneficial effects on insulin sensitivity, lipid levels, adiponectin levels. So I'll not go into too many details of that, but just to show you a snapshot of that many of these traditional foods that we are, all our traditional foods and spices have a lot of benefits on various components of the metabolic syndrome. Onions, fish oils, ginger, cardamom, all these have got significant benefits. We are now actually moving into the future is in the direction of precision nutrition. We say that precision nutrition with nutrigenomics playing an important role, and gut microbiota being understood more and more, gut microbiota being understood, and metabolomic studies coming in with a lot of information. All this will lead to more of precision nutrition, and that can comprise of stratified nutrition, individualized nutrition, and genotype directed nutrition. So these are the various components of precision nutrition, and that's what is going to be the future, where we're going to see more and more nutritional planning being done based on several different parameters collected from the individual.
Sir, can you conclude your talk, sir?
I'll just conclude in 1 or 2 minutes. Then role of physical activity cannot be overemphasized. There are different anti-obesity medication, which none of them have stood the test of time. And when you come to managing triglycerides, we have one interesting molecule called saroglitazar, which all of you are aware of. It's an Indian-made molecule which has got several different properties and has been shown to have a beneficial effect on not only reducing the triglycerides, reducing the non-HDL cholesterol, also has a significant effect on reducing HbA1c, reducing the small dense LDL, and also having an improvement in the ALT levels. And only this year it has been approved for management of non-alcoholic fatty liver disease by the Indian DCGI, and also for management of type 2 diabetes, also apart from the atherosclerotic diabetic dyslipidemia. Then importance of ACE inhibitors or ARBs, the RAS blockers, and management of insulin resistance, blood sugar control are all important aspects. One emerging area is again the fecal microbial transplantation, as we've seen the important role of gut microbiota. The role for fecal microbial transplantation is being more and more studied, and probably we can say that we have gone a full circle. If you see, right in the 14th century, people were looking at traditional Chinese medicine derived from fecal products, and from there it has gone all the way, and we are seeing now we have come back towards fecal transplantation and personalized medicine based on all this. So I think we have gone a huge circle with all these things, and I will try to end by saying that metabolic syndrome is a very important entity that has to be understood. Identifying components of metabolic syndrome early would help us in understanding the importance of the person going into diabetes and cardiovascular risk, and preventing that can be possible with early recognition of metabolic syndrome and adopting lifestyle changes which can prevent the development of metabolic syndrome, cardiovascular disease, and diabetes. Thank you all for the patient here.
Thank you, Dr. Sahai, for your beautiful talk. Now I will invite.
Now I request Dr. Prem Mittal sir to kindly invite Dr. Shibendu Ghosh sir for the penultimate talk of this conference. Dr. Shibendu Ghosh sir.
Good evening, Dr. Shibendu Ghosh. He is a professor head of the Department of the Medicine, had Obesity and Lifestyle Disease Division, IPGMER, SSKM Hospital, Kolkata.
Sir, please introduce Dr. Shibendu Ghosh, sir.
Shibendu Ghosh. Dr. Shibendu Ghosh is a professor of JIMSH, present affiliation, Professor of Medicine, JIMSH, Kolkata, ex-Professor of Medicine, Ramakrishna Mission, Seva Pratishthan, and Vivekananda Institute of Medical Sciences. His major achievements are: he has been a Vice President of Association of Physicians of India Headquarters, Vice President of Hypertension Society of India, Vice President Society of Tropical Medicine and Infectious Diseases of India. He honors or awards first certificate of honors in medicine from Medical College and Hospital, Kolkata. B.N. Bose Prize in Clinical Medicine from Medical College, Kolkata. Second certificate of honors in anatomy. Trained in nephrology at PGIMER, Chandigarh, under Professor K.S. Chugh. Trained in endoscopy in Chennai by Dr. V.K. Rao. 1 dozen international publications and half dozen national publications to his credit. Monographs: snake bite, organophosphorus poisoning, human hydrated cyst disease, and radiology for physicians. He has written a good publications. Thank you. I welcome Dr. Ghosh to deliver his talk. Dr. Ghosh.
Please Please unmute yourself, sir.
Yeah. Can you hear?
Please unmute yourself, sir.
Yes, Dr. Subhendu.
Sir, please unmute.
Dr. Shubhendu, are you listening?
No, I am listening. Unmute.
Yes,
Can you hear me now?
Yes.
Yes, sir.
Yes.
Dr. Subhendu.
Yeah, sir. I can hear you, sir.
Dr. Subhendu Ghosh.
Yes, sir.
You are not audible, sir.
Still now I am not audible. Can you hear?
Now. You are audible now, sir.
Audible, sir. You are audible, sir.
Yes. Now you are audible. Sorry.
Can you hear me? Hear the slide? Can you?
Sure, sure. Thank you very much, sir.
Can you see the slides there?
Yes, we can see your slides.
Please click on slideshow, sir. Please click on slideshow.
Yeah. Dr. Shubhendu, can we start?
Yes.
Yes. Why not, sir?
Yes.
Just a minute, sir. Okay. Thank you, sir. So I'm just starting with this. This is one of the very important session, though it's a penultimate, but I too do become grateful to very good luminaries of API, Dr. K.K. Parikh, Dr. Girish and Ramchandani and his whole team, that they have given this opportunity, a good opportunity to talk about this best oil in Indian soil. So with this, may I start the first slide, please? This is the currently we are confused with several brands available and each oil sporting all types of jargon on the package and on the TV and other medias. What is happening there? It is also a genomic. It's the problem of the people what they should eat, particularly the oil. We are talking much about the carbohydrate. We are talking about much of the proteins and fats, but we are talking less about these very important things, the oil to be consumed by the people in India. So most of the people if you think about the nutrigenomics, it's the external forces, the external intake, most of them may accept this cholesterol itself, that is causing more problem for us. Now look at this cholesterol. These are two types. One is low density, that is bad cholesterol, and another is either non-LDL cholesterol or HDL and plus cholesterol, which causes more problem. Now you can think of the saturated versus unsaturated. All unsaturated fat are bad, probably unsaturated fat are better. So saturated fat are bad. So they make oil thicker, solid, elevates both LDL and total cholesterol. The rich sources in ghee, butter, and coconut oil, whereas unsaturated fats are very common in sunflower, soybean, and other oils. Now, if you look at these slides of best and worst fat, obviously best MUFA, this monounsaturated fat is probably best, and probably worst is your trans fat. I'll go to that in a better details later on, but rich sources of this MUFA is olive oil, mustard oil, and groundnut oil, and canola or rapeseed oil. Whereas this margarine and vanaspati ghee that contains lots of trans fat, and it is banned already in US and other countries, including UK, not to be used because it causes lots of coronary artery disease, and which may be a problem in India also, but probably in India, at least the consumption of this trans fat has decreased to a great extent, having the knowledge from the country outside. Now, before going to that part, I am talking, this is the very important slide I am just looking about. The comparison, if you want to take what is the best oil in India, it will be a problem of confusion and problem of debate, and which I cannot help by 20 minutes time of talk. But the problem is that we do not know our own food, we do not know our own country, and everything is, we try to avoid our own conceptions and other. Because You cannot think about that. The Rajasthan, the history of Rajasthan is written by people outside the country. About snake bite, the protocol of snake bite management was written by people outside country, Australia and US people, UK and US people. So that way, we are forgetting our own thing. The mustard oil, which is very much used in the north and east part of the country, it's probably considered now as the best oil by the specialist and the super specialist, particularly the AIMS and other institutes who have done a good research. Why then? The WHO has said that omega-6 and omega-3 fatty acids is the ratio is the most important parameter of the patient who are bad oil or good oil. Obviously, the content of the MUFA is also good. If it is high, then it is a good oil. SFA, if it is high, SFA is saturated fat, it is a bad. So, considering all these things, if you can go to the first three oils, the ratio of omega-6 and omega-3 fatty acid is nearing 1. That is a good sign that these oils are very good. Whereas, even if he has got a very good N6 by N3 ratio, N6 is always a pro-inflammatory substances, whereas N6 is an anti-inflammatory. So you can see the N3 always cause good thing for us. So with this few conception, you go to the others. Soybean has got a N3 and 6 more than 10, whereas red palm more than 20, whereas olive oil more than 20, palm oil is more than 20, N3 and 6 ratio. And all these things, the sunflower, sapola, and groundnut has got a N3 and 6 ratio, which is bad for human being more. But the companies are all the time jargoning that this is a very good oil for us. And not only that, the badness of this thing, that we always use refined oil in our country because the companies influence on the market. Most of the refined oil are used less for us. It is the bad for our health because the oil is being refined. Most of the time, the oil is denatured, and this denatured oil in our body causes much more diseases than doing good. Not only that, after this refining, they are degummed, they are chemically changed with its oil property, as well as some of the very important antioxidants are being removed by this method of refining. So doctors always try to avoid refined oil for your patients because that causes more harm. You ask for the more omega-3, omega-6 ratio, and if it is near 1, that is a good one. Now going to another things, the contents of other things like tocotrienol, it is a vitamin E family. These are very good neuroprotective, anti-cancer, decreases liver cholesterol synthesis, and it's a natural antioxidant. It is contained in so many oils, including rice oil, coconut oil, and barley oils. And phytosterol, naturally occurring in cholesterol analog grounds, and 2 grams of phytosterol daily associated with 10% decrease in LDL. Sources are sesame, corn, canola, and wheat. Now, cold compressor, this was a very old way of using the oil to get the oils from the seeds. It is probably not being used now in India because of low production rate of this oil in India. So most of the time we are not using this cold compressor. We are going to first to the refined oil. Refined oil is a purified oil obtained from the oil cakes using the process of solvent extraction. Extraction causes more harm because the temperature range is more than 110 all the time and go up to 180 on a steam bath. And the extracted oil is then put to the further refining technique, degumming, neutralization, and bleaching. All causes harm to the oil, and this harmful oil is being taken by us and causes more problem for us. Refined oil is a high temperature process and weak carbon bonds of unsaturated fatty acid, particularly creating free radicals. Antioxidants like vitamin E, all these things is destroyed by high temperature. butylated hydroxytoluene, BHT, and other butylated products also being replaced the vitamin E, and they are destroyed by the heat. It produces a bland oil having only mild flavor, free from impurity, but more likely to run rancid, which is very bad for most of the time. Unrefined oil obtained by a process of pressing the seeds or other vegetable material. This uses a screw or continuous press with a constantly rotating worm cell. Healthy otherwise, unrefined oils are considered better and recommended due to presence of wide range of bioactive materials like antioxidant, flavors, and vitamin E content. The another problem is this oil is the rancidity, because the development of a disagreeable odor and flavor of the fats and oil. There are three types: hydrolytic, oxidative, and ketonic. I'm not going to details of that, but all this rancidity causes lipase enzyme, hydrolysis, and others. These enzymes destroy the fat and causes rancidity, bad odor, and causes more problem. And this type of rancid oil should not be used. Then another method of is our hydrolytic rancidity, and that causes also problem. Oxidative rancidity also problem. A gaseous decompression like rancid fats or carbon dioxide, and it's a problem for us. So with this, may I go to the next part of the slide? Is that induction period of this rancidity should be less, because the induction period, if it is more, this causes more rancid. So we should try to avoid the more amount of shelf life should be of the oil should be more, but the induction period should be less. Now, which oil to use? This is a very controversial topic, and I am unable to go in a conclusion that which oil to be used in Indian city. But I have got some intention that the patient should be a patient of this thing should be choice on the intended use. Oils with high smoke point for deep frying. I think one of the major issues in our country that we cannot control the kitchen. Kitchen is being controlled by our counterpart, and they always try to make the oil more fuming, more high smoke point, and they deep frying. They like to take more deep frying. This is good for they don't bother about the good health. They bother about the taste and other things, which is bad for us. We have to try to control the kitchen people to have not to have a deep frying method. Ability to stay on self and also fat decomposition. The ratio between MUFA and N3 and 6 fat component, and however many oils have some special component or characteristics which make them special. Now the mustard oil, I'm just talking because I love to take this mustard oil. I'm very fond of mustard oil, but I do not want to influence the people. But this is the best oil to my mind, because it is the oil, it is the contents, so many things that it contains about 70% of MUFA, and 42% of this is uric acid, 12 is oleic acid. Though previously it is containing a thing that uric acid is bad for health, today we are not thinking, because uric acid is being metabolized in human being in a better way. So we are not bothered about the content of uric acid. It is not a bad acid for our health. It has got 22% of PUFA, of which 10% is the omega-3 alpha-linoleic acid, and 12% is omega-6. And omega-3 is an anti-inflammatory. And this ratio of omega-3 and omega-6 is a very good composition as per the World Health Organization recommendation. If it is nearing 1, then it's a very good oil. Mustard oil has also high levels of omega-3 and a common cheap mass producer. What is the most important? It's a mass produced vegetarian source of omega-3 fatty acid. So I'm continuing with this. Mustard oil considered as one of the healthiest edible oil, as it has a low amount of SFA and high content of MUFA and PUFA fatty acid, which are good for health. Compared to other oils, mustard oil has several benefits. Ratio I've already talked about that. Unlike other oil, olive oil, where it is 20/1, mustard oil has got 1.2 into 2:1. High content of antioxidant and vitamin D, as well as the fact it is a cold compress. Add to the nutrition value of this oil. the sulfur-linoleic acid found in mustard oil, which give the flavor and the odor, the pungent odor, reduces the risk of heart attack. Several clinical studies have shown that mustard oil may be best for the healthy heart in our country. A study by Harvard Medical School of Medicine, All India Institute of Medical Sciences, Delhi, specifically by Dr. S.C. Manchandra and Sandeep Misra, and doctors from St. John's Hospital, Bangalore, found that there is significant dose-dependent inverse association between the vegetable intake and ischemic heart disease. And the more you use this mustard oil, they have found that if you more use mustard oil as a cooking media rather than other oil, use of mustard oil rich in linoleic acid associated with lower risks than the use of the sunflower and other. So now I am going to other part. This is a oil that has been looked down upon for a long time, rapeseed oil. It was being used in the recent shop for decades together. But you cannot believe when this resin oil going to our smart shops like mega shops, then it becomes a very important oil for us, the canola oil. Because canola oil and rapeseed oil has got no difference. Rapeseed oil is produced in India, canola oil is produced in Canada. This is the basic difference. The canola term Canadian oil and canola oil low in SFA, recognized by many health professional organizations, including American Diabetes Association and American Heart Association. Canola oil has been considered healthy food by FDA, but alas, we are still going back and we are not using canola oil, which is cheaper than even mustard oil and which is much better oil than your sunflower oil, which is a jargon by the media and others. Olive oil is a good oil that is considered because of the high MOFA content, but it reduces risk of cut, but it has also exerts some anti-inflammatory property, but its content, the ratio of N6 by N3 is bad. So it is not an ideal oil, what I should say. So the main limitation of this oil is does not have but it's a good oil when you use without being cooking time. You use it when the cooking has been done, and you just use some part of this oil above the food already prepared. That is a good way of recognizing. Rice bran oil, another good oil, but high content of rice bran oil. Rice bran oil extracted from the germ or mineral husk of the tissue. It is perhaps one of the most balanced oil, range of 40. But the major limitation, again, it has a bad or non-ideal N6 by N3 ratio. Sunflower oil, we are talking about the sunflower oil in the media, in the TV and other places that it is a very good oil. It contains so many things, but it is rich in lecithin, tocopherol, and PUFA, and also the vitamin E. The major limitation of this oil is a very poor N6 and N3 ratio. That is a more pro-inflammatory oil than a anti-inflammatory. Safflower oil, safflower oil is also has got the same thing, that the common one available in Indian market being low in SFA, initially used as a substitute for ghee, but it is not a good choice. However, rich in PUFA, very low in MUFA. Being high in PUFA, it is more likely to be turned rancid. But it is also the problem of causing the N6 by N3 ratio is not bad. Is not good, sorry. Palm oil is same thing extracted from the pulp of the fruit of the oil of palm, but it contains lots of antioxidant, but the same thing that its N6 by N3 ratio is not good oil. So major limitation of this oil, of palm oil also, that it has got an N6 by N3 ratio of 20:1. Butter is also, sir, within 2 minutes, sir, within 2 minutes, I am concluding. I think I should be concluding by 1 to 2 minutes. So butter is a fat derived from the animal, so high in SFA. It can raise the total cholesterol, good flavoring agent, having a low smoke point. It cannot be used as a deep frying. Whereas ghee is almost a basically clarified butter, but it can be used even for the frying because it's a very good and highest smoke point of oil. But I have to talk something about this banaspati, essentially refined vegetable oil, which has been made more stable. It has been more shelf-life and least likely to turn rancid. Not ideal for deep frying at a relatively low smoking. It is the unhealthiest of all the oils because not only devoid of natural vitamins and bioactive components, but it's a result of hydrogenation of the process. It contains undesirable type of fats called trans fat, and that causes more problem for us. And it is causes worst type of lipid profile possible and has been directly correlated with development of cat. The conclusion. This is the it is the conclusion slide, sir. You can see, sir. I have just started after your word or before your words. Review of several edible oils has been presented, and their benefits and harmful effects on heart health have been discussed. Out of the all several edible oil available, mustard and rapeseed oil appear to be more heart healthy as they are low in saturated fat, high in MUFA and PUFA, and they have a highest N3/N6 ratio. Epidemiological study also suggests that mustard oil can decrease the occurrence of coronary disease. Now, I'm going to very last penultimate slide of my lecture. This is the very picture of the crudest way of extracting the mustard oil from a factory in a village. And you cannot believe this is the best way because it contains lots of antioxidant. You can do it at even near your home. And not only that, it's like your other foods. The rice which is devoid of the husk is bad for us. This mustard also, if it is refined, if you do not contain the adequate antioxidant along with the oils, it is bad for us. So with this, Rabindranath Tagore's last poem is that Phire dao sei aranyo loho e nagor. Or that means we are socializing, we are modernizing, we are left with the very bad thing that we are not accustomed with the good things in life. The oil is one of the important issues that if the oil, if the cold pressed, if it is done in your village nearby, and then it is a best oil or as a healthiest oil, and mustard probably the best, mustard and rapeseed. With this, may I stop here, sir? And I have already concluded. So thank you very much, sir. Again, I am thanking the Dr. Padik, Dr. Mathur, and Dr. Ramchandani, along with my chairpersons and all the mentors of your eRAJAPICON. And I should think this is a eRAJAPICON, not eRAJAPICON. It's a eRAJAPICON. Thank you very much, sir.
Thank you. Thank you, Shubhendu. Thank you so much. So nice. Excellent.
Thank you very much, sir, for your kind words. And now I request Dr. Prem Mittal, sir, to kindly invite our next speaker quickly and welcome him, Dr. Soumitra Ghosh.
Dr. Soumitra Ghosh, welcome, sir. Welcome, sir. Welcome. Dr. Soumitra Ghosh is
There are 500 delegates who are attending and will be attending your lecture, Dr. Ghosh.
Dr. Professor Soumitra Ghosh is a head Department of Medicine, head Obesity and Lifestyle Disease Division, Institute of Postgraduate Medical Education and Research, SSKM Hospital, Kolkata. He is a faculty council member, Indian College of Physicians, former member of Physicians Research Foundation, Vice President, All India Association of Advancing Research in Obesity, Specialist Certification of Obesity Professional Education, that is the scope, from UK, is a fellow of American College of Physicians, fellow of American College of Endocrinology. He is an eminent person and very good speaker.
Thank you, sir. Respected chairpersons, I must thank all the organizers of. So, can you?
Yes, please start.
Okay, sir. So, all these respected, persons in Rajasthan, my friends, my colleagues, and my mentors, Dr. K.K. Padik, Dr. Mathur, Dr. Sanjeev Maheshwari, Dr. Ramachandani, and all these persons in Rajasthan, those who are passionate in organizing things like Raj So it is our task to discuss about the physician's approach to management of obesity. We all know that India is the third most obese country in the world, and we also know that it is the most burning chronic pandemic compared to this acute pandemic of COVID-19 with the effect on the multi-system. So it is a chronic, complex and multi-system disease, and it has a multiple etiologies, multiple determinants and multiple consequences. So while managing a case of obesity, we must include multiple consequences, and it should not be viewed as a single problem, because diabetes, hypertension, dyslipidemia, fatty liver, cardiovascular disease, stroke and cancers all are associated with that. And it has to be accepted that there is marked heterogeneity in complications of similar BMI, like all these complications of myocardial infarction, diabetes, hypertension, dyslipidemia. There may be marked metabolic complications in extremes of BMI, those who are in the left side and the right side. And you can see the common metabolic complications, which is more common in Indian scenario with the, sarcopenic obesity and these thin fat Indians. There is marked heterogeneity in the body composition of similar BMI, and there is marked heterogeneity in the outcome of the treatment, as well as this approach is completely different in different persons. So it is a big enigma, and while we approach this problem with this obesity in the management aspect, we have 1, 2, 3, 4, and we have one target to determine the customized and the best treatment plan with the person with obesity. And we have 2 questions in mind: why the person is obese and how much the person has been affected by obesity. We have 3 tools, that is etiology, complication and staging. It is very important, and we have 4 facets in the evaluation of the obesity for the appropriate management for every person separately. So we must assess the root causes of obesity, assessment of the adiposity and body composition, evaluation of the obesity related risk and complications, and assessment of the class and the stage. And it is very important. And the final and essential evaluation is the patient's readiness and motivation for change. It is very important because we want to deliver a precision obesity care for every person. And it is important to note these root causes of obesity, because this is the major hindrance that many doctors think that it is the, overeating and the laziness issue, but it is a metabolic thing. It cannot be dealt with by eat less and move more. And a whole lot of this homeostasis has to be deranged by this gut microbiota, gut peptide, muscle, liver, brown fat, adipose tissue, brain, etc. And this homeostasis must be disrupted to this obesity when it just gives rise to that. It may be a complex interaction of biology, behavior, environmental factors, genetic and epigenetic factors. Often they coexist, and often they are more than additive in action. And these major determinants are lifestyle, biological, environmental, and heritable factors. So while we deal with that, we take into account this diet pattern, calorie intake, muscle mass, gut microbiota, schooling, built-in environment, genetic, epigenetic factors, and fetal environment. But we must take into account that is why the person is actually obese. Without knowing why the person is obese, we cannot give a blanket therapy for all. As like in edema, we cannot give a blanket therapy for all. We must know whether it is because of the decreased muscle mass, decreased metabolic rate, deranged gut microbiota, decreased proliferation of adipocytes, brown adipose tissue, browning of body adipose tissue, sensitivity of the hypothalamus, or it is the exposure to endocrine disrupting compounds. Finally, it is a energy surplus state. Irrespective of etiology and metabolism balances this homeostasis a lot. So we must take into account whether it is because of the increased intake, decreased metabolism, or activity, whether because of this eating problem, sleep deprivation, medication, or emotional eating, whether because of the metabolic changes, age, sex, low muscle mass, less brown fat, hormones and other factors, whether it is because of the physical limitation, cardiorespiratory, musculoskeletal problem, chronic fatigue, etc. We must know why person is obese, whether it is simple obesity, genetic factors, secondary causes like hypothyroid, Cushing's acromegaly, etc., or some drugs is causing this obesity. We must take this account, these influencing factors like the eating pattern, activity pattern, screen time, TV, computer, mobile time, hours sitting down, amount of physical activity, life stages like post-pregnancy, life events like marriage, giving up, quitting smoking, giving up sports, etc. And other influencing factors, how much carbohydrate, refined carbohydrate, fructose, dietary fat, trans fat, monosodium glutamate, fiber intake, sedentary lifestyle, stress, sleep deprivation, affordability to the healthy lifestyle, all are important. and what is actually killing their muscles and what is killing their gut microbiota. This is the lifestyle factors we must take into account. Then we must go for this 5A of weight management, that is ask, assess, advise, agree, and assist. In the ask, we take about history, lifestyle factors, awareness, these root causes, influence factors, these risk factors, complications, classification. In the assessment group, in the advice group, means and benefits of weight loss, need for long-term strategy, treatment options. In the agree group, goals and motivations, treatment plan. And in the assist group, we must work on these drivers and barriers, referral and the follow-up, everything. We must ask permission because it is a very sensitive issue. We must not blame the patient or provoke any guilt in them. We must not presume the lifestyle or the motivation of the patient. And weight reduction may be a very difficult and hard to sustain, and we must explore this readiness to change. We must use this motivational interviewing for everything. We must ask, listen, and respond in a way to increase the motivation of the patient. We must ask about these lifestyle difficulties, triggers, detailed history about this maternal nutrition, maternal diabetes, obesity, diabetes, etc. Dietary history, the skipping breakfast, fast food, cold drinks, sugar-sweetened beverages, dietary behavior like snacks in between this intermittent snacking or watching television, or this level of activity, sedentarism, history of stress, sleep deprivation, snoring, intake of steroid, other drugs, irregular mens, hirsutism, etc. We must assess the waist circumference, which is very important. Assess obesity class and the staging, and assess the obesity drivers, complications and barriers. And we must advise the obesity risk, which is more linked with staging and not with BMI. That we must assess the ABC, means adiposity and body composition, adiposity and the body composition by anthropometric measurements, and this muscle mass, BMR, subcutaneous adiposity, etc. And in Indian scenario, this is the BMI cutoff, which is lower than the international cutoff, 23 and 25. And the waist circumference cutoff for men 90, and this waist circumference for women are the 80. And in below 18%, it is the percentile. The 85 percentile is the normal, more than 95 and less than the 5th percentile are these underweight and overweight respectively. And the evaluation of obesity related risk and complication is very important, because all these risks has to be assessed, because many times these risks are increased. So relative risk is increased, and we must know all these mechanical and the metabolic consequences of that. And we must assess all these things, obesity drivers, complications and barriers, by this 4M method, where these metabolic, mechanical, mental and monetary things are assessed. All these metabolic complications like type 2 diabetes, hypertension, dyslipidemia, coronary artery disease, stroke, fatty liver, gallstone, gout, hypogonadism, PCOS, cancers, etc. And the mechanical components like osteoarthritis, back pain, obstructive sleep apnea, chronic fatigue, musculoskeletal pain, plantar fasciitis, mental problems like low self-esteem, depression, social isolation, emotional eating. And this is the single most important barrier to the management of obesity and must be addressed in every patient. Thus, the monetary problem is very important, because these weight loss accessories are costly, weight loss programs are costly. Low income group, they have this low education and knowledge sometimes. So lack of money is a risk factor for becoming obese and may not afford management. So these are essential for effective management plan and addresses underlying issues related to obesity. So these are the 4M in a single slide we must assess before going into this classification and this management. So obesity class and stage is very important. This BMI says the how big is the person, the class. And in Indian scenario, there is a left shift for every target compared to the international one. The 20 becomes 25 becomes 23, 30 becomes 25, and like that. And in this Edmonton obesity staging system, we must shape that how sick is the person and what is the staging by the assessment of the medical, mental, and the functional assessment. In the class, we just just organize these things according to BMI, how big is the person and how much complication is there, and show no apparent risk factor, subclinical risk factor, established comorbidity, end organ damage, and the end stage disease. And we must not forget this waist circumference, male 90 and female less than 80. So in this stage 0, all these complications are absent. There is only BMI is increased, blood pressure normal, lipid normal, glucose normal, no physical symptoms. In the stage 1, preclinical risk factors are present, like this borderline hypertension, impaired fasting glucose, mild physical symptoms, and this mild psychopathology. Here we investigate for the non-weight related contribution of risk factors, intense lifestyle modification, diet and exercise, monitor and address the risk factors and improve the general well-being. It is done. In the stage 2, where comorbidities are present, like hypertension, diabetes, dyslipidemia, fatty liver, sleep apnea, osteoarthritis, here the indication to start intensive obesity treatment like the behavioral therapy, pharmacotherapy, surgical therapy, and essential to closely monitor and manage the comorbidities. In the stage 3, end organ damage is there, and all these AMI, heart failure, diabetes complication, severe osteoarthritis, severe psychopathology, severe impairment of well-being, functional limitations. Here we give aggressive obesity treatment, behavioral, pharmacological, surgical, and aggressive management to the comorbidities. And in the stage 4 or the end stage disease, there is severe chronic disease, severe end stage disability, severe disabling osteoarthritis, and this aggressive obesity treatment. And here, this, for example, 24-year physically active female, BMI 32, no demonstrable risk factor, no functional limitation, no mental health issues. This is obesity class 1 and stage 0. Here we focus on the prevention of further weight gain, and there is no benefit of aggressive obesity treatment. While with 32-year male, BMI 37, hypertension, sleep apnea, depression are present. So it is obesity class 2 and stage 2. So there is clear benefit of aggressive obesity treatment here in this group. While a 63-year-old male, BMI 54, disabling osteoarthritis, patient is wheelchair bound, severe hyperventilation, general anxiety disorder, fibromyalgia. So it is a obesity class 3 and stage 4, and aggressive obesity treatment unless deemed palliative care is important. And here there is Association of this Endocrinologists of America has given this guideline, and this obesity has been termed as adiposity-based chronic disease, and it is a complication-centric approach. And diagnosis is not solely depending on BMI. So adiposity plus presence of severity of the chronic complications and the problem of weight and the weight-driven diseases are very important. So anthropometry as well as the presence and severity of the chronic diseases complications. So it has the anthropometric component and the clinical component, but the presence and severity of the complications, biomechanical and biomedical, all these things are taken into account. So excess adiposity, how much that is causing the problem, all these complications, 16 complications which are present, and these complications may come first, while we'll have to assess the obesity later, or the patient may come because of this excess weight. We'll have to assess these complications, and we'll have to stage all these complications in a, staged manner. If we just look into this part, we can see the stage 0, 1, 2, but every complication is there, and we'll have to screen and diagnose all these complications, and we must assess not only the BMI, we assess muscularity, edema, volume status, etc. So treat the complications at the end point of weight loss therapy and not the BMI. After all these things, diagnosis, staging, and prevention, etc. So all these in the step 2, physical examination, review of systems. The step 3, severity of the complications and using complication selective criteria. In the stage 4, we only give therapy. In the stage 0, healthy meal pattern, calorie reduction, physical activity. In the stage 1, intensive lifestyle and the behavior therapy, medications. And in the stage 2, intensive lifestyle plus behavioral therapy plus medication, and consider bariatric surgery. In the stage 0, there is no complication. In the stage 1, mild to moderate complication. In the stage 2, severe complications are there. So in this anthropometric measurement and is not sufficient for complete diagnosis, clinical component or the step 2 is a must. So anthropometrically overweight or obese people must undergo for evaluation for the complications, and the checklist of the obesity related complications are there. And we must say that how much complication is there in patients with complications. Excess body weight is adversely affecting how much the health. So who will benefit from the weight loss therapy has to be assessed very fast. So in the stage 0, the secondary level of care with lifestyle modification, healthy meal plan, and these behavior modification, increased physical activity. In the stage 1, moderate weight loss 3 to 10% with excessive or this intensive care. In the stage 2, more than 10% weight loss and intensive behavioral therapy and sometimes bariatric surgery. So obesity 1, 0 and 2 is a lifelong disease. So follow up and the dynamic assessment to be done. So this kind of management can vary according to the presence of complications. Stage 2 and 3 should have this complication-centric approach to the diagnosis and management. It is very important. So BMI more than 25 may get the primary therapy, secondary therapy, or tertiary level care, complication-centric approach. So those patients with this obesity stage 1 and 2 may get this tertiary care level. So we'll have to classify them in the mild to moderate disease or a severe disease. And when it is a severe disease, we can opt for this lifestyle behavior therapy, bariatric surgery, or lifestyle behaviors of considered pharmacotherapy. Or when there is grade 0, we just give this healthy meal plan, physical activity, health education, and these other environment changes. So we must assess the patient's readiness and motivation for the change. And there are 6 stages of motivation. We always increase the patient's motivational stage and readiness to change. And we should give a focused target to determine the customized and the best treatment plan to the patient. We must overcome the challenges to successful management in every level, because appropriate planning for successful obesity management is the major task. We must always do that, because successful management, obesity management, depends on overcoming all the challenges which actually surrounds the patient's scenario. There may be physical problem, there may be psychological problem, there may be monetary problem, there may be other issues, and we should deal with every barrier and trigger of this obesity care in every patient, and accordingly plan which patient should be benefited much from this obesity care, which drug should be given to these patients, what is the condition which is triggering the patient's obesity. So with this, we must stop here. Thank you very much for your patient hearing at this, again, there's so many participants are still there. So that is the passion of eRAJAPICON, and we must, thank again all these mentors who are still present. So with these few words, I must then thank you very much, sir.
Thank you very much, Dr. Thank you very much, Dr. Soumitra Ghosh. Highly educative presentation.
To conclude,
Dr. Soumitra,
Yes,
still
sir.
there are 400 delegates who are attending your talk.
Thank you, sir. Thank you, sir.
So wonderful.
And that is only possible in Rajasthan.
Nicely explained each and everything. In spite of your last talk, I think you have done a good job and excellent deliberation.
Thank
This
you,
is
sir.
what
Thank you, sir. Your blessings.
Thank you, Soumitra. Thank you, Soumitra, for
Yes, sir.
thank you, Soumitra, for joining.
Yes, sir.
This
Sir,
late
sir.
hour. Thank you so much.
Thank you, sir. Thank you. Actually, we are there in a state, webinar also.
Yeah,
So, but we cannot refuse the invitation from our mentors, from our friends.
Thank you.
Yes, sir. Sir, we have all your blessings.
To conclude the session, I really thank all the esteemed speakers and chairpersons. And at this time of saying goodbye, I am really short of words to express my sincere gratitudes towards the stalwarts of Rajasthan API, respected Dr. K.K. Parikh sir, Dr. Girish Mathur sir, Dr. Ramchandani sir, and Dr. Maheshwari sir for giving me this opportunity and to include me in the organizing team of eRAJAPICON 2020. It is always a wonderful experience, sir, to working under your able guidance and leadership. Thank you so much, sir.
Thank you very much, dear Ashutosh. You are all of the day you are busy, and you are keeping everybody. Asking them to join and calling every chairperson, every speaker. Thank you very much.
Thank you, sir. Thank you.
For your
Congratulations, sir. Parikh Saab, Girish Mathur Saab.
Thank you, sir. Thank you, sir. Dear friends, really immense pleasure to extend a heartfelt thanks to all of you, all the speakers, delegates, and the chairpersons. And to organize the virtual conference was a different experience, certainly. And I am grateful to my mentor, Dr. K.K. Parikh. This conference is his brainchild. I am grateful to him for his constant support, guidance, and leadership. And I am thankful to all my friends, Dr. Pradhiman Sharma, Dr. Swati Srivastav, Dr. Puneet Saxena, Dr. S.S. Daria, Dr. Ashutosh Chaturvedi, Dr. Neeraj Loda, Dr. Anil Samaria, who were instrumental in running the 2-day sessions very smoothly. I am thankful to Ajay Sharma and Vishal Bancholi, who managed the show in a wonderful way. And my thanks are due to the team Vision Plus, Navneet Khandelwal ji and Ashish Bansal ji, for their flawless organizing this conference. Thank you so much.
Thank you so much.
Navneet ji, thank you very much. It was a wonderful event which we had, and this is all because of you. This flawless continuous going on. eRAJAPICON was a flawless and very entertaining, very updating. Bedaswal Sahab, namaskar.
सर नमस्कार।
नमस्कार।
आपके दर्शन कर रहे हैं सर बार बार।
दर्शन तो आपके हो गए सर।
We must congratulate the team of Rajasthan Epicon for their excellent exposition of a international conference to that extent in a virtual program. I think that's a amazing, extensively very good, simplified approach to the virtual program to enter. That is one of the very basic thing in this conference we can see. Anywhere you want to go as a speaker, as a spectator or listener, you can easily enter into, you can easily leave, you can easily go. That is one of the very basic beauty, at least in this conference, I have learned. Thank you, Dr. Parikh and your team, Dr. Mathur and Dr. Ramchandani. I think we are very much grateful to have this type of idea, attitude, and making a successful, super successful conference. Thank you, sir.
Thank you, sir. Thank you, Dr. Ghosh, for your kind words, and you are a great well-wisher of all of us.
Yes, sir. Thank you, sir.
Always with you.
Parikh Saab and all the team of Raj API for making this event very successful. It will be remembered for times to come.
I can see now the face of Navneet ji. Navneet ji, thank you so much for executing this conference flawlessly. Thank you so much.
Expectation से अच्छी आपने की है.
Very good. Extremely well.
बहुत बढ़िया, कहीं कोई दिक्कत नहीं आई. बिल्कुल, it was wonderful experience working with you.
Thank you so much, sir.
And hope that we'll in future also we will have you with us whenever we get the opportunity to organize a virtual conference.
Thank you, sir, for giving me this opportunity, and definitely I'm really very happy to associate with you all.
Thank you so
much. Great pleasure for me, sir.
बस वैलिडिटी चल रहा है, थैंक्स चल रहा है।
Thank you, रामचंद्रन जी, बहुत बढ़िया।
रामचंद्रन जी बिजी है टेलीफोन से।
नहीं सर, बिजी नहीं हूँ सर। लोगों के फोन आने को थैंक्स दे रहा हूँ।
Ramchandani is always busy with like a bee all the time. I can find him busy like a bee.
कल साहब
Exciting sector.
वाले अपने स्मोकिंग का
quit it, sir.
क्या बात है, वो ग्रेट।
ओपन प्लेटफॉर्म पे तो ये कहना पड़ेगा।